Department of Surgical Oncology, Apollo Hospital, Mumbai. Dr. Prakash Talkar from Indore. He is the director of Sri Aurobindo Cancer Institute, Professor of Medical Oncology, Indore. Dr. Dinesh Mangal. Dr. Dinesh Mangal is director of SEROC Cancer Center, head of Department of Radiation Oncology, Manipal Hospital, Vidyadhar, Jaipur.
Very good morning, ladies and gentlemen. I welcome you all to the scientific session of the 4th IOSICON. And as a chairperson, I got the privilege of inviting Dr. Anand Bhushan Ranade, the dear friend and consultant medical oncologist, senior consultant Department of Medical Oncology, Laksha Hospitals, Pune. And he's going to speak on the hype or hope in immunotherapy in head and neck cancer. Dr. Anand, please.
Good morning, everyone. At the onset, let me thank the chairs, both very dear friends, for asking me to come here, and the organizers, Hemant and Lalit. And they have given me a topic in an immuno-oncology society where I should be speaking in favor of immuno-oncology, but I don't know. The data doesn't suggest so. My number of slides is more, but I'll finish on time. So we all know pillars of oncology, starting from surgery, radiation, cytotoxic chemotherapy, and then moving on to targeted therapies and immunotherapy. And everybody thinks today that immunotherapy is the order of the day. Is it so? Let's think about it as we go through the presentation. Let's think about various scenarios of head and neck cancers, since we are talking about them. And rather than getting into more complicated, I have just enumerated 3 here with recurrent and metastatic, which has the maximum data, with immunotherapeutic agents. Then, of course, adjuvant setting, which is waiting for a practice-changing data to come in. It's important, but especially the second one, organ preservation protocol, which was practiced first time in the world for preserving an organ in the form of the larynx, also makes an important point. And recurrence-free survival, because it's a very complex organ, I would say, head and neck, so many organs inside, and so many different anatomies, and their behaviors are different. So having a disease-free survival, clear disease-free survival, also is very important. When we talk about immunotherapy, we will consider whether it should be a single dose versus multiple doses. Now you'll ask me, why am I talking about single versus multiple? Because there are trials of pembrolizumab in neoadjuvant setting with 1 single dose, or maybe with 2 doses, and then they go ahead with a regime, so on and so forth. Then should it be given with chemo? Without chemo? Should it be given with regular chemo, or should it be given with metronomic doses? Yesterday we had a wonderful talk by Dr. Banavli. So we'll talk about that. Then regular dose or low dose, that of the immunotherapeutic agents. After Vijay Patil's beautiful paper, things may have changed. Then we know that HPV status has something to do with it. And to me, in head and neck cancer, the most important thing is the variability of response evaluation. Are we going to follow the same radiology, or are we going to talk about total pathological response and maximal pathological response, and grade that MPR also in three subgroups of less than 10%, 10 to 50 and 50 plus, etc. And whether the T cell, the tumor which is taken out later on after neoadjuvant immunotherapy, is it T cell rich or poor? Yesterday, again, there was some light thrown on this T cell rich and poor. So do we make a tumor hot from the cold tumor and then treat it? Just before going ahead, I will like to show you, everyone knows this, audience doesn't require anything to be told about the HPV status And we are now going to concentrate more and more on HPV negative patients who really have a bad future. So what are the considerations for recurrent and metastatic? Normally we start with neoadjuvant chemotherapy, neoadjuvant treatment, then go to adjuvant and then go to recurrent or metastatic setting. Here we will start the other way because there's a lot of data, and actually the practice has changed as per guidelines in this particular setting. It's an incurable disease with poor survival outcomes. We all know that. Salvage surgery, which I'm a very fan of, is beneficial in very highly selected patients. And Dr. De Cruz will tell us more, but they are not more than 10% in recurrent setting. P16 positive population has a longer survival expectation, and many of the new young patients are fitting into this category. The comorbidity may limit therapeutic options. Yes, the comorbidities are so much, especially the patients can't eat properly and the nutrition suffers, and that causes a lot of stress on the system, which we are trying to work with. Earlier, before this, it was only chemotherapy and chemotherapy. With two trials, which I'll show shortly, we came to cetuximab and bevacizumab. But still, the 1 year survival in this particular group was pretty dismal, and something that we cannot talk about. So thinking about immunotherapy, what are the various things? Monoclonal antibodies, targeting molecular involving the tumor, genesis, EGFR. And we honestly know that in head and neck, like in lung cancer, we don't have so many driver mutations which are present on which we can act. So we have to think about something else. And that is the immune checkpoint targeted MABs, either PD-1 or CTLA-4, and the data which has made the differences in PD-1 with pembrolizumab and nivolumab. So I'll be briefly going through those two trials. This is extreme chemotherapy with cetuximab. Obviously, cetuximab showed better results, and then it was incorporated in standard of care guidelines. This was the other trial in which bevacizumab showed some kind of a better result, and there was no head-on comparison. And I really doubt in a good setup with good number of patients we will ever have these trials, because nobody is going to be interested in them anymore now. One more thing which I have to mention here is that biomarkers. Which are the biomarkers that we are going to talk? We just talk about PD-L1 expression, and PD-L1. Now we have started about high mutation burden, but there are so many other cells, so many other markers that we could be thinking about, including the T cell clonality, the presence of CD8 positive cells, whether they are more, are they increasing, are they getting reduced? And one has to mention gut microbiome also. Though the data is not going to be there in clinical practice with this, we have to think about it. Then we come to Keynote 48 study design. We all know this study design, pembrolizumab versus pembrolizumab plus carboplatin or cisplatin plus 5-FU, and extreme. They have compared it with the extreme study regimen also. These are the baseline characteristics of the intention to treat population. And in comparison to this, the ongoing response, which is supposed to be obviously better with pembro plus chemo, and definitely the trend showed that we should go for these particular immunotherapeutic agents. The overall survival for pembrolizumab plus chemotherapy versus extreme, we can see that the curves are separating, or one curve is remaining to be very small. Now, my topic given is it hype or hope? Honestly speaking, are we happy with this data? And I don't think any one of us is going to be happy with this, because even if it is better, I agree that we started with simple no treatment, then chemotherapy, some improvement. Then we had cetuximab and bevacizumab showing some more improvement. And then again, we have some more improvement in the form of these checkpoint inhibitors. These were the side effects. Most of the patients, even in our clinical experience, tolerate immunotherapy much better than many others. And this is overall survival in subgroups of pembrolizumab versus extreme, favoring pembrolizumab everywhere. Then we go to checkmate 141, nivolumab in recurrent metastatic head and neck cancers. The dose here is the standard dose which they use, 3 milligram per kilogram. And we will talk about that at the end of the talk. And the investigator's choice of treatment. Now, this particular trial was the first trial in second line treatment regime in recurrent or metastatic head and neck cancers. And here also it did show a good change and upward shift of the curve. So we know that nivolumab was the first one to get recognized in second line. Again, the side effect profile, everyone knows. I've just got 15 minutes, so I'm trying to rush through all this. Then we come to Keynote 4040 trial with pembrolizumab versus standard of care in recurrent and metastatic head and neck cancers. Again, a trial which showed positive results in favor of immunotherapy. And in case of overall survival, also it was good. And here we can see that when the subsequent use of checkpoint inhibitors was done and the patients were followed up, obviously it showed better response. So this is regards CPS scores of more than 1. Again, pembrolizumab was better. Also for CPS more than 50, it was better. We know this, so we are not going to talk about this. So what are the other combination therapies in recurrent and metastatic head and neck cancers? This is a huge list, but if you see on at the last column, no overall survival benefit. So these trials did not show a clear-cut, what should I say, a clear direction that yes, it should be used, but they were used in different combinations. And I wouldn't say that these studies really should have made a difference. The 3 trials which we saw, the checkpoints and keynotes, probably why probably? It actually did force the FDA to come up with guidelines that were supportive of immunotherapy. Having said that, I still feel that we are talking about very few agents. We are talking about nivolumab and pembrolizumab. Nivolumab in second line recurrent metastatic with progression on or after platinum-based chemotherapy. So, okay, one subset we have identified. Pembrolizumab can also be used in addition to the first one, like in first line recurrent metastatic head and neck as a single agent with patients with PD-L1 expressing tumors. And it can be used in combination. So in a way, we got some respite that, okay, chemotherapy will be continued along with this. The 3 other molecules were also tried in some of the trials. We don't have a clear trial showing that they are superior to either of the first 2. There is a good trial going on avelumab, and hopefully we should get those results very soon. And let's see if anything changes there. They're also trying these drugs in adjuvant setting, but no clear data of those trials is available, which will support that immunotherapy should be used in adjuvant settings. This is a pan-Asian adaptation of the same trial. So what do we have in recurrent and metastatic? No platinum-based chemotherapy during the last 6 months and PD-L1 positive tumors, pembrolizumab monotherapy, pembrolizumab plus chemotherapy. And the options are platinum-based chemotherapy and methotrexate or taxane plus cetuximab-based chemotherapy. The second subset is no platinum-based chemotherapy during at least 6 months and PD-L1 assessment not carried out. So, okay, we have one cohort of PD-L1 positive, and here we have unknown PD-L1. Again, we are talking about pembrolizumab plus chemotherapy, which is a safe bet, and we have various options in that group as well. The third one is no platinum-based chemotherapy during the last 6 months and PD-L1 negative tumors. Here again, we have to stick to chemotherapy, no immunotherapy intervention here. And of course, then pembrolizumab comes as an option. Pre-treated patients with platinum-based chemotherapy within the last 6 months, the standard is nivolumab because that trial very clearly showed that, and taxanes or methotrexate, these are the options. And the last one is pre-treated with platinum-based chemotherapy within the last 6 months and with prior immunotherapy, taxanes or methotrexate again. Now here, trials have been conducted with ipilimumab and nivolumab, but no clear-cut data, hence we are not talking about that. This is one area which I think we should be very hopeful about when we talk about immunotherapy, which should be sequentially used. And that's why in my first slide, I had shown that right now, okay, we know that Nivo and Pembro could be used in this setting, but what happens if one of them fails? Are we prepared today? Do we have the data to say that, okay, let's go ahead and use some other immunotherapeutic molecule? Then As the last part of this particular talk, I will mention this Vijay Patil's trial, which to me has been a big boon, and I'm very thankful to Tata Hospital and all the people who worked in that team, because in our country, using nivolumab in full dose or pembrolizumab is a big step, and it's quite costly. And most of our patients, more than 90% of our patients, cannot afford it. So they used metronomic chemotherapy, which was Dr. Banawali's brainchild, along with immunotherapy arm. And obviously the immunotherapy arm was superior. Here they used a fixed dose of 20, coming down from 240s to 20. And the results were really stunning. And because of this, I think most of us in our country have changed our practices. At least I have changed my practice. But Dr. Banawali yesterday mentioned that your dose of 20 is too less, and he was talking about 40. In this particular trial, the trial was well matched. The grade 3 toxicities were also less in the investigational arm, and median overall survival was significantly better. So I think it's time that we do come to the end of all this. I'll go through this. What are the ongoing trials now in phase 2 and phase 3 trials in head and neck cancer, especially locally advanced? Now, those two slides, I don't need to show them to this particular population. If there is a patient who has a technically unresectable tumor or locally advanced tumor, wherein we have to shrink the mass immediately and send the patient for surgery, that is something which everyone is trying to do. But again, no clear data, and time has lapsed. Around 2 years have gone since we have got these two molecules working in the metastatic setting. We still don't have anything in adjuvant. We still don't have a clear data stating how it should be given, when it should be given, or whether it should be given in neoadjuvant setting. But I think this area definitely tells us that there is a hope for using these molecules. And there could be other molecules also, because these are going to be treatment-naive patients, and probably the CD8 cells or the killer cells which are going to be there, they will act better, they will get that antigen exposure, and so on and so forth. So this is the area where I think it is going to work. This is again a list of trials that are going on. So to summarize, immunotherapy with checkpoint inhibitors is active. Yes. Both Nivo and Pembro are FDA approved. Yes, we know that. Pembro monotherapy with PD-L1 expression, positive patients, and combinations in all other patients in metastatic setting. We have to be worried about toxicities. We have to be vigilant about them. They're not very bad, but we have to be vigilant. And multiple treatment strategies combined with immune checkpoint inhibitors should be thought about. What I would like to say, I still feel that at this moment, this is a big hype, because if we are going to reach this particular picture with head and neck tumors, I think we are in infancy. There seems to be some hope in some typical areas, but beyond that, how much are we expecting? Are we still talking about 5-year survival in head and neck cancer? No. With immunotherapies, with chemotherapies, no. We are not talking about 5-year survival in metastatic setting. We should try and work with the neoadjuvant setting, wherein we can really make a difference. If an inoperable tumor becomes really operable with margins which the surgeons are very cautious about, I think that is the area of hope. But at this moment, I would say that yes, we are looking forward to something happening. Also, we have to think whether it is going to be only these checkpoint inhibitors, or are we going to think about tumor vaccines, or are we going to think about various other modalities through which we can go in immunotherapy and support our chemotherapy for those patients. We also need to understand what is the difference between the pathological pictures of treated patients and what is better. Because we are continuously thinking that making the tumor hot probably will help us. But is that true? We really don't know the answers to all these questions. What about the gut microbiome? A change there, will it change? There was an excellent paper by Dr. Jason Fung. It was not regarding head and neck cancers, but he stated very clearly that if you can work on the gut microbiome, and if you can work with the patient's general health concerning his metabolic syndrome, this is the last one. Concerning the gut microbiome, things will be different. Thank you.
Thanks, Anfal, for a lovely talk. I agree with you. 15 minutes is a very short time to go through immunotherapy, hope or hype. But I think you've done justice and at least set the tone for a great panel discussion. So maybe we can move immediately to the panel discussion in the interest of time. While the panelists are coming up, if there's anybody who wants to make a comment or ask a question, since we have a speaker on the podium, please go ahead, and I'd invite the panelists to come up. Sujit Kumar is our moderator. Sujit, would you come up from Chennai? Aditi Mittal from Jaipur. Vashisht Maniyar is here. Rohit Ribello from Udaipur. Shikha Dhal from Jaipur. Prashant Kumbaj. Naresh Somani. Ashish Agarwal. Ritu Jain and Santosh Kumar from Hyderabad. How do we make the arrangement? How many do we have enough chairs for all? Or yeah, we can come down and then the panelists can sit up.
Good morning, everyone. Respected chairpersons. First of all, thank you for the organizers for giving me the opportunity to have a panel discussion on such an important topic. Head and neck cancer is the cancer for most common cancers in India, and it's our burden of disease, and we have to find a solution. Let me ask the panelists to introduce themselves, please.
Good morning, everyone. I am Dr. Shikha Dhal, Associate Professor in Department of Radiation Oncology at SRCC, Mahatma Gandhi.
Good morning, everyone. I am Dr. Prashant Kumbaj, Associate Professor in Department of Medical Oncology, Mahatma Gandhi Medical College, Jaipur.
Good morning, everybody. I'm Dr. Rohit Ribello. I'm a Senior Consultant Medical Oncologist in GBH Cancer Institute, Udaipur.
Morning, everyone. Naresh Somani, Medical Oncologist, Jaipur.
Good morning, everyone. Myself, Dr. Santosh, Medical Oncologist, Kaizen Oncology Network from Hyderabad.
Good morning to everyone. I am Dr. Ashish Agarwal. I am Senior Consultant in Medical Oncology at KRS Hospital, Surat.
So in the next 30 minutes, I will be presenting the results of a survey that I did for this panel discussion, and we'll go fast through the slides. So as you all know, recently in December 2022, there was a ASCO guideline regarding use of immunotherapy and biomarker use. So we had a first question that are you aware of these guidelines? And fortunately, yes, 82% were guidelines. I think as medical oncologists, with so much advances happening in Western world, it's our duty to be aware of what is happening, the science, but many times we can only think globally and act locally as per our needs. So first we'll go to this patient. He's Mr. GP, a 67-year-old retired government employee. He was diagnosed with CA tongue in 2018, had right hemiglossectomy with neck dissection, nodes were positive. Post-operative radiotherapy completed in March 2019. In Feb 2021, he developed ulcer in the neck area, and there was a loco-regional disease unresectable. Biopsy was recurrent squamous cell carcinoma. As that was a standard 3 cycles of paclitaxel, followed by a scan which showed partial response, followed by 3 more cycles. The last dose was in June 10, 2021. Within 3 months of his last chemo, he had progressive disease locally. As you can see, this is a picture, a typical cauliflower-like appearance, what we say about recurrent squamous cell carcinoma. So coming to Dr. Aditi, yeah, what is your practice? Do you routinely do PD-L1 testing prior to start of immunotherapy?
So not in all cases. That's what I answer.
So you would say that no in all cases, or you have a choice among this? Yes, in first line, second line?
So as per the data, we know that PD.
Yes.
Yeah.
You will
Yeah.
choose one.
So not in all cases. That.
So in which cases do you do? Like first setting.
Yeah, first line setting in few cases of first line setting.
So this was the result, as you know, as you can see, this is divided opinion. 30% of medical oncologists do not do in any case, whereas 32% do in all cases. We'll see to the data and what is the recommendation. So this is divided. So we need to know why there is so much difference of opinion here. So yes, Dr. Shikha, what do you think is the biomarker of choice in first-line immunotherapy in recurrent metastatic head and neck squamous cell carcinoma?
It is PD-L1 combined positive score more than or equal to 1 or greater than 1.
So there are other options. Tumor mutational burden more than 10 is also one of the options. Now the trial by Dr. Vijay Patil had used TPS score precisely because CPS is somewhat costly and TPS is the most available by SP263. TPS is the most available option in our setup. So this is again, as you rightly said, most of the medical oncologists prefer doing PD-L1 combined positive score. More than 50% preferred that. Also, some of them are doing TMB, and around 20% of them do not do any biomarkers prior to immunotherapy. So what are the guidelines? Should PD-L1 testing be done in recurrent metastatic head and neck squamous cell carcinoma? The ASCO guidelines say for first line, yes, PD-L1 by CPS more than or equal to 1 is, in that case, immunotherapy is indicated, and TMB more than or equal to 10 in cases where NGS has been done. In second line, irrespective of PD-L1, we can consider immunotherapy. What are the trials? What did they do? In Keynote 48 regarding pembrolizumab, first line, the PD-L1 was done by 22C3 farm DX assay. In Checkmate, it was a second line. It was after progression on platinum, so there was no PD-L1 as part of inclusion criteria. And in the trial done by Dr. Vijay Patil in low dose, PD-L1 was done. I'll show the data. It was done by SP263. So they had not stratified based on that, but as part of the initial workup, it was done. So you can see this is the data that was discussed by Dr. Ranade also. You can see in spite of PD-L1 active or not, it's more than 50, 1 to 50 or negative. Most of them, when compared to the metronomic arm, they had numerically the percentage of patients living at 1 year was more. If it was more than 50, it was 54% versus 26%. And in PD-L1 0 also, it was 62% versus 10%. So yes, in patients who don't have PD-L1 expression also, it is the numbers are less. If you see in PD-L1 0, it is numerically the numbers are less, but still there is some response. So in patients who don't have PD-L1 expression, instead of pembrolizumab as first line, there can be a consideration of nivolumab in spite of the financial benefit also. So coming to Dr. Rohit, what is the most important barrier you think that we have in use of immunotherapy in head and neck cancer in your practice?
In my practice, it is financial affordability.
And we all agree to that. Also, there are, I'll come to the research, what the majority of participants felt. Yes, more than 91% felt that financial affordability is definitely a cause for problem for our patients. If you see the data from Tata Memorial Hospital, they had a real world data. Only 1.6% are affordable for immunotherapy when indicated. So 155, it's not for head and neck cancer, it is for total solid tumors. So from that is the main concern in everyday practice when we discuss regarding the option of immunotherapy. So you should just note the number 1.6% is affordable. So coming to Dr. Naresh, sir, in recurrent HNCC, what is your preferred choice of regimen? This question I'll ask everyone. Please take your choice.
So as we just had the lecture by Dr. Ranade, and I think he is willing to ask question also. So obviously, as on today, based on the guidelines, is the chemotherapy, platinum 5-FU plus pembrolizumab, the dose being prescribed for the patient. Yes, if the PD-L1 is high or the positive, then maybe the single agent pembro is almost equal to the combination chemotherapy. That's the preferred choice. But as we all understand the financial toxicity and sometimes the side effects of the combination of the chemo plus IO, and with the ease of the administration, I think the low dose nivolumab, something like 40 milligram every 4 weeks with the oral metronomic therapy, I think is equally good for our patients. But there cannot be the direct comparison. Yeah.
Dr. Santosh?
So the things I take in decision making in such scenario is what is the burden of disease, number one. Second is what is the percentage of PDL1 expression, number two. What are the finances and all. Suppose the burden of disease is very high, very fleshy. I need to reduce the burden of disease. In that scenario, even if PDL1 is more than 50, I would combine with platinum Taxol. I do not use 5-FU based. We have data of Taxol based that with this one. Suppose the burden is not so high, I would tend to use single agent pembrolizumab in more than 50%. In the intermediate case, I use always a combination of chemo plus this one, that is 1 to 50. In less than 1, we don't have strong data of combination of pembrolizumab. In that, I choose cetuximab based therapy with platinum and Taxol rather than pushing for immunotherapy. Of course, some fleshy tumors appearance, they respond very well to methotrexate. So if they're financially difficulty, sometimes there would be very magical response with methotrexate, the appearance of fleshiness and all.
Dr. Ashish, which will you choose among this?
I agree with most of point of Dr. Santosh. But first, I also look for the nutritional status of the patient and general condition. If general condition is good and PD-L1 score is more than 50%, I go with a single agent monotherapy, because in the trial, even in high burden disease, the monotherapy had good results compared to chemotherapy. And Taxol plus immunotherapy had category 2B recommendation according to NCCN guidelines. So
So in your next patient of this, would you choose? Yes. Yes.
No one wants to use metronomic chemotherapy, triple metronomic, when we are talking about financial status. And is anyone willing to work with regular chemotherapy plus low dose Nivo?
So actually, in my practice, if first line chemotherapy or is failed, then I go for the oral metronomic chemotherapy. If GC is poor, then I go for the metronomic chemotherapy. It's now it's current practice, sir. Maybe change in the next year.
See, with high disease burden, anyway, the patient has a lot of problems. So has anybody used in practice? We have started using as a.
So I use in to patient in recurrent setting, second line setting.
Not
sir.
first line.
Not first line.
So can I answer? So yes, I am using this since last 4 or 5 years. My combination is efatinib 30 milligram, 5 to 6 days per week, methotrexate 2.5 milligram BD, 2 days in a week. That is something like Monday, Thursday, and celecoxib 200 milligram BD continuously. This is the protocol I follow. Depending on the tolerance, then I may reduce it even further. And this I am talking in the first line, the patients who don't want to get admitted and the patients who are otherwise not so suitable even for the combination of the Taxol with the carboplatin.
Have you added low dose Nivo to any one of those patients?
So now I have started it, but my practice is again 40 milligram because I cannot get 20 milligram. I cannot club patient in the routine clinical practice in a private setup. So I do 40 milligram every 4 weeks, because now we have the data of the nivolumab every 4 weeks also, though the dose is double. But yes, 40 milligram every 4 weeks with the same combination.
So the results of the survey also showed that most of the oncologists prefer to check the PDL1 and consider pembrolizumab combination if CPS is more than 1. Around 25% of patients, the oncologists prefer having low dose immunotherapy with oral metronomic chemotherapy with or without PDL1. So we have around 25% of oncologists going for the low dose immunotherapy with metronomic. We have not asked, and I don't think we have a data right now to go for immunotherapy plus chemotherapy. But some of the patients can be started on weekly paclitaxel with low dose immuno. So we'll come to that. So coming to Dr. Aditi, what is your practice with pembrolizumab? As you see, more than 50% of the oncologists prefer pembrolizumab as first line in case they are affordable. So what is your practice? So which one will you choose?
So again, depending on the nutritional performance and the financial state of the patient,
They are financially fine.
They are financially fine.
This 4 group, what would be your choice?
So if the disease burden is more, I would go with combination and the patient performance is good, then I would go with combination with chemotherapy.
So, so in spite of having CPS more than 50,
Yeah, if the disease burden,
more, you prefer to go for combination.
Yeah, and if the burden is not very much, the patient is not very symptomatic and very not like PS2 kind, then single agent pembro would be fine.
Yes, score is at PD11 score. It's 50%.
CPS score, CPS. So I want to ask Dr. Ashish, what do you think is the response rate for single agent pembrolizumab, irrespective of PD-L1 status and irrespective of previous treatment? What
Sir,
would you think-
sir,
what would be the percentage?
in first line setting, if CPS score is more than 50%, I go with the monotherapy.
No, I'm asking the percentage of response with single
Around
agent immunotherapy.
around 33%, 38% is response rate, sir.
So that's what, so you can see again a divided opinion. Most of the patients, most of the oncologists, if the CPS is more than 50, consider combination with immunotherapy and chemotherapy, and many of them go for single agent pembrolizumab. The word of caution is that head and neck cancers, if the burden is high, immunotherapy may not work very fast. It's even the guidelines say that if the burden is high, please don't give single agent pembrolizumab, even if it is more than 50%, because patients can become very fast symptomatic and sick. They may not be actually fit for further lines of chemotherapy. That is one concern. Patients become sick, they don't go for chemotherapy. And I think in such situations when the burden of disease is more, better to combine chemotherapy with immunotherapy. Cisplatin 5-FU, I think is many of us don't use as a first line. Paclitaxel carboplatin is our use, so it can be combined with paclitaxel carboplatin also. So the response rates are close to 20% only, so better to go for combination. So as per the previous slide I had shown, less than 5% of patients are found to afford immunotherapy as per the approved doses. What percentage of patients in your practice will afford low dose immunotherapy with OMCT? So I can ask Dr. Naresh, sir.
So I answered also in your survey, and it's still not more than 5 to 24% of the patient, because it's gone giving it. It is not like the fixed dose combination chemotherapy that you give, counsel the patient for 6 cycles or something like that. So it's gone giving. This financial toxicity is always there, and it's not more than. And the problem now in our state is the mindset of the patient has changed. Now 70-80% of the population is covered by the various Rajasthan government health schemes. So the patient's mindset says that whatever is available in that government schemes, we want only that treatment. And IO drugs, whatever the dose as on today, are not in the guidelines.
In the context, sir, is there a cap for financial assistance from the government?
It's a both. It's the cap also, as well as there are the protocols and their codes also. So I can give only, let's say, like Paclicarbo with a code. I cannot add the IO drug in that. I even cannot add the IO drug at the cost of the patient. Yeah.
And Dr. Rohit, what do you think? How much percentage of patients will be able to afford when we consider the low dose?
So as sir said, it'll in our practice also is 5 to 24%, and it's that high only because we have government health scheme where we can probably give nivolumab, but in the routine Ayushman scheme we cannot give nivolumab.
And if it was single agent pembrolizumab or combination, what percentage it would be in your practice?
That is about 2% because government health scheme covers pembrolizumab. So only those patients we give pembrolizumab.
So yes, the percentage is still not like 50%. So you can see about 16% of oncologists feel that still less than 5% only can afford even low dose immunotherapy. That is the real picture of our country. And around 25% can afford the low dose. Some of them say that even around 50 to 74% is very less, but around 25 to 50% patients can afford when we have adopted low dose immunotherapy. So from less than 5% affordability, it has gone to more than 25% affordability. And that I think is the biggest advantage of this new trial from TMH, and that has changed our practice in immense way. So coming back to the case scenario, so PD-L1 was not done as second line IO plan. In August 2021, 2-weekly nivolumab 160 mg was started. Post 4 cycles, you can see the proliferative component has responded very well. PET-CT was partial response. Continued till 6 cycles. And this is a very common scenario in our practice. They don't afford like many months of immunotherapy. They may afford few. So there was financial toxicity. The discussion was done. And it was planned for OMCT with nivolumab 40 mg. You see, I have given only 6 weekly. That was the situation which was possible. I will come to the results, but this was what was planned. So what is your preferred regimen if low dose immunotherapy is planned? So as Dr. Banavali sir yesterday said, the trial had used 20 mg, but in private practice or even in the feasibility, the vial comes in 40 mg. The sharing that was happening in trial cannot be done in real practice. So Dr. Prashant, what do you think would be a feasible option for?
So definitely initially it was nivolumab 20 milligram every 3 weekly with Dr. Vijay Patil's paper, and yesterday's Dr. Banavali's talk. Definitely I will use nivolumab 40 milligram every 4 weekly with metonymic chemotherapy because it's easy.
And Dr. Santosh, what do you use currently? You do go by the trial data or you go by the feasibility?
So, sir, 40 mg every 3 weekly to start with. Once the response occurs, sir, we can make it 6 weekly also.
You are using so?
Yes, we have used in few patients. The thing is, sir, we have seen a lot of data in other cancers also. Once the response with immunotherapy occurs, there is long-standing T cell memory response. So some patients, even with one drug in neoadjuvant, they tend to have complete response, sir.
So that is what precisely, as you can see, the oncologists are clever enough to use what is feasible. Although the trial says it is 20 mg every 3 weekly, only around 32% or 1/3 go by that. Nearly 2/3 go by nivolumab 40 mg 3 weekly or 40 mg every month. So I think that is one thing, and we all know that it says it works. The receptor availability of the drug is for 6 weeks according to the preclinical data. So 4 weekly also may be an option in patients who cannot afford. So I think that is what we can understand. Around 2/3 of the oncologists use either 40 mg 3 weekly or 4 weekly. So coming to Dr. Aditi, do you consider ASCO guidelines on immunotherapy important for your clinical practice? Just the answer, yes, no, or what would you choose?
So third option, yes, only if adapted guidelines as per data and feasibility.
ESMO has adapted guidelines, but ASCO doesn't have. We'll come to the guidelines now for just for a revision. So patients with recurrent head and neck cancer do PD-L1 testing if CPS more than or equal to 1, either pembrolizumab monotherapy or with platinum 5FU. If any PD-L1 status and refractory platinum, either pembrolizumab or nivolumab, and in patients who have less than 1, combination immunotherapy. And if TMB testing is available more than or 10, you can go for interpreting as high and go with PD-L1 inhibitors. And I will not be discussing the nasopharyngeal, but still there are different immunotherapy options which can be used with gemcitabine and cisplatin. In salivary gland test, yesterday, Dr. Govind Babu sir showed a case scenario where patient with salivary gland cancer had responded beautifully with pembrolizumab. And in rare cancers, so I think salivary gland cancers and rare cancers will never get a randomized data or high level data. We have to go by these situations, and PD-L1 positive, they do very well, they do very bad with the chemotherapy. So I think this would be an option for our patients. Now, coming to Dr. Prashant, have you ever treated any oligometastatic head and neck cancer with radiation? I'm sorry, doctor, you are from radiation oncology.
Yeah.
Have you used
Shikha.
Shikha? Have you ever given any, is there any role for radiation in oligometastatic head and neck cancer?
There is emerging role of radiotherapy. In fact, re-radiation is possible, and many phase 1, phase 2 studies are there, which have majorly looked on hypofractionated radiotherapy and also SBRT. Looking at oligometastatic disease should be less than 1 to 3 metastatic sites.
Concept of oligometastasis as we have in hormone positive breast cancers or in lung cancer on immunotherapy, we sometimes have oligoprogression, we give radiation. Is there really a data for head and neck cancer?
This is all emerging data. Even I have looked up for immunotherapy, and radiotherapy and immunotherapy have a synergistic effect, definitely. So radiotherapy will have an abscopal effect, so it will affect the systemic immune response as well. So it will be helpful in escalating the T cells and help in tumor new antigens, anti-tumor response also. So there is a lot of emerging data, but yet to be studied.
So in continuity to the last question, now because we are in habit of doing NGS also even for head neck cancer also. So sometimes we get the mutations like the ARID1A, which give the more prediction of the response to the immunotherapy drugs, including the head neck, including the salivary gland tumors, especially the drug like pembrolizumab. So I think it is not only the TMB or the PD-L1 in head neck cancer which matter. Sometimes you get the NGS-based prediction also where you can give the straightforward immunotherapy, especially after the first line chemotherapy in salivary gland tumors.
So as we were discussing, they have about 1/4 only feels that ASCO guidelines are relevant in their current form. And more majority feels that we have to have adapted guidelines as per the data and feasibility. So this is very important. Very happy. Most of these participants have been from young medical oncology groups. So it's good that they are not blindly following the guidelines and they want to incorporate Indian data to this. So this is an important question. Do you think low dose immunotherapy with OMCT has enough evidence to be included in practice guidelines like ASCO, NCCN, and ESMO? So this is not a patriotic question, but going by the scientific data, what do you think? We'll start with just say yes. What you'll choose, Dr. Ashish, which is your choice. Just say the answer. No discussion.
I think third one, yes, it should be included in adapted versions of these guidelines.
Okay, Dr. Santosh.
Yes, sir. We need to, yes, the first option.
Yes, sir.
Sujit, I think we should say Indian guidelines. We have no authority over these guidelines.
Yes, sir. No, sir. The problem
So,
is
in fact, 2020, the Indian Journal of Cancer has brought out guidelines for all the tumor types, all the subsites of head and neck cancer, and it's just getting updated next month. So we have the Indian guidelines also. So
So
that
what
is,
what I'm trying to say is because head and neck cancer is still not only in India, we have.
I agree, but
countries.
we have no control over ASCO, ESMO, or
This is-
NCCN guidelines. So
this
let's
is a
talk
wish.
about our guidelines.
This is a wish. So what is the opinion from the panel?
So can I answer and try to clubbing the both questions? They are relevant only for the low middle income class. I was just reading one editorial written on this particular trial of Dr. Vijay Patil. One is that erlotinib is not the part of the treatment of the head neck. It's not approved drug, which is being used in the Tata trial. It is the afatinib, as I said. The dose of the methotrexate used in the trial is 9 milligram per square meter only, which is again less than the Western standard or the guideline. So that is the reason that they argue against this particular trial. It's the thought provoking. We need to reduplicate these in a more larger way, or maybe in a different versions of this particular oral metronomic therapy. Then only probably it will be in the guidelines which we say like ASCO, NCCN, and ISMO. As Dr. De Cruz sir has raised the question that money is, we are talking the science. So which one we will choose? 5-FU platinum with the full dose of the pembro versus oral metronomic and low dose of the nivolumab. So I will go what Dr. Santosh said, that is the Taxane platinum with pembrolizumab as on today.
So the reason
So,
why I
can I-
asked the question was,
Yeah.
now we have ESMO guidelines.
hello.
NCCN guidelines, trials from outside, and we are following it. So if we don't go by the demarcation of LMIC and HIC, is our data from TMH good enough to be replicated in patients of US who are not affordable for pembrolizumab? That is what, if it goes into that guidelines, whether it will help, is that good?
Sir, there is one question.
Just 150 patients total.
There's one question, just against the Dr. Anil. Suppose in your financial toxicity, 80 to 90% are non-affordable. Then what we as oncologists, we should advise to those patients who comes recurrence after 2 years or 4 years or 5 years.
So
That should this guideline be put there
As
in
an
patients
option.
who can't afford in Western, that will be our
So-
program,
so-
that will be our thing.
So-
I think the points Naresh made, what he's made low cost, look at the response rate in the 65%, the others don't have so much. So we need to introspect and really make the world get convinced. The points.
let me clarify that we are trying to
The only point against it is how long will you continue Nivo in that? In Vijay's trial also, see, ultimately 5 doses of Nivo are going to be costly. When we were talking about full dose, up to 5% patients affording it. So I think that is going to be the question. Once you get a response, once you get continuous response, when will you stop Nivo? Because OMCT can be continued.
So let
So,
me
Dr.
let
Yeah,
me
Dr.
raise a word of caution that we are trying to compare and make the comment on the first line trial versus a patient scenario where the platinum refractory or platinum use combination patients followed by oral metronomic with the different drugs with the IO. So we should refrain ourselves from having the cross trial comparison, rather cross scenario.
I think Dr. Bhavna Parikar, just a short comment only. So of course, we all are very happy using low dose Nivo. But before we also incorporate in our own Indian guidelines also, ideally, we should have a trial comparing full dose Nivo and then see the results and then incorporate, because the finance is a different thing. We do modify the guidelines or we do take care of our patients. But when it's a question that what you are supposed to do scientifically, a majority of patients, even in Dr. Vijay Patil's trial, also were more of oral cavity tumors. And all the areas of head and neck cancers were not there in the trial. It is there in his comments also.
We recently had a journal club on this, ma'am, and we asked the same question to Dr. Vijay Patil. So what
Yes.
he said was, oral cavity cancers, when they are recurrent, are one of the most notorious head and neck cancers. So if
Yes.
it's working in oral cavity, it might very well work. That was
Again, that's a
Yeah, but
postulation.
I think
That's
we
what
should
he
have
said
a
is, yeah.
trial, and we must have, even with the full dose Nivo, then certainly we can incorporate our trial, sorry, our guidelines, whether ESCO includes or not, that doesn't matter. But we must have one authentic guideline.
So ma'am, you are talking full dose Neo in which scenario? Second line oral metronomic or first line?
Sir, I will
Second line.
stop here.
Second.
Yeah.
Next few slides are there.
Thank
So this is what the result, around 80% said that inclusion can be considered, but it's very well taken. It should be for the Indian guidelines or LMICs. So this is what we did. So you can see 6 weekly maintenance. This is what the patient was having, 54 kg at the start of maintenance. It is now 66. He's now, this is a scenario that has happened. I just wanted to ask Dikru sir, will anything, if the disease is free, will he's the main concern here every time he comes is this 5 mm, when will it stop? It will close. Is any role for a single stitch or something that it will help? No.
It will break down. It is when you have to submit the tissues. I can feel that they're just so hard, they won't take any stitch.
He's every day, every time he comes, he's asking. When
What flap? Another flap for from a plastic surgeon?
It is so difficult to take a call. By the time the flap sutures are out, we'll get nodules here and there. So it's a very tough concept. Very, very.
We have one very similar patient. We've done a flap. The plastic surgeon was insistent and we continued giving Nivo.
Possible, but you had one case, I had 19. It's a tough one. You have to base your judgment very individually. It's a call.
He's
If
fine, sir.
if it's a simple procedure, I'll give the benefit of doubt and do what he's suggesting. Continue, Unnibiru.
In this patient, 1 year maintenance with 9 doses, 6 weekly, 40 mg. I think along with, and we did not give erlotinib to this because this was started before the trial data came from Dr. Vijay Patil. So erlotinib was not part of the plan. So this is a way. So it's at 0.3 mg per kg is enough for around 75% of receptor getting plateaued and 6 weekly. So this is one option where which can be considered as a maintenance in patients who don't afford. So coming to the last aspect, which Dr. Ranade had said, that is the future. So I will ask Dr. Aditi, is there any, have you ever used in IO for neoadjuvant setting?
Sir, as we said, there's less than 2% who can afford in this and not used actually, but yes, read it's quite upcoming and read about it. So it's quite exciting. Let's see what happens.
Dr. Naresh, sorry, Dr.
Trials are ongoing and very soon it will be there because major pathological response is quite high, even with the 1 or 2 doses, but not in the real clinical practice.
So that is what most of them say. There are trials are ongoing and it will be useful. This slide just shows that what are the various studies on immunotherapy in oligometastatic head and neck cancer and in NACT intent. So this is my last slide. So I think we are all celebrating the key, but the treasure is the human immune system. So let us celebrate the marvel called human body and not only the key. Thank you so much for the patience. Thank you all the panelists for participation.
Thank you, Dr. Anand Bhushan sir and Dr. Sujit for nice talk on immuno-oncology and the head and neck cancers. Next whole session on the lung cancer. First, I would like to chairpersons on the board. Dr. Shahid Ali Siddiqui sir, he is the professor and head Department of Radiation Oncology. Can we wait? Thank Dr. Girdhar Singh Bhati sir is the professor Department of Medical Oncology, Mahatma Gandhi Hospital, Jaipur, and Dr. Bhavna Parikh ma'am, senior medical oncologist from the Bombay Hospital, Lilavati Hospital, Bombay. Someone is trying to man
Good morning to all of colleagues. Now we are starting the session on the lung cancer. And the first talk is by Dr. Naresh Somani, a renowned medical oncologist of country from Jaipur. And he will talk on immunotherapy of lung cancer and the role of biomarkers. I invite Dr. Naresh Somani.
Thank you, chairpersons. Good morning. And I also welcome all delegates from outside Rajasthan in big city of Jaipur. So I have been assigned talking about the biomarkers, their impact on the treatment decision in lung cancer. And as we just had the talk in the head neck cancer where Dr. Ranade was talking about the few points regarding the biomarker prediction of the immunotherapy in head neck cancer in the various settings. So is the importance of this topic in the lung cancer also. I will be restricting myself basically to the NSCLC. So cancer immunotherapy predictive biomarkers are fundamentally different from the other biomarkers or the target mutations in the NSCLC like the EGFR, ALK, ROS1. Not only biologically, but their impact on the treatment also. And they are being affected by the host factors also, other than the presence or the absence of these biomarkers. Now, these biomarkers had markedly improved the survival rate of patients in lung cancer, has introduced the new era of the lung cancer treatment like many other malignancies. But as we all understand, with the immune checkpoint inhibitors, all patients are not benefited. So in the lung cancer also. And yes, immune toxicities are the different phenomenon, and financial toxicity is, I think, of the prime importance when we consider immune therapy. So it is very important that we identify the potential positive as well as the negative markers, if possible, that who are the patients who may be benefited by the immune therapies. So these all biomarkers may be incorporated that predict the utility of the bioscore system, decision-making algorithm, so that we can guide the application of these immunotherapy in our clinical practice. Now, these various biomarkers like which give the positive predictive value or the effectiveness of the immune checkpoint inhibitors like the PD-L1, TMB, tumor-infiltrating lymphocyte, MSI, which can be the pan-agnostic, KRAS, P53, and so on. And the druggable mutation markers like the EGFR, LP10, MET, and so on, to give the immune therapies are probably not going to work in the first line as well as in the second line also. And then there may be the certain biomarkers to predict about the hyperprogression of the disease, which is a rare thing, but yes, it's a possible. Now, first I will be talking about the TMB. As on today, TMB is not being so much used in the lung cancer to predict, but yes, it's a marker. A lot of trials has been done based on the TMB. The population of the TMB high or the TMB positive population may be the different from the PD-L1. There are certain association of the PD-L1 in the smokers or the squamous or the small cell lung cancer, but the trials so far done based on the TMB are not being followed routinely in the clinical practice. The markers which we most commonly use as far as the lung cancer is concerned, that is the PD-L1, the various ways, the various settings, the various cutoff values and the various monoclonal antibodies for the assay expression of the PD-L1 are there. It can be the adaptive PD-L1 expression or it can be the constitutive PD-L1 expression. And as we know that the PD-L1 expression is there both on the immune cell as well as on the tumor cells also. Yes, it is an approved biomarker to predict the PD-L1 blockade in the lung cancer. It is currently used to guide treatment decisions and regulatory approval, and its expression may vary over the time and across the multiple tumor sites also. So these are the various important factors which we need to understand when we plan our patient to do the PD-L1 testing. There are two ways to express the values of the PD-L1, that is the TPS and the CPS, which we all know. The TPS probably is more commonly or uniformly being used for the non-small cell lung cancer, which is basically based on the tumor cell, while the CPS is being more talked about in the other solid tumors other than the lung cancer. So what is the TPS? Few of the pathologist colleagues also sitting here, they know it very well and more than us. That is the number of the PD-L1 stent tumor cells divided by the viable tumor cells and then multiplied. While the CPS is the number of the PD-L1 stent cells, including the immune cell, divided by the total number of the viable cells multiplied by the 100. So that is the basic way of that how the TPS and the CPS scores are being expressed or being reports are given. In one of the studies, it has been correlated that what is the difference in the TPS and the CPS in the lung cancer. And there were the major concordance also between the two. So if the values are being reported in the CPS also in the NSCLC, I think that can also be taken as a valid expression of the values in the NSC also. But when we do the PD-L1 testing, certain pre-analytic conditions are important. Like any other markers, especially when we talk about the ERPR, HR, it is something like that. The specimen type, the preparation, the cold ischemia time, fixity, how old is the sample, and from what part the sample is taken, thickness of the sample, viable cell. So many factors, the pre-analytic conditions are there, which may make the change in the PD-L1 value. Now, on top of that, we have the multiple assays for the multiple drugs in the multiple scenario. For pembrolizumab, we often talk about the 22C3 Pharma DX. For Nivo, we talk about 28.8. For atezolizumab, it started with the SP142. And now presently, we often talk about the SP263 for most of these drugs in maximum scenario. And for the pembrolizumab also, if we talk about the ISC22C3, its expression or the utilization in the different scenario based on the PD-L1 cutoff value may also change, less than 1%, equal or more than 1%, 10%, 20%, 50%, and so on. So PD-L1 is a predictive as well as the prognostic marker also. When we talk about the predictive, it's a companion marker. When we talk about the prognostic or a complementary marker, then it's understanding changes. And if you talk about its prevalence, it is being said that approximately 30% of the patients have the high PD-L1 expression in the non-small cell lung cancer. Studies has been done where the concordance has been studied among the various expression methods, that is the 22C3, SP142, and SP263 also, and other markers also. And the blueprint PD-L1 ISCSA comparison project was the one where the two methods, that is the DACO auto stainer as well as the Ventana benchmark ultra was being studied. And there was the high concordance, whether it was the biopsy based, whether it was the aspiration sample based, or whether it was the full surgical specimen or the resection block based. And there was the good concordance except the SP142. And when the results were analyzed for the overall survival and other parameters in the atezolizumab trial in the lung cancer, and again there was a good concordance among the various SMS-based overall survival outcome. So SP263 assay for the newly initiated lung cancer trials, I think is being talked about maximum. And it is probably the assay of choice for lung cancer and for maximum number of the solid tumors also to best harmonize the testing landscape. And important thing is that when the AI, artificial intelligence based and the pathologist based TPS calculation was done in NSCLC on the Ventana platform, again, there was the high concordance. So probably in the future, we will have the more and more trials of the result based on the SP263. But we need to remember certain characteristics of the tumor-based PDL1. There is the intratumoral heterogeneity, whether we take it from the central part of the specimen, that is the true cut biopsy, core biopsy, versus we do the PDL1 assay based on the whole tissue section, the results may change. Intertumoral heterogeneity again may be there, that is the primary based metastatic, though yes, recommendations are not there, but it is being talked that the PDL1 expression may be higher on the metastatic side. And we should not forget that PDL1 is a dynamic marker. It may change based on the disease progression, based on the surgical treatment after chemotherapy, as well as after the immunotherapy application also. Routine way in NSCLC, we do the decision making based on the PDL1, whether PDL1 is negative or less than 1, it is 1 to 49%, or it is equal or more than 50%. But we should remember that these are not the absolute cutoff values. Probably a PDL1 40 plus will respond in a similar way like 50 plus. So this is the way that the guidelines move, and it's definitely a predictive biomarker as far as the NSCLC is concerned, that how to choose. Previously, 5 years back, we used to talk about the chemotherapy plus minus immunotherapy. Today, based on the PDL1, we talk about the immunotherapy plus minus chemotherapy in advanced NSCLC. So the various cutoff values for PDL1 measurements required in the different scenario are something like 1%, 5%, 10%, 20 or 50%. So higher is the cutoff value for the PDL1, more is the positive correlation. And probably the more is the accurate prediction, but that reduces the sensitivity and probably the few false negative results also. That means we are neglecting few patients who could otherwise benefited from the IO in that particular scenario. And probably the CPS is the one way to answer this question, that what should be the predictive cutoff value or the predictive value. Based on the PDL1, we all know that the various drugs has immune checkpoint inhibitors in the different scenario in MSC has been approved in the adjuvant setup also, neoadjuvant setup also, stage 3 disease also, as well as in the metastatic first line as well as the second line also. If you look at the various pivotal trials, we see that always PDL1 is being used to characterize, to enroll the patient and to do the assessment further. Now, moving from the stage 4, if we talk about the stage 3, we see, yes, 2 trials are there, which we offer about. That is the one adjuvant trial, where the atezolizumab after surgery has been studied with a positive result. And similarly, in the unresectable patients who are treated with the definitive CTRT, followed by the Pacific trial, that is a durvalumab, and again it's a positive trial. So obviously we will move to the early stage also, that is the stage 1 and 2, and there is always rationale for using the immune checkpoint inhibitors in the neoadjuvant setting also, particularly, and the Nivo-based trial with the chemotherapy before surgery in a resectable lung cancer. Yes, it is there with the exciting results also. So what's the future as far as the predictive biomarkers are concerned? The combination of the PDL1 and potential tumor-dependent biomarker is probably the way to improve the predictability, because we all know the immune checkpoint inhibitors, the response rate expected is not more than 40–50%. A positive or negative regulatory relationship in a PDL1 and specific markers is very, very important to understand and to develop. The PDL1 combined with the specific markers may improve the prediction accuracy. And in non-squamous NSCLC, STKI mutation is the one marker which probably gives us the idea that this particular tumor may be the resistant to the PDL1 blockade, probably making it something like the personalized immune checkpoint inhibitor further. And combining novel in vivo technique with the PET spec based to map the spatio-temporal heterogeneity of the PDL1. Liquid assessment of the PDL1 can be used for dynamic change of the PDL1 where the repeat tissue biopsy is not possible, and probably to monitor the response also based on the immune checkpoint inhibitors. Nuclear PD-L1 is another way. What we are doing is basically the membrane staining. So if you do the nuclear PD-L1 assessment, that probably give the poor prognosis and poor response to the immune checkpoint inhibitors. And then another way is the assessment of the PD-1, PD-L1 proximity also. And another approach in providing the personalized immunotherapy. So these are the ways which are coming, that how we can refine the immune checkpoint inhibitors based on the biomarker. So I would like to conclude, yes, PD-L1 is a predictive biomarker, the first line, second line, or later line of the treatment. It is important to consider and meet the standards of the various methods like pre-analytical, analytical, post-analytical requirements to make it PD-L1 ISC as reliable as possible as on today. And in the future studies, sampling more and more larger biopsies, recording the biopsy size, tumor load, probably will give us the more idea that how to use the PD-L1. And the newer methods like AI, immunofluorescent, PET, SPECT, liquid biopsy, and other techniques probably are going to revolutionize the clinical application of the PD-L1 in the near future. And as on today, it should be tested in all patients with the NSCLC, especially the advanced stage of the patient. As on today, it's a companion as well as a complementary predictive marker, depending on what is the stage, what is the line of the treatment, what is the molecule we are going to use, and what scenario of the disease it is. It is probably the best available, but not ideal marker. TMB, as on today, probably in the routine clinical practice is of no use in the NSCLC. Thank you.
Thank you very much for very lucid presentation and clarifying many things. I have one question in my mind, that the patients who will receive atezolizumab, say in the early stages of the disease, in the adjuvant setting, and suppose this patient comes to you in stage 4. So in that situation, what will be your take for immunotherapy? Is there any data, or you also mentioned that PD-L1 is a dynamic marker. So would you like to give some comments on that?
So very difficult to answer, but if adjuvant setup, it is being used, treatment is over, and probably the 1 year period is gained, then probably I will be happy to reuse some chemotherapy or immunotherapy based on the PD-L1 expression that time. But suppose if there is a recurrence within 6 months or so, then probably I will hesitate in the routine clinical practice to use another IO drug. Dr. Purvi, sir, good morning.
Good morning.
Sir, would you like to add some comment on this question?
Let me ask my question to him first.
Oh,
So great presentation. Earlier this month, there was a publication using cell-free DNA to assess tumor mutation burden. And they have shown that serial measurements is a very good marker for response to immuno-oncology. So your thoughts on that?
So TMB has been studied. It had been the part of the guidelines also previously. The present guidelines do not give much importance in the routine clinical practice. And the drugs like IO has talked a lot about the TMB also. And what you are talking about, the cell-free DNA. So cell-free DNA has been used for many markers and many ways to assess the response, as you also know it. But assessing IO-based response assessment and following it based on the TMB, I think in the routine clinical practice, it is not there. And it's so cumbersome also, and probably not the cost-effective also.
Thank you.
Yes, Dr. Batra, good morning and welcome in Jaipur. Lot of these cell-free DNA and other methods which I just mentioned, the last line in that was that it's a too cumbersome and costly affair, not only costly, cumbersome in the routine clinical practice. Thank you, sir.
So I would agree with Dr. Parekh. There are numerous studies which have shown that if you clear the ctDNA earlier, you are going to have a very good PFS and OS. So in the stage 4 disease, not in stage 1, in stage 4 disease, if you at 3 months, you clear a ctDNA earlier, not necessarily TMB, the ctDNA, you are supposed to have an PFS and OS advantage. But the problem in this is going to be, as you said, cumbersome. How many people are going to get the blood testing done and the cost of it? But for the research purpose, yes, it is a very valid tool.
So a big question about this is that it's a predictive.
Yes.
Now, if I ask you the counter question, suppose your patient has a stable disease, has the best response, and TMB has not cleared, or any other response marker has not cleared. Still in the routine clinical practice, we will be continuing the same treatment till unacceptable toxicity or progression of the disease.
Fair enough. So these are being employed if you want to stop immunotherapy at, let's say, 6 months or 1 year. See, right now you in keynote 189 or keynote 42 in the stage 4 disease, you give it for 2 years. Now, if there's a data which says if you clear your ctDNA at 2 years time, at 6 months time, whether it's worth it. Number two, if you're giving a single agent immunotherapy at this thing and you do not clear ctDNA, then whether it's worth adding a chemotherapy to that. So these are the research questions which are coming up for the value of ctDNA. But still in the research, not in the practice.
And that is the reason. And that is the reason that you are one step ahead of all of us. Yes, please.
In lieu of the same discussion, I would add that the accumulation of the long non-coding RNA in the patients, who has cleared the ctDNA, still still represent the therapy resistance. They contribute to the therapy resistance. I'm talking about the end-stage NSCLC patients.
So, Dr. Bhavna's question, in fact, I also want to know about if somebody has received Atijo in adjuvant setting and then relapses, is there any marker or anything other than Dr. Somani has suggested? So can Dr. Ulas or anybody throw some light?
So I didn't get the question, ma'am. The question is if somebody has got adjuvant atezolizumab and then has relapsed.
Yeah.
Biopsy proven.
Biopsy proven, it is now stage 4. So is this patient eligible for immunotherapy or there's some other
So
marker?
typically, ma'am, in the clinical trials that we use, as Dr. Somani very rightly said, if you have 1 year gap between the last atezolizumab and this thing, you can re-challenge with immunotherapy and chemotherapy, depending on the PD-L1 expression at that time. 6 to 12 months is controversial. Less than 6 months, you will just go ahead and give them chemotherapy plus minus VEGF inhibitor.
But even at that time, I will strongly recommend to undergo the NGS
repeat biopsy
to understand that can we get some predictive biomarkers of the resistance to the immune therapy, like STKI, as I said.
Through that.
Yeah, so fresh biopsy is necessary.
A fresh biopsy is always, I will say, mandatory.
Sorry, Bhavna, I forgot to respond to your statement. Yesterday in the panel discussion, I skipped one slide which showed 6 new biomarkers that have the potential to be used in the future. And one of them is the ratio of the infiltrating lymphocytes to the rest of the WBCs. So if you look at clinical trials, yes, there is a potential for that. If you look at real world practice, none of them are ready as yet.
Thank you very much, everybody, to participate so actively. Are there any other questions? Then I think in that case, we thank Dr. Somani and we wind up this session. Yeah, thank you.
Thank you, Dr. Naresh Somani, sir, and team chairperson. For next topic, I would like call Dr. Amit Ratan, sir. He is the HOD of Medical Oncology, Manipal Hospital, Bangalore, and is going to panel discussion on the topic of real life clinical experience in the management of extensive stage small cell lung cancer.
Good morning, everyone. I thank the organizers for giving me this opportunity. So I'd like to invite the panelists. I have Dr. Deepak Shukla, Dr. Preeti Agarwal, Dr. Jitendra, and Dr. Anu Rajpande. Right. So let's get started. This is going to be basically just a quick discussion on small cell carcinoma. If you'll all introduce yourselves very quickly, because you and I.
Sir, I am Dr. Deepak Kumar Shukla.
I'm Jitendra.
I'm Dr. Preeti.
Hello, sir. Hello, everyone. My name is Anu.
Right. So what we do is we've been kind of talking about small cell a lot, and we keep telling there are not much advances happening in small cell. So we'll try and see, have we really moved the ladder up? Have we moved? Are we getting better, or are we still right there? And how do we do better and better for our small cell patients? So just to a quick case, this is a 62-year-old smoker, presence with breathlessness, found to have a lung mass, found to have multiple liver nodules. Biopsy shows small cell lung cancer from the lung, and MRI brain is normal. So you have an extensive stage small cell. So let me start off. Dr. Anu, when you see such a patient in the clinic, what are your thoughts on this patient's prognosis, survival? How do you talk to them?
So first of all, I'll see or assess the performance status and the financial status. Based on that, I'll offer chemotherapy plus immunotherapy.
And in terms of prognosis, what are you thinking in your minds in terms of survival, and how do you talk to them about the median survivals?
Okay, so I explain like this. We have comparatively shorter overall survival, but the current treatment in form of chemotherapy plus immunotherapy, the disease response. So at least we can offer symptom relief, and we can improve the quality of patient. So I'll motivate for the chemotherapy plus minus immuno. Yeah.
And small cell has always been an issue for us when we treat patients. We know even with extensive stage, they will respond, and they will do a dramatic response even to chemo, and we get very excited about it. And then eventually they progress very rapidly, and we know the survivals have always been on the short, or medians have never been great. So now we are moving forward, and we are starting to talk about more than chemo. So Dr. Preeti, how are you thinking about your first line treatment? Finance apart, patients can afford all the treatments nowadays. What do you think about this?
So the first line treatment remains chemoimmunotherapy. So although the response rates are similar, but seeing the 2-year OS being 22% is nothing. It's not that we have seen previously. Like overall, patients surviving for 2 years in extensive stage small cell lung cancer, 22% is a good number. And this is the new thing that has come up, and probably in last 30 years.
So all your patients, you do talk about small
Yes,
cell
yes,
chemo.
those who are affordable, yes.
Right. I think that's been the sea change now which has happened. We're talking to all our patients about chemo immuno in small cells. Right. Dr. Chitendra, so coming to specifics then, which chemo and which immuno, and how are you talking to your patients about this now?
So actually, this patient has to stop smoking, because that's the main concern what we have usually, because they never quit smoking because they are usually heavy smoker. Second thing, as guidelines suggest that the chemo would be itosis if we can give it, but since they are elderly, usually we have to give carbo, and immuno maybe means, since previously I have used Atejo, started one patient on Durva, but still I am more confident with Atejo. Yes.
So chemo is platinum etoposide and Atezo or durvalumab, both ways you get it. Dr. Deepak, your thoughts on the combinations?
Yes, sir. So cisplatin etoposide or carboplatin etoposide, in my clinical practice, majority of the patients I am using carboplatin etoposide. My goal is, though I discuss with role of immunotherapy, but my first issue is because of cost constraints, sometimes patient may not even take carbo-eto. So first thing is carbo-eto, based on the finances, add an IO. There are some means not very clear-cut difference as to which IO is better, but one of the IO should be added if patient is affording.
Right. So we've seen, let me just put the curves and put it right there. Yeah. So this is what we're talking about. We're talking about chemo, platinum-eto, and we're talking about addition of immuno. It could be Atezo or it could be durvalumab. And we have seen both the data sets from the IM Power 133 and the Cascade data. So Dr. Anu, let's say, what's exciting you about these? Are you happy with this much improvement, or are you unhappy with this, or is this good enough for you?
Well, I'm not extremely happy, but I'm pretty convinced. to use them.
Right. So we're so hopeful that immuno will give us that big extension, and that's what keeps coming to our minds. That immuno works so well in certain group of patients, and you start putting the curves really up. And this is not what's happening in small cell. So again, why is it this? So let's try to get to a little bit thought about small cells. And why do you think? See, these are cancers which are happening in smokers. These are the ideal immunoresponders. You would think of they're smokers. They would have high, very tumor mutational burden. So what are your thoughts? Why do you think small cell is giving us response, but not that great as in other cancers? Any thoughts on this, Dr. Preeti? No, anyone can take this. It's just a contemplation. We don't have a clear answer, so that's why there's a lot of contemplation on this. What do you think?
So since the Tajo trial did try to convince a TMB in that case, but as we know, smoker will have more mutagenicity. But probably what I personally think, or what is there, that these tumors are very aggressive, number one. Second thing, they are very hard to treat because they try to invade the bone marrow very early. So they are very, means those patients deteriorate very fast. Even within 3 months, they will have a very poor PS. So we will not be able to give second line chemo at all. So probably that's why they are very aggressive, and probably the WBC cannot catch those antigen. This is probably what I can say.
So you're right in some ways. There's no clear answer, and no one has the answer to this. That why do small cells, though they are the smoker population, the high DMB population, the ideal ones which should respond to immuno, but the responses are never long lasting. So the thought is this, that it's not that you don't have, you have a lot of mutations, but it's really highly proliferative as mentioned. And the immune environment is very immunosuppressive. And that's what's creating the issue there. You don't get T cells into it. And that's probably a reason is because they are multiplying so rapidly. So now, recently, if you look at it, MD Anderson got out a new kind of a classification for future small cells, and they looked at the transcriptome analysis, and they said there are 4 groups of small cells which will come out. And the analysis said that there is one group which is called an immune group for small cells. And that is the group which will respond very well, and other groups are not responding very well. There's also a very interesting paper just come out a few months back, which looked at metabolomics. And it said that in small cells, because of the rate you are multiplying, you're using up the way the utilization of the metabolomics should have happened, is that your T cells are just not coming into it. And that's very unique about small cell, and which is something we have not seen in other cancers. So for us, that's been a disappointment, but I'm sure as we start analyzing small cells much more into these finer categories, understanding how metabolomics is going to get into the picture, we'll probably get better understanding of which patients would respond or not. But till then, this is what we have. And I think Dr. Preeti mentioned this. What excites you about this? We see what not excites us, but what excites us is the 2-year OS curves. Clearly, we have seen this 2 years. If you see the Caspian data, now you have 3 years data. You're talking of 17% patients, 3 times higher patients having an overall survival at 3 years. And this is something we had not seen in the previous era. So clearly, there is a small population who's doing very well, but unfortunately, we are not able to identify.
By the biomarker for identifying those population, that
Right.
population.
So the question of biomarkers, would you test any of your small cells for TMB or PDL1?
So PDL1 or TMB has not correlated with the outcomes. So no, as of now.
No, as of now. Dr. Deepak, would you ever think?
Agree, sir. So I'm not using TNB or PDL1.
Any idea if you did PDL1 in small cells, what would happen? What would come out?
Very high.
High TMB and PDL1 both are high.
So that's what's surprising. In small cells, TMB will turn out very high, but PDL1 is actually coming to hardly any positivity. So that's again the nature of small cells. You don't have PDL1 positivity. You don't get T cells infiltrating into the tumor, again because of the high multiplication rate. So PDL1 usually will come out negative in most small cell cancers. But TMB, yes, it will come out high. Now, we've seen the data analysis of TMB, and this has again been a very major disappointment. You've seen TMB high at 10 and 10 at 16, both were looked at from the ATEZO data from the IM power. And what we eventually saw was even patients who had high or low, they may respond or they may not respond. So again, TMB has no role to play in small cell carcinomas. And similarly to that, PD-L1 also has no role, as already mentioned. So moving to the differences between using Atezo and durvalumab, do you, Deepak, do you have any thoughts about the slight differences in the trial, in
Yes.
Caspian and in the IMPower 133? Do you think in clinical practice it has relevance, or any of these things you use?
I think in clinical practice, mostly the finances is the top concern. But looking into the trial data in the atezolizumab trial, brain mets patients were only 10% that were included. There was no means PCI was received only in limited number of patients, and majority of the patients received 4 cycles. And the backbone chemotherapy was carboplatin etoposide. While in Caspian, it was more patients with brain mets were enrolled. 6 cycles of chemotherapy was given. Also, nearly 20% of the patients received cisplatin etoposide as compared to none in the Atezo trial.
So Caspian was more of a kind of a real world population where you do use a lot of carbo or cis, depending on your patient's suitability. And you do sometimes end up giving 6 cycles, and even brain mets were taken up. So a little bit more wider expanding population. But if you look at the curves are really similar. But these are the differences between the two clinical trials when you look at the IMPower or the Caspian data sets. So this patient ends up getting Platin-Eto and gets Durva and gets a good response, and a very good response. So moving on, if such a patient comes to you and you get a very good response, Dr. Anu, what are your thoughts on PCI? Do you do PCI in extensive stage settings? How do you look at it in small cells?
Okay, so here we have near CR. So 2 things we can do. Either we can offer PCI or we can put him on surveillance every 3 monthly MRI. So many trials have shown in Japanese trial that it has not showing OS benefit. So I think we can put in surveillance.
Correctly, in your small cells who do well in extensive stage, with or without whatever it is, do you give PCI or no?
Yes, I give, because most of the time we are not using immunotherapy, and if patient is showing response, then I send for PCI because it's hard to keep them under surveillance.
Okay. Yeah, I think fair enough. We've got data sets from both sides. Earlier, we moved to an era of not giving. Then we had that data from the European study which said no, giving has some benefit, and people started giving it. And then the Japanese study came that said that no, maybe it's better not to give PCI. Probably it's better to do surveillance as long as you're doing close surveillance. Extensive stage, I am not using too much PCI. I am also prefer the surveillance group. I really worry about whole brain radiation effects, and it's really, I don't think there's any advantage to it, if that's my personal opinion. And especially with the immuno era, whether that's going to make a change is something all of us will have to wait and see. What about thoracic radiation? If you end up with getting a good response, a small mass left behind, no other disease anywhere, what are your thoughts on thoracic radiation?
So only lung disease, some small lung disease is remaining behind, then yes, thoracic RT. And it is in complete CR, then no.
Right. Dr. Jitendra, do you use radiation as a consolidation
Sir,
stage?
if the extensive stage is only in the lung and some supraclavicular lymph node in the opposite side, then probably a remaining tissue can give you an PFS advantage if it is in the liver, everywhere else. Although achieved a good CR in liver, but still I will not give those patients. But only in lung, primary disease remaining, then probably we can think of for a PFS, not at all for the tumors.
I would fully agree. It's like it's never been clearly proven, but it's clearly known that if patients end up with a very good response, have a little bit of local burden in the chest, we end up giving PCI, and we used to do this even with in the non-immunotherapy era. The whole thought is possibly when you add you're going to have some more difference in regulation of T cells, and there's a thought that maybe there's an additional advantage, but again, it has not been proven. So we really don't have a prospective answer. But again, the guidelines put it there that you could select and choose your patient well and consider radiation to the chest if you think it's in selected patients, it should be fair enough to do if you have got a very good response. Brain mets, Deepak, symptomatic versus asymptomatic. So everywhere earlier we should talk of treat the brain mets first and then start treatment. With the immuno era, is it changing your thoughts in small cell?
So sir, again, how it depends on the visceral disease burden. So if the visceral disease is more and the patient is having asymptomatic brain mets, I'll err towards giving chemo with IO. And possibly if a patient is having symptomatic brain mets and limited visceral disease, possibly I'll go with PCI, not PCI, Wolbrin RT, and then go to the systemic treatment.
I fully agreed. I think symptomatic brain mets we would probably treat and go ahead with the systemic treatment then. But asymptomatic nowadays we're okay with just withholding radiation, starting off our systemic therapy, seeing how the chemo works, and then adding in. But again, these are individual decision making depending on the patient situation. I think we have seen this data from the Caspian study with durvalumab, because this had patients with brain mets and treated brain mets, and this clearly showed that the benefit is even there in patients with brain mets. So using IO plus chemo in this group of population is perfectly fine to do. I would like to kind of take this to one step more. Is nowadays we do this. We do treating chemo immuno is what we're talking to all our patients, and we have started doing it. But we know there are going to be patients who progress, and there's always that question comes when the patients ask you, you've done the best of things and you've put in a huge expenditure and you progress in a few months, what do you do next? So Dr. Anu, what are you thinking next for your patients in this group of?
So after progression on chemo immuno.
So patients who got chemo immuno progress, what do you talk to them about in treatment?
Okay, so again, we have to check the performance status, whether he's able to take next therapy or not. And we have an option of chemotherapy only.
So chemo, and what chemo do you offer?
Either irinotecan or taxane.
So irinotecan is a regime which most of us used to use, and taxane, and yes, that's another regime which does work for patients. If a patient is not exposed to IO first, by any chance, do you get tempted to use IO in second line settings or later lines? Yes.
So again, the difference when the patient relapses. So now recent guidelines recommend that a patient is relapsing after 3 months, then we can re-challenge with platin etoposide. Previously, the interval was 6 months. And if they are relapsing before that, I think some other chemotherapy as discussed should be used. Definitely, if immunotherapy is not used in the first line, then there is data for single agent immunotherapy in the second line. I'm not aware of any good data with combination chemotherapy, but again, in the relapse setting, it is always, though in the absence of data, to use it in combination with chemotherapy, if possible.
Yeah. So I fully agree with when you use platin eto and immuno and you give it and then you continued immuno maintenance, and after a few months you relapse, adding platin eto or adding chemo in various forms, that's definitely the way forward. And we do see responders in certain group of patients. But small cell is a very unforgiving disease, not an easy disease to treat. And what's been seen is even the second line data is really poor with immuno. Even data sets which you saw with single agent immuno, you saw data sets with combination of PP-Nivo, not really very great responses. And that's the reason why you keep thinking, if you need to offer immuno, you better do it upfront. And that's the reason we try to keep counseling our patients, pushing them to upfront immunochemo, hoping that they are in that small segment of patients who respond to treatment. The unfortunate situation is there's really not much you can really offer your patients when they progress. As mentioned, irinotecan, topotecan, paclitaxel weekly. These are things we do in practice. There's a lot of talk internationally of using the drug called lurbinectedin. There's a lot of, it's a new drug and it has all data coming out from small cells. But the phase 2 of lurbinectedin was very exciting. And in the US, they always talk about lurbinectedin as second line therapy. But we have recently seen one phase 3 of lurbinectedin being a negative study. So again, may not be one of the promising options is what we think for. I think the most exciting thing in small cell, we have set the bar, at least we have set the base now. It's chemo immuno is our base, and that's where we are going to start with for most of our patients who can afford treatment. I think I think I'll finish my excitement and then I'll ask you the question. Yes, I think the most exciting thing I am finding is the role of a bite in small cell lung cancer. And it's amazing to see that. We have seen so many bites in non-Hodgkin's lymphoma. The NHL space is is now flooding with bites. Unfortunately, in India, we are so far back that it's going to take time for it to come. But the way the bites are moving up in NHL, it's very exciting to see bites in solid tumors. And so we already have bites which you're using. You have chemotherapy in melanoma, ocular melanomas. You have a bite which is showing amazing responses. You have a bite now for small cell lung cancer, and it's a bite for two. It's a bite against the DLL and CD3. So we had a monoclonal antibody for DLL, if you remember, just a couple of years back. Everyone was very excited about it, but that failed. The trial data failed, though there were some responses. And then now you've come up with a bite which binds DLL on small cell and T cell, and that's killing the small cells. They had a population of, it's a small data set, but they had patients who had 4 lines of therapy, getting a response of about 35% and getting OS there. You never see these patients survive. So a lot of thought is, yes, the immune system is important, and there are different ways we will have to capitalize on it. Yes, Dr. Sudhir.
Yeah, thank you, sir, for a very enlightening session. I wanted to have a comment on the thoracic RT. So I had a patient of extensive disease who was on etazolizumab and cisplatin, carboplatin etoposide. Post 4 cycles, had only a small residual in the lung, basically in the mediastinal region. And then he got, because we got radiation opinion, brain RT was given, and also the radiation oncologist was asking that there is an evidence for thoracic RT in that situation, so we should give. That was not much there, so we proceeded with that. Unfortunately, in a month's time, he developed a severe pneumonitis, and we had to stop the treatment, and he went for best supportive care. So I think we should be very wary of when we are planning thoracic RT after immunotherapy and chemotherapy. That might actually be counterproductive. And second thing I wanted to ask in regarding to brain mets, suppose there are symptomatic brain mets, how do you sequence? Should we start with whole brain RT first and then start chemoimmuno, or whether adding a chemoimmuno first, will it have some sort of radio sensitizing benefit in brain metastasis? What is our...
So I would say for a symptomatic brain mets, there is role of starting radiation first. I don't think we are doing a sort of a synergism or anything like that. It's just that you're symptomatic there, so you want to start treatment first. But if your patient, as Dr. Deepak mentioned, has a huge visceral burden and fast progressing disease, we sometimes even start off systemic therapy. So there's a lot of data now about SRT in small cells. And if you're doing SRT, you don't really need to wait. You really don't need to wait the full complete treatment. You can just take the SRT and start off immediately. So that's what we are doing for our patients where we're using SRT. But yes, if you're talking of the whole treatment, we go by the amount of disease and the burden, which is more symptomatic. I think it's an individual decision. Right?
So does etazolizumab have a, does it cross blood-brain barriers?
So this question is for all immunotherapy drugs. You believe they are all monoclonal antibodies, they are all heavy molecules. They really don't cross blood-brain barrier per se. But you are seeing responses to even with brain mets. You're seeing that there. So
yes.
There's some way by which your immune system is affecting, your T cells are getting there, and that's what's causing the effect. So I think there is clear-cut responses we have seen with with brain mets in various malignancies, even in certain situations when we have not used radiation and watched that.
Yes.
And that's why in this present era, we get more and more ambitious. Can we hold the radiation? Can we hold the radiation toxicity? But yes, I think SRT has been a real a tool which has helped reduce toxicity for our patients.
Yes, thank you, sir.
Your comment on radiation and causing more pneumonitis. I think from the Pacific for non-small cells, we learned that really it's not really a major issue. But yes, your one-off patient can have that, and that may not be a major worry. It could be the location, it could be the timing, it could be the patient.
So is it that in a Pacific post-CTRT, we are adding immunotherapy? The reactions are less. Maybe it's the fractionation, because in thoracic RT, typically they give 30 grade 10 fractions or so. Maybe hypofractionation has caused, or is it a one in a case? I don't know. But really, I think we should be
right. I agree with you. I don't know. So do we have early analysis from Pacific too when they're doing it concurrent? Is there data of the toxicity part with the concurrent part? Not high.
Around 8 to 9% with the it's not very high.
Yeah, so I think that's worry is a little lesser.
Yes, and I would agree. I think the issue which has happened is that maybe the fractionation thing which you told, when you give 30 grade infection as in the Gomez protocol, That's where you can get more pneumonitis along with the immunotherapy. But if you give a conventional one, I don't think it will cause.
Agree. Yes. So I think we finished this fast. So quickly, let's summarize. I think everyone agrees on this. Immuno-chemo is the way forward for small cells, and if you have to put the immuno, let's do it first line. I don't think we should really wait for any later lines. There may not be a later line in small cell. That's the nature of the disease. We have data of Etizo, we have data of Durva. Durva has a little longer data. You have the 3 years data, and that's the most exciting for us. Seeing patients, 17% patients survive at 3 years. This is not something we had seen in our previous small cell era patients with chemotherapy. And toxicity has not been a major concern. IRAs we know about, and we all know how to manage IRAs. And I think safety has never been a major issue in small cell carcinomas when we talk about addition of immuno with chemo. I think financially what all of us worry about more, and that's the reality of our Indian situation. But there is definitely a segment of patients who are surviving better, good quality of life, and improved survival. Thank you very much. I thank everyone. Any other comments from anyone?
No, sir. Thank you.
Right. Thank you. Thank you very much.
Thank you so much, Dr. Amit sir and esteemed panelists. For next talk, I would like to call Dr. Lalit Mohan Sharma sir. He is the senior consultant in Department of Medical here only. The topic of discussion is the redefining in the management of NSCLC with Etizo.
So warm welcome and very good morning to all of you. Can I have my slides on the screen, please? So today's topic is about the redefining the management of non-small cell lung carcinoma, and especially focused on atezolizumab. What is understanding and what will be the next step? Slides are not moving, so can the technical team help me? Yeah, I think it's okay. So this symposium is sponsored by Roche, and the slide set has been given by Roche. We all know about Etizo, that its approval has been in non-small cell lung carcinoma. And if we see to begin with around 8 years back, the approval was in the second line metastatic non-small cell lung carcinoma. And in the OX studies, this was compared with the chemotherapy and was found that chemotherapy compared to Etizo works better. Then the approvals came as first line in metastatic non-small cell lung carcinoma, IM power 150. It was proven that the first line addition of Etizo is much better. And then further improvement about the working, it was IM power 130 and then IM power 110. And recently I'll be focusing mainly on the 010 IM power trial, which is on the early stage non-small cell lung carcinoma. So this is about the Etizo. First line, we have seen 3 major studies, 110, 130, 150. So in this, we can see that it was compared with the chemotherapy versus Etizo arm. Here it was chemotherapy plus Etizo versus carbonepacli. And in the IM power 150, Bev was also one partner. So I'll be focusing mainly on the 2. So the first one is IM power 110, which was for squamous and non-squamous carcinoma. And here we see that the stratification was chemotherapy naive patient, PD-L1 positive, and the actionable mutations negative. And based on the PD-L1 IHC expression, the randomization 1:1 was done. Etizo was given 1,200 milligram every 3 weekly till progression or loss of clinical response or benefit. In another arm, it was chemotherapy, which was platinum, along with pemetrexed or gemcitabine based on the histology as mentioned. And in the maintenance arm, non-squamous carcinoma, pemetrexed was given, while in the squamous cell carcinoma, further treatment was not given and they were observed till progressive disease. The primary endpoint was overall survival in the non-mutated patient, and these were the secondary objectives of PFS, overall response rate and duration of response. So if we see the patients who received Atijo in this arm, the blue curve denotes Atijo. So we can see the median OS is improved by 7 months. So we can see as compared to the chemo arm, there was 7 months benefit, and the median OS in the Atijo arm was 20 months as compared to around 13 months in the chemotherapy alone arm. And we can see at 12 months also 64.9% versus the 50.6%. So it was showing benefit in patients who had high PD-L1 expression. The benefit was across all the groups, including all the age groups. We can see male, female, and the tobacco users, and the histology also that it worked in both the histology. Of course, the better benefit was seen where the PD-L1 expression was higher. And this again denotes that in patients with PD-L1 expression higher, the response rate with Atijo was better as compared to chemo alone arm. And these were various methods by which the PD-L1 testing was done. And we can see that clearly in all the subsets with different methods of doing PD-L1, the median overall survival was close to 20 months in all the subset versus the low OS, and the hazard ratio was around 0.6 in all the subsets. In the non-small cell lung carcinoma NCCN guidelines, we see that the addition of Atijo has been there, especially in patients who have PD-L1 positive and patients who is negative for the X-enable mutations. So based on this, the Atijo was approved. And the summary of this IM Power 110 study was that Atijo represents a promising first-line treatment option in patients who has high PD-L1. IM Power is positive study which suggested meaningful improvement in the OS in patients with high PD-L1 expression. It was safe to use and no new or unexpected safety signals were identified. Immune-mediated adverse events were generally low, and Atijo had a favorable safety profile, and patients treated with Atijo has a longer treatment exposure than patients treated with chemotherapy alone. So this was one in the metastatic setting. And now the exciting part, we see that Atijo in the early stage non-small cell lung carcinoma. Of course, in our clinical practice, we see less commonly patients who are having early stage, but this particular study that focused on early stage non-small cell lung carcinoma. So the IM Power 010, Atijo versus best supportive care after completion of adjuvant chemotherapy in patients who are up to stage 1 to stage 3, and these patients have undergone an R0 resection. So this is the schema. This is phase 3 multicentric trial conducted in almost 222 sites with more than 20 countries. It was open label randomized study, and the inclusion was stage 1B to 3A non-small cell lung carcinoma. And of course, the stage 1B, they are saying equal to or more. This was the surgical intervention, either lobectomy or pneumonectomy, depending on the surgical decision was done. And the tumor tissue was positive for PD-L1. So we see that after completion of this R0 resection, patients were subjected for 1 to 4 cycles of platinum, and along with that, either gemcitabine or the pemetrexed or docetaxel or vinorelbine. So after completion of the adjuvant chemotherapy up to 4 cycles, these patients were randomized in 1:1 fashion. Atijo was given for up to 16 cycles, so almost 1 year. And the other arm was best supportive care, and more than 1,000 patients were enrolled at randomization, and these patients were followed up till survival. If we see the stratification factors, histology was considered, stage was considered, PD-L1 expression was considered, and the primary endpoints was the investigator-associated disease-free survival. So this was important. and the PDL1 expression of more than 1% and all randomized stage 2 to 3A population, and then ITT. So I'll be coming briefly in the next slide about this. The secondary objectives, secondary endpoints were overall survival. This was the statistical analysis plan. DFS was seen in patients who had PDL1 equal to or more than 1% by this particular method in stage 2 or 3A. Another was disease-free survival in the overall group, and then it was in the intent to treat population, and finally the overall survival was calculated. This is a busy slide, but if we see stage 1 patient, they were close to 12%. If we see stage 2 patient, that was close to 40%, and around 40% patients one in stage 3. And if we see PDL1 proportion, the TC was more than 1% in almost 54% of these patients. 11.6% patients were having EGFR mutation, and 3 patients were having 33 patients, they were having some ALK positive. If you see the primary disease-free survival endpoint was tested in the PDL1, this was in more than 1%. So this was tested, and we see that the IM power 010 matrix primary endpoint of improvement in the disease-free survival versus best supportive care in patients with PDL1 more than 1%, and this was for stage 2 to stage 3A, which was close to 75% plus patients. So this was amongst that group, and we see the median disease-free survival in the ATIJO. We see at 24 months, it was 74% versus 61% in the observation arm. And if we see at 3 years, it was 60% versus 48%. And if we see the hazard ratio, it is 0.66, denoting that there is 34% reduction in the risk of disease recurrence or death in patient who received the ATIJO versus the best supportive care. And this benefit is in addition to the previously established benefit, which is chemotherapy, adjuvant chemotherapy. So this is exciting data about this study. DFS benefit was consistently observed across the key subgroups of the PDL1, where the score was more than 1%. And we see that all patients having score of more than 1%, they benefited. Other than one subset, I can see that the tobacco current users, they were not that benefited. And here, if we see the other points, that depending on the mutation burden, the patients having high PDL1 score, they were doing better. And in all stage, like stage 2, stage 3, all patients, they were doing better with the ATIJO arm. So about the second analysis, DFS in all randomized stage 2, stage 3 population, the IM power 010 matrix primary endpoint of improvement in disease-free survival in all randomized stage 2 and stage 3 population. And here we see at 3 years, it is 55% versus 49%. And there was a statistically significant difference of 21%. So the hazard ratio is 0.79. It means 1 out of every 5 patients will be benefited with the ATIJO at 3 years. So that is also good improvement. About the PDL1 status, if we see the PDL1 higher, they were doing better as compared to the PDL1 low. Here we see the same thing, that the PDL1 score, the higher score group was doing better as compared to patients who are having low score, and patients with 1% were also benefited. If we see the third subset, there was the DFS in the intent to treat population in stage 1B to 3A, and we see there was the significant boundary was not crossed at this interim DFS analysis, and the final DFS analysis was expected in 2022. However, if we see the DFS in the intent to treat population, at 3 years, the difference was 57% versus 42%. Until the publication of this report, it was 32.2 months follow-up. And patients with stage 1B non-small cell lung carcinoma typically relapse later. This, we all anticipate that early stage patients will be doing better. And this may explain the DFS did not cross the significant boundaries. Overview of this plant OS analysis. There were 5 formal OS analysis planned in the intent to treat population. And we can see the results in next few charts that patients who are having PD-L1 of more than 1%, they were doing better. And we see at 36 months, 82% of this is overall survival. So 82% in the Atezo versus 78%. And if we see at 5 years, that was 60 months, 76% versus 67%. So the median OS also was better in patients who received Atezo as compared to patients who were on the observation alone arm. About if we see the overall survival interim analysis, this has not yet been reached. The median OS in both the groups has not been reached. Based on the score that whether more than 50%, less than 50%, we know that higher PD-L1 score group was doing better in the both arms, whether the mutation was positive or whether the mutation was absent. In both the arms, it was doing better as compared to the best supportive care arm. If we see the median treatment duration with the Atezo, it was 10.4. The dose intensity was maintained in almost all patients. Number of cycles received was highest 16, and if we see patients who received 16 or equal was almost 2/3 of the patients, they received the planned doses, while almost 10% patient received between 8 to 16 cycles, and 25% patient received less than 8 cycles. If we see the safety analysis, overall the drug was found to be safe, and there was no significant treatment-related significant effect. And there was common of the AEs related to the immuno-oncology drugs. So the conclusion of this IM Power 010 that this is the first phase 3 study of atezolizumab cancer immunotherapy to demonstrate the disease-free survival improvement in the adjuvant setting in early stage non-small cell lung carcinoma after giving the platinum-based chemotherapy as per the available clinical practice and guideline. Adjuvant Atezo following complete resection and adjuvant chemotherapy showed significant improvement in the DFS in patients who had higher equal to or more than 1% of the PD-L1 stage 2 and all randomized stage 2 to 3A. Every subset was benefited. DFS in the ITT population, including patient with stage 1B disease, which is earliest disease with very good prognosis, did not cross the significant boundary at time of this interim DFS analysis. An OS trend in favor of Atezo was seen in patients with PD-L1 equal to or more than 1% in stage 2 or 3A population. And we can see the hazard ratio of 0.71 at the time of the first pre-specified OS analysis. The safety profile of Atezo was consistent with prior experience and across all the indications and lines of therapy. If we see the latest version of the NCCN guidelines, it suggests that in patients with stage 2A, where we have achieved R0 resection, chemotherapy for high-risk patients, followed by the Atezo. If we see patients 2B and patients 2B, that becomes margin negative patients, R0 resection, it mentions category 1 evidence about chemotherapy and Atezo combination. And in stage 3A, 3B, after R0 resection, we see the Atezo has been included. So based on this, it looks that Atezo in early stage non-small cell lung carcinoma is beneficial. Of course, the PD-L1 score should be positive. So with this, I thank all the participants for patient hearing. I thank Roche for supporting this activity. Thank you so much. Over to Dr. Satyajit.
Thank you, Lalit sir, for a nice talk. With this all moving forward with next panel discussion, I would like to call Dr. Ullas Patel sir. He is the co-director of Department of Medical Oncology and the Chief of Thoracic Oncology, RGCARC, New Delhi.
Good morning, everyone, and thank you organizers for calling me here and trying to infuse some life into a Saturday morning, a good Saturday morning here. And can I please invite my panelists, Dr. Bhavna Parekh, Dr. Anu Rajpurohit from Jaipur, Dr. Sujit, Dr. Asim Samar, Dr. Neha Sethi, Dr. Atul Sharma, Dr. Mansi Shah, and Dr. Amit Rautan, please, if he can also come onto the stage. And for Dr. Somani, who is looking at me with expectant eyes, I will throw some questions at you, sir. I mean, but I think there was only this much space over here, and I didn't realize you were sitting over there. I would have called you earlier. Okay. Amit is there, okay? Okay. So I think we have a plethora of a galaxy of medical oncologists here. And how many pathologists? We have only one pathologist. I guess. No, yeah, one. Okay, fantastic. Great. So let's start the crosstalk between immunotherapy, target therapy, and chemotherapy in non-small cell lung cancer. And okay. My first reactions when I first saw this topic about chemotherapy, immunotherapy, and target therapy in lung cancer, my first reaction, and probably a patient's reaction about when they hear about a immunotherapy or a target therapy in oncology, is like a game of chess. It's absolutely right. You go one place here and you go one place there, and both you, that is the oncologist, and the patient and the disease, will have equal chances, right? But unfortunately, my subsequent reaction, Amit, can you please come on the stage, please? And I hope we have a place for him. Yeah, I think we have a place here. Okay. My subsequent reactions about target therapy and immunotherapy in oncology, that unfortunately, this is not a fair game of chess that we are playing. The cancer has unfortunately got more steps than what we actually have. And cancer life, is like chess, and you don't want to move. You don't want to waste a move. And the cancer has got more moves than what you actually think it is there. So let me start off with saying, let me say Dr. Hemant Malhotra is there, or Dr. Jyoti Bajpayee is there, or nobody is there. Okay, fine. Let me start with Sujit. So what exactly do you think are we going to discuss right now? Crosstalk? Because I spoke to 10 other different people about the crosstalk hoti kya hai yahan pe. I mean, what are we supposed to discuss in this?
You are very right, sir. I also had to check it in the resources, what is crosstalk. So what I understand is how can we combine them in treating the patients? Is there a way that we can combine immunotherapy, targeted therapy for the same patient in treating, whether there is an interaction, positive interaction for the benefit of the patient? That would be my thought process about crosstalk.
You will look at the positive interaction between how can you combine them.
Positive, negative. So that
when in doubt, talk to a pathologist. So let me talk to Dr. Neha Sethi, madam. What do you think are we going to discuss in the next 25-30 minutes? Because I'm not sure actually what are we going to discuss. I mean that's what okay.
I think you will discuss your clinical aspect and your therapeutic aspect, prognostic, everything.
To a lot of people, because that's not what I prepared my slides for actually. Okay.
And
let me go to Dr.
very less about pathology, I think.
Very less about pathology. That's absolutely right. Dr. Mansi, what do we think are we going to discuss? I have made 40 slides, yaar. I mean, kuch to banaya hoga na.
Just like you said, the positive interactions about and the safety profile, how can we avoid?
I think I'm going to disappoint all of you. Okay, Dr. Bhavna, what do you think we should discuss?
We are discussing crosstalk between different mechanisms of action or the pathways, because now we have realized that hitting only the tumor doesn't help us. We need to concentrate on microenvironment. And when we are following all these pathways, and if they're helping each other to produce better results, I think that will be a positive crosstalk.
Okay. I think I should now go and disappear for the next 15 minutes because that is exactly not what I have prepared. Amit, you have just been called over here. What do you think are we going to discuss?
So I have that advantage. I'm impromptu, so I don't have to really think.
That's what. Because I asked a lot of people, what should I discuss? I mean, everybody gave me all these ideas like this. And I said, okay, fine, what you're saying is right. How do you have a panel discussion on tumor microenvironment, madam? I mean, nobody knows.
No, I think what we should talk about is
each molecular subtype, each targeted subtype, and whether immuno works in that and doesn't work, why and how?
Finally, I have got somebody with what I have prepared today. So we will go with Amit Rautan and we will see what exactly we go.
I think he saw your presentation.
No, he did. I just made it today morning, ma'am. I have just made it 15 minutes back. I'm infamous for that. So I don't think he would have seen it. Okay. So in electronics, actually, crosstalk is any phenomenon by which a signal transmitted on one circuit or channel of a transmission, it creates an undesired effect in another circuit. So basically, what I'm going to discuss is your interplay between NGS and PDL1 and other things. I mean, as what almost all of you said, but it's not really going to be a positive subtype. I'm going to focus on what we may not actually do. Everybody said what you can do, but what we should not really do. So I have three things to be doing for this panel. One is crosstalk between immunotherapy and target therapy based on the NGS reports. You know, everybody says NGS, NGS, NGS. Like Dr. Somani very rightly said, the patient got stable disease here, and now the patient has got a ctDNA positive. What will you do? So, you know, I mean, to me, that crosstalk is an unnecessary interference in our hospital settings. You are treating a patient, your administration comes and says, "Nahi, aise nahi karna." That is a crosstalk. You know, the unnecessary relatives who come over there is a crosstalk, who are not allowing you, to do your work very properly. The second will be obviously a crosstalk between immunotherapy and chemotherapy. And third will be crosstalk between chemotherapy and TKIs. I mean, that is what I thought because the slides were actually a bit less. So let's start with the case, and I will start with Dr. Anu Rajpurohit. This will go to you. A stage 55-year-old male, no comorbids, ex-smoker, and diagnosed as stage 4 non-small cell lung cancer, pleural effusion, skeletal mets. For all practical purposes, everybody's PS1. Because I was PS3 or 4 when these slides were made yesterday night. So every patient is PS1. They are not, MRI brain was normal, biopsy done adenocarcinoma, TTF1 positive, P40 negative, and PDL1 is 90%. So your choice of treatment, this is an immunotherapy oncology association seminar. So how would you go ahead? Would you want to go ahead with a single agent immunotherapy, a KN24 IM power 110? Or a immuno-chemo combination, or still a lot of people, 97% of us will actually give chemotherapy, or a checkmate, I didn't see BMS presence, but that's what, or any other thing that you will do.
Okay, so I would like to know about the skeletal mets. There are multiple, patient is symptomatic because of skeletal mets.
Patient is PS1 month, no radiation therapy.
Okay.
We are medical oncologists right now, so no radiation therapy right
Okay.
now. Radiation therapy ka rule is only consolidation right now as far as we are concerned in lung cancer. Okay.
Okay, I'll go with immuno plus chemo.
You will go with immuno plus chemo. Fantastic. Anybody else? Anybody, Dr. Hasim?
Yeah. So there are two options. We can go single agent immunotherapy like pembrolizumab in KN24, but the best result was achieved with the chemo immunotherapy combination.
Sujit
as far as PFS and OS.
Sujit found out something.
No, I purposefully you have removed the NGS report.
Yes, I have purposely removed that.
There is no NGS report regarding what is the status of EGFR. And
I have purposely removed that because that is what I do with all my classes over there. I purposely removed the NGS report and I purposely, I was watching this mentalist thing yesterday.
Yeah, so it was like implied like that there should be negative and we are discussing the immunotherapy and all that.
I gave you ideas towards the immunotherapy conference. I purposely removed this because this is very, very important and this is not something that I don't see. We get to see a lot of patients, PDL1 90%, NGS, EGFR, AL cross not done. So, I mean, we are so engrossed into that we sometimes miss that. And unfortunately, this patient's EGFR came as mutant. So now, Sujit, we'll go to you. EGFR mutant, a DEL19, your choice of treatment now.
Again, as we discussed, we are going with the scientific aspects. Osimertinib would be the first choice.
So some EGFR TKI. I mean,
Yeah.
osimertinib or something exactly will be there. Fantastic. So that as I knew you will give the Sahi Jawab over there. That's absolutely fine. What I would like to ask from you, Dr. Bhavna, is why not immunotherapy? What is the crosstalk? I mean, what happens when it works in everyone else? Then what happens with EGFR mutant non-small cell lung cancer that immunotherapy we don't even consider over there? And has immunotherapy been tried in this subset of patients? What happens to the crosstalk between EGFR and immunotherapy?
So there are two things. Of course, the results of all the TKIs in this group of patients are very encouraging, and we have very long-term data. So we are all convinced about the data. Secondly, there is definitely a data where the immunotherapy was used in this group of patients. There were some patients in the trial who were EGFR or ALK positive, and they found that the results were definitely inferior.
Fantastic.
And that is the reason that we all are convinced that if patient has these driver mutations, then we'll follow that path. And we will not give immunotherapy as
Absolutely bang on, ma'am. And I think you also saw my slides because this is exactly what I have kept over here. So it is not that immunotherapy has not been tried and tested in a patient of stage 4 EGFR mutant non-small cell lung cancer. They have been tried. But if you look at this, the overall response rates with osimertinib are 78%, with gefitinib are 71%. And the overall response rate with a single agent immunotherapy, whether it is pembrolizumab or durvalumab or anything, is exactly 4%, 10%, 11%. So that is one thing which is very, very important. The median PFS, 10.8 months with IRESA, with the gefitinib, 19.4 months with the, osimertinib. The median PFS is 2 months, 4 months associated with in patients with who have got a single agent immunotherapy. Single agent immunotherapy does not work in EGFR mutant non-small cell lung cancer. Why? Normally, EGFR mutant non-small cell lung cancer have got a low TMB, low PDL1 expression, and a limited T cell infiltration. Typically, what I would say is immunotherapy in a EGFR mutant non-small cell lung cancer or a EGFR mutant non-small cell lung cancer is like a Delhi ki sardi. It's an immunologically cold environment. It is not a Delhi ki May wali garmi. It's a cold environment. Your immunotherapy won't really act. The only thing about is you stay away. You absolutely stay away about immunotherapy in EGFR mutant non-small cell lung cancer, ma'am.
So in your patient, the PDL1 was 90%, and he had EGFR positive.
Yes,
both were present.
I will come to that also, ma'am. I'll come to that. So, ma'am, I think you definitely have read my slides. So at least even at 12 o'clock in the night, I was not PS4. So I was still thinking about what people will think. So, Dr. Mansi, your thoughts about why not combine, why not have the best of world for AstraZeneca, combine osimertinib with durvalumab, then what happens?
As you said, sir, there is because that is EGFR mutated also. In this patient, he was a non-smoker, so I would go for TKI.
TKI. So again, immunotherapy and EGFR TKI combination has been tried in EGFR mutant non-small cell lung cancer. The response rates are higher, definitely. PFS is better, but not better than a single agent TKI. And the problem is this drug is toxic. This combination is toxic. You will have a 25% chance of pneumonitis. And the only person who will be happy probably is AstraZeneca. But I'm sure you will, and the only other person who will be happy is your lawyer, because you will have a very difficult time in telling your court that why did you give a combination of EGFR TKI and immunotherapy. Again, my thing will be stay far away. So do not use immunotherapy in EGFR mutant non-small cell lung cancer. Do not use a combination of immunotherapy and a TKI in non-small cell lung cancer. Whatever your PDL1 would be. And this is our data, Dr. Bhavna ma'am. This is our data. What we did is, because in our center, we do EGFR and PDL1 for all our patients. This was a research study which was funded by the institute. And what we basically found out, we thought that if your PDL1 is high, probably this will be like a Delhi ki sardi. EGFR TKIs won't act. And if the PDL1 is low, but unfortunately, it did not make a difference. So you can have a PDL1 0, you can have a PDL1 90. It does not make a difference. Yes, Sujin.
So I want to ask regarding subsequent therapy when there is a progression.
So on progression, if you have a T790M, definitely your immunotherapy combination, even with ABCP, will not work. If you do not have T790M, then there may be an interplay between a Atezo, Bev, Paclitaxel carbo combination that IM power 150 can be tried. But again, PDL1 expression does not really make much of a difference over there. So PDL1, as Dr. Somani said, was an imperfect biomarker. Dr. Somani first and then Dr. Bhavna. सर कुछ ज्यादा ही कुछ ज्यादा ही जरूरी क्वेश्चन होगा इतनी दूर से बाहर जाके भाग के
So as you were talking about the crosstalk and you all said about the EGFR and the immunotherapy, rather we have the data that if the immunotherapy is indiscriminately used first and if then use the osimertinib, it's a very, very tough situation.
Yes.
So my question is that this crosstalk is valid for how many markers? For all 10 markers like EGFR, L, cross?
You have not seen my presentation. Please have a seat. I'm going to have fun. We are going to have fun in the next 15 minutes. This is just the appetizer, sir. I'm going to have fun. Okay, yes, Dr. Bhavna, you had a point.
I think, as you mentioned correctly, in the ABCP trial, they had some patients, I
Yes.
think.
So again, ma'am, that the benefit in ABCP did not depend on what the PDL1 expression was, not that the higher
Yes.
PDL1 improved. So
Yeah.
irrespective of your PDL1 status, you can give ABCP later on in people who do not have a T790 to them. Yes, Dr. Anand.
Yes, sir. So in ABCP, they remove a BAB, then there was no benefit. So might be trees because of that.
Okay, so let's put a twist in the story. And this twist will go to Amit Rotan. Amit Rotan was very happy about TMB story in small cell lung cancer. So Dr. Amit, the same patient. Now I'm beginning. I have removed all ifs and buts from here. PDL1 90%, NGS no actionable mutation. What is the role of TMB? Do you ever do it? You will do it because you are from Manipal, Bangalore, and you send everything to foundation. You will do it, but do you act on this?
No.
Rich people.
So no, we don't.
You are rich, but you don't use.
No, in lung cancer, TMB has really not been a great marker to rely on. So TMB is something that in lung cancer, we have not really. So we were excited about it in the Checkmate 227 when the PFS data came out. That was a few years back. But then when the OS data came out, clearly you saw TMB did not matter. And after that, TMB is really not.
Why, Dr. Amit, TMB is not good? The pros and cons of TMB.
So my thought is this: a high TMB may respond, but it does not mean a low TMB will not respond. So you're excluding immuno for this patient, and your NGS is negative. I would not like to exclude immuno for this patient.
So the pros is it's an improved as a tumor agnostic marker. The TMB more than 10. But the cons include which method, how many genes did they took, what is the cutoff, 10, 16, 20, blood or tissue, standardization, what NGS, FMI just came today morning and said more than 10 is, more than 16 initially, and then they said more than 10 is improved. So we don't know, but there is some data, and this is where I'm being slightly provocative. So this is the data of Keynote 24, which was presented by Royal Herbs. And what they said was in PDL1 more than 50%. This is important. If you want to use single agent immunotherapy and you have a high TMB, so the higher the PDL1, and if you have a higher TMB, your single agent immunotherapy will work. But that's just one data analysis. High PDL1, low TMB, single agent immunotherapy may not work. So again, a crosstalk between the PDL1 and the TMB. However, this data, the relevance of TMB is out if you're using immunotherapy chemotherapy. So in the Keynote 189, between 1 to 49%, if you are using both, if you're using Pembro plus chemo, there is no relevance of TMB. The only relevance would be probably if you are using a single agent PDL1 immunotherapy in, let's say, in PDL1 60%. And if you have a higher TMB, if you already have the report. In our practice, in my practice, I do not use TMB at all. But if somebody has come from outside with a report of TMB, I may decide to act on it, may not necessarily change the treatment. But the only place that I may use a TMB is high PDL1, where I want to use immunotherapy or immunotherapy plus chemotherapy. That's my thing. So to me, TMB in lung cancer is hanging by a thin thread. That's all. It might just break anytime there is a cyclone or anything over there. Now let's go for another twist in the story. Dr. Somani insisted on some twists in the story. So you have a 72-year-old female. Oh, this was the old patient. This was weak. I used all same patients over there. A non-smoker, massive pleural effusion, PDL1 70%, EGFR cross were negative. NGS done, HER2 new negative. So let me go to Dr. Anu. HER2 new mutation positive. What will you do?
I'll do the same.
You will do the same.
Yeah.
What is that same?
Okay, so immunotherapy plus
This
minus
is why it is easier to sit in a panel with Kumar Prabhas and all sitting over right side. No, I say I will do whatever Kumar says. Then Kumar asked me, tell me what will you do? Tell me what will you do? I don't know.
So I'll use immunotherapy plus minus chemotherapy.
In a patient who has a HER2 new mutant, there are two specific questions I ask because I get to ask this question very lot of times in clinic. Will you use there's a year-end review in breast cancer going on right now. Will you use a pertuzumab, docetaxel, trastuzumab? A. Will you use a TDX2? Or third, will you use a chemoimmunotherapy? Difficult question. And just in case you thought your job sucked, there are multiple other jobs which are equally bad. So anyone, yeah, Amit wants to think.
So till some time back, if you had asked me this last year, I would have said I would do IO chemo upfront, first line, and then progression, I would look for anti-HER2. Now I have changed my mind from TDXT data. I think though the data is still second line approval, I think we would do TDXT upfront, first line. That's my thought.
So Jay?
First thing I would try to do is I would ask whether the IHC has been confirmed to be lung.
No,
I'm
this
sorry.
Is, IHC have been confirmed to be lung, TT1 positive.
So I have the response rates of immunotherapy in HER2 mutated patients is not as good as what we have the data for other cases. So I won't be, I might either go for chemotherapy or go for a HER2 directed treatment. It may be trastuzumab deruxtecan or TDM1.
Okay, fantastic. So there are three questions I asked. First question I asked was, will you use a pertuzumab, trastuzumab, docetaxel? And the answer which was presented in the 2021 annual ASCO meeting. And they said PTH was tried over here. The median PFS was only 6.8 and the median OS was 17.6. So A, we will not use a PTH kind of regimen in a patient of HER2 mutant non-small cell lung cancer first line. That is one. Second, there are two agents which are approved right now, and Amish is here. Okay, hi Amish. You just came. And I never knew that. No, I didn't see it. And you didn't make a noise. There was no crosstalk. This is what the example of a crosstalk that I was referring to. Okay, so there are two things that we will do. The two agents, one is TDM1 and one is TDXD. And again, important thing over here is if you look, TDXD in second line has a median PFS of 14 months and a median overall survival of around not reached right now. So what I would probably do is I will put them onto a chemotherapy plus minus immunotherapy depending on the PDL1 and the patient's this thing. Not necessarily very convinced with the immunotherapy in the first line. In the second line, I will definitely want to give either a TDXD or a TDM1. Yes,
why not first line?
You 100% have seen my slides. Why not first line? We will do it first line, but I still, unfortunately, I do not have a single patient in India. We have 3 patients in India. We have a trial coming on about TDXD. Versus chemotherapy in first line lung cancer. AstraZeneca has been over our mind because the recruitment is very, very slow. So anyone, if you have a patient of HER2 new mutant non-small cell lung cancer first line, please give it to us. We will give us means anywhere in India. It's yes, Sujit.
So I had a patient, not a female, but male patient with metastatic disease. Yeah. So what happened was he had a synchronous renal cell carcinoma, so he was not eligible for trial. But he was started on chemotherapy, 4 cycles PEM carbo, progressed. Then he was started on TDM1, and he's responding. So that is what I feel.
So again,
so Ullas, sorry.
Crosstalk.
Crosstalk. Yeah. So the crosstalk between HER2 and PDL1 is what we are talking here. The Destiny Lung 04. Does it include PDL1 positive also?
Yes.
It includes PDL1. So PDL1 and MSI, normally they do not have a crosstalk with HER2.
Yes.
Right? So Amit, what you are saying, if the PDL1 is 70% and you are trying to TDXT in first line, you need to have the lawyer what he has that lawyer.
No. I don't think so.
Can you use first line TDXT with PDL1 70 or 90% positive? Where is the data?
So that's what. So this is
where is the data?
So that's what my thought
in
is.
The clinic, how to start?
So do you believe in a driver where you have an excellent drug? Will it be better as?
1 second. Can I just come in?
Yeah.
So, Amish, 1 second. Can I come in? Let's say you have a patient of EGFR mutant non-small cell lung cancer, PDL1 of 90%. What will you do?
I'll give anti-EGFR.
There
is a data.
HER2 new.
Ullas, there is a data. And second important thing.
Dr. Amish, wait for 2 minutes. I'll show you some slides.
Okay.
So you have biomarkers in 2 ways. One is in smokers enriched, smokers not enriched. In smokers not enriched, you have EGFR, ALK, ROS, HER2 new, NTRK, and RET. In these patients, it is absolutely okay not to give immunotherapy single agent. You can give immunotherapy in combination with chemotherapy.
Chemotherapy, correct.
Single agent immunotherapy in these patients, these are immunologically cold tumors, probably the same as what EGFR is. So you will be absolutely okay. And I can also defend you in the court if you want, without a degree.
Chalo, done. Then you can go ahead.
Okay. So if you have any patient of autoimmune mutant non-small cell lung cancer, Govind Babu sir is not even looking at me. You know? No. In this trial, it is chemo IO versus TDXG, the first line. In this particular trial, the Destiny Lung trial. Okay.
It is quite okay to have that approach that we'll still give chemo immuno to this patient
Yes,
first
you can
and
give-
keep
you
the,
can
this
give
is
chemo
still,
immuno.
yeah.
I will show you a summary slide, madam. I mean, that is why I did some time for this actually. Yes.
There must be two arms na, in this particular trial. So one arm is giving chemo immuno and then other is TDXD and all that.
That's
The results are awaited then.
the trial is, we don't have patients here.
It must be international trial. So
It's an international,
yeah.
that's a Destiny Lung trial. Yeah. So now let's put one more twist into the story. Similarly, some diagnosed, I don't know what I have written, 65-year-old female, never smoker, stage 4 non-small cell lung cancer, EGFR R cross negative, PDL1 25%, pemetrexed carboplatin. This is going to be interesting. Now the NGS report comes as KRAS 12C. Who will take it up? Dr. Anu or Dr. Mansi? You always get the difficult questions, I guess. Okay, Dr. Mansi.
I think I will continue with continue chemotherapy. for
Okay,
now.
fantastic. You will continue chemotherapy. Yes.
Continue chemotherapy and when it fails, then we'll address anti-KRAS drug. Sotorasib, yeah.
Dr. Bhavna.
I think same, since we don't have first line data.
Okay, fantastic.
We have tried to involve in one trial of AstraZeneca, so they refuse our patient. Like you wait for the failing of this patient, then they will aid with the cell
So
purgatory.
again, very important. Sotorasib basically was approved only in the second line. I mean that's very important. Sotorasib was approved in second line. That's the code by K100 trial. For all the great things about it, the PFS is only 6.8 months. So this is even worse than Jefferson. Yes, Sajid.
Is it true that in KRAS mutation, the immunotherapy will add on to benefit?
So I will come to that now. Okay, so then Dr. Hemant, you can just just 2 seconds and then you take a snap of the slides also and then you post it on the group, sir. So what is the role of co-mutations in KRAS mutated non-small cell lung cancer? And the role of co-mutation, basically what we say is a jiggery yard status. So a man is known by the company he keeps. And in the context of today's, if one of them is a KRAS mutant non-small cell lung cancer, one of them is a P53 or one of them is a STK key. So you can always find these 3 people all together over there. So when you look at KRAS, Amit, this will go to you. This is why you are specifically called over here. Foundation medicine, KRAS. What do you look at? What happens if you have STK and STK and KEEP or P53? What is the role of co-mutations?
So what we are learning clearly, at least this is all retrospective analysis. What we've seen clearly is if you have an STK11, you have resistant to immunotherapy, and these are patients who progress very rapidly. But is that stopping us from using? That's very difficult to answer as of now.
I will tell you this. Sujit, you have a point? Sujit is always the first person to have a great point. That's why this is a difficult question. I mean, honestly, even after reading so much for this panel, I also don't have an answer right now. So I mean, it's very difficult to put this question across actually, but still.
I am not aware of this.
Dr. Somani is disappeared. Oh, Dr. Somani is there. Dr. Somani, what happened? You were asking about the other status, sir.
I will go what Dr. Amit said that the resistant sort of the mutations are there like STK.
Okay.
Then probably I will keep myself away from immune therapy.
Okay.
So do you believe the Poseidon data which says immuno is better in this group?
You definitely have seen my slides, Dr. Govind Babu, sir.
Yeah, Ullas, I think all this we are still learning. Sometime back we had a conference on MRD in solid tumors.
Yep.
So one of the things that we started looking at is quantitate what changes are there.
True that, sir.
Allele frequency fractions, and that may tell us whether you can look away from what KRAS mutation is there or you need to act on that. So those are becoming important.
True that. So what Dr. Amit Radhan was saying was right. If you have KRAS, yes, Dr. Somani, I'll make this point and then I'll take your question, sir.
Still it's not clear to me. You go back to the slide.
This one, jiggery yard?
No, not jiggery yard. I can't comment on that.
Nobody can, sir, if we have to.
This Sotorasib trial design.
No, that's the second line design, sir.
I just want to know. Now you said the standard treatment. Those things are still not clear to me. Standard treatment is chemo, or it is chemo plus IO, or it is the sequential chemo plus IO required.
I will tell you, sir. Okay. So what happens is, if you have, I have a summary slide for this. So if you have a concurrent KRAS STK keep, again remember, KRAS STK keep is Dilli ki sardi. It's again an immunologically cold tumor. Maybe your single agent immunotherapy will not act. So definitely a chemoimmunotherapy at least, or what Dr. Amit Rautan said in the Poseidon trial, a double IO plus a chemotherapy. So if you have, there are two places for a double IO combination as far as I am concerned. One is the PDL1 negative squamous cell, and second is somebody with a KRAS and a STK and a KEAP mutation. So maybe, as far as the Poseidon trial showed, and that is where the interest is, maybe they'll have a huge advantage over there in the STK KEAP mutation along with the KRAS mutation status. So this is again a foot in the door for a double IO inhibitor. And Dr. Somani, just to answer your questions, this is an article which I would request everyone to read. It's a Nature Review article published on January 13th. That basically means that I read it. A. Second, I also mentioned that I made my slides only 2 days back. Okay, 1 day back. So this basically says, if you have a KRAS mutant non-small cell lung cancer, please go ahead and use chemotherapy plus minus immunotherapy in the first line. If you have a KRAS mutant along with STK keep, please try to refrain from using a single agent immunotherapy. I mean, that is what I would probably take it out from this trial. When you use chemo-immuno, all your paap jo hai wo dhul jate hain. That is what I would probably take out from this. The last one, this is again a contrast study. Again, a bit of self-promotion. A second line Novartis wala 12C inhibitor. This trial is going to start recruitment in second line, and these people also required a chemoimmunotherapy to be given prior. So I think KRAS 12C, you can do that. Yes.
So do you, in second line, KRAS G12C inhibitor plus anti-EGFR
No,
or without anti?
Only.
No, do you believe in it?
That's a good question. That's a good one. But that's what the trial is. That's what the trial that we have right now. The last one I have, let's say you have a BRAF mutant tumor. What will you do? And then I'll give you a summary slide, and I think our time is already up. So BRAF mutant, we will go to Sujit. So let's say you have a BRAF V600E mutant. What will you do?
I'll be continuing chemotherapy.
You'll be continuing
Dabrafenib pamitamig in second line.
I'm sure all of these guys feel that their job is worse than the person who is sitting over here. I understand that. Again, if you say BRAF is the only tumor, only oncogene addiction, which has got a slightly more better response rate in the first line with immunotherapy alone. And again, if you see over here, this is the thing. If you have a BRAF V600E, the PFS is the highest in the immunotarget study. And again, the same lines at the crossroads, they basically say that dabrafenib trametinib is a very good option because it's an oral medication, but you will be absolutely okay in giving a immunotherapy and chemotherapy or a single agent immunotherapy as well for a BRAF V600E and a non-V600E also. So my thoughts on the crosstalk between immunotherapy and target therapies in non-small cell, these are my thoughts, and these are no thoughts because this is stupid my thoughts. EGFR cross, first line, don't give immunotherapy single agent combination. First line TK is the standard of care. Red, HER2 new, exon 20. This is to answer your question, Amish. There is no or a minimal role of a single agent immunotherapy, even in PDL1 more than 50%. Please mind my words, is single agent immunotherapy. But chemoimmunotherapy can be considered. Since let's say somebody comes with red, we don't really have selpercatinib or pralsetinib right now. So you can give chemoimmunotherapy. What about KRAS mutant? There is no difference in the immunotherapy response rates between KRAS 12C and non-12C. KRAS and P53 is May. KRAS and STK keep is Delhi in December. And monoimmunotherapy if PDL1 more than 50% and chemo IO may be considered. BRAF, both options of their TKIs or single agent immunotherapy are acceptable, and we can go ahead with that.
I had a practical question. In apart from these molecular things, suppose patient is having a high PDL1, what are the other considerations which you take into account to decide chemo immuno versus immuno alone?
I had a question over. Okay, I'll just I'll show you here. So just to show that if it is a single, so you're asking PDL1 more than 50%, single agent immuno versus immunochemo. One is age. Patients more than 75 years of age have not been shown to tolerate immunochemo as well. That is one. This is the one. Non-smokers. The non-smokers is the one where a single agent immunotherapy doesn't work that well, which we can see over here. But that is also partly because NGS was not done for all of them. See, in India, we always criticize us. But the point is that, in India, NGS is such easily available. 14 days, you will get the report. So non-smokers, you will want to go ahead with only chemo-immuno. More than 75 immunotherapy, volume of disease is always there. You have a high volume of disease, you want a high response rate, but there is no advantage if you see of a immunochemo combination over immunotherapy in PDL1 more than 50%. So that's the way it basically goes. And yes, Amish, we have a point.
नहीं उल्लास सर आपकी समरी स्लाइड में IO plus IO if you have to add, can you just revise it?
So
just
IO plus IO is PDL1 negative squamous cell women brain mets. That's the one in which I didn't know. No, this was a crosstalk between this thing. In a KRAS one, if you have an STK and a KEAP tumor, I would probably go ahead, and a non-smoker, I would probably go ahead with the IO plus chemotherapy, a checkmate 9L or a Poseidon trial, which is there. The last one, just to show, the crosstalk is not only between immunotherapy and target therapy, it is also between immunotherapy and target therapy and genes. So we did analysis of our 92 cases of EGFR. We looked at co-mutations over there. The most important co-mutations were P53 and PIK3CA. Others was P10. And again, we say that if you have a co-mutation, your PFS and the OS will be absolutely inferior to what they have. So if you have co-mutation, probably again a case of giving a KN regimen, a Kumar Narunoha regimen. Maybe I'm not a big fan of that. But still, if you have a co-mutation, maybe a case of giving a TMH kind of the Kumar Narunoha, the TMH regimen over there. So with this, I thank all my panelists. I would like to conclude by saying there's a lot of crosstalk between tumor, TME, and immune system. We need to have a broad vision while treating patients of lung cancer. We probably have understood very little in complex NSCLC biology. It's an exciting time to treat lung cancer, but we have miles to go before any one of us thinks that, as Dr. Govind Babu rightly said, before we even start thinking that we know something about it. So with this, thank you. And I really don't envy you for being in a very stupid position over here. Thank you. Thank you.
Thank you.
Thank you.
In the treatment of metastatic urothelial carcinoma from clinical trials to clinical practice. So over the last 2 decades, we know that platinum-containing chemotherapy is the standard of care. This treatment is associated with a high initial response rate, but the median survival is low, close to 12 to 15 months. Another problem with metastatic urothelial cancer is that nearly a third of the patients are only able to receive subsequent line of therapy, as is evident from this real-world studies in the metastatic setting. So the patient profile is for metastatic urothelial cancer is divided whether a patient is platinum eligible or platinum ineligible. And for platinum eligible, the current standard of care is platinum-based chemotherapy. So the traditional approach is wait and watch. We give platinum-based chemotherapy with gemcitabine, and we wait for we give it for 6 cycles and then wait for the progression to occur. To improve upon this, continuation maintenance and switch maintenance have been tried. So coming to the wait and watch approach, which we used to practice prior to the maintenance IO data, the first-line platinum-based chemotherapy is associated with the overall response rate of 50% with a disease control rate of close to 50 to 80%. But median overall survival is poor with close to 15 months median survival. To improve on this, the maintenance approach was tried. So giving an IO with chemotherapy followed by an IO maintenance, or by giving an IO-IO combination. Various immunotherapy drugs like atezolizumab, pembro, and an IO-IO combination of durvalumab and tremelimumab have been tried.
but these trials failed to improve on the median overall survival. So then came the switch maintenance. So switch maintenance is when we give a gemcitabine, cisplatin or platinum-based chemotherapy, and patients who do not progress go on to receive a maintenance with an IO. So the only positive data so far that we have is with the Javelin blended 100 with the use of avelumab in this setting, while pembrolizumab in a similar trial design failed to show any improvement in overall survival. So currently, what in the last 2-3 decades we have been able to improve is by giving an avelumab maintenance with a switch approach. So for a maintenance treatment, there are few key essentials to make it successful. So the drug should be able to work with the previous treatment that the patient has received. It should prolong the response of the previous treatment that has been given. And also, as this is a maintenance approach, it should not affect the quality of life of these advanced stage patients and should be well tolerated. So these were met by the Javelin bladder 100 trial, and I will discuss the trial data in a bit detail. So this was a phase 3 randomized open label trial in 370 locations with close to 700 patients with locally advanced metastatic urothelial cancer, and patients who were responding to platinum based chemotherapy went on to receive either best supportive care or avelumab with best supportive care. The chemotherapy given was either 4 or 6 cycles of cisplatin gemcitabine or carboplatin gemcitabine, and these were the primary endpoints. The primary endpoint was OS, and these were the secondary endpoints. So the scientific rationale behind this approach that by giving chemotherapy, we are generating a lot of tumor neoantigens, but in the absence of immunotherapy or in the normal setting, the tumor cells are able to express PD-L1, thus leading to T cell inhibition. When we give an IO like avelumab, it binds to PD-L1 and it reverses the exhaustion or leads to the T cells to recognize this tumor cell and thus leading to tumor cell kill. So the median age in this trial was close to 68 years. The majority of the patients in the trials were male. Majority were having a good performance 0 or 1. 55% patients had a visceral metastasis, and nearly half of them received gemcitabine cisplatin. A few patients were switched from gemcitabine cisplatin to gem-carbo because of change in creatinine. So this trial showed an unprecedented OS benefit in overall population. So initial data cutoff in 2019 showed a hazard ratio of 0.61 in favor of avelumab maintenance with a median overall survival of close to 21.4 months. And in the avelumab arm as compared to 14.3 months in the standard of care or the observation arm. The difference was 7.1 month. In an extended follow-up till June 21, the hazard ratio was 0.76. The delta improved close to 9 months. It was 23.8 months median survival in the avelumab maintenance arm as compared to 15 months in the standard of care observation arm. The benefit was more pronounced in the patients who were PD-L1 positive, and at the updated analysis, the hazard ratio was 0.61 favoring avelumab maintenance with a median overall survival close to 31 months in the avelumab maintenance arm as compared to 19 months in the observation arm. The overall survival benefit of avelumab maintenance was seen irrespective of the type of chemotherapy used, the response as well as PD-L1 status, and was seen in the overall population. If we look into the overall patients, overall population, the benefit in terms of median PFS initially was close to 1.7 months with a hazard ratio of 0.62 favoring avelumab maintenance, and at a longer follow-up, the median PFS improved by close to 3.4 months with the addition of avelumab maintenance. The median overall survival improvement was seen irrespective of the response to prior chemotherapy, whether patients had a complete response, partial response, or stable disease. Also, the PFS benefit was seen whether the response was a complete response, partial response, or stable disease. The benefit was also seen irrespective whether patients received a gemcitabine cisplatin based chemotherapy initially or a gemcitabine carboplatin based chemotherapy. The overall survival was not affected whether the patient received 6 cycles or 4 cycles. However, only limited number of patients were in the 5 cycles subset. The OS and the PFS benefit by the treatment-free interval when the avelumab maintenance was initiated, whether the treatment-free interval was 6 to 8 weeks or between 8 to 10 weeks, both the subset of patients derived equal benefit from avelumab maintenance. If we look into the safety and tolerability profile of the avelumab maintenance, the overall discontinuation rate of avelumab maintenance was close to 12%. The majority of the side effects were seen, which were comparable between the best supportive care arm as well as the avelumab plus best supportive care arm. A look into the immune-related adverse events. So there were no grade 4 or 5 adverse events in the avelumab arm. Majority of the immune-related adverse events were either grade 1 or grade 2, and only 7% were grade 3 adverse immune-related adverse events. Close to 9% patients received a high-dose corticosteroid in the avelumab arm, and the most common immune-related adverse events were hypothyroidism, rash, hyperthyroidism, and maculopapular rash, which is similar to what we see with other IO agents. If we look into the patients continuing on the avelumab maintenance, thus giving us a strength that this drug can be given for a long period of time. So close to 47% of the patients received the drug for greater than 6 months, 28% received it for more than 12 months, and 20% received it for more than 2 years. Also, the benefit in terms of OS was not that in this trial, close to 53% of the patients received subsequent PD-L1 or PD-1 inhibitor in the best supportive care arm. If we compare it to the other trial, this done in the similar IO setting, either continuation or switch maintenance, close to 60% patients went and received some form of systemic treatment in the best supportive care arm. If we look into the subset of patients in the Javelin Bladder 100 in the Asian subgroup, so close to 147 patients were in the Asian subgroup. The patient baseline characteristics were similar between the treatment arms and consistent with the overall population. In the Asian subgroup of patients, there was prolongation in overall survival, which was close to median overall survival in the avelumab arm was close to 28 months, as compared to 18 months in the best supportive care arm with a hazard ratio of 0.78. The PFS was also improved in the Asian subgroup. It was 5.6 months in the avelumab maintenance arm as compared to 1.9 months. Again, the safety finding in the Asian patients in longer term analysis was consistent with the initial trial data that I have discussed for the whole population. And for the Asian subgroup, again, this trial showed that the median overall survival is close to 28.7 months in the Asian subgroup, and the best supportive care arm is 18.2 months, and it lead to a 22% reduction in risk of death when the avelumab maintenance was given. So if we use the immunotherapy drug at the right time, and if we make a calculation of the initial chemotherapy period and the TFI that was given, so in total, the survival is close to 30 months. If we compare it with other approaches which can be done in a similar setting, this approach leads to the maximum survival across the other strategies if we compare with it. So to summarize the Javelin Bladder 100 data, that in the longer follow-up at greater than 2 years in all the patients, the avelumab maintenance continues to prolong overall survival PFS with as compared to best supportive care. The overall survival rate at 2 years in the avelumab plus best supportive care arm is close to 38.4%, and the 2-year PFS rate is close to 23.4% versus 7.1% in the best supportive care arm. The long-term safety profile is consistent with what has been reported with previous monotherapy studies, and OS was prolonged with avelumab maintenance despite a high proportion of the patients went on to receive subsequent anti-cancer treatment, and also 50% patients receiving immunotherapy as subsequent line of treatment. And these results further support the recommendation that avelumab maintenance in patients who have not progressed on platinum-based chemotherapy, it is safe, and it is associated with a high percentage of patients continuing on treatment at 2 years, suggesting a good tolerability and feasibility of this regimen. And based on this data, majority of the present guidelines recommend avelumab maintenance in patients who have not progressed on cisplatin-based chemotherapy. And it is also supported by NICE guidelines. Thank you.
So thank you for a very lucid and detailed presentation. Maybe I'll ask you a question. You referred to the rationale of this therapy being an increased load of neoantigens that are generated. Is there any more understanding about the nature of these neoantigens and how they might actually contribute to an improved OS?
Actually, as already discussed in the presentation also, most of the immunotherapy drugs work in similar fashion. But we do not know why particularly avelumab maintenance, why did it work and why not pembrolizumab maintenance. So the rationale could be, means such rationale was there for all other immunotherapy drugs. But still, personally, I do not know why particularly as compared to other immunotherapy drugs, why only avelumab maintenance work. Regarding new antigens, this is a basic rationale that is applicable for majority of the immunotherapy drugs and why we are using it and why we are trying it in possibly with radiotherapy, after radiotherapy. So particular new antigen means this is one of the hypotheses that is given that possibly why an immunotherapy drug could work in post-chemotherapy setting or with chemotherapy.
Okay.
Hi, Jyoti. Excuse me. Yeah. In a nice talk. The trial had platinum containing chemotherapy followed by avelumab, Javelin 100. If the patient's GFR is less than 30 and patient is not eligible for even carboplatin and you give only taxane and patient responds well, would you offer avelumab to that patient? Because none of the guidelines, every guideline mentions not progressing on platinum containing chemotherapy. So if you give only taxane, would you offer avelumab to that patients?
So, sir, actually, we do not have data to support, but again, we need to discuss with the patient. Possibly, one of the patients where I may consider giving it is possibly a PD-L1 positive patient who does not progress after chemotherapy. In that setting, if at all, I'm going to, because as discussed, possibly only 30% of the patients go on to receive subsequent second line of treatment. So there may be no, possibly this patient won't go on to receive subsequent immunotherapy. So possibly in a patient who is PD-L1 positive, even without platinum-based chemotherapy, if he is not progressing, possibly I'll discuss with the patient.
So if the PD-L1 is negative and taxane patient has an excellent response, you would not offer avelumab.
Sir, I can, means we can discuss with the patient, but if we look into this trial data as such, the maximum benefit is derived by the patient who are PD-L1 positive. So if we are going against the guideline, possibly the best place to choose will be a PD-L1 positive patient.
Okay.
So thank you, Dr. Deepak Shukla, and thank you, chairpersons. We will have the continuation of the discussion during the panel discussion. So may I request Dr. Professor Hemant Malhotra, sir, to come for the moderation of panel discussion, pushing the limits in carcinoma bladder, and where do we place immunotherapy? Until he is coming, may I invite the panelists also, Dr. Jitendra Pahaljani. Dr. Jitendra is Senior Consultant Medical Oncologist in Jaipur. Dr. Ankur Punia. Dr. Ankur is Senior Consultant Medical Oncologist and Faculty in Medical Oncology at Mahatma Gandhi Medical College. Dr. Shruti Gandhi. Has Dr. Gandhi come in? Yeah, thank you so much, ma'am. So she is from Pune. Dr. Ajay Yadav. He is Associate Professor in Medical Oncology at Jaipur. Dr. Ajay Bapna. He is Senior Consultant and he is Director of Medical Oncology at Bhagwan Mahavir Cancer Hospital in Jaipur, one of the senior most medical oncologists in Rajasthan. Dr. Sandeep Jasuja is probably on the way. He will be joining us shortly. So with this, I request you to please.
Thank you very much, Dr. Lalit. After a beautiful background which has been set by Dr. Shukla, we'll take this forward and thrash out some of the practical problems of the implication of the Javelin 100 trial. And I think we will certainly address your question, Amish. We have some very expert panelists over here. So I have about 60 slides. We'll go quickly. So this is my panel. Other than Dr. Jasuda, everybody is here. So welcome to this conference and this panel discussion. I hope you have a good time. And this is the disclaimer. This is a Pfizer sponsored session. So you may need to keep that in mind. So the monoclonal antibody, the immuno-oncology drug, which we're going to talk about and focus on today is avelumab. And this is a humanized anti-PD-L1 monotherapy. And all of us are very much aware that this engages both adaptive and innate immunity. So this molecule avelumab has been approved for monotherapy for first-line maintenance, which kind of we're going to focus on today. It is also approved in combination with VEGF TKI in the first-line treatment of adult patients with RCC and also for Merkel cell carcinoma, just to complete the list of approvals in our country. So we're going to focus on first-line maintenance in metastatic or locally advanced urothelial cancers today. And is there a role of immuno-oncology maintenance or any other maintenance in this situation? So why are we wanting to use something in the maintenance once we've achieved a partial response or a complete response with chemotherapy or whatever modality of treatment you wish to choose? Why do you want to give maintenance? So this is the reason why we want to give maintenance as soon as we finish the first-line treatment, because a very small number of patients, only about 1/3 across these 4 studies which I'm showing you, get to receive the second-line treatment. And why is this so? Because the patient is not inclined once there is recurrence, the patient's general condition deteriorates if there is recurrence, and so many other factors. So if you are a believer of maintenance, then use it as soon as your induction treatment is over. So let me come to my panel. Let me start from the left side. Dr. Ajay Bapna.
Yes, sir.
Can you please tell us that in your practice, which patients, how many patients of locally advanced or metastatic urothelial cancer you see are cisplatin eligible?
Cisplatin eligible, sir, 50% will be cisplatin eligible. And if you combine the cisplatin ineligible, then 2/3 of them will be this group of patient and 1/3 will be definitely platinum ineligible.
So same question to Dr. Shruti. Shruti, in your practice, like how many patients of the category which I just mentioned would be platinum ineligible?
So platinum ineligible will be 40% of the patient.
About 40%.
Yes, sir.
And so about half would be cisplatin ineligible also. So everybody else agrees, or is there a major dichotomy in any of the other panelists thinking? Okay. And Ajay, can you tell us what would be your criteria for cisplatin ineligibility? Which patient would you consider as cisplatin ineligible, just for our younger colleagues?
First and foremost is the performance status. The better performance status, we can easily give the cisplatin or the carboplatin. And then the condition of the heart. If the patient is not in the NYHA 3, then probably this patient will be can get the cisplatin or carboplatin. And then peripheral neuropathy, anything more than grade 3, PS more than 3, peripheral neuropathy more than grade 3, NYHA more than 3. And if there is patient is having some problem with the hearing, then this is also contribute to the platinum ineligibility.
So everybody else agrees, and I think this is. pretty
And
much standard.
creatinine clearance also should be more than 30 ml per minute.
Renal functions is the number one criteria. So if the patient has PS 3 or more than 3, creatinine clearance of less than 30, peripheral neuropathy of grade more than 3, whatever the cause, NYHA heart failure more than 3. This again is a big problem with the fluid, which is mandatory to be given whenever you give platinum, and patients with PS2 and with the poor creatinine clearance. Dr. Jitendra, do you routinely do an audiometry when you are planning cisplatin in your patients?
Yes, sir.
In all patients?
Yes.
And then you periodically do it during the treatment also?
No, not
Is this-
periodically.
Do you do it because it is mandated by Chiranjeevi, or do you do it?
No, so we do it, but follow-up, actually, we should do every 8 to 12 weeks, which usually I don't do. But yes, definitely I asked for hearing loss. Means 4 weeks back only I found a patient who had a hearing loss due to that. And I had to omit cisplatin.
Is that a contraindication? At what cutoff would you, we're talking about audiometry, at what cutoff would you not offer that patient cisplatin?
So if patient is having significant hearing loss with less than 15 or 20, then we would not give cisplatin.
Okay. May I wake up the audience a little bit, show of hands for the medical oncologists, or for those of you who are using chemotherapy, how many of you do you get routine audiometry done for all patients who you plan to give cisplatin? So like a vast majority as a routine, unless the patient is obviously hard of hearing and he asks you what 3 times, you don't get it done. I don't get it done myself. So, but
By
I'm very
default,
happy.
actually, sir, we are doing these days because 80% of our patients are, supported by the government schemes. Let me have a confession to make that only because of these schemes, we are doing it.
I did ask Jitendra specifically that. So in our state, if you want the government to give the patient cisplatin, then you have to give an audiometry report before the government sanctions the cisplatin. So it may be good or it may be bad, but it is something which we are mandated to do. And if you do an audiometry and don't do it again after 8-12 weeks, then it again doesn't have much significance. Yes.
You have.
Yes, we have a very fine, if you genuinely want to get it done, we have a very nice auditory vertigo lab in our institution. So that is a little bit of plus. So let me start from this side now, Dr. Ajay Yadav, just a ballpark figure. I mean, I'm quite aware that you won't have hard data. What is the overall survival with only chemotherapy in patients of metastatic urothelial cancers in your practice? Like, how long do they live?
Sir, in metastatic setting, it range somewhat between 12, 13 or 14 months.
So everybody agrees on the panel, like approximately 1 to 1.5 years. Okay, good. So then we can move on. So this is some data available for almost 2 decades. There have been very little progress with this malignancy. And even though with the present gemcitabine plus platinum containing chemotherapies, we do achieve a response rate of almost in 3/4 of our patients. But this is short-lived, and within a matter of months, about half a year, 6 months, almost 2/3 of the patients come back with evidence of disease progression, and quite a few of them do not receive the second-line treatment. And the survival, as has been mentioned by my learned panelists, is about a year or a year and a half. So there is a significant unmet need in patients of locally advanced or metastatic urothelial cancers. We do really want their survival to increase. So let me ask Dr. Jitendra now. Dr. Jitendra, for the cisplatin eligible patient, what would be your choice of first-line chemotherapy?
So gemcitabine cisplatin based preferably.
And Ankur, what would be your choice for the cisplatin ineligible patient?
Then, sir, either a single agent taxane or single agent gemcitabine, sir.
Or what about gemcitabine carboplatin? Patient is
Yes, if
cisplatin
patient is
ineligible.
if platinum eligible, then yes, sir, definitely I will substitute with carboplatin.
So anyone of the panel, Shruti, maybe you can address this. Are you still a believer of dose dense MVAC in a certain segment of patients, or nobody gets MVAC?
No, sir. In a case of metastatic urothelial cancer, we can still go ahead with the dose dense MVAC.
Yeah, so
Yes.
you would prefer MVAC over taxane or?
Yes, sir, definitely.
Ajay, Dr. Bhavna?
So the level of evidence for dose dense MVAC and cis-gem is same. So might as well use the regimen which is not that toxic at that age. So age is a big consideration when you are planning treatment for metastatic urothelial cancer. So absolutely cis and gem, or cis or carbo or gem.
So my question to my audience, show of hands only, how many of you would use MVAC as first line in your practice? Nobody. So in a selected group of patients. Okay, fair enough. We can move on.
So Amish, who are these selected group of patients?
Right, good performance status, young age, and who are platinum ineligible, na? Because as you rightly said, both are category 1, both have equal, survival outcome. So going on the second line taxane, when I don't have the data, I would definitely offer DDMVAC to these patients.
Fair enough. So again, there is no hard and fast rule, and that is where the art of oncology comes in. You have to balance everything and then decide the best treatment for your patient. And whatever the guidelines might be, you have to individualize for each patient. We all know that. Of course, the senior people know that, the junior people who are just coming into practice, they also know that. And that's what we teach our students also. So I'm coming back to the right corner of my panel again. Dr. Ajay Yadav, we have two Ajay, so there's a little bit of confusion going on. So normally I like to address so old now, okay, everybody by first name, but Dr. Ajay Yadav. So you have these three strategies for the patient who's had a good response to first line chemotherapy. Wait and watch, continued maintenance in the sense that in your induction therapy itself, you use an immuno-oncology agent and continue that as maintenance till there is progression. Or do you think of switch maintenance? Switch maintenance, for those of you who are not familiar with the term, you finish your induction chemotherapy and then switch to IO maintenance. So what would be your preferred regimen? Genuinely, honestly.
So first line only chemotherapy. If patient not progressed on gem pluses, then I will give my maintenance treatment.
So is there any evidence of first line chemo plus IO?
Yes, sir. But the point is, by giving induction, we are choosing a select group of patient, and the financial toxicity is also less. Although Pembro can be given with chemo, but still I will prefer switch maintenance because the selected group of patient will be there and toxicity will be less.
You are giving the patient a platinum with gemcitabine, but would you like to add an immunotherapy agent?
No, sir.
No. Ankur, same question to you, like a chemotherapy doublet or a chemotherapy doublet plus immunotherapy in the induction to start with newly diagnosed patients.
In the doublet, in the combination, 4 trials have failed actually of combining immunotherapy except Evolumab. All those they started with immunotherapy combination and they failed to show any difference. So based on whatever evidence, best evidence is to switch to a maintenance rather than starting upfront with immunotherapy.
Correct. So I think that's what we're going to kind of hammer in as the panel discussion goes on. So this is the downside to the first approach, like you give an induction chemotherapy, get a remission as deep as possible, and then wait and watch because a small number of patients are then able to get on for maintenance treatment. And again, we did discuss the reasons why. So Shruti, you want to highlight why is this data? Why can only 1/3 to half of the patients get on second line treatment?
Sir, overall survival with the first line treatment is just 1 and 15 months till 15 months. That's why 1/3, only 1/3.
12 to 15 months. And there are several reasons why the patient doesn't opt or cannot take the second line treatment, financial exhaustion, deterioration in general condition and performance status, and the disappointment and the depression of the disease coming back. But the data is such that a significant number of patients don't opt for second line treatment. And is there a role of immunotherapy in the first line? We've already discussed. Does anybody in the panel uses chemo plus immuno in the first line, newly diagnosed patients? Right. So, yeah, any comments on that? Okay, and this is because we have these three studies: the IOSICON 130, the Keynote 361, and the Donoby study, in which chemotherapy was combined with IO. And they were basically negative trials. One is still waiting for the final results to read out, but at the interim analysis, there has been no difference in the overall survival in all the three studies. And here are the survival curves for you, the overall survival curves, the IOSICON 130 and the Keynote 361, as Jitendra was mentioning. So they don't have either a significant OS advantage or a significant PFS advantage. And the third study, a combination of two IO agents, again, did not show a big benefit. So these three strategies that all the three immuno-oncology trials, all of them are, when in the first line treatment, all of them are negative or barely positive. So again, I'll ask this question to all my panelists, starting from Dr. Ajay Bafna. Ajay, for a patient who is like no economic constraints, would you subscribe to switch maintenance?
Yeah, this is a standard of care now.
And what about you, Shruti?
Definitely, yes.
So how many patients in your practice do you have on maintenance Avilomab?
Sir, because of limited experience, I don't have any patient on maintenance.
I love that candid answer. I have zero number of patients myself. So now I'm about maybe when I think I did my medical oncology, you must have been in school at that time. Ankur, how many patients do you have? One or two or none?
At present, none, sir.
But do you subscribe to this?
Yes,
If you
sir.
have a patient who doesn't have an economic constraint, do you believe in switch maintenance?
Yes, sir, definitely.
Jitendra?
One patient awaiting, sir. Miss, they have to come.
अच्छा वो CGHS को लिख के
No, RGHS they have to come. They have to decide.
So for the delegates and faculty who are out of state in Rajasthan, we have a category known as RGHS, Rajasthan Government Health Scheme or Service or whatever, in which whatever you write to them, the hospital and the government has to provide. So I think in that category, we are beginning to use a lot more immuno-oncology. Ajay, well, same question to you. How many patients are you?
Sir, no patient.
No patients, but you're a believer or you're not a believer?
Yes, sir, I'm a believer.
And why are you a believer? Are you a believer because of this study?
Oh, yes, sir. We have enough data that it is useful.
So level 1 evidence?
Yes,
sir.
It is.
So I think this has already been shown to you very in quite a bit of details, the Javelin 100 study. I'll very quickly recap for you. This is again the three strategies which we've discussed in a few previous slides. And there is now data, as the panel is telling us, that the only approach which has led to an increase in overall survival is the switch maintenance. And switch maintenance, once again, is when you finish the first line chemotherapy, and as soon as you finish the first line chemotherapy, you switch to immuno-oncology maintenance. And this evidence has accrued because of the Javelin 100 study. And this has already been shown to you, a phase 3 randomized open label parallel arm study, very significant number, 700 patients of locally advanced metastatic urothelial cancer. And this is the schema of the study, 1-to-1 randomization between Avilomab maintenance, Avilomab plus best supportive care, and best supportive care alone. Patients were stratified according to best response and metastatic site, visceral, non-visceral. Primary endpoint was overall survival and several other secondary endpoints. And this has already been shown to you. And this again is a quick snapshot again shown to you. Majority of the patients with PS0, almost half of them received GEM-CIS, and half of them received GEM-CARBO. So GEM-CARBO is a pretty acceptable regime. And here is the, I'd like you to look at this curve because this is the long-term analysis in the middle of last year. And you can see we're talking about overall survival. There is an increase in overall survival from 15 months in the best supportive care arm to 23.8 months, 8.8 months difference, and a hazard ratio of 0.76 and a pretty significant p-value of 0.0036. So I think this is the level 1 evidence which my panel is referring to. And this is actually a practice changing study. And quite a few of us, again, if you take out the economic issue out of the decision making, quite a few of us have shifted to this. Yes, Amish.
Just wanted to have it thinking. Normally, all IOs in the tail, the graphs separate. In this particular study, like I have gone through this javelin many times, placebo is classically following exactly the IOCA thing. And if when the other IOs have failed, sometimes it wonders in the mind that what is that special with evolumab that is clicking?
So I think that question was asked in the previous panel. And it kind of amazes me also so many times that you have drugs with the same mechanism of action, maybe a little bit of difference in the sense PD-1 inhibitors or PD-L1 inhibitors, and they work quite differently in the same disease subset. And you have approvals of one and no approvals of the other. And when you have this very narrow benefit, then 1 or 2 patients this side or that side makes the difference. And I mean, it's if you look at the numbers very carefully, which the publication never tells us. I'm aware of the BELA study. I was part of the BELA study, CML, first line, bosutinib. And the primary endpoint failed because 2 patients out of 800 patients in the global cohort were withdrawn from the study in the study arm because of diarrhea. If those 2 patients had continued bosutinib, it would have been a positive study. So you have these fallacies of clinical trials.
So Amish, the curves are further separating because just now we have 39-month follow-up now. So for the median overall survival for the entire population is 24 months. And for the PDL1 patients, it is 31 months. So its curves are, you can clearly see.
There is a gap. What I'm saying, in the tail of IO study, the tail separates out. Here they are not separating. There is a difference, but they are not separating.
So again, I think we've seen this also in patients who had PD-L1 positivity. There was a statistically significant difference, as Ajay is saying, 30.9 months in the latest analysis versus 18.5 months in the best supportive care arm. Again, a very satisfying and healthy hazard ratio. And if you look at the subgroup analysis, again, I want you to focus on this one. Across the subgroup, whatever type of chemotherapy they received, whether they had visceral or non-visceral metastasis, little better for non-visceral metastasis. And across PD-L1 status, even for PD-L1 negative, there was benefit when you look at the subgroup analysis. And this is the progression-free survival. Again, you can see significant divergence of the curves. So again, now I come to my panel, starting with Dr. Ajay Bapna. Ajay, we are talking about urothelial cancers. You are contemplating evolumab in a patient. Would you mandate a PD-L1 testing or no?
Just for the academic exercise, otherwise for the clinical practice, irrespective of the PD-L1, there is a category 1 indication. Yeah, only if you want to collect the data, otherwise it is not really.
Any difference of opinion from any other panelists? Okay. So this is, like across guidelines, Evolumab is approved in the maintenance, irrespective of PD-L1 status. So as Dr. Ajay said, if you wish, you could get it done. But you would be perfectly justified if you start the Evolumab maintenance even without having a PD-L1 report or a PD-L1 negative report also. So you've given your induction treatment. This question is to Dr. Shruti. The patient has not achieved the CR. You've given 6 cycles of chemo. Patient has achieved a partial response. Would that be a candidate for switch maintenance Evolumab or no?
Yes, sir.
Yes. Okay. Any difference in opinion on the panel? Okay, very good. So this is, I think, some data on that. For patients who have complete response or partial response or stable disease, the two curves, Evolumab maintenance as compared to best supportive care, they are seen to diverge. So even if the patient has a PR, you're still, within recommendations to think of switch Evolumab. So let me come to the question. Okay, Ankur, this question is to you. How many cycles of chemo do you normally recommend for your patients? 4, 6, more than 6?
Sir, if I'm just giving chemo, then 6 cycles, sir.
Where did that number of 6 come from?
It's just an arbitrary number, sir, because most of the studies have been done with 4 to 6 cycles, but maximum studies have been with 6 cycles.
If there is acceptable toxicity.
Yes, if patient is tolerating well, then.
So the patients who are getting the 4 cycles are benefiting as much as 6 cycles. So might as well restrict yourself to 4 cycles.
Yeah. So, like, what do you do in practice? Like, we have a senior oncologist here. Colonel Chitalkar, what do you do? 4 cycles, 6 cycles, more than 6? So 6 is the magic number. Amish, your comment? Yeah, 4 cycles. Yes. Okay. And if the patient is continuing to have response, then like you've done ultrasound and the mass is less at 2 cycles, and then you do at 4, the mass is still less, then still 4, and the patient doesn't have any huge toxicity. Of course, the patient is for IO, but he is having.
If the patient is for IO, they switch to that is what the data says.
Okay, so
if the patient is not for IO, sir, and if the patient is a palliative setting we are giving, metastatic setting, then you may consider 2 more cycles. But otherwise, if the patient is for IO, follow the trial.
So in the metastatic setting also you give switch maintenance.
Metastatic setting you give switch maintenance of what, sir? If the patient is not eligible for IO, you have started with, say, gemcitabine carboplatin. A patient after 4 cycles has a partial response, performance status is good, you would continue.
So that's what I'm saying. You would give
no,
6
only then you may not stop at 6 also, na?
Yeah. So again, there is some data that whether you give 4 cycles or 5 cycles or 6 cycles, all these patients benefit. So I think Lalit is here standing on my head. And also, if you start the maintenance at 4 weeks, 6 weeks, 10 weeks, all of them benefit. And this is some data for that. One last question to Jitendra. Jitendra, are you convinced about the Javelin data to change practice from Monday? Oh, you've already changed practice, but would you still like to see data from Asian subsets and Indian patients before you get even more convinced?
Definitely, we should have Asian data, but still the data is convincing.
Okay. So everybody would like to see data from Indian patients, whether we are genetically different, whether our urinary bladder cancer is the natural history is different. So we do have a small subset of patients from the Asian subgroup, about 1/5 of the patients. And again, the same benefit was seen with the switch maintenance. Toxicity, I think in the previous talk has already been discussed in details. This is just a summary of the Asian subgroup data, and this is just telling you that the response rates are there as compared to the overall cohort, and also that the toxicity is not more in this cohort. So you can rest assured that the drug is as effective as was shown in the international cohort. Very quick comment or question.
So just as a I'm a clinical radiation oncologist. I just want to, there was a query about 6 cycle or 4 cycle. In totality, if we see if ask any medical oncologist or so 6 cycle chemotherapy or 4 cycle.
Can you ask a question?
My question is, my question is, if it is 4, why 4? If it is 6, why 6?
So I think we've already discussed that. So we just, toxicity has already been shown to you, talk to you properly. Won't do this. We just go to the conclusions quickly. So this is the best possible treatment you can give to your patients now. Finish your first line chemo, 4 or 6 cycles. That is still up for debate, how many cycles. Then give Abilimab maintenance. And then once the patient progresses on that, then you can think of your second line treatment. And this is recommended by several guidelines also. So I think this is all fine. This is the new standard of care in first line metastatic urothelial cancers. And we've already discussed that. And it's 80 milligram infusion given over 60 minutes every 2 weeks. So any quick take home messages from any one of the panelists?
I think the time has come and that there should be a shared decision with the patient.
That time has been around for a long time. Yes, Dr. Ajay Yadav?
Sir, definitely patient response to chemotherapy, then it should be offered for immune checkpoint inhibitor.
And I think my wish list is that I hope the price of the drug comes down and they have a generic soon. So with that, thank you very much. And please give a big hand to everyone who learned that. Thank you. Thank you.
So thank you so much for an enlightening discussion. Next topic is the changing paradigm in the management of esophageal and cervical cancer. So may I request Dr. Amit Rotan, who has already been introduced to you. Dr. Amit is very vibrant, always smiling medical oncologist. Thank you so much, Amit, for taking this forward.
Good afternoon, everyone. Again, thank you, sir, and thank the organizing committee for giving me this opportunity. So this was an interesting topic, I felt, because this is something new which has come up, and this is a new indication for us in clinical practice and a new indication and a new approval in India. So I felt this is something interesting that for all of us, we should probably be clear on where we will be using immunotherapy in these two malignancies. So this is. Let's start off with pembrolizumab in advanced cervical cancers. We know cervical cancer is the second most common cancer in India after breast cancer. Most of the patients which we see in cervical cancer are early stage or loco-regional disease, what we say, and most patients would end up getting concurrent chemoradiation. There's a very small population which comes with advanced cervical cancer. And these are the guidelines. And as I said, very, very few patients undergo surgery. It's only till stage 1A, till 1B when surgery is done. 1B onwards till 3, it is always concurrent chemoradiation, which is the standard of care. And in the advanced setting, the treatment was based on chemotherapy earlier. So a few years back, that's about 5-6 years back, we saw this data. This was of using bevacizumab in cervical cancer. And this was a GOG 240 data set, which changed practice. What it looked at was saying is if you did chemo and you use carboplatin paclitaxel versus Bev without Bev, and clearly this showed that you improved survival of metastatic advanced cervical cancer patients. And you talked about a median being somewhere about 13 months without Bev, and it went down to about 16.5 months with Bev. And that's was a significant improvement, and it got approved and it got utilized into clinical practice. So the standard of care then became chemo plus Bev for advanced cervical cancer. And now we have the Keynote 826 data, and this is again going to become a practice-changing data, and it's going to change. It's already there, but it's going to get an Indian approval. So it's got an Indian approval recently, so we are going to start using this for clinical practice. So Keynote 826 is a phase 3 study. It's a first-line treatment for advanced cervical cancer. You're talking of patients with recurrent metastatic and persistent cervical cancer. Now, the eligibility for these patients was looking at the advanced cervical cancer patients who had not received any systemic therapy for their advanced disease. they could have received prior concurrent chemoradiation for their stage 3 disease or 2 disease. Now, it was a 1:1 randomization. The comparator arm was using paclitaxel with platin. It could be cisplatin or carboplatin, with or without bevacizumab, depending on the clinical situation. So the standard would have been with bev, but it could be also patients without bev. The comparator arm used this with addition of pembrolizumab, 200 mg every 3 weekly flat dosing for 2 years. There was a stratification factor which looked at PD-L1 CPS, which was less than 1 or less than 10 or greater than 10, and plant bev use yes or no, and metastatic disease was present at diagnosis or not. The endpoints, it was using a dual endpoint, was OS and progression-free survival. The analysis was based on OS looking at PD-L1 greater than 1%, then greater than in the intent to treat population, and then looking at greater than 10%. Even the PFS went in this way. The secondary endpoints were overall response rate, duration of response, 12-month PFS, safety, and there were patient-related outcomes as exploratory analysis. Testing of PD-L1 was based on the DACO-22C3, the clinical C3 platform, and it was using CPS as a cutoff. So these are the baseline characteristics. This trial had about 617 patients, 1:1 randomization, so about 300 in each arm. You had PD-L1 positive, CPS greater than 1% in 89% of patients. So this is the first learning point in cervical cancer. In most cervical cancers, PD-L1 will be positive, at least CPS greater than 1%. So the whole question comes, it's not like one of those cancers where you talk about 10%, 20%, 30%, or 50% positivity like you talk about in lung cancer sometimes. This is, most cervical cancers are PD-L1 positive, and about 89% of these patients were PD-L1 CPS more than 1. Patients who received bevacizumab in this study, 63% patients did receive bevacizumab, and the rest did not get bev. Histology, about 75% of patients had squamous cell histology, which is the common cervical cancer histology we would see for. About 23% had adenocarcinoma, and 5% had an adenosquamous histology. The previous treatment, only prior chemoradiation received was about 39% of patients. Prior chemoradiation and surgery were 17%. So the rest of the patients would have been the naive kind of patients. So this is the primary endpoint. The first was looking at PFS with PD-L1 CPS greater than 1%. And you saw clear improvement in PFS. It went up from 8.2 months to 10.4 months with a hazard of 0.62. So this was clinically significant. Looking at the overall survival in the CPS greater than 1% population, again, you see an improvement with a hazard of somewhere about 0.64. The median for the comparator arm was 16.3 months versus not reached with the pembrolizumab arm. Now, this comparator is exactly where we saw the GOG 240 data when bev got approved. You talked about a median OS of about 16.6 months when you use chemo bev as your first-line therapy. So clearly, you are improving the overall survival. And if you look at 2-year OS rate, it's 41% versus 53%, about 11% improvement in the OS rate, which we have seen is clearly significant. And the whole thought keeps coming as you get longer follow-ups, whether you'll hit the plateau, and that's what everyone keeps looking for. So with this, this is a positive study with both endpoints being met, the PFS and the OS for the PD-L1 greater than CPS greater than 1%. Now, what happens is all of us try to kind of look at subgroups, and looking at the forest plot, we were trying to look at, does everyone benefit, or what happens to the PD-L1 negative patients? And that's where you start seeing here a slight difference. What you're seeing, PD-L1 negative, there's no benefit there. But if you see the number, it's only 69 patients. So it's a very, very small number. So 90% of patients are PD-L1 positive in cervical cancer. It's only the 10% who are negative. And that this small number is being compared and said there's a benefit or no benefit. So this becomes really very controversial for clinical usage. Are you reliable enough PD-L1 to say that you don't want to offer immunotherapy? Again, with this small data, it becomes a big controversy. What about patients who got bev and no bev? Again, you see a benefit is there in patients who got bev, but there's also a significant patients who did not get bev. And again, the type of presentation who came directly with metastasis or those who got CTRT and then metastasis, again, there's equal benefit in both arms. Now, This is looking specifically for that population, that 89% population who are PDL1 greater than 1% CPS. And what we see, there's benefit in every subgroup. It does not matter when you're talking of squamous or non-squamous cervical cancer, the benefit is equally there. You see whether you use cisplatin or carboplatin, again, the benefit is there in both the agents. Whether you got BEV, no BEV, again, the benefit is there. And again, whether they got previous CTRT or not, again, the benefit is there. So clearly, in the CPS greater than 1%, there's a clear benefit in all subgroup of patients adding pembro to chemo. Now, again, the all comers also looked at the same kind of benefit if you look at it totally. But one interesting point for us is always this, because we always have that BEV has a significant impact in OS. And we always believe BEV, when you add to immuno, there is a synergism there. And we always think BEV with immuno will improve your responses. And we like doing that. And you see so many malignancies where anti-VEGF and IO combination is always improving your responses over immuno. So for me, in cervical cancer, I always think if I can add BEV, I would definitely add BEV because anyway to chemo BEV, there's an improvement in overall survival. And yes, if I was giving immuno to this patient, I would prefer them to be immuno-chemo BEV rather than immuno-chemo alone. That's my thought. But what we saw from this study, it does not matter. If your patients who are not eligible for BEV did not get BEV but added immuno, the immuno benefit is exactly there over chemotherapy. And that's the one with the big no there. You're seeing clear improvement, 12.6 months going to 16.8 months, hazards of 0.74. So there is a benefit in this group of patients, even when BEV is not there. If you look at the other side, 24.7 months versus not reached. So that's the arm which is really doing well when you add BEV. So BEV is adding in, and over that you're adding in the immuno is giving further responses, and you have a hazard of 0.63. Now again, this analysis is not to talk about BEV. It's just that in cervical cancer, we know there are patients who can't get BEV. You have always a worry, and that's what I worry when I see cervical cancer recurrences in our practice. Those who have got CTRT, they're so prone to fistula formation. And you give BEV, and a few months later, they come with a fistula, and you regret why you did the BEV there. You could have just got away with chemo alone and pushed it. So there is a clear segment of patients who will not be able to take BEV in clinical practice. So what it tells us is, if you add pembro to those patients with CPS greater than 1, there's a clear benefit. We don't really need to worry if we didn't add BEV. But yes, if you can add BEV and add pembro, and you get that good benefit there, which you're seeing with a hazard of 0.63. The other endpoint was also, the secondary endpoint was response rates. ORR, 50% response rate went up to 68% response rates. And again, median duration of response, placebo was 10.4 months, went up to 18 months. So clearly very significant improvement in duration of response. What happens to the adverse event profile? Again, what we see, if you look at all grade 3 events, 75% with the placebo arm, going up to 81.8% by adding pembro. Really not a very significant increase in the grade 3 toxicity. Pembro, most immunos, we really don't worry too much about side effects, but what you're seeing is most of the baseline grade 3 side effects are due to the chemo or the chemo BEV which you're giving them. If you look at treatment-related adverse events, and especially try to focus on the immune-related adverse events, because that's what we keep worrying about in practice. Will the IRA be so bad in these patients or in any special subgroup of patients? What we saw, grade 3 IRAs in placebo, about 3% and about 11.4% when you added pembro. This is similar to most phase 3 immuno trials. When you look at the IRA grade 3, in most trials, you can blindly say, if someone is asked, what is your grade 3 IRA events, you can say 5 to 10% and you'll be correct. Because in most phase 3 trials, this is what we have learned. When you 5 to 10% will have a grade 3 IRA. Again, it will be very unpredictable. You can't predict who will develop it, but that's something that one has to be very watchful about and very carefully manage those patients. How many of these led to death? No, the IRA, that was only one patient out of the whole sequence, so 0.3%, so really not a worry at all. But how many led to discontinuation? We saw it was 5% of patients had discontinued immuno due to an IRA grade 3 event. So this is something, again, we have seen in all our phase 3 data sets with immuno. So really, not that the adverse events are adding too much toxicity. The adverse event profile is not changing too much by adding immunotherapy in clinical practice in cervical cancer. So this was the summary of the 826 data set. we saw a significant benefit in all the protocol specified endpoints. You saw it in greater than CPS greater than 1%. You saw it in greater than all comers. I didn't show the curves for greater than 10%, but there also the benefit was clearly there. This benefit was irrespective of the type of platinum usage, the type of metastatic setting, whether BEV was used or not used. We saw the benefit in every subgroup of patient. And with these results, this supported the use of pembrolizumab with or without bevacizumab as the standard of care for metastatic recurrent cervical cancer. We saw the NCCN guidelines. Now it's clearly included there right as a category 1, pembro in combination with platin, with paclitaxel, with plus minus bev, depending on your clinical situation, in PD-L1 positive, that is CPS greater than 1%. Now, this is our Indian approval, which we saw from the CGI, and this approval says we have to give it to our cervical cancer patients with CPS greater than 1%. So we can't offer it to all our cervical cancer patients, but the good thing for us is 90% of patients are going to be CPS greater than 1%. The other side is we can offer it to all our patients, whether they are squamous or whether they are adeno, and whether we give BEV or no BEV, we can offer it to our patients. So I think this is a very clear, clean indication for us for cervical metastatic settings where you are improving survival by adding pembrolizumab to the chemotherapy or to the chemotherapy and bevacizumab. Again, we don't have too many data from other trials here. You don't have an actual comparator trial where in some cancers you end up talking about 3 trials together and then you try to compare them and say that maybe this is better or this is better, and that creates a lot of controversy in clinical use, as we will see in the next presentation where we talk about esophageal cancer, where it is so controversial. In cervical cancer, absolute no controversy, adding immuno first line, clear improvement in PFS, clear improvement in overall survival. But yes, mark you, the approval should be for CPS greater than 1%. Right. So let's move on now. So we finished the cervical cancer where there was no controversy to go to esophageal cancer where there is total controversy. And this is one place where, esophagus and stomach, you can sit and debate over for hours and not come to a conclusion. How do you place immunotherapy in clinical practice? And I'm sure everyone here has their own opinion on it. And none of us are right or wrong. You have some approvals, and approvals are not based on all the clinical studies. Some studies have shown something and the approvals have shown something else. And there's so much controversy in what we do in clinical practice. So looking at pembrolizumab in advanced esophageal cancer. 5th most common cancer in India. Also 5th most common cancer in mortality. Esophageal cancer varies a lot in India depending on which part of India you come from. It's clearly one of those cancers where it differs a lot in the type of cancer you see, the histology you see. Some people would talk about squamouses and some would talk of adenocarcinomas with lower, maybe severe type 1 kind of GE junction cancers, and it varies a lot. The standard of care for esophageal cancers metastatic setting has always been, the base has been platinum 5-FU, and this has always been the standard of care. Yes, we do different ways of doing platinum 5-FU. Some would look at a triplet, saying that we want more response, and we know triplets have shown us higher response rates. Adding docetaxel platinum 5-FU give us more responses than platinum 5-FU, but unfortunately the clinical trials didn't show an OS benefit. So that's why the recommendation still goes with platinum 5-FU as an option. Yes, in many parts of India, Asia, all of us in many situations don't do 5-FU also. We do platinum with taxanes, and that's also a regime for esophagus, which doesn't come in from the West, but comes in more from the Asian and our practice, which is perfectly fine to do. But what we have learned by this is whatever you do in metastatic esophageal cancer, you hit an OS of about somewhere around 9 to 10 months. And that's been the situation irrespective of what you did, whether you did a doublet or you did a triplet. That was where you stood with the metastatic setting. So this is Keynote 590 study. This study was reported 2 years back. These days, 2 years is a lot in immuno. You hardly talk about a trial which is 2 years back in immuno. After that, there are around 5 new trials which come in, and the whole data changes. So this is a little older trial, I would say. It already is written up already, and we've seen the whole publication almost a year and a half back. Now, pembro looking at in the first line setting for esophageal cancers with combination with chemotherapy. So the key the eligibility criteria for Keynote 590 was looking at advanced, unresectable, or metastatic esophageal carcinomas. Now here, they did not take only squamous carcinomas. They said it could be esophageal carcinoma, which could be squamous carcinomas, or it could be even the lower esophageal adenocarcinomas. So they took the GE junction Sievert type 1 also. So this trial is histology independent. So that's the first controversy which starts off, when you start comparing trials. This is a histology independent trial. When you start looking at the NEVO trials, you'll start seeing that those trials are histology dependent trials, but not location specific. So that again creates a controversy. Now, these were patients who were treatment naive, so it's a first line setting. And they were looking at a 1:1 randomization between chemotherapy. Here, platinum 5FU was the standard of care versus platinum 5FU with pembrolizumab, 200 mg 3 weekly for 2 years. And that's standard pembro trials. The good thing about pembro trials are all of the trials are 35 cycles, fixed dose trials, very easy to remember, very easy to know. They're fixed dose, they're finite trials. All the NEVO trials will be indefinite trials. Other trials are again dependent on which malignancy you're seeing. But the good thing about all pembro trials are they are fixed duration. So 35 cycles, stop at 2 years if patients are doing well. Now, they had a stratification of looking at whether Asia, non-Asia, a stratification of using adeno or squamous. And it again had a dual endpoint. And the dual endpoint was looking at overall survival. Again, this whole controversy starts off when you have these endpoints where you look at differentials of PDL1. So they took their first endpoint as overall survival in PDL1 greater than 10% CPS. The next was looking at all intent to treat population. And then it was looking at all patients with PDL1 greater than 10%, irrespective of it being squamous and adeno. The PFS also was looked at in a similar way using CPS, intent to treat, and then all CPS greater than 10. There were secondary endpoints of response rate, safety, and quality of life. Now, these are the baseline characteristics. You had about 50% of patients from Asia and 50 non-Asians. Metastatic disease. So there's this is one thing, at least in this clear, is they were all metastatic. Though we say recurrent esophageal cancers, some of these are recurrent unresectable, they would do much better. So that when you club them all together, again, your data analysis becomes different. But here, 90% of patients were metastatic esophageal cancer. Only about 7-8% were unresectable or the locally advanced disease. 73% patients were squamous. About 26% of patients were adenocarcinomas. And even the adenos 26, they looked at whether they were esophageal or GE junction Sievert's type 1. So they did that classification. Now, PDL1 CPS greater than 10%, here is 50%. So about 50% of patients in esophagus you expect will have CPS greater than 10%. This is the primary endpoint of looking at overall survival. And they were looking at it at CPS greater than 10. And what you see, 8.8 months in the comparative placebo arm, going up to 13.9 months in the comparator arm with pembrolizumab. Hazards of 0.57, clearly very significant. If you look at 2 years OS rate, 2 years OS rate is clearly jumped up from 15% to doubling of 31%. So clearly showing that there is a benefit of adding pembro in this population with CPS greater than 10. In the right side, if you see, that's PDL1 CPS greater than 10, all populations. So that includes both the adeno and the squamous, but CPS greater than 10. Again, there's a clear benefit with a hazard ratio of 0.62. This is the progression-free survival data. Again, with CPS greater than 10, what you see, an improvement of PFS from 5.5 to 7.5 months, hazard of 0.51. So clearly beneficial when you added pembro to your chemo. Now look at the subgroups. And that's where, again, the point of interest comes up. Can we tease out a population who has better benefit and not better benefit? We never, with immuno, that's the problem. When you have that huge cost you're giving, when you say give it to everyone, that's the burden of it comes to a clinician's burden that if you don't respond, you're in trouble. And you keep looking for populations where you think you're going to respond better. Maybe that's where you want to spend the money and get response and not use it for patients who are not going to respond. Now, if you look at subgroups, the histology did not matter. Even in the adenocarcinoma, the hazards were 0.74 and the squamous, the hazards were 0.72. So both of them showed equally good benefit in terms of adding pembro. But if you look at the CPS greater than 10, the hazard was 0.62. But if CPS is less than 10, the hazard went down 0.86 and it's cross unity. So you're not really seeing the benefit in patients less than 10, at least in this kind of analysis. What about other endpoints? When you look at response rate, you double the response rate going up from 27 to 51%. Again, duration of response, 5.6 months going to 10.4 months, clearly very significant. So secondary endpoints were also met. Toxicity, again, what we see most of the toxicity is chemo-induced toxicity. Adding immuno is really not adding too much in terms of toxicity. Grade 3 events were 67.6 versus 72%, really not too much different. Immune-related IRA is greater than grade 3 onwards. If you look at it, 2.2 in the chemo arm, going up to 7% in the immuno arm. Again, you are well below in that 5 to 10% range in what you're seeing as toxicity of grade 3 IRAs. So not very toxic in terms of addition of pembro to the chemo arm. Quality of life again was maintained completely even when you added pembro. So so quality of life is really good. So this is how so this was the summary of the trial. So they summarize what you see here in the esophageal squamous cell carcinoma population, CPS greater than 10, you have a clear benefit, hazards of 0.57. If you look at the total esophageal squamous cell carcinoma without the PD-L1, intent to treat 0.72%. And if you look 0.73, and you looked at all CPS without adenosquamous, again 0.62. Clearly telling us it does work, and it works in most of these subgroups. But again, if you want to tease out subgroups, CPS greater than 10 is where you're seeing the maximum benefit. Possibly that's what's driving when you look at all the patients together. That's why when you looked at especially only CPS less than 10, the benefit is lesser there. The safety was no new safety signals. It was clearly very well tolerated, and quality of life was well maintained. These are the NCCN guidelines. They have put it there clearly for a patient. So where does this come from now is when you have a keynote 590 and we have seen the esophageal data from the checkmate 648 data. So Matthew, Nivo, checkmate 649 was the data for the stomach, which is approved in India, but 648 is the esophageal data where you've looked at purely squamous population. And that was looking at platinum 5FU plus Nivo versus platinum 5FU. And you saw a benefit again there in all the patients, more than CPS. Again, there, the CPS1 was where the benefit was. But if you look at guidelines and approvals, Nivo has been granted FDA approval as first-line setting for everyone, irrespective of PD-L1, though the trial did not show that same benefit. In India, we don't have any approval of first-line nivolumab in squamous cell carcinoma, in esophageal carcinomas. So this is probably the first data for us in India where we can use immunotherapy in the first-line setting. If you see our approval in India, this is how the approval is. It is pembro in combination with platinum 5FU, first-line therapy. It can be any metastatic carcinoma esophagus. It can be squamous or it can be adeno. But it has to be HER2 negative and it has to be CPS greater than 10 of PD-L1. So this is something that we'll have to align ourselves when we start using pembro in our first-line practice. We'll have to start really insisting on the CPS score for all our squamous cell or adeno-CS esophagus if you're thinking of offering them pembro. But I'm quite excited about this. The reason is we did not have any immuno to offer our first-line patients. We have been looking for this for the last couple of years since this data came out 2 years back. But we were not able to offer anyone immuno in first line. And it becomes very difficult in practice because you tell your patient you can't offer first line, then they progress second line, then you say, I can offer you third line immuno. And there you know the responses are not great at all. But third line approval is there. So that's where the whole dilemma comes into practice. So this is at least gives an opportunity of putting immuno right in first line. Yes, in the US, they could do IO immuno first line. FDA has approval directly without any PD-L1 with Nivo as in esophagus and also in stomach. But in India, we have to really divide our patients. In stomachs, we have only approval of Nivo FOLFOX irrespective of PD-L1. And in esophagus, this is the new approval which we have. So CPS greater than 10, pembro chemo can be offered to our patients. Thank you very much.
Yeah, Amit, it's an excellent, whenever we hear the enthusiasm, peeps out very nicely. 2 questions. One is on cervical. The experimental arm versus the control arm. If you see the control arm of BEV, is almost equivalent or slightly better than the IO alone arm of no BEV. And if you know, graphs are glaring. So you have to choose only one. You know, of course, we all know if the patient is eligible for both, definitely IO plus BEV plus chemo is the superior to all. But if you have to choose only one between BEV and IO, going by the cost and other parameters, what would you choose? That is my first question. Esophagus may CPS more than 10. Was it an exploratory or they had predefined that?
It was
Predefined.
So secondly, it was predefined. So they clearly looked at that, and that's their first primary endpoint. So they did that in sequence, greater than 10, intent to treat, and then. So to your first question, I know. So I always think, you know, we shouldn't. So it's the same way as when you use BEV anywhere in practice. You know, you shouldn't probably integrate that decision making. If you need BEV, put BEV. I would say that way in cervical cancer. If it's an indication for BEV, please use BEV directly. If there is too much of a risk factor for BEV, then you can avoid it. The practice in India, BEV cost is not great. So you really are not worried about it, you know. You're only worried of fistulas. I've seen patients and had patients who had a fistula. I've had patients in cervical cancer who had operation. I didn't have a bleed in cervical cancer, but we have seen all this. So we worry a lot about BEV in that situation. But I think if you have a clear-cut metastatic cervical cancer who comes with liver mets, lung mets, or any of those, clearly BEV will help. It's only those post-CTRT patients where we start worrying too much. So I think that decision should not be integrated with that. BEV should be there, and then add the pembro. The same thought will come always for pembro is maybe you will become a long-term survivor. Of course, we just have data for 24 months, so I don't know that in this cancer, but you never know, 3-4 years down the line, we may have long-term results. So no, I would say absolutely no. The extrapolation for a indication doesn't make sense. But there is a study, there is some data for already for vaginal cancer, squamous cell carcinoma vagina. There is already some data sets, but they're not phase 3 data sets. But they have actually, there is small studies which have shown immunoaddition is making a benefit in these cancers also. But yes, we should wait for trials.
Just one
absolutely no idea.
And also you get HPV patients doing well. Here you had 87% of patients who were HPV, I mean, not HPV positive, they were PDL1. So have they stratified that data? Have they done a subset analysis for HPV in that?
I don't think they've even, I think it's a very interesting question. I will look at this and try to get back on this. It's a very interesting thought that does HPV make a difference in terms of survival in these group of patients?
And if it does it mean that the virus itself is immunogenic or responsogenic, whichever way you want to put it? In two different malignancies, if you see this, that immunotherapy also works better.
So the data of viral-induced malignancies with immuno is so varying. You're just not able to answer correctly. Like look at HCC. And we're not able to even clearly say these are the patients who will benefit. Sometimes you say yes, and some trials say no. But I'm interested in this question which you asked me. I think we should just ask, we should get back to them, and I will look at this.
Yeah, Amit, excellent presentation. One point I wanted to add is that among the toxicities of bioacquisition, one should always add limb ischemias. They do happen once in a blue. Once you see them, you'll never forget it. So, besides fistulas and perfect.
Limb ischemia due to the immuno.
Yeah, because of the bioacquisition. It's okay. Yeah, I've seen colon cancer, I've seen in cervix cancer. So.
Okay.
Just want your comments, please. Yeah. In cervical cancer, you have CPS score more than or equal to 1 compared to esophageal, where you have drawn a line. It should be more than or equal to 10. Why is it so?
So the whole thought is, so CPS per se for us comes out from every cancer, and we start defining, we start defining what population has a CPS positivity, and second, you start defining which population will probably respond better. Now, what we are learning is CPS, so it's not the same in every cancer. You yourself see in cervical cancer, the immune infiltration is so much that probably this is being driven by the ICs rather than the PCs. And that's my thought. The immune cells are so much that the whole thought is that CPS is very high. And that's why you have a 90% patients who have immune cells there. But if you look at varying cancers, the CPS rate varies. But for cutoffs, all of us start looking at somewhere you have to draw a cutoff for response. Always thought is CPS more than 10 should respond better, more than 5 should respond probably better than 1. But this is not panning out. And sometimes you see the response is same whether your CPS more than 1 or more than 10. It's not very different. So the problem for us becomes, as clinicians using immuno, one needs to know which cancer we are treating, which PD-L1 we are looking at, which scoring we are doing, and then follow the guidelines. And the guidelines are varied. But the good thing about some guidelines is like FDA has clearly just given blanket guidelines. You don't bother about PD-L1 for esophagus and stomach. But that's not the way it is in India. So we have to follow the guideline.
Thank you.
Yeah, we
Shortly, we are starting the inaugural function, so everybody can take this. Yeah, sure. Good afternoon and a warm welcome to all the dignitaries, faculty, and delegates with immense joy and great exultation. I feel privileged to welcome all the privileged to welcome all to the inauguration function of 4th Immuno-Oncology Society of India, IOSICON, organized by Dr. Hemant Malhotra, Dr. Jyoti Bajpai, Dr. Lalit Mohan Sir, and Dr. Ajay Yadav. On this auspicious occasion, it is a proud privilege to invite our honorable guest to please the grace to the dais. Dr. Vikas Surankarji, sir, Chairman of the Mahatma Gandhi University of Medical Sciences and Technology, Dr. Sudhir Sachdevji, sir, the President and Vice Chancellor of MGU MST, and Dr. Ganesh N. Saxena ji, sir, the Pro-President of MGU MST. And I also invite the organizers of the conference to take the seats on the dais. And let me put forward a big thank you to all the one who are assembled here on this occasion with us. We are overwhelmed with your presence, sir. We are overwhelmed with your splendid response. So for seeking the choicest blessing, we invoke Goddess Saraswati by kindling the lamp of knowledge and wisdom. So I request our honorable guest and the organizers to please light the lamp.
तुषारहार या शुभ्रवस्त्रावृता या तुषारहार या शुभ्रवस्त्रावृता या
Happiness. So I thank each one of you for lighting the lamp. Now I request Dr. Hemant Malhotra sir to honor the chairman, MGU MSD, Dr. Vikas Swarnkarji, with shawl, memento, and pagdi.
आपको टोपी पहनाने की परमिशन टोपी नहीं तो देश बहाने से सुधीर जी का एक्सपर्टीज है सर इसमें
Thank you so much, sir, for such a kind gesture. Now I invite Dr. Lalit, sir, to welcome our President and Vice Chancellor, Sir Dr. Sudhir Sachdevji, with shawl, pagdi and memento. Thank you so much. Now I request Dr. Ajay sir to welcome our Co-President Sir Dr. Saxena ji with shawl and memento. Thank you so much to all the organizers for welcoming our guests so honorably. Now moving ahead, I would like to invite our Director of Shriram Cancer Center and MGU MSD, Dr. Heman Malhotra, to give us a welcome address. Thank you.
Thank you, Priyanshi. Dignitaries on the dais, Honorable Dr. Vikas Chand Swankar, our head of the institution, our chairman, Honorable Dr. Sudhir Sachdev, my very dear friend and the Vice Chancellor of this institution, Dr. Ganesh Narayan Saxena, teacher of teachers, my teacher, co-president of this institution, Dr. Jyoti Bajpai, very dear friend, Professor of Medical Oncology from the Tata Memorial Cancer Center, Bombay, and the Secretary of the Immuno-Oncology Society of India, my very dear friend, Dr. Lalit Pawan and Dr. Ajay Yadav, members of my team here at Shriram Cancer Center, Mahatma Gandhi Medical College Hospital, my dear friends from all across the country, ladies, gentlemen, friends, members of the press, welcome to this inaugural function. And before I forget, my better half is also sitting here. Welcome to this function and thanks for your help. So, ladies and gentlemen, in addition to welcoming you to this conference, this fourth annual conference of the Immuno-Oncology Society of India, I'd like to give you a snapshot of the highlights of this meeting. For this conference, which is focused on one of the most recent advances in oncology, meaning immunotherapy, we have 12 international faculties helping us in this. Most of them have been connected online with us. We have close to 60 national faculty from all across the country. We have faculty from Nepal. We had faculty from Bangladesh join us online yesterday. And we have delegates, our own students and researchers from all over the country. This organization is a healthy mix of clinicians and basic researchers. And it is my privilege to welcome the basic researchers who have done really pioneering work for this conference here to this, our institution and to this hall and to this conference. Immunotherapy, you would be aware, is a new field, not really a new field, been around for a long time, but it's taken a real quantum jump in the past 10 years. We are now able to identify the defense mechanisms of the cancer cell. We are able to identify the shield which the cancer cell shows to our immune cells. The immune cells recognize the cancer cells as self and do not destroy it. So now we have ways and means to destroy this shield. And that is what immunotherapy is all about. We can do it by monoclonal antibodies, which are proteins injected in the blood, or we could do this by tweaking the immune cells of the patient, which is known as the cellular therapy. One of the very successful forms of cellular therapy is CAR T cells. And I'm really privileged to welcome to our institution the two pioneers of CAR T cell therapy in our country. And very soon, I think this year or at the most next year, they will have the Indian car on the roads for us to use and drive for the benefit of our patients. And Dr. Gaurav Narula from Tata Hospital, pediatric oncologist, and Dr. Rahul Pawar from IIT Mumbai, they have made this Indian car, and we are really, really proud of these two gentlemen, in addition to so many other people working in the immunology field and in the oncology field. So once again, welcome to this conference, welcome to our institution. Please find some time to look at our department. We are a young department, but we are a growing department. We have a 6-bed transplant unit. At the moment, 2 patients of allogenic transplant, haplotransplants are admitted. So our transplant program is really taking off. And we have all the facilities for a comprehensive cancer center, excellent surgical oncology support, excellent radiation oncology support. The chief of radiation oncology, Dr. Shahid, is sitting here. And we are ready to take on immunotherapy. And if everything goes well, maybe we will manufacture the CAR T cells in our own institution. So with these few words of welcome, I'd like to take my seat, and thank you for being here, all the delegates, all the faculty, and let's hope that we make this conference a good conference, not only academically, but also socially. Thank you very much.
Thank you so much, sir, for welcoming all the dignitaries and guests delightfully. So now moving ahead, now I would like to say a few words for our honorable chief guest, Shri Dr. M.L. Swarankarji, Chairman and Managing Trustee of MGU MST, who has been the founding father and the backbone of this institution. It's his vision and execution that first private medical university was established in North India, and it is a great height in all specialities, who could not be physically presented due to certain commitments. And we would be playing his recorded message for blessings and motivating this auspicious gathering. Thank you.
I'm really very happy that 4th National Conference on Immuno-Oncology Society of India is being organized at Mahatma Gandhi University of Medical Science and Technology, Jaipur, this morning. And our center, which is Sri Ram Cancer Center, which is headed by Dr. Hemant Malhotra, who is also the organizing secretary and chairman of this conference, is doing wonderful job by doing all these academic activities. I'm really proud of all of our specialists in different branches of the oncology, like surgical, radiological, medical, and immunotherapy is again a very important branch or modality of the treatment for the cancer, especially the advanced stage cancers. And these drugs are very costly drugs. So with the interaction from the different regions, the delegates who have come here, they will exchange their ideas, and I hope some fruitful discussions will result into the benefit of the patients, and the cost, which is very high, of the immunotherapy will come down in the near future. That is what we expect. And I welcome all the delegates who are participating in this conference, all the faculty members participating in the conference, to be the part of this conference, and I wish them successful meeting. my best wishes are there with the organizing committee, with all the members of the Congress. Thank you very much.
Honorable Sir, your kind words for the program has encouraged us a lot and made us more confident in the past, in the future lives. So we missed your physical presence, but you are present in each and everyone's heart. Now, I request IOSI Secretary Dr. Jyoti Bajpai, an eminent oncologist at Tata Memorial Hospital, to present the report of the association.
So thank you very much, Priyanshi. And dignitaries on the dais, the faculties from overseas who are with us virtually, the national faculties, and each and everyone. So it is extremely humbling for me to stay today and discuss about Immuno-Oncology Society of India. It's a very special relation with this, kind of our kid to me. So right from the conception of the society in 2018, when it was looking a Herculean task, until today, we have really made steady progress, and I'm really thankful to each one of you, each member of Immuno-Oncology Society, whose contribution is tremendous, and especially in the initial days when it was conceptualizing and gradually developing. All the founders members has taken all the pains and trust that this endeavor is worth, and it should be making a progress. So at present, after its conception, now we have taken few steps, and now we are part of World Immuno Council as a partner. So these are 20 partners world over, and they have chosen Immuno-Oncology Society of India also, one of those. Every year with the Society of Immunotherapy of Cancer, which is the biggest society, SIDSI we call it as. With the sidelines of that meeting, the World Immuno Council is having their symposia where every year we are invited to present our important data. Besides that, we are also having other international collaborations like with SIDSI, and now it is a formal collaboration also which is in progress. So Society of Immunotherapy of Cancer and Immuno-Oncology Society of India, we are now jointly spreading the awareness and education towards immuno-oncology. And today also we will be having a joint symposium wherein SIDSI faculty, the leading, they are essentially the giants in the field. They are joining us in the cyberspace for biomarkers and toxicity session. So that is one of the collaboration I would like to highlight, which is really would be beneficial to bring in more and more trials in this country to increase access of these expensive molecules to our patients. Another thing, the another collaborations are with ESMO, that is the European Society of Medical Oncology, and its immunotherapy wing. And we are having every year their faculty who are visiting us, who are connecting with us on several fronts, and we are having collaborative links with them. We are also establishing links with other Asian societies, and several endeavors are in progress as well. Besides that, now we are endorsing MD Anderson affiliated journal, the JIPO, which is a Journal of Immunotherapy and Precision Oncology. So Dr. Ong Liang, which was our past faculty who visited us in person as well for our National Annual Congress of Immuno-Oncology Society of India. And he is the chief editor. I'm privileged to be on the editorial board for a few years. And now our society has, officially endorsing JIPO as an official journal. And there are many collaborations and collaborative efforts which are in progress. Every member of Immuno-Oncology Society will have benefits, including to have a chance in publishing to JIPO with a very discounted rates. Our society annual meetings are being promoted by JIPO, and our proceedings and abstract links are being published in Journal of Immunotherapy and Precision Oncology. So there are several other things also which are in progress. But I will, in the interest of time, I will not, discuss everything. We will be releasing our newsletter also soon today, which is a society newsletter we are, kind of releasing every year. And that will also give you some information. We are now 500, nearly 500 members, which are part of Immuno-Oncology Society. And I'm hoping that each and everybody who is present here should be a member after this inauguration. So with this, I thank each and everyone who are helping us in growth of the society. And thank you very much on behalf of my organizing team as well. We welcome all of you. Thank you very much.
Thanks a lot, Dr. Jyoti ma'am, for detailed report. Now, I request Dr. Ajay Yadav, Senior Professor, Medical Oncology in MGU MST, to carry out the award distribution ceremony.
Dignitaries on dais and dear friends, for excellent work in the field of oncology, we have decided to honor our people from various states in India. We have two categories of awards. One is for scientists and next is for clinicians. So we have 3 names in the list of excellence in scientific work and 4 names for the clinicians who have excellent work in field of oncology. So first, for scientific work, I announce name of Dr. Anil Suri. Give a big hand to sir. Sir, please come on the desk. Anil Suri sir is a well-known figure. He is an eminent cancer researcher working in the field of translational cancer research. He is former professor of eminence, National Institute of Immunology, New Delhi. He is an elected fellow of National Academy of Medical Science and elected fellow of National Academy of Science, India, an editorial board member of Cancer Research Journal, and elected executive member of Indian Association of Cancer Research. He is vice president of Indian Society for Study of Reproduction and Fertility. Currently, sir is associated with us at MGU MST. He is director of Center for Cancer Immunology at Shri Ram Cancer Center, Mahatma Gandhi University. Next award for scientific activity goes to Dr. Rahul Purwal. He is Associate Professor at Department of Bioscience and Bioengineering, Indian Institute of Technology, Mumbai. He has done his PhD from Hannover Medical School, Germany. He was Research Fellow at Harvard Medical School and Scientist at Immuno Journal, USA. He has several publications and patents to his credit. He is also ad hoc reviewer of Journal of Immunology and several other journals. He is an academician turned entrepreneur and founder of Immuno ACT, which has in news of us are aware of. Thank you, sir. Next award in this category goes to Dr. N.K. Mehra. So his flight is delayed, so he will join us in the evening. He is an immunologist and head of Department of Transplant Immunology and Immunogenetics at SRL Limited. He is former Dean of Research and holds the ICMR Dr. C.G. Pandit National Chair at AIIMS and elected Fellow of International Medical Science Academy and the World Academy of Science, the Indian Science Academy and National Academy of Science, India. Now we move to clinical work. And first name on this category is Dr. Purna Kurkure. She is among senior most pediatric oncologists in India and Southeast Asia. She established the Department of Pediatric Oncology at Tata Memorial Hospital, Mumbai. She has been teacher of many of us. Her major achievement is development of ACT clinic, after cancer therapy clinic. She has made a group of pediatric centers, cancer survivors called UGAM. Many thanks, ma'am, for your contribution in oncology. Next award goes to Dr. Raghunath Rao, sir. Give a big hand for sir. Sir has been one of the senior most person to put all the efforts in developing medical oncology in India. He has been teacher of excellence and pioneer of bringing clinical trials in India. Many of us got training under him, and he is very much concerned about cost-effective cancer therapy, and he has various publications in different journals. Thank you, sir. Next award goes to Dr. K. Govind Babu, sir. Sir has been the head of department, Kidwai Medical College, Bangalore. He has contributed in many clinical trials in India as well as at international level. He has served as president of Indian Society of Medical and Pediatric Oncology and president for SAARC countries. Currently, he is head of Department of Medical Oncology at St. John's Medical College, Bangalore. And next award goes to Dr. Purvish M. Parikh, sir. Purvish sir is well-known figure in the field of oncology and hematology. Purvish sir has served as HOD of Department of Medical Oncology at Tata Hospital, Mumbai. Currently, sir is associated with us at MGU MST as Head of Department of Clinical Hematology. Sir has been pioneer in doing collaboration work in the field of oncology. He has established Indian IOSICON, Indian Cooperative Oncology Network, and which held many meetings per year. He is one of the top medical oncologists to have highest number of publications. Thank you, sir.
A very kind gesture by Dr. Ajay Yadav. Thank you, sir, for conducting the award distribution ceremony. Moving ahead, I would like to request Dr. G.N. Saxena, sir, Pro-President of MGU MST, to deliver some kind words to the audience.
Good afternoon, everybody. Dr. Vikas Swankar, our chairperson. Dr. M.L. Swankar, emeritus chairperson, who is not here physically, but he's online with us. He just gave his address. Dr. Sudhir Sachdeva, Dr. Jyoti Bajpai from Tata Memorial Hospital, Dr. Hemant Malhotra, Dr. Ajay Yadav, Dr. Lalit Mohan, and all the faculty members and guests present here. It's been a very fine conference that started yesterday, and I attended some sessions. And what I found interesting was the interaction between the Ayurvedic drugs and malignancy. And I'm sure in the coming years, this interaction will grow further, because the talks that were there yesterday in the session on Ayurveda included the Vice Chancellor of the National Institute of Ayurveda, and then we had doctors from Bombay, Mumbai, and other people who were attending. And with the tide turning in favor of the Indian systems, I'm sure more and more funding will be available for such endeavors and such trials. As it was mentioned yesterday, in that if we keep copying the West further, or we just start doing trials which are copies so that we can get the permission from our DCGI, DGCI and things like this, then we'll never be able to catch up. We can just hop, step and jump straight on by using molecules which are present in our system, which have been around for hundreds, if not thousands of years. And anything which has been present in continuity for thousands of years definitely needs a second say. There have been several hundred years now when these things have not been promoted, but the yesterday's session told me that such things are taking place, and I wish the immuno-oncology, or others, oncology especially, because this is one field where Ayurveda is very often looked at by patients, that maybe they have some hope where others don't. So I hope and wish all the delegates have had a good time and a good academic time, and also a pleasant, the weather is very pleasant at the moment, so they enjoy their stay in the Pink City. Thank you, everybody.
Thank you so much, Dr. Saxena, sir, for delivering such a kind words. Now I would like to request Dr. Sudhir Sachdev, our Vice Chancellor, MGU MST. He has been the pillar of MGU MST since its very inception, to deliver his words of wisdom. Thank you, sir.
नमस्कार। इम्यूनो ऑन्कोलॉजी सोसाइटी ऑफ इंडिया की इस चौथी कॉन्फ्रेंस में आज पूरे राष्ट्र से, बाहर से भी अभी डॉक्टर हेमंत मल्होत्रा जी ने बताया कि तमाम डेलीगेट्स इसमें हिस्सा ले रहे हैं, और वो लोग जो कि इम्यूनो ऑन्कोलॉजी में बहुत एक्टिव रूप से हिस्सा ले रहे हैं, जिनका नाम पूरी दुनिया पहचानती है, ये बड़े ही हर्ष का विषय है। मैं आप सभी का हृदय से स्वागत, अभिनंदन करता हूं। महात्मा गांधी विश्वविद्यालय की तरफ से हमारे एमेरिटस चेयरपर्सन डॉक्टर एम.एल. स्वर्णकार जी, जिनका कि अभी आपने संदेश सुना था, जो कि फाउंडर हैं इस विश्वविद्यालय के, इस संस्थान के, जिन्होंने इसकी संस्थापना की, जो हमारे प्रेरक हैं, जो हमारे मोटिवेटर हैं, डॉक्टर एम.एल. स्वर्णकार जी। हमारे आज के समारोह के माननीय अतिथि, परम आदरणीय चांसलर चेयरपर्सन डॉक्टर विकास चंद्र जी स्वर्णकार, प्रो वाइस चांसलर डॉक्टर गणेश नारायण जी सक्सेना, डॉक्टर हेमंत मल्होत्रा, डॉक्टर ललित मोहन, डॉक्टर अजय और डॉक्टर ज्योति वाजपेयी, और भी मैं सामने देख पा रहा हूं कि सभी बड़े गणमान्य चिकित्सकगण, सारे कई कैंसर से जुड़े हुए हमारे जितने भी विभाग हैं, उनके सारे विभागों के सभी लोग यहाँ उपस्थित हैं। विशेष रूप से मैं डॉक्टर भारती का भी स्वागत करूंगा इस अवसर पे, जो कि मेरी क्लासमेट भी हैं और एक प्रोफेसर, सीनियर प्रोफेसर हैं माइक्रोबायोलॉजी की, एंड शी इज बेटर हाफ ऑफ डॉक्टर हेमंत मल्होत्रा जी, जिनको वो भी आभार दे चुके हैं। आप सभी का हृदय से स्वागत और अभिनंदन। महात्मा गांधी विश्वविद्यालय सन 2000 में विश्वविद्यालय की स्थापना हुई और महात्मा गांधी विश्वविद्यालय मेडिकल कॉलेज, डेंटल कॉलेज, नर्सिंग कॉलेज, फिजियोथेरेपी कॉलेज, ऑक्यूपेशनल थेरेपी कॉलेज, कॉलेज ऑफ हॉस्पिटल एडमिनिस्ट्रेशन, हेल्थ इंफॉर्मेटिक्स एंड कॉलेज ऑफ पैरामेडिकल साइंसेज, तमाम संस्थान कई वर्षों से यहाँ हम चला रहे हैं। मेडिकल कॉलेज में प्रतिवर्ष 250 विद्यार्थियों को प्रवेश मिलता है यूजी एमबीबीएस में, और एमडीएमएस कोर्सेज में, ब्रॉड स्पेशलिटी में प्रतिवर्ष 167 एडमिशंस पर एनम होते हैं। डीएमएमसीएच कोर्सेज में 64 एडमिशंस पर एनम वर्तमान में है, जिनको कि हम सन 2025 में विश्वविद्यालय अपना रजत जयंती समारोह मनाने जा रहा है, तो हम कोशिश करेंगे तब तक की संख्या और अधिक बढ़ सके, जैसा कि हमारे एमेरिटस चेयरपर्सन डॉक्टर अमित स्वर्णकार जी चाहते हैं, और उन्होंने तमाम सुविधाएं भी हमें उपलब्ध करा रखी हैं। लगभग सभी विभागों में पोस्ट ग्रेजुएशन, सुपर स्पेशलिटी सारी फैसिलिटीज हैं। श्री राम कैंसर सेंटर हमारे फाउंडर ट्रस्टी श्री राम जी लाल स्वर्णकार के नाम पर है। श्री राम जी लाल स्वर्णकार के नाम पे ये एसआरसीसी श्री राम कैंसर सेंटर, इट इज ए कॉम्प्रिहेंसिव कैंसर सेंटर, जहां मेडिकल ऑन्कोलॉजी, सर्जिकल ऑन्कोलॉजी, रेडिएशन ऑन्कोलॉजी, न्यूक्लियर मेडिसिन, डिपार्टमेंट ऑफ इम्यूनोथेरेपी, पैलिएटिव केयर, सभी तरह की सुविधाएं उस एक छत के नीचे अवेलेबल हैं। डॉक्टर हेमंत जी ने आपको बताया कि बोन मैरो ट्रांसप्लांटेशन भी हम लगातार कर रहे हैं। तो इन सारी व्यवस्थाओं में आप सब लोग यहाँ आप पधारे, आपने संस्थान को देखा, और इन 2 दिन 3 दिन की आपके इस कॉन्फ्रेंस में डॉक्टर स्वर्णकार जी ने भी कहा कि निश्चित रूप से आप लोग किसी नए विचार की तरफ बढ़ेंगे। इम्यूनोथेरेपी पिछले कुछ वर्षों से जब से आई है, एक युग बदलने लगा है, और अब हम इस उम्मीद में हैं, बहुत वर्षों से हैं, लेकिन एक जगह आकर के उम्मीद साकार होती है। वो समय दूर नहीं है जब आप सब लोग मिलकर के प्रयास करेंगे, और हम कैंसर पर रोक तो हम प्राप्त कर चुके हैं, लेकिन हम कैंसर को बिल्कुल समाप्त कर सकें, एक स्टेज में हम रोक देते हैं, समय से पता लग जाए तो उनका निदान कर देते हैं, लेकिन आने वाला समय बहुत उज्जवल होगा ऑन्कोलॉजी के लिए, इस इम्यूनो ऑन्कोलॉजी के लिए। मैं इस अवसर पर आप सभी को बहुत बहुत शुभकामनाएं देता हूं, और इस कॉन्फ्रेंस की कामयाबी के लिए अपने बेस्ट विशेस आप सबको कन्वे करता हूं। आपका यहाँ स्टे सुखद रहे, और यदि किसी प्रकार की असुविधा हो तो कृपया बियर करें। बहुत कोशिश करते हैं, हो सकता है कुछ कमियां रह जाए, लेकिन आप सब लोग इसको एंजॉय करें, अपना ध्यान रखें। विश्वविद्यालय की तरफ से आप सबको बहुत बहुत शुभकामनाएं। थैंक यू वेरी मच।
A very kind and valuable advice given by Dr. Sachdev Sarji. Now, I would like to request our dynamic and ever-smiling personality, Dr. Vikas Swarnkar ji, the chairman of MGU-MST, to deliver your address and enlighten the gathering.
Very good afternoon, distinguished guests on the dais. Our guest, Dr. Jyoti Bajpai from Tata Memorial Hospital, Mumbai. Vice Chancellor of the University, Dr. Sudhir Sachdev. Pro Vice Chancellor, Dr. G.N. Saxena ji. Director and the head captain of our oncology program and oncology center, Dr. Hemant Malhotra ji. His very dynamic team, Dr. Ajay Yadav, Dr. Lalit Mohan Sharma, and members of his team sitting in the audience. I welcome you to the 4th Annual Congress of Immuno-Oncology Society of India. It's a great pleasure and a privilege to welcome all of you to this venue. I congratulate the organizers on getting this event to the university, and also wish the success for the forthcoming part of the program. There has been a sea change in the last years in the healthcare sector. whereas changing profile of emerging diseases, rapid growth in healthcare technology are placing healthcare challenges to meet the demand. This is a great opportunity and occasion for all of us as medical fraternity to interact with eminent personalities in this field and from the field of oncology as well. The university is having a well-equipped Center for Cancer Immunotherapy and Research, which is being led by none other than Dr. Anil Suri, whom the organizers were gracious enough to award this afternoon, wherein high-end point-to-point research is being conducted on dendritic cell vaccines for reproductive cancers. Immunotherapy has evolved from an option on the lab bench to a therapy that's available on the bedside, and that's making a difference in the outcomes. However, more data and trials are needed to test the safety and efficacy of various immunotherapeutic regimens and their combination with present modalities. We are at the optimum level of technological advancement due to ready and affordable availability of genome sequencing and similar technologies through various platforms. And at the same time, there is a reasonable degree of awareness amongst the medical doctors, and demand about it is ever increasing. More interdisciplinary cooperation and interaction is needed in the field, along with collaborations from non-oncology immunology at all levels, that is the institute, national and international, to enhance our knowledge, especially related to therapeutic window, adverse drug reaction, possible resistance to this therapy, monitoring of effects, etc., to name a few. I would like to take this opportunity to offer the help of or assistance of Mahatma Gandhi University and Shri Ram Cancer Center, along with Mahatma Gandhi Hospital, to assist, partner, and volunteer in this direction with the eminent personalities in the field of immuno-oncology. It is for your kind acknowledgement that Mahatma Gandhi University of Medical Sciences and Technology has a medical college with 1,460 bedded multi-speciality hospital, a DCI recognized dental college, nursing and physiotherapy college, hospital administration college, as told by our Vice Chancellor. This has revolutionized the private sector in the field of medicine, especially in the state of Rajasthan. As a university, we aim at taking the education of medicine, the practice of medicine, and medical research to the best possible level. The effort and direction have been made not only at the state level, but also nationwide. The university is at the forefront in providing comprehensive and cutting-edge healthcare to the patients. Mahatma Gandhi Hospital is the primary and renowned hospital in the field of transplant and is doing almost 2 kidney transplants every day and has a done of cumulative more than 1,400 transplants so far, 50 liver transplants so far, and having pioneered the first heart transplant of the state and revolutionized the work in bone marrow transplant, both thalassaemic and neoplastic indications of bone marrow transplant. Dr. G.N. Saxena is sitting here. So the development of thalassemia-related bone transplant at the Southeast Asia Center of Transplantation goes to Dr. Saxena and his wife and his entire team. And for neoplastic indications, Dr. Hemant Malhotra and his team, Dr. Ajay Yadav, Dr. Lalit Sharma, Dr. Priyanka Soni, they are doing a wonderful work in the field of bone marrow transplant. The hospital has good technological infrastructure and medical facilities that allow safer, better, and comprehensive care with success rate at par to global standards. The institute is supported by world-class services in oncology, transfusion medicine, pathology, and other fields like cardiology, endocrinology, nephrology, and pulmonology, all of which combine together to give the patients and the students an extra edge in treatment and training, respectively. The university is already running comprehensive MD programs in the allied fields of oncology like nuclear medicine and palliative medicine. Also DMMCH programs in medical oncology, surgical oncology, radiation oncology, and oncopathology. But I can foresee with this interaction and with this gathering that have come here that DM in immuno-oncology is not far. And probably next 2 to 3 years, it's going to come, and onus is on you as medical oncologists to keep it safe with you, or it, diversifies itself as a new field like DM and immuno-oncology. But the way the technology is evolving, the way it is specializing, where the specialists are coming up, I think it's a reality, and it would be a welcome development in patient care and training once the science expands so far. Thank you so much, everyone, for giving me this opportunity to interact with you. And I would like to use this platform to humbly acknowledge that it was my privilege and my honor to welcome such stalwarts and such dignitaries, and also award them with various awards as decided by the organizers. So the good fortune is mine. And I hope you will enjoy the future and the forthcoming sessions of this academic feast. Warm hospitality of Dr. Hemant Malhotra and his team and the university, and also enjoy Jaipur as a city and go around and enjoy yourselves in the conference. Thank you so much for coming to this place, and thank you.
Thanks a lot, sir, for taking out your precious time to be with us and motivate us. Our organizing team is really grateful to you all for all your support and guidance at each and every step. And every step of this is initiative. Now, again, I would like to invite Dr. Jyoti Bajpai for unveiling the newsletter. Yes, sir, everyone can join. Thank you so much, all of you, for unveiling the newsletter. Now, I would like to request Dr. Lalit Mohan, sir, to please deliver the vote of thanks to all.
So thank you so much, Priyanshi, and dignitaries on the dais, our chairman, Dr. Vikas Swarnkar, Dr. J.N. Saxena, sir, Dr. Sudhir Sachdev, sir, my guru, Dr. Hemant Malhotra, sir, Jyoti, and Dr. Ajay. Dignitaries of dais, my gurus, my teachers, and all the faculty members. First of all, I'm thankful to Indian Society of Immuno-Oncology, and special thanks to Dr. Jyoti Bajpai for selection of Jaipur to give us the 4th national conference. And then I'm thankful to Dr. M.L. Swarnkar, sir, Dr. Vikas Swarnkar, for giving us opportunity to host this meeting in the premises of Mahatma Gandhi University of Medical Sciences and Technology. My special thanks goes to Ratanji Soni. In fact, when 2 days back, we were told that the auditorium will be used by some other function, which was unavoidable. So Soni sir personally took us to RK block. He showed us all other facilities, and he shifted very gracefully our academics on day one in the another building, RK block. And he offered us very good food, as well as on the rooftop we had enjoyed the dinner also yesterday. So special thanks goes to him, because we were on the last moment very much upset that what will happen, how we will organize, but he took very personal attention of all the needs of us, and I'm really thankful to him. I thank all the faculty members to whom we have interacted on each platform for each session, who will be chairing the session, who will be the panelists, who will be taking the lecture part, who will be moderating. So we interacted with them at many odd hours also, and many times we bothered him Dr. Bhushan Ranade, I informed him 2 days back that you need to take the lecture and you can't say no to this. So I'm really thankful to them. And again, I thank from bottom of my heart that they all have agreed on very short notice and we got full support from the respected faculty members. I thank all the young budding students and scientists, those who have presented their abstracts and their posters. And during the conference, we have more than 40 posters and abstract presentations. And in fact, it was so interactive that we were excited and thrilled. And the time given was short, looking to the interest of audience and the question answer sessions. I am thankful to all the MGUMST staff, my Department of Medical Oncology and other oncology fellows of radiation oncology, surgical oncology, and other colleagues, my residents who have helped me in designing the scientific agenda and helping us on day-to-day basis for various activities. I thank MICE Idea team, Rajesh Sharma ji, Priyanshi, Neerav, and many other partners who have worked day and night to make this conference and to make this scientific agenda very crisp, to make your stay, your travel, your food, everything very comfortably. My sincere thanks goes to Parikji, who has been pioneer in organizing the awareness activities, and about the media also is helping us. And he managed the interaction between the Ayurvedic and Ayurveda system as well as this, and he managed to call the top people from Ayurveda also. And I'm happy to share that we have got a official MOU which is to be signed between the National Institute of Ayurveda and Mahatma Gandhi University of Medical Sciences and Technology. We will review and then we will get it done. I'm thankful to Honeydew Restaurant, who is helping us for beautiful meals also. And after the ceremony is over, you will have lovely food. I'm thankful to them also. I thank all the pharmaceutical companies who are supporting us, and especially the oncology pharma companies, which are the manufacturer of immuno-oncology products, because these are the products which we are using to our patients, and we are able to do research based on the pharmaceutical products. So I'm really thankful to pharma companies for bringing up molecules for research as well as for clinical use to us. I am thankful to all the patients who are taking active role and active participation in various clinical trials, and those who are coming to us and showing their faith and trust in us and getting the treatment based on the clinicians' decisions, including the immunotherapy and other things. So with this folded hands, I thank all of you, each one sitting in the audience. I thank all the audience, delegates, faculty members, online participants for their active participation and enthusiasm. At the end, if you find any fault or any mistakes in the management, your food, your stay, travel, transport, it becomes my sole responsibility, and I expect forgive from all of you. Thank you so much. God bless us all.
ललित जी, मैंने तो पूर्व में ही कह दिया था कि अगर आप लोगों ने यहाँ कॉन्फ्रेंस की है तो ये हमारे लिए बड़े हर्ष का विषय है, लेकिन कोई किसी प्रकार के भी इस कॉन्फ्रेंस को यहाँ ऑर्गेनाइज करने में किसी भी तरह की इनकन्वीनियंस अगर आप लोगों को हुई तो उसके लिए मैं विश्वविद्यालय की तरफ से आपसे क्षमा चाहता हूँ। एक दिन के लिए आपकी कॉन्फ्रेंस को इस हॉल से वहाँ आरके ब्लॉक में शिफ्ट करना पड़ा। देखिए, मैं आपको एक बात बताऊं, एंड टाइम पे दिल्ली से आदेश आया कि ऑनरेबल प्राइम मिनिस्टर ऑफ इंडिया आदरणीय नरेंद्र मोदी जी एक रोजगार मेले को संबोधित करेंगे और उसमें आपके महात्मा गांधी मेडिकल यूनिवर्सिटी में इनकम टैक्स डिपार्टमेंट और रेलवे डिपार्टमेंट और पूरा खचाखच भरा हुआ था, और यहाँ पे कुछ 71,000 कुछ नौकरियों के उनको अपॉइंटमेंट लेटर डिस्ट्रीब्यूट करने थे, तो बड़ा मेला सा यहाँ लगा हुआ था। और वो हमारी उस समय एक असमर्थता थी केंद्रीय सरकार के आदेश के समक्ष स्वयं को प्रस्तुत करने की। लेकिन मैं आप लोगों को बड़े विश्वास के साथ कहता हूं कि भविष्य में जब भी आप लोग कहीं इकट्ठे हों और तय करने लगे कि कॉन्फ्रेंस कहाँ करनी है, तो आप महात्मा गांधी यूनिवर्सिटी में करें। जब भी आपको यहां से जाने के बाद हमारी याद आए तब भी यहाँ करें, और हेमंत जी जब जब हमको याद आएगी तब भी हम इनको बुलाएंगे, आप आएं और हमारे यहाँ करें। सिर्फ ऑडिटोरियम की ही बात नहीं है, किसी भी प्रकार की सहायता आप हमसे चाहेंगे ऑनरेबल एमेरिटस चेयरपर्सन सर के बिहाफ पे, चेयरमैन चांसलर विकास चंद्र स्वर्णकार के बिहाफ पे विश्वविद्यालय की तरफ से मैं आपको आश्वस्त करता हूं, ऑडिटोरियम एक बहुत छोटा सा हिस्सा है। आप जिस प्रकार की भी सुविधा चाहेंगे, विश्वविद्यालय आपके समक्ष हाजिर है, लेकिन हम मिलकर के एक सृजनात्मक कार्य करें और कैंसर जैसी व्याधि से समाज को मुक्त करें। आपको हमेशा हमेशा के लिए आमंत्रण है विश्वविद्यालय की तरफ से। इस बार हुई आपको असुविधा के लिए मैं व्यक्तिगत रूप से पुनः क्षमा याचना करता हूं। थैंक यू वेरी मच।
Thank you so much to all the faculties, delegates, and dignitaries. Now I would like to request everyone to stand for national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात द्राविड़ उत्कल बंग हिमाचल यमुना गंगा जलधि तरंग तब शुभ नाम जागे तब शुभ आशीष मांगे हे तब जय गाथा विधाता जय 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 जय
Now the lunch is ready. You all can take the lunch and we'll assemble here after 35 minutes.
lunch session, we will be having one oration. And to chair the oration session, may I request Jyoti Bajpai. Dr. Jyoti Bajpai has been introduced to you all. And along with him, may I request Dr. Hemant Malhotra sir also to please come for some time.
So good afternoon, everyone, and apologies for a few minutes delay due to the inauguration, which was very fascinating. And now this is the one of the most sorted session, the oration. And for delivering the society oration, none other than our immediate past ESMO president, Dr. Solange Peters is here. And she's joining us in a virtual space. Dr. Solange in oncology world and immuno-oncology world doesn't really need an introduction. But I will still say a few words to, in honor of her. So she's an MD PhD, which is from medical school at the University of Lausanne in 1998. And following that, she attended the Microbiology Institute at the University of Lausanne until 2002, and concluding with the MD PhD thesis on a new HIV drug resistance mechanisms. She was later at various Institute of Excellence. And her very prominent introduction is that she is the immediate past president of ESMO. She's a professor at Lausanne University, and she's a very prominent oncologist in the field of lung cancer and immuno-oncologist. She's having several hundreds of papers in leading journals, leading immuno-oncology and oncology journals. And she's authored many books. She's a mentor for many, many students. She's pioneer. And she initiated many important things. To name a few, Women for Oncology is one of her forte. She made it very strong in ESMO, and now with her initiative and her force behind, in ESMO meetings, there is as much gender neutrality as possible. She is one of the very important member of ESMO Women for Oncology Forum as well, and I'm privileged to be part of that. I can vouch for that she's trying to establish gender neutrality in world over. So without taking more time, I think we can begin Dr. Solange Peters' recording, and she will be joining live for the question answer session. So thank you, Dr. Solange.
Dear colleagues, it's my great pleasure to be with you today and to try to have a look with you at everything which represents today the current best practice and treatment trends using immunotherapy for all stages of non-small cell lung cancer. This is my disclosure slide. Let's start from the basis. It was the time I started to treat lung cancer, and it was also the time where the HTNM classification has, I would say, changed the way we stratify our cancers. And this HTNM classification very clearly tells you how the outcome of lung cancer remains poor, and probably the most importantly to keep in mind as a kind of denominator to start with is the 5-year survival of a metastatic disease at the time of immunotherapy was not available. As you can see on the blue line, the late line of this table, 5-year survival using chemo, radiation, targeted therapy at the time of the HTNM classification was 0%. So that's maybe what you have to keep in mind when we will start to see the data about immunotherapy. Immunotherapy is a big word. To speak mainly today in oncology about two pathways, two synapses, which define the use of immunotherapy agents. In the priming phase of the immune response, the CTLA-4 signaling pathway, and on the effector phase of the immune response, probably in the tumor, the PD-1, PD-L1 signaling pathway. Both of them tend to inhibit an immune response. It might participate to homeostasis, but of course also participates to cancer protection against the immune system. We have been developing many compounds. Only two 2 targeting CTLA4, but a very largely growing number of anti-PD-1 and anti-PD-L1, as you can see, which basically represent a series of compounds with comparable activity in the patients. However, we still all hope that it might define a better accessibility in terms of pricing and reimbursement in the future across all continents. Let's start first with this metastatic non-small cell lung cancer with this 5 years, 0% overall survival. This is how we were treating lung cancer in the 2010s. It was about using a combination of platinum-based chemotherapy with the same efficacy regardless what you were using, a median overall survival of 8 months and a 1-year survival of 33%. The difference between the regimen was toxicity, and the joint factors, the common factor between the regimen was the absence of biomarker and the limitation due to toxicity. Now, this is the complex landscape of treatments using immunotherapy. I will look at it and go through it with you today, step by step. You can use the slides, of course, to have a reminder, but I will try to show you how today it is the standard of care to use immunotherapy in all patients frontline, with maybe one exception, which is the oncogene addiction, EGFR, ALK, RET, ROS, BRAF, where targeted therapies should be used frontline. However, immunotherapy for all the other patients frontline. I will drive you through all the details of this algorithm. So first of all, a ballpark. I told you before, 8 months overall survival without immunotherapy as a median time. And here you can see that the median PFS time using immunotherapy across all of these trials is now more than a year. And the median overall survival is not 8 months, but it's 1.5 up to 3, even more years of overall survival. So basically, we have more than doubled the outcome of our patients with non-small cell lung cancer. There are many ways to introduce this immunotherapy frontlines, and I will make you understand how and why we can choose between these ways. Monotherapy, combination, so the backbone, importantly, is always an anti-PD-1 or anti-PD-L1. This is a blue triangle, but you can use it as monotherapy, combined with chemo, combined with an anti-CTLA4, combined with both an anti-CTLA4 and chemo. Of course, you can also look at potential new combinations. So let's start with monotherapy. Monotherapy checkpoint inhibitors, anti-PD-1, anti-PD-L1 can be used in one clinical scenario. It is the high PD-L1, used as the biomarker. In lung cancer, we have been pioneers in defining how to measure PD-L1 using various assays, which are almost all superimposable, and measuring the PD-L1 on the tumor cells. So high PD-L1 means more than 50% of the tumor cells expressing PD-L1. We know PD-L1 is heterogeneous. We know PD-L1 is dynamic, but we also know we can use cytology to measure it. And that's the reality of PD-L1 that we will never be able to do better. So high PD-L1 is the important point. When you have more than this tumor cell, more than 50% of this tumor cell expressing PD-L1, you can use monotherapy, pembrolizumab, atezolizumab, or cemiplimab. These are the 3 trials which, as you will agree, are very superimposable comparing monotherapy to chemo. The left-hand side, the pembrolizumab, is interesting because we have 5 years outcome with 32%, a doubling of long-term survival versus 16% for chemo. You will ask me why 16? You told us 0% in the beginning of this talk. It's because, of course, of the crossing over of patients to immunotherapy in second line. Same data on the right with cemiplimab. This trial was performed only in smokers, which make maybe the hazard ratio later on slightly better. And on the left-hand side, a result which is a little blurred by the fact that Roche, using atezolizumab, is slightly differently defining high PD-L1, but you will agree with me that the result and the curves looks more or less the same with atezolizumab versus chemo. Very importantly, when you look at this high PD-L1 and you try to understand if chemo would be useful, what I mean by that is chemo IO better than this IO monotherapy? This is a real-world data analysis we have performed with the ETOP group in Europe, and the conclusion is irrespective of the presence of brain mets or liver mets, using chemo IO is not better in terms of PFS, response rate, overall survival, is not better than monotherapy IO in high PD-L1 non-small cell lung cancer. One exception, the never smokers. If you have a never smoker, he will need chemotherapy in combination with IO, and you should not use IO monotherapy, even if the PD-L1 is very high. Okay, You know everything. The 5 years outcome of pembrolizumab. It's interesting just to look what it means, a long-term outcome. So remember in these trials, the KEYNOTE-24, the pembrolizumab had to be stopped after 2 years. So when you look at 5 years outcome, you can look what happens 3 years after stopping, the pembrolizumab. At 2 years, everyone is controlled. And the good news is at 3 years, on the right-hand side, you can see that 81% of the patients are still alive, which is good. However, under the table, be aware that after stopping in the next 3 years, 54% of these patients will progress. And this is more than what would be expected if you continue. So there's always a risk to progress when you stop IO, just food for thoughts, right? Okay. Of course, the threshold of 50% was not found by chance. First of all, there was a ROC curve produced by MSD showing something like a shoulder of the ROC curve at 50% for monotherapy. But more importantly, we have tried with lowest threshold. Nivolumab with 5%, durvalumab with 25%, atezolizumab with 1 to 49%, and all of them have failed to show a superiority of IO versus chemo. And importantly too, the more the best. On the left-hand side is a series from US big centers. On the right-hand side is the cemiplimab trial. You can see incremental in terms of PFS, response rate, overall survival with higher rates of PD-L1. 60 is better than 50, 19 is better than 80. So this is quite important to understand that this 100% PD-1 patients has a very, I would say, good prediction of outcome under monotherapy. So for all the other ones who don't have a high PD-L1 more than 50%, what to do? You can combine with chemo. I'd like to show you one trial. It's a landmark trial because it looks at all histology frontline. It is well stratified by PD-L1, negative, 1 to 49, and more than 50%. This is giving cemiplimab plus chemo versus chemo, very usual chemo regimen for squamous and non-squamous. This is what you find when you combine chemo IO versus chemo, hazard ratio 0.71, median OS 22 months. Very nice. I just would like you to look at the waterfall plot. This holds true in most of the subgroups looking at PFS and OS. Maybe one point I'd like to stress with you is the magnitude of benefit you observe in negative PD-L1. You remember the one who have a very low level of the biomarker on, I would say not a low level, in existing biomarker, 0. You can see here that the overall survival here is almost demonstrating the absence of benefits of chemo IO versus chemo. The hazard ratio is 1. But if you go beyond and higher, 1 to 49, more than 50, you start to see the benefit. So keep it in mind, if any benefit, it's very low in negative PD-L1, but in that trial, it was none. Okay? There are many trials performed with chemo IO versus chemo in non-squamous non-small cell lung cancer. Many because there is this use of anchor drugs, right? It's a large series of anti-PD-1. You can see, or anti-PD-L1, you can see it on that slide, all these positive trials showing really the same outcome, the same type of hazard ratio of chemo IO versus chemo in non-squamous. Same table on, just one thing before changing. It's important for the KEYNOTE-189, we have in all comers non-small cell lung cancer, non-squamous, you have this 5-year now outcome being described with 20% long-term survivors. Quite interesting to keep it in mind using pembrolizumab chemo. Okay, this is a table I wanted to show you in squamous non-small cell lung cancer. Again, a series of 5 trials, so the benefit of chemo IO versus chemo, and again 5-year results for the KEYNOTE-407, again using pembrolizumab chemo versus chemo. The pembrolizumab chemo again gives rise to almost 20% long-term survivors, which is really a promise for medical oncologists. It is squamous, but across all strata of PD-L1. So sometimes you can also imagine to be chemo-free and combine with CTLA-4. Well, here we only have one trial, which is a very complex trial, which was criticized because the endpoints changed many times. But basically, it was comparing, to make it simple for you, nivo-ipi versus chemo. The endpoint I would like you to look at is overall survival. And unfortunately, at the time of designing the trial, we decided to look at overall survival. But I would say sizing the trial and designing the trial only to look at positive PD-1 patients. We thought at that time it would be better outcome in positive PD-1 population. So nivo-ipi versus chemo with a primary endpoint being defined in positive PD-1 patients. So let me show you. In the positive PD-1 cohort on the left-hand side, you have a positive trial, hazard ratio 0.77 for nivo-EP versus chemo. There is an exploratory arm of nivo monotherapy, which is closer to the chemo arm, really showing the contribution of component nivo-EP is better than nivo, which is better than chemo. So that's an important endpoint. Look also at the circle. What we don't like in oncology is when you don't use chemo. There are some patients fast progressing and unfortunately dying from the disease, an excess of deaths in the first 3 months that one has to keep in mind. And we were not able to identify today who are these patients who progress and die fast, which is really something we have to pay attention to when we treat patients. On the left-hand side, this is not even a secondary endpoint. It's an exploratory population, so negative PD-1 cohort, which has even a better hazard ratio for nivo-EP versus chemo with a hazard ratio of 0.65. However, it was exploratory, and the difference is mainly due to the fact that the chemo is underperforming in negative PD-1 cohort, is performing less well than in positive PD-1 cohort. But that's 227. Importantly, in 227, we also look at histology, and the benefit of nivo-EP versus chemo is seen across histologies in positive and in negative PD-1 cohort, with probably the most important benefit seen here in squamous negative PD-1 cohort with a hazard ratio of 0.5. But of course, it becomes very small subgroups. More, I would say, straight to the point, more straightforward, because 227 has this problem of changes over time, is the next step. The next step is 9LA. 9LA is a very clear trial, all non-small cell lung cancer naive, stratified by positive, negative PD-L1 sex and histology. This patient received as a standard arm classical chemotherapy, and as the experimental arm, nivo-EP, as usual, low-dose EP, 1 mg per kg every 6 weeks, plus chemotherapy, but only 2 cycles of chemo, very short course chemotherapy. Primary endpoint OS. So first of all, no excess of deaths, no early deaths, very importantly. And hazard ratio 0.74. At the time being, we have 3 years follow-up and a lot of censoring, as you can see, but very interesting data to offer a new possibility for these patients of receiving CTLA-4. Why would you think about CTLA-4? So maybe like melanoma, thinking about long-term outcome, maybe CTLA-4 adds some memory T cell, new recognition of neoantigen, and might improve very long-term outcome, but we still don't have this data. But very importantly, it's quite important to stress one thing for you here, maybe the third circle, is about some brain mets. The melanoma colleagues have shown us before that to have a good response to IO in the brain, adding a CTLA-4 adds an incremental of benefit. And more importantly, the negative PD-L1. Remember, the marginal benefit of anti-PD-1, anti-PD-L1 in negative PD-L1, when you give a CTLA-4, you recover this population of negative PD-L1, and you make them probably PD-1 positive, and you make them respond to IO. Interest in brain, interest in negative PD-L1. Let's keep in mind that never smoker had benefit less from immunotherapy, and let's keep in mind that the benefit is seen across histologies. Just the brain, I just wanted to show you here's a nice analysis. The patient with or without brain mets at baseline, all the brain mets had to be treated and asymptomatic, but you can see this incremental of benefit of the strategy in patients with brain mets. And you can see the amazing intracranial PFS with a hazard ratio of 0.36 in 9LA. Last but not least, recently FDA approved the most complex chemo CTLA-4 anti-PD-L1 trial. This is a Poseidon trial. Standard arm is chemotherapy. One experimental arm is anti-PD-L1 durvalumab plus chemo with continuation of durvalumab until progression. And the third arm is the most complex experimental arm, tremelimumab durvalumab chemo. The tremi is given for 5 cycles. The durva chemo is given for 4 cycles, and durva is continued until progression. So 4 cycles altogether, 1 additional cycle of tremelimumab, and durvalumab is continued until progression. Primary endpoint was defined, interestingly, for the dark blue endpoint, durva chemo versus chemo. Secondary endpoint was, however, alpha controlled according to a hierarchy, looking at the clear blue versus the standard arm. Let's look at the result together. You can look on the right-hand side. This trial is positive in positive and in negative PD-L1 for the clear blue, the tremi durva chemo versus chemo, but not for the dark blue, durva chemo versus chemo, surprisingly. And more importantly, I would like really you to look that the main benefit again is observed in negative PD-L1. So when you add a tremelimumab in negative PD-L1, you recover the benefit of immunotherapy. So the interest of CTLA-4 might be the brain, might be the long-term outcome, but more importantly is negative PD-L1 populations. So now you understand my graph very well. High PD-L1, monotherapy. 1 to 49, you can use chemo IO with this benefit in negative PD-L1s. And all the other one from 1 to 49 is going to be chemo IO with a range of possibilities in non-squamous and a range of possibilities in squamous. What about new combinations? Very fast. First of all, when we speak about new combinations, remember we always keep the backbone of anti-PD-1, anti-PD-L1 on the left-hand side. On the right-hand side, combination can be about cytokines, can be about new checkpoints, can be about vaccines, can be about T-cell therapy, can be about other microenvironment modifiers like adenosine pathway. So many opportunities still to be proven and developed. In lung cancer, we have trials which will very soon read. First of all, the use of PARP inhibitors to increase the neoantigen burden, the killing trial using olaparib in squamous and in non-squamous, the ZIL1 using niraparib across histologies. Also, the opportunities of using lenvatinib, an anti-angiogenic drug with pembro chemo versus pembro chemo. They should read very soon. And you have heard about skyscraper 1, tiragolumab plus atizo. Of course, in high PD-L1 versus atizo, it didn't meet PFS, but we are waiting for OS result. This will come very soon. Of course, the main question is what to do when you resist to IO. So we know more or less, I invite you to go through this wonderful, really review of Sean Fenn and colleagues showing you what are the mechanisms, the potential mechanisms of resistance from the loss of interferon gamma sensitivity to the depletion of neoantigen or the inactivity of the immune system to recognize a neoantigen by T-cell exclusion, for example, on new checkpoints. Knowing that, we have to think about strategies to overcome resistance. It can be the old days chemo or chemo anti-angiogenic. It could be, of course, to make sure that you have not forgotten a driver, but it can be also new combinations, or it can be antibody drug conjugates. And on the right, on the right, the pink one, new combination, are mainly about the TAM inhibition, which is a series of receptors which are immuno-inhibiting. So the TAM, which is AXL, MER, and TYRO, are receptors which can be inhibited by cabozantinib or by sitravatinib, but they are all also anti-angiogenic, lenvatinib, cabozantinib, and sitravatinib, and these drugs are combined with a checkpoint in second line. These are 3 phase 3 trials ongoing, which are based on promising results in phase 1 and 2. However, unfortunately, we already have a press release showing that this phase 3 CONTACT-01 using cabozantinib, a TAB inhibitor, and an anti-angiogenic inhibitor as compared to docetaxel failed to meet its primary endpoint and of overall survival and is a negative trial. We will wait very soon the LEAP-008 and the SAPPHIRE to read and maybe to help us treat patients. Let's go also to the next stages, to early stages of non-small cell lung cancer, which is closer to try to cure more patients, even if maybe we can cure stage 4. So first of all, there's a series of trials looking at immunotherapy in early stage. First of all, the classical adjuvant approaches. Adjuvant is after surgery. You can give chemo followed by IO, mandatory chemo followed by the IO. We have one trial there which has given results, or you can give optional chemo based on investigator assessment followed by immunotherapy. And we also have one trial having given results, but 2 ongoing trials. Then you can use the other way around, neoadjuvant. And now in the neoadjuvant, we use chemo IO. So usually 3 cycles of chemo IO followed by surgery. One trial has shown result here where it stopped after surgery, so no additional IO, but we have many trials using the sandwich. We can also call it perioperative strategy, when you give 3 cycles of chemo IO surgery, followed usually by 6 months, but more often 1 year of immunotherapy, the sandwich strategy, where we are waiting many data. So adjuvant or neoadjuvant, and I will show you what we have. First of all, we have, of course, the standard of care, which is adjuvant chemo in patients with stage 1B more than 4 centimeters to stage 3B. or 3A, of course, has to be resectable, with an absolute benefit at 5 years of only 5% of survival. However, it is about cure and it is standard of care. The first trial with adjuvant IO is the IAM-POWER10, which is mandating chemotherapy at least one cycle in the adjuvant setting. It, of course, looks at patients more 4 centimeters, stage 1B to stage 3A, and it gives up to 1 year of atezolizumab. On the right-hand side, it is a PEARLS trial, same trial in terms of design, 1 year of adjuvant pembrolizumab, but here the chemotherapy is optional. Importantly, the stratification factors are slightly different and the primary endpoints are different. In the IAM-POWER, it is a complex hierarchy. I will show you of endpoints. In the PEARLS trial, it is DFS as a primary endpoint in the overall population and in the high PD-1 population. But you will agree with me, with the slight differences, the small differences in the trial, the curves in the ITT population, IAM-POWER on the left, PEARLS on the right, look very similar with a hazard ratio respectively of 0.81 or 0.76. And as you can see, very, very same shapes of the curve. So this is a slide about IAM-POWER10 and the trial design. As you can see, it's a complex hierarchy looking at DFS in stage 2 to 3A. First of all, in positive PD-L1, would it be positive in all randomized, all strata of PD-L1? Then looking at the ITT population, then looking at OS. I will just show you the curves. So it was positive for the trial. The DFS was positive for positive PD-L1 stage 2 to 3A, for all randomized patients stage 2 to 3A, but it didn't cross the boundary of significance for the irrespective of PD-L1 stage 1B to 3A population. So again, it's only valid for stage 2 to 3A at the time being. Okay. Of course, the greatest magnitude of benefit, as expected, was seen in high PD-L1 with amazing hazard ratio of 0.43 in more than 50% PD-L1. And if you want to be very critical on the right-hand side, one might say that the benefit is mainly driven by high PD-L1 more than 50% because the benefit is very modest in 1 to 49. So basically in the US, the reimbursement is for positive PD-L1 stage 2 to 3A, but in Europe, is only for more than 50% stage 2 to 3A, and now you understand why. Overall survival is immature, but this is the very early curve where we can imagine at least that there will be a benefit of survival in more than 50% PD-L1 on the right-hand side. So PEARLS, the Keynote 091, as I told you, the endpoint is slightly different. Chemotherapy was optional. So the primary endpoint on the left-hand side was ITT population irrespective of PD-L1. It is a positive trial, irrespective of PD-L1 is stage 1B to stage 3. But surprisingly, on the right-hand side in high PD-L1, it was not positive. So very strange because we expect the main benefit being seen here. We could analyze it further down the road and present at the ESMO meeting. And this is due, as you can see, not of an underperformance of pembrolizumab. Pembrolizumab is doing better in high PD-L1, but unfortunately and unexpectedly, the control arm is overperforming. We cannot explain why. It's unexpected, but to me, it doesn't remove the fact that pembrolizumab should be delivered regardless of the PD-L1. Okay, this is a large landscape of adjuvant immunotherapy trials that are coming in the future and have presented data for 2 of them at the time being, and we will wait for the other ones, again, with more or less in all trials 1 year of adjuvant IO. Neoadjuvant IO, remember that we can give also neoadjuvant chemo. We have, first of all, the LACE meta-analysis, which was showing that neoadjuvant chemo has the same 5 years absolute benefit of 5%, but also the NATCH trial comparing neoadjuvant to adjuvant chemo, which was showing similar results. So you can give also neoadjuvant chemo. You can give neoadjuvant IO, and in this graph, the idea is to tell you why potentially neoadjuvant IO is more interesting than adjuvant IO. First of all, because you have the tumor in place, meaning that you have a visibility of the neoantigen. So neoantigen are clonal because they have not been exposed to any selective pressure. And this is interesting to use also for an early read of the endpoint and to assess with 2 biopsies, 2 samples of the tumor, the efficacy of what you do. So basically, a window of opportunity for immunotherapy. We have 2 trials, one phase 3, one phase 2. The Checkmate 816 was looking at stage 1B to stage 3 non-small cell lung cancer, giving 3 cycles of nivo chemo versus chemo. followed by followed by surgery, followed by nothing in terms of immunotherapy later on. So it stopped at surgery and didn't deliver further immunotherapy. That's the only trial which will stop at surgery. Nadim, on the other hand, is looking only at stage 3 patients, stage 3 A and stage 3B, 3 cycle of Nivo chemo versus chemo. Primary endpoint is pathological complete response, and it doesn't give 1 year like the other trials of adjuvant of continuation IO, but only 6 months. So let's look at the result. Very similar result. Checkmate 816 give rise to a pathological complete response, one of the primary endpoints, of 10 times more than chemo, 24% versus 2.2. Nadim is giving rise to a huge also improvement in pathological complete response at the primary endpoint. I remind you, 37% versus 7%. So amazing improvement in this primary endpoint. There is a second co-primary endpoint in Checkmate 816, which is EFS. And as you can see, very positive in all comers, hazard ratio 0.63. Which is absolutely amazing. It was an exploratory secondary endpoint in Nadim, but again had a ratio 0.48, as you can see. Survival is not mature, but will probably be positive in both trials. Improvement in pathological complete response, improvement in EFS. This is the curve of Checkmate 816, amazing curve, showing an amazing improvement of event-free survival in all of these patients, stage 1B to stage 3A, irrespective of PDL1. This is about stage. The benefit is seen across stages, slightly higher in stage 3A, as you can see on the upper panel, and looking at PDL1, slightly higher as expected in positive PD-1 patients. However, FDA has granted approval in all comers, 1B to 3A, irrespective of PDL1. This is a Nadim curve, very similar, as you can see, PFS and OS. As you can see, very nice separations of the curve very early too. Last but not least, pathological complete response has been shown to correlate with event-free survival in both trials. You can see the upper curve is the pathological complete response. The lower curve is a non-pathological complete response. In Checkmate 816, this is also true for chemo. A pathological complete response in chemo defines a good outcome. However, as you remember, there are 10 times less patients on the gray curve as compared to the green curve. So less patients benefiting from long-term EFS benefits. There is one trial, another perioperative trial, the first one, I would say, with the sandwich, the agent trial, which is using 3 cycles of neoadjuvant chemo durva, followed by 1 year of durva, which has 2 co-primary endpoints, pathological complete response and EFS, which already has a press release telling that the pathological complete response is met, which is not surprising, but we wait for the full results. This is a huge landscape of perioperative sandwich IO trials that should read for many of them still this year in the field of non-small cell lung cancer. I have 2 last slides about the patient who cannot undergo surgery, stage 3. So standard of care is 1 year of durvalumab based on Pacific trial, and this holds true regardless of PDL1 as confirmed by real-world data. And importantly, there are many trials trying to improve it or improving it by adding some components after concurrent chemorad, so adding, for example, TIGIT, adding new adenosine pathway inhibitors or new immunomodulation. There are also trials trying on the right-hand side to start the immunotherapy concurrently to the chemorad followed by IO. For example, the Pacific 2, the Checkmate 73L. So all of these trials will try to, based on Pacific, to improve outcome, and we are waiting for all of them. So with this, you know everything about lung cancer, and I thank you for your kind attention.
So thank you very much, Solange. Indeed, it was a great presentation. And now we have some questions. So Dr. Lalit.
Yeah, Solange, it was excellent talk. In fact, in over 30 minutes, you have covered so many trials. In fact, it becomes amazing. Thank you so much. So the question is, like, we clearly understood that the PDL1 more than 50% we use monotherapy. How about the patients, like those who have received either neoadjuvant chemotherapy or immunotherapy or adjuvant immunotherapy, like IMpower 10? If these patients do relapse, what do we offer them?
Thanks so much. And thanks for having me with you virtually. I'd like to come once, but traveling remains sometimes a little difficult. Thanks for your question. You here open a new chapter, which is really, I would say, a gray zone. The question you ask has no clear answer today. There are probably two scenarios in which we don't have really data. The first one is what to do after neoadjuvant or adjuvant IO. And we already had the question about the consolidation, like Pacific, for example. What do you do with someone having a consolidation, durvalumab, for a year after radiochemo is progressing? So basically, I think without having data, we try to define some different scenarios. The worst of the worst is a patient progressing under IO. During the 1 year of durvalumab, atezolizumab, maybe in the future pembrolizumab. This probably means an immunotherapy refractoriness. So here you have to switch back to be very rational. At the time being, you have to switch back to chemo. If you are more than 3 months from the last platinum-based. If you are less than 3 months, you'll be probably limited to docetaxel or docetaxel and anti-angiogenic. So that's really the refractoriness, right? Would maybe the trials in second line, you know, we still have citravatinib trial, lenvatinib trial. If this trial read positive, this is kind of same scenario. So you could move like a second line for resistance to IO. But still, we have absolutely no positive trial in second line using IO. We still have only docetaxel. So that's the scenario. Then the main question in the community, and I would like to hear your opinion, how long would you consider being a decent interval to start again IO if you are after IO? Is it 3 months? Is it 6 months? The Society for the Immunotherapy of Cancer has said 6 months. So for them, you should re-challenge IO at relapse if you have passed more than 6 months after the last dose of IO, which probably makes sense in terms of pharmacology, you know, the plateau and so on. So probably you have to forget about your adjuvant or consolidation IO if you are 6 months after having stopped, right, your strategy. But that's really a gray zone in which I think we all do slightly differently. But sometimes the only answer you have is chemo and even worse, docetaxel, right?
Thank you. Thank you so much.
You're welcome.
So can I ask a question, Dr. Peters? This is Hemant Malhotra. Excellent presentation. Thank you very much. And we also really truly wish that you could have been present in person. So my question to you is somebody who has a targetable mutation in a high PD-L1, say for example, ALK positive patient with PD-L1 expression of 70%. So is there a role of immunotherapy there, or are there any studies of combining, targeting both the pathways?
Yeah. So there are two answers to that. First of all, we have to be very careful in oncogene addiction, being EGFR, ALK, RET, ROS, BRAF, and NTRK, because the only expression of the mutated pattern or the rearranged pattern can induce the expression of PD-L1. So sometimes the PD-L1 expression is not due to the usual T-cell exhaustion that you'd like to counteract with immunotherapy, but just an undue and artificial expression, overexpression of PD-L1. So a high PD-L1 is not to be trusted in oncogene addiction. You have to forget about it. Maybe just one element, if you really have zero PD-L1 and an oncogene addiction, here you cannot be betrayed. It really means you have something like a low mutation and an immune desert. So the positivity is betraying you, but the complete negativity is telling you that really you are in a bad situation for IO. But in general, there is a modest, not inexisting, but a modest benefit of IO in mutated lung cancer, probably because of the low mutational and neoantigen burden in patients who have not smoked. When I say modest, you divide everything by 2. So if you expect a response rate of 15%, you will have 7. If you expect a PFS of 6, it's going to be 3. So very modest. That has to really be put in the balance of accessibility, cost, and of course, availability of the drug, right? So I think that's an option, potentially immunotherapy in these patients, but only in late lines. We had seen at the ESMO Asia was a nice trial of Nivo plus chemo versus chemo as a first line when you have exhausted targeted therapy in EGFR mutated. So again, here it was a modest benefit, unfortunately not meeting significance, but probably just because they have looked at the result a little too early. But again, a very modest benefit. So I think it has really to be discussed with your insurance system and with the patients, because you shouldn't expect too much about it, right? There are trials combining a TKI and checkpoints. There are two things. First of all, it doesn't improve the outcome of the TKI. And the second thing, sometimes it is toxic. Osimertinib doesn't go with IO. Crizotinib doesn't go with IO. They can induce pneumonitis, hepatitis. So a word of caution here, it can be pretty toxic.
Thank you very much.
Congratulations, Dr. Peters. I have a small question. In neoadjuvant setting, the response evaluation was in all these trials was based on radiology. Do you think that is the right way to go ahead, or would you be considering pathological responses or any other responses in any other way?
I agree with you. It's not the way to go. I guess when you expect, and what we have seen with immunotherapy is sometimes you have still remaining mass, right, at the time of the CT scan, and you will be surprised that it's only necrotic tumor cells and lymphocytes, a lot of lymphocytes in the tumor. So I think we more and more will try to move to pathological response. But the main question we have is, it's kind of a debate. If you have a complete pathological response after 3 cycles of chemo IO, does it mean that you're cured and you can stop? Or does it mean that your immunotherapy was so efficient that you should continue for a while? So we absolutely don't know. We have one trial, the Checkmate 816, which stopped at surgery. So we will be able to see in that trial the quality of pathological complete response, meaning at 5 years, did they relapse, yes or no? If no, we can stop here. If they relapse, maybe we should continue. All the other trials will continue the immunotherapy. So we will never know the utility of continuing. But I agree with you, radiology will betray you because it's too short. 3 cycles, immediate kind of CT scan, it's too short to see if it's about T cells or it's about tumor cells, right? And they don't correlate, by the way. Pathological response does not correlate with radiological response.
Thank you.
Thank you very much. And your talk is always thought provocative, and there are a couple of questions more also, but in the interest of time, we have to move. So I will pass on to you those questions and maybe we can answer them later. But now it's time for oration ceremony. So can we, Rajesh, can we have a display? Right. So it would have been a great pleasure, Solange, if you could be present here in person. But now this plaque we are handing over to you virtually, and whenever I'm meeting you in person this year, then I will hand it over to you.
Thanks so much, right? It's first of all a great honor to be with you for the 3rd year, I guess, in a row. And the most important thing for me is to promise you that I'll travel to you. I'm sure next year all this story of COVID and so on should be perfectly calm and gone. So I would be very happy, first of all, to meet you this year a bit everywhere in the world, but also to join India, which is a wonderful country, as soon as I can. And I'm sure my colleagues will come with me to join you in India as soon as we can travel without any limitations or questions. But I think we are getting there. So much, I would say, grateful for the opportunity and for the recognitions, Jyoti. Thanks so much.
Thank you so much. Great pleasure. Now I'm handing over to Dr. Lalit Mohan for further proceedings. Thank you very much, Solange.
Thank you.
So thank you, Dr. Jyoti, and thank you, Malhotra sir, and thank you, Solange, for excellent talk. With this, we start the next session, that is session 11. And now we'll be discussing about advancements of immunotherapy in other solid tumors. So to chair the next session, may I request Dr. Vinay Deshmane. Is Dr. Vinay Deshmane here? Yes, sir. Thank you so much. So Dr. Vinay Deshmane is a senior breast surgeon settled in US, sir. Correct me if I'm right, or you're in Mumbai. Settled in Mumbai. Along with him, trained in England and currently giving services in Mumbai. Very fine breast surgeon. And along with him, Dr. G.S. Bhatti. Bhatti sir is king of oncology in Rajasthan, Padaru Mare Desh, and Jodhpur ka asli sona hai Bhatti sahab hamare liye. Very much thank you, sir. Thank you so much for your presence here. Yeah, but we'll be having this session, which is virtual. It is keynote lecture 4, recent advances in immunotherapy of breast cancer. And Dr. Rebecca Dent from Singapore, she is medical oncologist and will be speaking on that.
I want to thank the organizers for inviting me to speak to you today on the role of immunotherapy in breast cancer. These are my conflicts of interest. So first of all, I think it's impossible to talk about immunotherapy without just mentioning briefly the role of prevention. As we know, nearly 20% of cancers worldwide are actually caused by a virus. And we know that there's this long latency. So these viruses don't cause cancer until long after they're initially infected. And there are a number of viruses that we're aware of that actually lead to cancer. And I think, vaccines against cancer are also now routinely administered. So the hope is that in the future, we'll see a lot more focus on prevention. Now, when it comes to breast cancer, I think we don't classically think about breast cancer as one of the tumor types that we thought immunotherapy would be of benefit. But through this evolution of our ability to classify breast cancers and tease out the fact that it is such heterogeneous disease, not only by looking at molecular subtypes, but also being able to do immunome analysis and doing immune cell profiling, we can actually differentiate those small subtypes of triple negative and also potentially other subtypes that might be amenable to this approach. Now, our colleagues in pathology identified for us well over a half century ago that there was this subtype of breast cancer that had this brisk lymphocytic infiltrate that had what we would now refer to as TILs. And it's not just lymphocytes, but exhausted T cells and myeloid-derived stem cells. And what's interesting is that this varies actually quite significantly between ER positive and ER negative breast cancer. So those genes associated with good prognosis and poor prognosis are not only different, but distributed differently between ER positive and negative. And I think that likely reflects this differential response we're seeing, especially when it refers to immune checkpoint inhibition. Now, Brian Lehman and Jennifer Pietenpohl have done some great work, developing some of our understanding, more specifically looking at triple negative and understanding that through these different data sets and integrating them, that we have this real range of breast cancers from the fully inflamed that, let's be honest, we know that likely have this interferon gamma signature and likely would benefit from even single agent immune checkpoint inhibition, to the other end of the spectrum where we have these immune deserts. Well, we know we have to do a lot to reactivate the immune system. And so the therapeutic approach is very different. Now, when we think of TNBC, classically this immune portrait, why was that a group of patients that we thought of targeting first? And that was basically related to the fact that there was a higher rate of T cell infiltration, PD-L1 expression, and a higher mutational rate compared to other subtypes. Now, since that time, we've learned that it's in fact much more complex than that. And especially when it comes to ER positive breast cancer, the interplay between the, ER-driven cancers and these different factors that can upregulate or downregulate these important immune-related genes is much more complex and dynamic than we ever imagined. And so when we think about trying to identify which tumors might be sensitive to immune checkpoint inhibition, again, it's much more complex than I think other tumor types, and why it's been so much harder to get to where we want to get to. So first of all, why combine chemo with immunotherapy? Certainly the data across many tumor types now, but especially in breast cancer, has shown us if we expose the tumor to chemotherapy, we get upregulation of PD-L1, T effector cells, which make these tumors much more likely to benefit from checkpoint inhibition. So in previous studies, IO immunotherapy has been shown to be a benefit in combination with chemotherapy versus chemotherapy alone, but only in those patients that express PD-L1. So we've heard a lot of these studies before, so I'm just going to go over them briefly. But when it came to looking at atezo plus nab-paclitaxel versus nab-paclitaxel alone in the Impassion 130 study, we saw an improvement about 2.5 months in terms of progression-free survival, very modest, and we were looking at solvent-based paclitaxel. And then in Keynote 355, pembrolizumab plus chemotherapy versus chemotherapy alone, again, we saw an improvement in PFS with a hazard ratio of 0.66. But what was most dramatic is that we saw this improvement in overall survival, but only in Impassion 130 and Keynote 355. So you can see here in Impassion 130, again, atezo plus nab-paclitaxel versus nab-paclitaxel alone, we see an improvement from 15.5 months to 25 months in favor of the addition of atezolizumab. Now, unfortunately, in Impassion 131, where they were using solvent-based paclitaxel, we saw no difference in terms of PFS, OS in any of the subgroups. And then in Keynote 355, we saw an improvement from 16 months to 23 months, again, in terms of overall survival with a hazard ratio of 0.73, and you can see these curves continue to separate. Now, what was most important, I think, for patients and for patients and doctors seeing these patients in clinic is that in the Keynote 355 study, the patients received either nab-paclitaxel, solvent-based paclitaxel, or gemcarbo, and all of these different chemotherapy subgroups seem to benefit in terms of improvement in progression-free survival and significant hazard ratios. And as we know in clinical practice, nab-paclitaxel is considerably more expensive, and gemcarbo gives them a non-hair-losing option, which is very attractive, especially in that first-line setting. So for these reasons, both atezo and pembrolizumab have now been incorporated into numerous guidelines. These are the ESMO guidelines published last year. And as you can see, what's really exciting for metastatic TNBC is that we now have a number of targeted agents that are now available, both targeting BRCA, but also antibody-drug conjugates in the form of sacituzumab govitecan. And so that leads me to talk about how can we augment the immune response. And one of the ways in which that might be done, as I said, was combining it with chemo, but perhaps even more so when we combine antibody drug conjugates with checkpoint blockade. And that's really because of its different mechanism of action and its impact on the tumor microenvironment. And so that binding of ADC increases their TILs, increases our functional T cells. And so its power to convert cold tumors to hot is even more impactful than just chemotherapy alone. And so just two trials I wanted to highlight that were just presented at San Antonio. So as we recall, this was a basket study looking at vertically integrating PD-L1 inhibition, specifically durvalumab, with these different targeted agents. And this particular study in the Begonia was looking at advanced ER-negative, HER2-low metastatic breast cancer, about 58 patients, looking at T-DXd plus durva. And you can see overall, this is quite well tolerated. I think the most significant thing is to look at the waterfall plots, which are really quite impressive. And this was regardless of PD-L1 expression. So I think this is what's most profound. Overall, quite well tolerated, which is nausea being the main side effect, which we know is from T-DXd. About 60 patients, but about 57% of these patients had a response. And then median PFS was almost 13 months. So this is a single arm as far as this phase 1b/2 trial. But really quite impressive responses, again, combining T-DXd with PD-L1 inhibition in this triple negative, but HER2 low cohort. And so we anticipate larger trials exploring this combination. Now, another antibody drug conjugate in combination with immunotherapy is, again, another arm of the Begonia study, which was arm 7. And here was combining Dato-DXd, which is a TROP2-directed antibody-drug conjugate, so very similar to sacituzumab, but without, this was actually just a single-arm study, Dato-DXd plus durvalumab. And again, this was a small study, but 61 patients who were getting the combination, fairly well tolerated, no unexpected toxicities, very expected for PD-L1 inhibition. And they had to be about more than equal to 12 months since their taxane for early stage disease, but no previous treatment for stage 4 disease. And what you can see, again, very impressive waterfall plots for this very active combination, again, TROP2 directed ADC of Dato-DXd in combination with Durva. Only 61 patients, but again, in terms of response rates, we have a 74% response rate. Again, single arm study. These results, though, were independent of PD-L1 expression. This combination, the side effects most notably are nausea and stomatitis. And there is an ongoing first-line TROPION-02 study, which is actually looking at Dato-DXd plus Durva. The question is, how much is the IO really contributing? But stay tuned for both the trial looking at Dato-DXd versus standard of chemotherapy, and then also combination of Dato plus Durva. But there are many more targets coming in this metastatic space. I think the most interesting to me is some of these novel small molecule PD-L1 targets, and really nicely outlined in this recent review. And then finally, I think we've heard a lot about these personalized neoantigen-based vaccines. And so the idea is training your own immune system. And so first we start with target discovery. So doing this somatic mutation identification, finding out what are these immunogenic epitopes, and then really moving through developing the vaccine, doing the immune assessment. And as we know in breast cancer, this is in the very early stages, but certainly there are many trials ongoing. One of the things many people ask about is adoptive cell therapy, which, as we know, has been very exciting in our liquid biopsy space. But in solid tumors, it's not yet sort of something that we are too confident about yet, but is very exciting to start exploring. I would recommend this review because it really walks you through the fact that when we're talking about adoptive cell therapy, it's not so straightforward. It may be referring to TIL therapy, CAR T cell. Might be referring to dendritic cell therapy or NK cell therapy. So in fact, there are many ways to take this approach. One of the trials that you're probably most familiar with that was published last year in JCO was looking at TIL therapy, where they took 42 patients, they isolated TIL cultures and then identified some of these somatic tumor mutations and then did this neoantigen screening. What was impressive is almost 70% of patients contained TILs that recognized at least one immunogenic somatic mutation. Now, 6 patients received treatment in combination with Pembro. And then there were 3 patients that were noted to have these objective tumor regressions, including one in complete response. As you can see, this is the case that's been, described several times. And I guess one of the questions is, would you have just seen this with pembrolizumab alone? And so again, exciting, but I think there's a lot of work to be done. So where we really want to make the most impact is in early triple-negative breast cancer. And so when you actually look at the data, immune activation is clearly higher in primary versus metastatic. And so we'll talk a little bit more about this because I think this is very relevant in terms of how we select patients. And so why this is so is that, we've learned from looking at advanced cancers, first line early breast cancer, is that you see in early a higher rate of stromal TILs, a much higher rate of this interferon gamma related signature, which again makes tumors much more sensitive to immune checkpoint inhibition. And then there's this concept of as tumors evolve, as they're exposed to treatments, we lead to this concept of immune escape and immune subversion. So a lot of people say, well, what predicts this response to immunotherapy? And as I mentioned previously, in fact, in breast cancer, it's much more complex, related to tumor metabolism, the tumor microenvironment, the biomarkers. And so one of the things people is that why in metastatic disease do we have to test for PD-L1 where we don't in early? And what's really interesting is when we expose tumors, especially in the untreated population, what we see is dramatic upregulation of PD-L1. And so again, maybe we don't have to select for it because chemotherapy potentially acts as this neoantigen and upregulates PD-L1. Now, the first trial to look at the role of pembrolizumab or a PD-L1 inhibitor in early breast cancer was the I-SPY2, which, as we know, is this Bayesian adaptive model design, where they looked at paclitaxel, Pac plus Pembro, and then followed by AC. And you can see the Pembro was just in combination with the paclitaxel. And as we know, these are Bayesian adaptive model designs where you get these estimated PCR rates, but the most promising combination was in triple negative, where there was an expected success rate of over 99% with an estimated PCR of 60%. And hence we saw the Keynote 522 study design. This is a phase 3 large trial conducted throughout the world, almost 1,200 patients. These were patients with confirmed triple negative breast cancer, you can see T1C with an N1 or 2 positive disease, or T2 to T4, N0 to N2. You can see that inflammatory breast cancers were actually excluded, and patients were randomized 2-to-1 to either receive carbopaclitaxel followed by an anthracycline alkylating agent in combination with pembrolizumab versus chemotherapy alone plus placebo. This was the neoadjuvant component, surgery, and then pembrolizumab in the adjuvant treatment versus placebo. Now, what's most interesting is that, there were stratification factors included the carbo schedule, either weekly or every 3 weekly. And, when we were designing this trial, it was really important to us that we include platinum as part of the standard regimen. And I'm very happy to see Sudeep Gupta's data recently at San Antonio confirming the added benefit of platinum in this neoadjuvant component of treatment. And what you can see here is an improvement in PAS-CR of about 14%, again, regardless of PD-L1 status. And in fact, you see a greater delta in those patients that were PD-L1 negative. And then here you can see the improvement in terms of event-free survival with the addition of pembrolizumab is 8%. So from 76.8 with standard state-of-the-art chemotherapy, which increased to 85% with the addition of pembrolizumab, a hazard ratio of 0.63. This is the p-value 0.00031. And it was this data that led the FDA to approve this. And this has now been approved in many sites throughout Asia. Again, what's important is that PD-L1 testing is not required. You can see here in terms of event-free survival, both the PD-L1 positive and negative patients benefit. If anything, the hazard ratio is even more impressive with the PD-L1 negative, 0.48. How do we select patients for immune checkpoint inhibition in the curative setting in TNBC? Well, this is quite challenging. We don't know how to select patients. I think based on the past CR rates, we thought maybe being node positive might help us select, because we seem to see a greater delta in terms of the percentage of patients that achieve a past CR was higher. But in fact, when we look at event-free survival, the hazard ratios are almost identical for node positive and node negative patients. Now, this is the event-free survival, and what you can see here is that in those patients that did not achieve a past CR, the amount of benefit in terms of event-free survival is even greater, so 57 to 67%. And in those patients that achieved a past CR, the benefits seem to be more modest. And so really begs the question, do we need to continue immunotherapy in patients that achieve a past CR? And the bottom line is we just don't know. And in fact, just like giving HER2-directed therapy, what is the magic amount that we need? And we just don't know. And so I wanted to mention the Asia subsets. This is data presented a few years ago, where in fact we saw a greater delta, about 20% improvement in PAS-CR in this sort of slightly smaller Asian subgroup. And then more recently, we saw data in event-free survival presented at the JESMO meeting, where again, we see the delta is even greater than the larger cohort, again, a smaller sample size, but especially in those patients that did not achieve a PAS-CR, an improvement from 63 to almost 80%. And again, these are small numbers, but slightly larger delta in terms of event-free survival in those patients that achieve a past-CR, again, highlighting we really don't know if these patients need to continue it. And this is, again, just highlighting the EFS, the IA4 global and the Asian subgroups seem to benefit. Hazard ratio in the Asian subset, 0.35. Now, I think a real area of interest to me is this concept of residual burden. And the reason is that when you compare regimen A to regimen B, and you just looked at past CR rates, you actually might see that these two regimens are actually quite similar. But we know that if a patient has residual disease, they're not all made similar, and hence the concept of residual burden that was created to help sort of ease this out even more. And so you can see here in this particular regimen, there's been actually a shift towards more RCB1 and less RCB2 and 3, but we wouldn't capture that if we just looked at past CR. And so what we see here, looking at Keynote 522, is there is a big shift to, fewer patients being RCB2 and 3 down to 0 and 1. And so one of the things that comes up is that, we really see this dramatic benefit in the RCB2s. So in those patients that have residual disease, we see this 20% improvement in event-free survival. And the question is this benefit a legacy effect from immunotherapy and plus chemo in this preoperative setting, or is it continuing to have its benefit in this residual disease setting? And so I really don't think we know, but clearly we still need to do better. And I think what's really quite important for our patients and for us is how to counsel patients. One, there's an added cost, but two, there's added toxicity. Now, these toxicities, for the most part, seem to be quite common in things that we can manage, like thyroid dysfunction. But some of these other rare toxicities, such as pneumonitis and colitis, again, seem to be quite rare, but we do have to counsel our patients because these are things that have led to discontinuation. Now, fortunately, most of these toxicities seem to happen in the combination phase and not in the adjuvant component. But I do encourage you to go to a lot of the publications that currently exist to walk through some of the toxicities, how to monitor them, and how to manage them. Because I think as the learning curve improves, especially those of us that treat breast cancer, it's only been the last couple of years that we've been using immunotherapy. And certainly if we can promptly recognize some of these toxicities, start to treat them, I think bottom line is their severity can be significantly reduced. Now, one thing that was just presented at San Antonio by Heather MacArthur and of great interest was what was the impact of radiotherapy? And what you can see here is patients either had sequential or concurrent radiotherapy, and it didn't seem to make a difference in terms of event-free survival. Now, why that's important is that there was some thought perhaps that giving it concurrently might make a difference, but also important is there didn't seem to be a big difference in terms of immune-related adverse events depending on the schedule. So for now, it doesn't seem to matter which schedule in terms of efficacy or toxicity. And finally, I wanted to sort of mention that these results from Keynote 522 seem to be quite consistent. The Gepard Nuevo was a study looking at durvalumab in combination with chemotherapy, did not have a platinum, and it did not continue at the adjuvant component. But this was a randomized phase 2 where we see a very modest improvement in PCR, which did not reach statistical significance. But then when we looked at it, invasive disease-free survival, distant disease-free survival, and overall survival, we clearly see a benefit with the addition of PD-L1 inhibition. And so I think for me, this sort of says these results are consistent, but yet there's a lot of unanswered questions. So we don't have a biomarker to select the patients. We see benefit both in PD-L1 positive and negative. We see relative improvements that are similar in terms of event-free survival in node positive and node negative. We really need to figure out how we can de-escalate chemo. And it's not clear if all patients need post-operative immunotherapy. And there really is no best approach for residual disease. I want to thank Dr. Leubel for this graphic, because I think it really highlights that there are a number of ongoing trials looking at neoadjuvant, only neoadjuvant followed by adjuvant. There's some rescue studies looking at can you give it post-neoadjuvant if they have residual disease. And then, of course, a lot of excitement of IO and ADCs. And then finally, this is just to highlight how complex the portrait of triple negative really is, and that I think we're far from understanding which patients truly benefit. And I think further technologies will help refine this even better in terms of selecting patients. So with that, I want to acknowledge colleagues that loaned me slides, and thank you today for your attention. Thank you.
Thank you, Professor Den, for a wonderful lecture. Any questions from the audience? Yeah.
So especially those who are receiving neoadjuvant pembrolizumab in 522 strategy, those patients who did not achieve pathological CR, if BRCA positive, should we continue this or shift to an agent like olaparib, something like that?
Great question. I think this is one of our biggest challenges. Now, I've been fortunate in that I think, the data suggests that germline BRCA patients are more likely to pass CR. And so I've been fortunate in clinical practice. I have yet to see a patient has residual disease in this context. But as we know, I've been consulted by colleagues and many people see this. So I would say for a patient who's germline BRCA, I think if I had a choice, if I only had to give one agent, I would give them olaparib alone in that residual disease setting. If I was able to, though, and the patient could afford it and regulatory bodies would allow me to be honest, I would give both. And the reason is I think we have a fair amount of data, at least 3 trials in the metastatic setting now that have confirmed non-overlapping toxicities. If anything, potentially some synergy. With PARP inhibition, you see upregulation of the STING pathway that potentially makes these tumors more susceptible to immunotherapy. So again, thankfully, this isn't such a common scenario, but if we're able to, I would give both. I don't think we'll ever have a study in this germline BRCA population to be able to show that, except for we know that these patients have a very high risk of relapse. So I think in discussion with these patients with selected cases, it's reasonable to discuss. But if I'm only allowed to give them one treatment, I think I would focus on biology and give these patients olaparib.
So one more basic questions I have, like you mentioned that yearly TNBC, it's very. So you mentioned that yearly TNBCs with IFN gamma increase are more sensitive for the PD-L1 therapy. So we can use some other surrogate markers instead of PD-L1 actually, because there is no difference between the PD-L1 present patient and the absent patient. The treatment outcome, there's no difference. Is there any surrogate markers can we consider for the PD-L1 therapy, whom to actually we have to give the PD-L1 monoclonal antibodies against, kind of, can we use some of the surrogate marker like IFN gamma, TGF beta, or think of some immune cells markers, M2, M1 kind of?
So I guess the first thing is, in early breast cancer, it doesn't seem to matter, meaning there isn't a way currently to select the patients. And I think it's partly because we can potentially recruit, immunogenic cells that we can actually convert these patients from having a cold to a hot, to put it in very basic terms. So right now, we don't have anything to select. In the future, the question is, how are we going to de-escalate? Are we going to de-escalate the chemo component, or are we going to de-escalate the immunotherapy component? And, ironically, some would say, well, we'll de-escalate chemo because, that's the more toxic. Other people disagree, and they say because these rare significant side effects, we should actually de-escalate the immunotherapy. And so I think there's a lot of sort of disagreement about where and how we should de-escalate. So right now, even though the interferon gamma signature looks really exciting, we're not using it to select patients in the neoadjuvant or adjuvant or metastatic setting. I think it's more just to highlight, it gives us a better understanding of what's happening. But I think right now we're not in a position to be able to select patients, but it's where the research should go. And as I said, the irony is, even if you look at the PD-L1 positive patients, both in early and metastatic, those patients that are PD-L1 positive do better. So ironically, they're more likely to benefit from chemo. They're more likely to benefit from immunotherapy. And so we're still picking out the really good players. Ironically, we need to focus on the patients that don't have that interferon gamma signature, that are PD-L1 negative, to figure out how we can recruit more of those to become, susceptible to some of these therapies, because they may need more combination therapies. So I think the only thing is, the hope is in the future, yes, if you have that signature, maybe you could get away with just immunotherapy, or maybe in the metastatic setting, you could get away with just immunotherapy. It's going to be hard. Maybe you guys could do it there, because that's going to be a hard trial to convince pharma companies to do. They already are going to have approvals, and it's going to be a lot of money and very difficult to do. But I agree with you. I mean, if you look at the HER2 positive world, in the trials of Herceptin and pertuzumab, there was that small ER negative HER2 positive group of patients that got PH and got a pass CR rate of almost 30, I think it was 30%, but no one's explored that as a curative treatment. So the hope is we were brave enough to do it at some point in the future.
Thank you.
Jyoti?
Yeah, so thank you very much, Rebecca. It was an awesome lecture. And my question is, because our patients of breast cancer, especially these triple negative one, they are at borderline age, when they're diagnosed. And there is enough evidence that post-treatment, they have the least chance of, conception, etc. So we need to do, all the measures to, spare their fertility. We have now data for chemotherapy that, if somebody is having a pregnancy-associated cancer and second trimester onwards, we can treat them with chemo. There is, the space is really kind of nothing available for immunotherapy. What is your personal experience and what you suggest in immunotherapy era if we need to treat a patient of pregnancy-associated breast cancer and immunotherapy is indicated? One, and if a patient gets accidentally pregnant while she's on immunotherapy, what advice you will give?
I was funny, I was just asked this the other day, and I think we really don't have the data right now. We just don't know the evidence. My gut feeling would be that it would be inappropriate at this time, and that we really I would think the patient would be at very high risk. So my recommendation right now is that we don't have any data to support doing it. So I will not be using it in patients who are pregnant.
Thank you very much, and hope we will host you next time in person.
Thank you. Thanks so much.
Yeah, I'll hand over to chairpersons.
Thank you.
One last question. I mean, we were a lot about immunotherapy in triple negative breast cancers. What do you really see its role in hormone receptor positive?
Talk first, and then we will have one more virtual talk, and then we will have talk with Dr. Bakulesh Kumar. So Dr. John Hannan will be the first person.
Good afternoon, everyone. So we are going to start with the next talk by Dr. John Hannan on current status of treatment of cutaneous melanoma, which will be a virtual talk.
Thank you for the kind invitation to speak on this wonderful conference. I'll be talking about the treatment of cutaneous melanoma in 2023. Here are my disclosures. So the menu of today will be talking about stage 4 disease, and I will point to a couple of different studies in first line and second line, and then move to stage 2 and 3 disease. So when we talk about different cutaneous melanomas, we have to realize that there are different histologies and morphologies. So we have the lentigo-maligna melanoma, which is caused by chronic sun damage, with usually high TMB, but also, of course, the melanomas of the trunk and extremities, which are the most frequent occurring melanomas, which also have a high TMB and about 50% BRAF mutation, and at least in Caucasians, a much more rare type of melanoma, the aqueous melanoma. It's not more than about 3%, but it can be much higher in other ethnic populations with a low TMB and also low BRAF mutation rate. And then we have the desmoplastic melanomas that often occur in the face and skull, which is much more rare, which has a very typical features of spindle cell-like histologies with a low TMB and also a high response rate to anti-PD-1. Most of these, the studies that I will be showing, have included patients with superficial spreading and nodular melanomas of the trunk and extremities. The first study I would like to mention is the Checkmate 067 study, a phase 3 randomized study in non-pretreated patients with unresectable or metastatic melanoma, about 1,000 patients randomized 1:1:1 between either the combination of ipilimumab plus nivolumab or nivolumab alone or ipilimumab alone, and this was a placebo-controlled trial. And the trial was powered to show differences between the combination arm or the nivo alone arm compared to the ipilimumab arm, so not between the nivo arm and the ipi-nivo arm. Therefore, the study was not powered, and the endpoints were progression-free survival and overall survival. Now, with almost 8 years of follow-up, what you can see is that both of the OS on the left, the PFS in the middle, and the melanoma-specific survival on the right, the curves plateau. And in fact, that after 5 years, only few patients progress or die from the melanoma, which is, of course, is fantastic news. And you see in red, patients treated with a combination, in green, patients with nivolumab alone, and in black, patients who treated with ipilimumab. And I want to point out that the difference that you see between the red and the green curve is not statistically significant, although numerically different. When we look at the objective response rates, it's much higher for the combination, with 58% versus 45% for nivo alone and 19% for ipi. But mind you that the toxicity of the combination arm is also much higher, with about 60% of patients developing grade 3 to 4 toxicity, which is only 15% for patients with the nivolumab arm alone. When we look at patients treated with a combination and look at patients that required that developed grade 3 or 4 toxicities and had to stop the treatment compared to patients that were able to continue the treatment, what you can see is that there is no difference in PFS or OS whether you stop early or continue with the treatment, which of course is very good and important news. Another trial that I would like to mention is the Keynote-06 study, where pembrolizumab in 2 different doses or schedules were compared to ipilimumab, mostly in treatment-naive patients. And again here, the PFS curves that flatten after about 3 years. And the same is also true for the overall survival, again showing that pembrolizumab is a better first-line treatment compared to ipilimumab. When we look at the long-term safety data, it's important to see that patients develop long-term toxicities, and especially hyperthyroidism, that occurred in this study in patients treated with the pembrolizumab in about 9% of patients, but also other immune-related adverse events occurred. Still, we think that this treatment is quite well manageable. Also, again, looking at patients that develop an immune-related adverse events or did not, there was no difference in PFS in this study. So for whom are patients, so which patients require ipilimumab plus nivolumab versus anti-PD-1 alone? And we think that especially patients with a high LDH, asymptomatic brain metastasis, and perhaps patients with liver metastasis require combination immunotherapy. And just looking at the LDH levels, these are data coming from different checkmate studies. And what you can see is that patients with normal LDH to the left and patients with elevated LDH to the right, there's a clear difference there in response rate to the different treatment regimens. So in orange, combination, in blue, nivolumab, and in green, ipilimumab. As you can see to the right, there is no effect of ipilimumab in patients that have a very high LDH, and you can see that there's a decline in the response rate also for the other treatments. Therefore, we think that the best treatment is the combination treatment for patients with a much elevated LDH. Also, patients with asymptomatic brain metastasis treated with combination immunotherapy do fairly well. So this is a study called the Checkmate 204 study, a single-arm phase 2 study where patients receive combination immunotherapy, and the overall survival, despite having brain metastasis, was extremely good. This is also coming from the ABC trial, a study performed in Australia, where, and again, the combination of ipilimumab plus nivolumab led to a much better progression-free survival, about 50% compared to nivolumab alone, 14%, again indicating that patients with asymptomatic brain metastasis derive much more benefit from combination immunotherapy. What about liver metastasis? Well, there is a difference in general between patients having liver metastasis or without liver metastasis. Your survival is better if you don't have liver metastasis, but there seems to be some more benefit for the combination compared to nivolumab alone, although those data are not very convincing, but I think this could be considered. Is there anything new in melanoma? Is there new drugs available? Well, we have the anti-LAG3, another checkpoint molecule expressed on activated T cells, oftentimes exhausted T cells. LAG3 can bind to MHC class II, present on antigen-presenting cells, sometimes also on tumor cells. Melanoma cells can express also MHC class II, and blocking this with an antibody, in this case, relatlimab, in combination with nivolumab, may give more benefit to patients with melanoma. This was studied in the Relativity 047 study, again a randomized controlled study, started as a phase 2 study, but then moved to a phase 3 study where the combination was given or nivolumab alone was given, and the primary endpoint was progression-free survival by independent review. And here you do see the difference between the PFS curves, with a doubling of the median of the PFS for the combination arm versus nivolumab alone. But so far, there is not yet an overall survival benefit. As you can see here, the hazard ratio is 0.8, and the confidentiality interval crosses still 1. When we look at immune-related adverse events for the combination, there seems to be some higher adverse events rates in the combination, especially hepatitis occurred more often, and also myocarditis you may see more often with this combination. So in general, is the addition of anti-LAG3 to anti-PD-1 a true improvement? We don't know yet for sure. There is no overall survival benefit. There seems to be a little bit more toxicity. In the control arm, the objective response rate was rather low, 32%. Mostly it's in the low 40%. And the study started as a phase 2, was extended to a phase 3, but we don't know what happened to the PFS in both arms by the expansion. So do we need a confirmation trial? Well, there is another trial ongoing, the fianlimab plus cemiplimab trial versus cemiplimab, and perhaps we have to wait for those results to see whether it can be confirmed. What about targeted therapy? Well, of course, for patients with BRAF V600 mutated melanomas, we have different combinations of targeted agents. So in this case, dabrafenib plus trametinib, and we have already 5-year overall survival results coming from the COMBI-D and the COMBI-V study. In the COMBI-D, the combination of dabrafenib plus trametinib was compared to dabrafenib alone, and in COMBI-V, the combination was compared to vemurafenib. And here you do see the pooled analysis of the combination treatments from these two studies, and you see that after 5 years, around 20% of the patients still not have progressed the disease, and most of these patients have continued the treatment for that period of time. When we look and try to understand who benefit most of this treatment, it seems that patients having a normal LDH benefit more from patients with an elevated LDH, and especially patients with a normal LDH and few disease sites seem to have the best chance of responding long-term to this combination of dabrafenib plus trametinib. There's another trial called the Columbus trial, where a new combination of encorafenib plus binimetinib, also BRAF MEK inhibitors, was compared to either encorafenib alone or vemurafenib alone, mostly in non-pretreated patients. Here are the progression-free survival curves, again showing that at 5 years, around 20% of the patients did not progress in the combination arm. And again, patients with an elevated LDH have much worse outcome to this treatment compared to patients with a normal LDH. So patients with normal LDH, few organ site involvement, good performance status, have the most benefit from the combination therapy, but it's also probably true for anti-PD-1 treatment. And recently there was an exploratory analysis performed in the Columbus trial, where patients with high tumor mutational burden, high interferon gamma signature, a wild-type PI3 kinase gene, and a low ERBB2 gene expression seem to have the best progression-free survival. And interesting that TMB and interferon gamma gene signatures that are mostly correlated with immunotherapy also seem to predict response to targeted agents. So perhaps there is also a part of the treatment is performed by the immune system when treating patients with BRAF MEK inhibition. So how to best sequence the immunotherapy and targeted therapy? That question was addressed by the DREAMSEC study for patients with BRAF mutated melanoma that were randomized to receive either the combination immunotherapy until progression, followed by dabrafenib plus trametinib, or the opposite, starting with dabrafenib plus trametinib, and then upon progression, switching to ipi/nivo. And here are the survival curves. So there is a population that benefits mostly from the starting of the dabrafenib trametinib. That is the red curve here. But you can see that after 1 year, the curves really cross and separate with about 20% or more difference in overall survival, favoring the starting with immunotherapy. And I think this study really shows that starting with immunotherapy for most patients results in the best benefits compared to starting with targeted agents. Why is that? Well, if you start with immunotherapy here, this is arm A, and then go to the targeted therapy, you can still see that there is still a high response rate of the targeted agents. But if you start with the targeted therapy and then move to immunotherapy, the response of a rate in immunotherapy is much, much lower, and it also results in a very poor progression-free survival of only 3 months. When we're looking at the duration of response, also there is a big difference when you start with ipi/nivo compared to the targeted agent, and that's something that we already learned a long time ago. What about patients that have failed anti-PD-1? There are two important studies, the SWOG 1616 study and the TIL study, which I would like to mention here. So the SWOG 1616 study was patients that had progressed on anti-PD-1 and then were randomized 3-1 to either combination immunotherapy or ipilimumab alone. And what you can see here are the progression-free survival curves of the combination compared to ipilimumab alone, with a 6 months medium with a 6 months progression-free survival rate of about 34% versus 13% for EP alone. This can be compared with a TIL trial, where patients with mostly anti-PD-1 refractory disease were randomized to receive either tumor-infiltrating lymphocyte treatment or ipilimumab, and the primary endpoint was progression-free survival in the intention to treat population. When we think about TIL, first, a metastatic lesion needs to be removed, and then the cells are grown to very high numbers and concentrated, and then given back to the patient that had received first lymphodepleting chemotherapy, and following infusion of the TIL, the patient received interleukin-2. And here are the progression-free survival curves. You can see there's a clear improvement in progression-free survival with a hazard ratio of 0.5 for TIL, with a very nice p-value. And when we look at the 6 months PFS rate, it's 53% for TIL versus 21% for EP. Also, the response rate was much better, with a 49% response rate for TIL versus 21% response rate for EP, and 20% of the patients that received TIL had a complete remission. So what to do in second line? Of course, in the BRAF V600 mutated melanoma, BRAF MEK inhibition is probably the best and a very good choice, but one could also consider ipi-nivo or TIL or a clinical trial. What about stage 2 and stage 3 melanoma? We know that there are a couple of trials that have shown that there is benefits of treating patients for 1 year with either combination dabrafenib ramucirumab in BRAF V600 mutated melanoma compared to placebo, nivolumab or pembrolizumab. And all of these studies have shown about a 20% improvement in relapse-free survival rate for the adjuvant treatment arm. We have also data in stage 2 disease, so T3B to T4B disease, where patients were treated for 1 year with pembrolizumab or placebo. And again, you see that there is a difference of less than 10% in relapse-free survival, favoring the pembrolizumab treatment. And also for nivolumab in the Checkmate 76K show more or less the same results. So people are now talking about a lot about neoadjuvant immunotherapy, which seems to be superior compared to adjuvant treatment. Now, why is that the case? Because we think that once the tumor is still present, you may induce a better and broader immune response and take the tumor out after that you have induced this immune response. So this may lead to a better clearance of micrometastatic disease. And the OPECIN study, where patients receive ipi-nivo prior to surgery compared to following surgery, led to a broader immune response with more expansion of already existing T-cell clones and the development of new T-cell clones. So this was also addressed in a larger study, the OPECIN-NEO study, where patients that have a very nice pathologic response have a very good outcome, and especially patients that have a high interferon gamma gene signature or high TMB seem to derive much more benefit from the combination immunotherapy compared to patients that have a very low interferon gamma signature and low TMB. So these may be very interesting predictive markers. Interesting is this study, the SWOG 1801 study, where patients with stage 3 disease, mostly, there were a few patients with also resected stage 4 disease, were randomized to receive, after surgery, 18 cycles of pembrolizumab or 3 cycles of pembrolizumab prior to surgery, and then the 15 cycles after surgery. And what you see is that there is a clear difference in the event-free survival for the patients treated with the neoadjuvant part of the pembrolizumab, and this difference was very, very significant, indicating again that that neoadjuvant treatment may really lead to a much better immune response compared to only giving the treatment adjuvantly. And there's now a 3-year trial ongoing. It's called the NADINA trial, where patients were randomized between surgery followed by 1 year of nivolumab as a standard of care, or 2 courses of ipi/nivo prior to surgery, and depending on the major pathological response, either receive no treatment, or if there is no pathologic response, receive adjuvant treatment. And this trial should show whether neoadjuvant immunotherapy may be enough for this patient population. So to summarize, the treatment of cutaneous melanoma has changed rapidly over the past 10 years, and immunotherapy has become the main driver of the treatment algorithm that we have today. Anti-PD-1 consisting therapy has become first-line treatment, and for failures, TIL could be a treatment option. And of course, for BRAF V600 mutated melanomas, BRAF inhibition is a standard of care. For stage 2 and stage 3 disease, there's clearly an improvement of adjuvant treatment, but the question is 1 year really necessary? And shouldn't we move to neoadjuvant immunotherapy, at least as a component, because there is clearly an important effect there? And can we tailor perhaps in the future neoadjuvant immunotherapy towards patient-specific or tumor-specific characteristics? And with that, I would like to end my presentation. And
Dr. John is online, so we can take a few questions before the break.
Thank you, Dr. John Hannon. It was an excellent lecture as always, and thank you very much for joining with us successively in our Immuno-Oncology Society meetings. It's a great pleasure and honor. So it was a phenomenal talk and lot of advancement in melanoma field. I would like to take your advice for the clinics. Now there is a lot of new adjuvant which is coming up. What is your own practice and what you suggest? Because there is definitely a very fascinating thing that if we use new adjuvant in patient going into PAT-CR, perhaps we can tailor it in adjuvant, and there is a lot of cost saving as well.
Yeah, yes, I think that's a very important question for the whole field, not only melanoma, but perhaps even beyond that. So far, I think the data of leaving out the adjuvant part are still sparse, right? So the only data that we have are coming from the Opacin NEO study and the Prado study. These were smaller studies, and therefore I think to be 100% sure that we can leave out the adjuvant part of the treatment, we need to wait for the results of the NADINA trial. And the NADINA trial has now accrued over 200 patients and requires more or less a doubling, so about 400 patients. We expect to finish the accrual at the end of this year. And then we need a little bit of follow-up in order to say whether the difference that we see is strong enough to consider patients that have a complete or major pathologic response based on the neoadjuvant treatment is enough and do not require any adjuvant further treatment. I think and I hope that will be the case. But I think in order to be 100% sure, we have to have these results.
Absolutely. Another question again, I'm thinking for the cost saving, issue, which is very, very applicable, especially in low middle income countries. So now the adjuvant indication is creeping into earlier stages, stage 2. So there is, data which is a little bit emerging, but what is your current practice? And do you think it is really practical? We can use abbreviated course if it is a stage 2 and adjuvant therapy, or really still standard of care 1 year?
I think it's what, let me put it this way. In the Netherlands, the adjuvant treatment for stage 2 disease has not yet been approved. And one of the major reasons is that there is, of course, no difference in overall survival. That's even true for the patients treated with stage 3 disease. So far, we've only seen relapse-free survival data and not yet an overall survival difference. The overall survival in the end will be very important because if there is no overall survival difference following adjuvant treatment, that means that many of the patients that recur later on can be rescued by treatment in stage 4 disease. So I think in the end that will be a major thing to have that. While waiting for that, I think what one could consider, and it's certainly something that we are considering in the Netherlands, is approving the adjuvant treatment for stage 2 disease, but then require patients to be put on a trial where we compare 3 months adjuvant treatment with 12 months adjuvant treatment to sort out whether 3 months would be enough treatment. I cannot imagine that you really need 1 year of adjuvant treatment.
Sure. Another practical question from clinics is that, many times we are not able to give dual therapy, epi, nivo, both. So if a patient is started to begin with a single agent, but at a later point we are considering it, what is the window you feel? Is it 2 months, 3 months time? Within that, if we want to combine epi, it is the best, or we can combine it at a later point also. What is your practice on that?
So I think if you would give the first line treatment with anti-PD-1 for 3 months, and you would see that the patient has a clear response, you would not consider adding ipilimumab. If the patient has stable disease, I think I would continue to 6 months and then make a new scan. And if then there is no change and there's clearly disease present, one could consider the addition of ipilimumab. If you fail anti-PD-1 after 3 months, the combination that's coming also from the SWOG 1616 study can rescue a couple of patients with a response rate of close to 30% in that patient population. So yes, I think you could sequence these the addition of ipilimumab, but it would very much depend on the results seen at 3 and 6 months with anti-PD-1 alone.
So thank you very much. I think there are lots of questions, but in the interest of time, perhaps we need to move on, and I'll keep, writing to you. Yeah. So there's another question which we will take, and later we will continue on email.
Okay, sure.
I would
take too much
love
time.
to be there in live with you. I'm sorry I can't be there.
Yeah, I'm Shubrajit. Actually, I'm basic scientist, so my question is also a little bit in the basic way. You're telling about the TIL therapy, right? That is tumor infiltrating lymphocyte. And along with that, you are giving the interleukin-2, right?
Yes.
So question is that is after the treatment, that what is the situation of the CD8 plus positive population, as well as the any immunotolerance in terms of the FLOXP3 expression over there in the patients after therapy? Yes.
Yeah. So I can see your point. You think if you give high dose interleukin-2, we may also expand the FOXP3 positive cells as they are 25 positive. Apparently, that is not the case. So we don't see both in the production of TIL, where we also use high doses of interleukin-2, expansion of FOXP3 positive cells. So there are only very few FOXP3 positive cells in the end product.
And normal cytotoxic T cell, that is CD8.
Oh yeah, the majority is CD8 positive T cells. So the majority of the cells are, let's say, CD8 positive T cells, and they have the hallmarks of cytotoxicity. In the patients, first of all, we induce lymphodepletion, right?
Right.
Start with lymphodepletion, and then we give the cells to allow them to expand under homeostatic expanding cytokines like IL-7 and IL-15. Exactly. And then we give the high-dose interleukin-2 to further stimulate and the cells in vivo. We do see expansion of the CD8 T cells, but of course we don't know whether these cells are the cells that were infused because the TIL are not tagged. You cannot see them, right? They are just a bulk of autologous T cells.
Yeah. Thank you. Thank you. Maybe next speaker or thank you, John.
You're welcome.
Thank you, Dr. Priyanka, and thank you all the participants. And the next session will be another keynote lecture, which is progress in immune checkpoint blockade in sarcoma and skin cancers, with special focus on Merkel cell and squamous cell carcinoma. To chair this prestigious session, may I request Dr. Vineet Talwar. Dr. Vineet Talwar is Senior Consultant Medical Oncologist from Rajiv Gandhi Cancer Hospital, Delhi. Dr. Dinesh Yadav. Dinesh is probably busy, naughty, he is our surgical colleague. Dr. Bharat Rekhi from Mumbai, he may be joining virtually. Dr. Jyoti, can you introduce the speaker if you have more details?
So it's an extreme pleasure and privilege to introduce none other than Dr. J.Y. Blay, and he is a very dear friend, and we work in close collaboration for many things, including ESMO guidelines. And Dr. Blay is, he's the president for French Sarcoma Group as well as Unicancer, and also he's the current ESMO policy head. So without going into much, much details, I think we will hear him out and later having a chance to live interact with him. Thank you very much.
Good morning, good afternoon. My name is Jean-Yves Blay, and I would like first to thank you for the invitation to give this lecture on immunotherapy of sarcoma and skin cancer. I'm working in Lyon, France, and I'm the president of the French Sarcoma Group. These are my disclosures as both an investigator and as the director of the hospital where I work. And I would like to start first by working on the question of immunotherapy of sarcoma, with several subtopics indicated here. First, the classification of sarcoma, the results, biomarkers, and the next step to be conducted for the immunotherapy of sarcoma. As we all know, sarcoma is a very heterogeneous group of disease. There are more than 150 different histological and molecular subtypes of sarcoma reported in the latest WHO classification. Most are very rare, with an incidence inferior to 1 per million per year. Few are a bit more frequent, but anyway, it's a very fragmented group of disease, which is further fragmented by the observation that we have an additional layer of complexity with molecular characterization of this disease, with molecular subgroups, with kinase mutation, translocation, and so on, which further increase the complexity of this classification. So what about immunotherapy in these tumors, which are very complex, and probably we can assume that the impact of immunotherapy on these different tumors are not going to be very homogeneous. And actually, immunotherapy of sarcoma is a long history. It started at the end of the 19th century by local injection of bacterial lysates in tumors, showing the activity of this strategy, cholestoxin, which remained in use for several decades actually after its identification. Also, anecdotal observation which came out from activators of the immune system, such as mifemertide, which reported in randomized studies an impact on the reduction of the risk of relapse of osteosarcoma, but this is not registered everywhere around the world. Actually, of course, when we are speaking of immunotherapy of sarcoma, we are speaking of the immunotherapy using the most modern immune checkpoint blockers, CTLA-4, and more importantly, PD-1 or PD-L1 antibodies. And the first results were not so convincing. Looking here on the left-hand panel at the immunotherapy of uterine sarcoma in a small series which reported no impact on tumor control. And a second series, which was reported by the French Sarcoma Group, using a combination of pembrolizumab together with low dose of cyclophosphamide, which was basically very negative for all histological subtypes tested. There was only one response out of these first 30 patients on the solitary fibrous tumor, so not very active. Subsequent studies reported more interesting response rate, but they remain somewhat limited. The SARC-028 study used pembrolizumab in advance of tissue and bone sarcoma, showing on the left panel, actually it's only a minority again of the different histological subtypes tested here. In this case, the differentiated liposarcoma and UPS responding, and for relatively short duration. It was even worse for bone osteosarcoma, as shown here. The nivolumab with or without ipilimumab study, the Alliance study, which was a randomized study comparing ipi plus nivo versus nivo, also reported interesting observation, in particular the fact that the combination of ipilimumab plus nivolumab seemed to provide some additional response rate in patients with advanced disease. But these were, again, unselected patient populations. And probably with some difficulty to identify what are going to be the next step, was the histological subtype who truly benefit from this treatment. The pembrolizumab study I was mentioning also explored bone sarcoma with basically the same results than those reported by the studies of our colleagues from the US. Actually, the next steps were to investigate the combinations of VEGFR2 inhibitors, in this case axitinib, and PD-1 antibodies in combination treatment in phase 2 studies. And these provided interesting results, in particular these first results reported by Dr. Wilkie showing the activity of the combination, in particular in a rare histological subtype, which is alveolar soft part sarcoma, where response rates were quite high. We know that this is a tumor which is sensitive to VEGFR2 inhibitors. It's also found to be sensitive to PD-1 antibody. Interesting observation, which was also reported by our colleagues from the HAIS group. Javier Martin Broto reported on the combination of nivolumab and sunitinib in advanced soft tissue sarcoma. That was a phase 1b/2, which actually provided some substantial side effects. What is interesting is that, again, a fairly larger proportion than with single agent, fairly larger proportion of patients with advanced sarcoma did achieve some tumor control in the form of shrinkage in green or prolonged stable disease. And this was observed in a wide variety of different histological subtypes, synovial sarcoma and differentiated pleomorphic sarcoma. There were a few alveolar soft part sarcoma, but they seem also to derive some benefit in this case. So interesting observation showing a combination can be useful for the treatment of this patient. In view of this first generation of studies, it was interesting to observe that response rates were somewhat variable across the histological subtypes. Again, alveolar soft part sarcoma seemed to derive some more benefit in the different studies which were reported. UPS maybe only, leiomyosarcoma to a lesser extent, and this was observed with combination treatment with PD-1 and CTLA-4 or single agent. So what was the next step? Trying to define what are those patients responding to this treatment? What are the predictive biomarkers? PD-L1 expression, mutation burden, immune infiltrates, aneuploidy. Actually, an interesting observation came out from the analysis of a US study at the pembrolizumab study, trying to identify who are the biomarkers, which are the cell immune infiltrates, which could be correlated to response and prolonged tumor control in this patient population. And the presence of B cell was reported in this paper, as well as in other papers in different tumors, as being associated with response to immunotherapy and immune classification of these sarcoma using an expression profile reported by Petitpré and collaborators in Nature identified one group with designated as tertiary lymphoid structure I sarcoma, which seemed to be the group with this tertiary lymphoid structure present in the primary tumor or in metastasis at initial diagnosis or at relapse. And even though representing about 18 to 20% of the patient, these were the patient in red here who seem to derive a benefit from the treatment with immunotherapy. So that was a retrospective collection of data. Is this also true when you look prospectively? That was investigated in the subsequent step of the pembrolizumab trial and was reported in Nature Medicine, showing that indeed, as shown on this panel, patients selected on the basis of the presence of tertiary lymphoid structure seem to derive a better progression-free survival, overall survival, did derive better benefit than unselected patient population, and sometimes with prolonged duration. So that's interesting, and that's probably going to serve to guide us for the future. But not only, because we know that beside these biomarkers, histological subtypes, and we have seen that with alveolar soft part sarcoma, can also guide us to better define the treatment. The ACCE-PAMBRO study was a study conducted in France, designated to explore ultra-rare sarcoma subtype to try to identify, on the basis of these previous reports, who were the patient truly benefiting from immunotherapy in rare sarcoma subtypes. That was a general program designated to explore rare adult solid tumors, and this was one arm on sarcoma of this basket axis pembrolizumab study. Very simple design, selection of the patient on the basis of these histological subtypes, centrally reviewed, pembrolizumab given to every 21 days according to the usual specification. Primary endpoint, objective response rate, which was measured at actually day 84, and secondary endpoint indicated here, all the classical secondary endpoint. We first reported on the first 80 patients included. The majority were actually chordoma, alveolar soft part sarcoma, plus a small number of rare histological subtypes, desmoplastic small round cell tumors, SMARCA4, malignant rhabdoid tumors, and few others. Interestingly, the first evaluation, the primary endpoint, was actually quite deceptive in showing only a 6% response rate. What was very interesting to observe is that actually the majority of response occurred later, with some patients deriving also prolonged tumor control in patients who are not immediately responding in the first 6 weeks. And responses and tumor control were observed in a wide variety of different subtypes. Chordoma, alveolar soft part sarcoma, epithelioid sarcoma, SMARCA4 malignant rhabdoid tumors, with median progression-free survival of the whole series close to 8 months, median survival close to 20 months. You can see here in yellow and in orange, actually, that alveolar soft part sarcoma and chordoma did derive the larger benefit. Some patients with epithelioid sarcoma and rhabdoid tumors also derived benefit, but there were overall a larger population of the first 2 histological subtypes, and this was also translated in an apparent survival, better survival outcome of these 2 histological subgroups. Nevertheless, and that was reported already, there were some very dramatic responses in patients with rhabdoid tumors, previously rapidly progressing, and this patient is still alive, progression-free, more than 3 years after initiation of treatment of a highly metastatic, rapidly progressing tumor. Intriguing, we are not there yet to understand what is happening. But what we see is that we have in this study the observation that some histological subtypes seem to derive benefit on top of those identified also with the presence of tertiary lymphoid structure. So really 2 parameters, tertiary lymphoid structures and specific histological subtypes as predictor. So what are the next steps? The next steps are cell therapy. This is one of the next steps. There are many others. Different studies conducting, exploring T cells transfected with T cell receptor recognizing either MAGE-A4 or NY-ESO-1 in an HLA-A2 context were demonstrated quite nicely the efficacy of this approach. Spearhead-1 tests such cells called AFAMI cells, recognizing MAGE-A4 in A2 context for synovial sarcoma and myxoid round cell liposarcoma, which are known to express frequently these tumor-specific embryonal antigens. Very simple design to be included the patient first to be screened for HLA-A2 and MAGE-A4 expression. Then cells were collected, transfected. The patient was given lymphodepletion with fludarabine and cyclophosphamide, then re-injected, then followed. Shrinkage of the tumor was, in this case, with a synovial sarcoma observed in a large proportion of patients, with a single reinjection of transfected cells. And on a larger data set, which was subsequently reported, we observed that both using independent and investigator review, a large proportion of patients did derive at least stable disease, and some of them complete or partial response in a large proportion of patients. And we can see here in this spider plot that these responses can be very long-lasting in this patient population. Who are the long responders? Well, small tumor burden, probably female patients seem to derive a larger benefit, but this is still work in progress. Here for synovial sarcoma, the other product, letetresgen autoleucel, is recognizing this time tumor cells, synovial sarcoma or myxoid round cell liposarcoma in an HLA-2 context expressing NY-ESO1. I show you here the results obtained with myxoid round cell liposarcoma, which are, of course, less frequent than synovial sarcoma, showing also significant level of tumor shrinkage, which can be prolonged for some patients. So studies are still ongoing and accruing. That is a complex and probably very expensive, but very interesting strategy with some prolonged progression-free survival in some patients. All right, what are the next steps? What are the ongoing clinical studies? Several studies have been investigating as it has been done in more classical tumor types targeted for immunotherapy, such as melanoma or non-small cell lung cancer, the use of neoadjuvant treatment. And this is one of the studies exploring UPS and the differentiated liposarcoma. In the RT immune studies, we are using the same strategy with atezolizumab, randomized before or after treatment with surgery in combination or not with radiotherapy, with a primary endpoint, which is translational research. Study is ongoing, close to completion. Hopefully, we will get some important information from this one. And also, next steps are studies focusing on this population of patients which have been identified, such as a tertiary lymphoid structure positive sarcoma. The Congress study in this patient population within the French sarcoma group is exploring the combination of nivolumab plus relatlimab versus nivolumab, and the study is also rapidly accruing and probably now close to completion. We have other combinations which are being investigated, in this case in the atezology study, exploring imatinib alone in late stage treatment as compared to imatinib plus atezolizumab just started. Time will tell whether this is a strategy which can be useful as suggested by first results in this patient population. All right, in a few minutes where I'm left, I would like to cover with you briefly the question of immunotherapy of skin cancer. And again, here the publication is quite rich in informing ourselves. And I would like to cover these different topics quite rapidly, starting with sarcoma again, Kaposi's sarcoma, where with a very nice publication conducted in multicentric study exploring patients with Kaposi sarcoma, 17 patients included. You can see here that the tumor shrinkage is very substantial, close to 60% of the patient achieving tumor control, which can be very prolonged. The response is occurring quite rapidly, as you can see on this patient population. This is both sporadic, classic, or endemic Kaposi sarcoma, and these are encouraging data from as compared to the other option that we have for these patients. Merkel cell carcinoma is also a rare malignancy. I will start with a study report, which was a bit late as compared to the first studies with avelumab, testing first-line pembrolizumab for advanced Merkel cell carcinoma. We can see here that the median progression-free survival was close to 12 months, a bit more, slightly better, of course, survival in patients achieving tumor control, but still a significant proportion of the patient not responding to this strategy in first line. And this was, of course, tested before in the Javelin study for patients which were explored in previously, who had been previously treated, showing again a tumor control rate which is in the range of 30%, median progression-free survival and overall survival quite comparable to what has been observed in the previous study I was showing. No significant difference here in terms of overall survival according to the level of expression of PD-L1. So an active treatment, but an active treatment only in the selected patient population. And this is true in the subsequent Javelin study conducted in first-line patients, where the response rate is slightly superior, close to 45%, but still the overall survival remains somewhat limited, with 12 months overall survival in this case of 60%. Active treatment, superior to what had been reported previously with cytotoxic chemotherapy, but still a proportion of patients not responding. And we are not there yet to identify who are these patients responding and not responding. Interesting treatment available in some countries around the world. Advanced cutaneous squamous cell carcinoma, several studies have been reported in patients with metastatic disease, in patients with locally advanced disease, with doses given per kilograms of flat doses. And the results are, I must say, quite impressive in terms of complete response rate, partial response rate, or even in terms of stable disease in this large data set integrated phase 2 study of cemiplimab in this patient population. Shown here, and you can see that with the orange that the group with locally advanced seem to do slightly better, both for progression-free survival and for overall survival, with a two modality of administration on dosage, which seems to be similar. Very active treatment in terms of tumor shrinkage and prolonged activity if we look at PFS and overall survival in this case. In neoadjuvant setting, again, it's quite attractive. It's impressive. Impressive in terms of pathological complete response, which is observed close to 50% of the patient. Also, major pathological response against the neoadjuvant approach is very much encouraging in this patient population. It needs to be further investigated as a therapeutic strategy for large tumors. Work in progress here. I would like to conclude by saying that for advanced basal cell carcinoma following classical EDGEOG inhibitor therapy, studies have been also reported showing again shrinkage of the tumor in about 30% of the patient, and interesting progression-free survival of these patients, again with locally advanced progressive non-resectable tumors, showing a median PFS close to 19 months. Interesting observation. We have strategies to treat patients with locally advanced skin tumors beyond melanoma. That will be my conclusion. Immunotherapy is working in sarcoma and skin cancers with a higher response rate and tumor control rate in skin cancers, but still interesting observation in sarcoma, which needs to be further evaluated in these tumor types where we missed additional options in advanced phase in patient failing the classical treatment. Thank you very much for your attention.
Thank you, Dr. Jean. And before we put the questions open to the House, I would like to ask you a question. You mentioned in the treatment of sarcomas, the use of ICIs, pembrolizumab and the others, they have been used, and the data which you showed, it was promising for chordomas and alveolar soft part sarcomas amongst the others. So in the treatment paradigm, where would you put the ICIs? Where would you start treating them with the immuno-oncology drugs? Upfront, after first line, second line, or where would you actually put this drug? Can you hear
I
us?
think there is some connectivity issue with Dr. JY, isn't it?
I guess he cannot hear us.
Yeah. So I think then we'll keep our questions reserved meanwhile.
Yeah. So
Dr. Bharat, are you there? Dr. Rekhi?
I think there is a...
Yes, Dr. Jyoti, I am very much there. And thank you for having me.
Yeah, so thank you very much for both the chairs. Unfortunately, Dr. JY joined, but there is some connectivity issue in between. So at present, we are not able to see him live. So
Okay, but I was just trying to text him. I think that might work because he might be able to see the chat box. So I'm just putting something in the text in the chat box. If it's okay for some queries, if I can.
So all the queries you please send out to us, because we tried, but he is not able to. In the interest of time, we need to move on now, and he will join later. Then we will again open the questions.
But I must say it was a fantastic talk. I was just telling him, writing to him, for dismal tumors, rare tumors, which had less hope, and you've shown us, and Dr. Blaise talk mentions about, hope with the immunotherapy for all these tumors. So it's really very nice to have heard. And I had some questions about Merkel cell. Maybe I'll just, put it to you, which you can forward. Thank you so much.
Sure. Thank you so much for joining here.
So thank you, Dr. Talwar. Thank you, Dr. Rekhi, and thanks to Dr. Jyoti for arranging this virtual talk for us. The next session is on the CAR T cell therapy in sarcoma, and the speaker will be Dr. Sandra from MSKCC USA. Dr. Jyoti, can you please introduce her formally?
So Dr. Sandra is a lead medical oncologist from Memorial Sloan Kettering Center, USA, and she's pioneer for the CAR T cell work in sarcoma. Her experiment and her work was one of the plenary in ASCO this year. So without much delay, I would invite her for the talk. Thank you very much.
Thanks so much to the meeting organizers. It's my pleasure to share an update in the progress made in the field of T-cell therapy for patients with sarcoma. These are my disclosures. By way of background, sarcoma is a group of diseases characterized with over 80 different subtypes. Each disease behaves unique, though there are some overlap. Our standard frontline therapy for patients with soft tissue sarcoma includes doxorubicin or gemcitabine and docetaxel. With those agents, the median progression-free survival is about 24 weeks, the median overall survival is about 19 months, and the response rate remains in the 20% range. When you look at the progress made with immunotherapy in the field of sarcoma, the response rate, even with these approaches, also remains consistently in the less than 20% range. I'll highlight, though, that these studies were all conducted in a lumped fashion in unselected histologies. We've come to appreciate that recent successes in sarcoma has actually been driven by underlying biology and by histology-specific studies. Some examples of such success includes pexidartinib for the treatment of patients with advanced tenosynovial giant cell tumor, or nab-sirolimus for patients with malignant picomas, or tezimitastat for those who have INI-1 loss and a diagnosis of epithelioid sarcoma. So when we look at immunotherapy studies, if we begin to split out these histologies, we may begin to see some hints of activity. For example, with undifferentiated pleomorphic sarcoma, pembrolizumab alone has shown a response rate of about 23%, while combining CTLA-4 blockade with nivolumab leads to a response rate of almost 30%. Similarly, with alveolar soft part sarcoma, atezolizumab has shown a response rate of 40%, and this is now actually FDA approved in the United States. And then we see that those with cutaneous angiosarcoma can have very high response rates with checkpoint blockade as well, with a response rates almost approaching 70%. Alternatively, diseases like osteosarcoma and uterine leiosarcoma, checkpoint inhibition has remained quite dismal with really minimal evidence of efficacy. And so what we've begun to do in the field of sarcoma is conduct histology-specific studies. We divide the patients by their underlying disease. And while on trial, there's a conscious attempt to try and obtain pre and on-treatment tumor biopsy to collect tumor, serum, plasma, stool, and really hope to identify biomarkers of response, primary resistance, toxicity, acquired resistance, and even histology-specific markers. We hope by doing that, that could provide some rationale with future clinical trial development. And in the end, we are now tailoring our options based on specific biology. So if you look on the right, undifferentiated pleomorphic sarcoma, this is a tumor that can have high tumor mutational burden. We know that there are immune infiltrates present. It is characterized by tertiary lymphoid structures. And in this disease, monotherapy checkpoint blockade actually can help a number of patients with this diagnosis. Alternatively, on the complete contralateral side of UPS are translocation-driven sarcomas, diseases such as synovial sarcoma and myxoid liposarcoma. For these diseases, we've opted to take a completely different approach. Synovial sarcoma is indeed the prototypical immunological cold cell tumor. So for that reason, it actually serves as a great model to explore T-cell therapy. Synovial sarcoma has the lowest expression of PD-L1, the lowest amount of T-cell infiltrates, low tumor mutational burden, and the microenvironment is quite it's quite challenging with high interstitial fluids and significant hypoxemias. Synovial sarcoma is a rare and aggressive malignancy. It actually accounts for about 5% of all sarcomas. The median age of presentation is about 20 to 30. There's 600 cases each year diagnosed in the United States. Metastatic disease can occur in 6 to 20% of newly diagnosed patients. Response rate to frontline chemotherapy can be quite high, almost 40%. However, in the refractory setting, it remains in the 5 to 15% range. And despite response rates, we know that once patients develop metastatic disease, cures are rare and seldom. Synovial sarcoma is actually characterized by a prototypical chromosomal translocation. SS18 on chromosome X fuses with SSX on chromosome 18. And as a result, this leads to aberrant transcription and cellular metabolism. And in addition, it's also linked to NY-ESO expression in the tumor. Indeed, nearly 80% of synovial sarcomas have strong NY-ESO1 expression in a homogeneous and very high fashion. That actually formed a lot of the interest in exploring adoptive cell therapy approaches in this tumor. There's a number of different ways to integrate adoptive cell therapy into the clinic. Much of the efforts in sarcoma, though, have been focused with engineered T-cell therapies. In these efforts, genetically engineered T-cells encode tumor-specific TCRs, and they target antigen peptide HLA complexes. And the success and progress has really been made with two targets, with NY-ESO and MAGE-A4. The power of T-cell therapies is the power of the potential and number of targets that exist. TCRs actually can recognize intracellular antigens, which comprise nearly 90% of the proteome. Some examples of that are tumor tissue differentiation antigens, or shared cancer-specific antigens, such as cancer germline antigens, which is where much of the efforts in sarcoma have occurred. In addition, there's other novel approaches, such as targeting private neoantigens and public neoantigens. One of the limitations, though, of TCRs are their dependency on HLA, and that can, in fact, potentially limit broad applicability of this approach. Specifically, cancer testis antigens are very promising therapeutic targets. They are so because, first, they can elicit both cellular and humoral immune responses. And importantly, their expression is restricted in immune-privileged sites, such as the testes. There's limited or no expression in normal tissue. NY-ESO specifically is highly expressed in numerous solid tumors. Of interest to us is its high prevalence in both synovial sarcoma and myxoid brown cell liposarcoma. Some of the earliest efforts with TCRs targeting NY-ESO originated at the NIH under Steven Rosenberg's group. And what they showed was that when patients received the NY-ESO TCR, along with IL-2, about 50% of patients had a decrease in tumor burden. That led to the basis and rationale of embarking on this particular clinical trial. This was a pilot study of NY-ESO TCR, now referred to as lete-cel in synovial sarcoma. This trial initially opened at Memorial Sloan Kettering in 2014. The inclusion criteria are fairly typical of sarcoma studies, with the exception of the necessity for the tumor to express NY-ESO, as well as the presence of the specific HLA-A02 alleles. The primary endpoint was overall response rate. Secondary outcomes included duration of response, progression-free survival, and overall survival. And exploratory outcomes included qualifying persistence, phenotype, functionality of lete-cel, as well as exploring mechanisms of response and resistance. Here are the methods. Part one is screening. This is there's an effort to really explore the presence of NY-ESO in the tumor, as well as the appropriate HLA-A02 allele. Once screening is completed and a patient is deemed eligible, you initiate the process of leukapheresis and manufacturing. Manufacturing can take up to 4 to 6 weeks. And once the product is prepared and sent back to the specific site, patients undergo lymphodepletion chemotherapy, followed by infusion of lete-cel, followed by follow-up for disease and assessment, and then long-term follow-up. In this study, there were 4 cohorts. The initial study was really just cohort 1. In endeavor, there was an interest in really highlighting evidence of efficacy with this TCR in those patients who had tumors that expressed high NY-ESO expression. And in this effort, in cohort 1, patients received high doses of fludarabine and cyclophosphamide, as noted on the slide. The study evolved and other important questions were then asked. In cohort 2, those with low NY-ESO expression were allowed to enroll. In cohort 3, there was an interest in potentially mitigating some of the hematological adverse events, and therefore fludarabine was omitted from the lymphodepletion regimen. And then in cohort 4, it was a modified attenuated dose of lymphodepletion chemotherapy that was utilized. Here are the demographics of all the enrolled patients. In total, 253 patients were screened, and ultimately 45 went on to receive T-cell therapy. We'll highlight that much of the screening and failed screening was due to the lack of the appropriate HLA allele. Patients' median age was about 32. There was an equal representation of both males and females enrolled. Nearly all patients had prior systemic therapy. The median transduced cell dose was 2.4 billion cells. I'll highlight that in cohort 1, bridging therapy was not allowed, and therefore patients, after signing and pursuing screening followed by leukapheresis, they were not allowed to receive therapy. Unfortunately, there were a number of patients that progressed and were unable to receive T cells. And therefore, with evolution of the study, bridging therapy became an important part of allowing patients access to cells. Here are the response rates. As you can see, the response rates range from 20 to 50%. The duration of response ranged from 8 to 32 weeks. Cohort 1 was the cohort that utilized the highest lymphodepletion regimen, and that indeed seemed to have the best efficacy with the longest duration. And that is the chemotherapeutic dose that is being utilized in future studies. We also learned some important findings with these studies. First, higher lymphodepletion chemotherapy seems to be associated with lower endogenous lymphocytes, higher IL-15 levels, which are both correlated with response. The IL-15 levels were lowest in cohort 3, as you can see in the figure on the far right. In that cohort, fludarabine was omitted, and that highlights the importance of including fludarabine in these lymphodepletion regimens. In addition, higher lymphodepletion chemotherapy regimen correlates with expansion, persistence, both important findings which ultimately correlate with response. In addition, there were efforts looking at mechanisms of resistance to lete-cel. Importantly, the antigen seems to be expressed at the time of progression, though there does seem to be a decrease in both HLA-A expression as well as antigen-presenting machineries. And these two findings can potentially highlight important combinatorial strategies in future studies. Based on the efficacy seen with lete-cel in synovial sarcoma, and based on the fact that myxoid round cell liposarcoma also expresses NY-ESO, a second study was opened looking at lete-cel in those patients with advanced myxoid round cell liposarcoma. Just by way of background, liposarcoma is one of the most common histological subtypes of soft tissue sarcomas. Myxoid round cell liposarcomas accounts for about a third of all liposarcomas. Unfortunately, a third of patients with myxoid round cell liposarcoma will develop recurrent and/or metastatic disease, and prognosis for metastatic disease is quite dismal. Again, response rates in myxoid round cell can be quite high and often durable, although in the context of metastatic disease, we can all appreciate that cures are also rare and seldom. Similar to synovial sarcoma, myxoid round cell sarcoma is an immunologically cold tumor. This particular study had similar efforts and processes as already described in synovial sarcoma. There was a screening phase followed by leukapheresis and manufacturing, integration of bridging therapy if necessary, followed by lymphodepletion chemotherapy, T-cell infusion, appropriate disease assessment, and long-term follow-up. This study also evolved. The initial cohort utilized a reduced dose of lymphodepletion regimen. Given though the signals of improved efficacy were with higher chemotherapy doses, cohort 2 was then later introduced. Here are the baseline characteristics of those patients enrolled in both cohorts. There were 10 patients enrolled in each of the cohorts. The median age was about 40 to 50. All patients had received prior systemic therapy. I will highlight that chemotherapy between apheresis and lymphodepletion varied amongst the two cohorts. In cohort 1, only most patients actually required lymphodepletion. Most patients required bridging therapy. However, in cohort 2, only 3 patients required bridging therapy. And this may suggest a more indolent or perhaps less aggressive biology of enrolled patients in cohort 2. The median cell dose in both of these cohorts was similar at 4.6 billion cells. Cohort 1, the response rate was 20%, and the duration of response was about 5 months. And then cohort 2, the response rate was 40%, and the duration of response was 8.7 months. As a result of these 2 studies, an initial master protocol has since opened. This is called the IGNITE-ESO study. This is evaluating lete-cel in patients with synovial sarcoma and myxoid round cell sarcoma. To date, there are 2 cohorts which actually have completed accrual at this time. Cohort 1 enrolled 10 patients with previously untreated disease, and then in cohort 2, which has a potential registrational strategy, has enrolled 55 patients, and we anticipate these results soon. Shifting gears now, MAGE-A4 is another cancer testis antigen that's actually expressed in a number of solid tumors, and particularly prevalent in synovial sarcoma at a prevalence of about 50 to 80%. There was an initial phase 1 study with afami-cel, which is a TCR that targets MAGE-A4, which noted impressive response rates in synovial sarcoma. And that phase 1 study actually formed the basis of the SPEARHEAD-1 phase 2 clinical trial. Similarly to the lete-cel efforts, the eligibility, the screening, and the study methods are quite similar. To date, cohort 1, which aimed to enroll 45 patients, has completed enrollment. And then with cohort 2, 45 patients is the goal, and this is actively recruiting, though only synovial sarcoma cell patients. Here are the baseline disease characteristics, which are again similar to patients enrolled in these types of studies. I will highlight, though, that the median cell dose on this study was 8.8 billion cells, which is almost double that seen in the myxoid round cell liposarcoma, and nearly 4 times of those seen with the initial synovial sarcoma studies with lete-cel. All patients did have prior systemic therapy, and about 40% required and used bridging therapy. The overall response rate was 36%, 40% in synovial sarcoma, and 13% in myxoid round cell liposarcoma. The duration of response was 50 weeks in synovial sarcoma and 18 weeks in myxoid round cell liposarcoma, and there are 8 responses ongoing at this time. Important clinical factors have emerged as potentially signals of where we can see improved efficacy, and these can actually help us determine when to integrate the therapy for our patients. Importantly, responses seem to be higher in those with a lower tumor burden, no bridging therapy, and a higher H-score. The H-score highlights the amount of MAGE-A4 expression. I'll summarize the adverse events here with lete-cel and afami-cel. As you can see, grade 3 events are quite common. Nearly 100% of patients have grade 3 events, almost always characterized by cytopenias, namely neutropenia, anemia, and thrombocytopenia. In regards to cytokine release syndrome, the prevalence is also nearly universal across both lete-cel and afami-cel, occurring in 70 to 80% of patients. Importantly, the grade 3 events are quite rare, particularly with afami-cel. And I think that also reflects the evolution appreciation that tocilizumab, which is used to treat cytokine release syndrome, is safe. And in general, we tend to integrate it sooner in a patient's treatment journey as opposed to later. Importantly, with lete-cel, there was 1 case of persistent cytopenias that resulted in death of the patient. And then there was also 2 cases of Guillain-Barré syndrome that resulted with integration and utility of IVIG. So when we look at the evolution of T-cell therapy sarcoma, I think we've come quite a long way. The initial protocol, which opened up at least at MSK in 2014, demonstrated important signals of efficacy with response rates ranging in the 20 to 50% range and the duration of response in the 50 to 30 week range, though it's clear that we need to do better with regards to durability. What we learned in 2013, though, is that higher lymphodepletion chemotherapy impacts efficacy, and that fludarabine seems to be necessary, and that bridging therapy is an important option for patients. Correlates of response include expansion, persistence, IL-15 levels, and the depletion of lymphocytes. And correlates of resistance include loss of HLA expression and antigen-presenting machinery. In 2016, we've learned that there was similar efficacy in myxoid round cell liposarcoma, and importantly, aggressive management of cytokine release syndrome seems to be safe and preferred, and tocilizumab doesn't appear to impact efficacy. In 2019, we've appreciated and learned that MAGE-A4 is also a promising target for patients with synovial sarcoma, demonstrating response rates of nearly 40% and with over 50 weeks of durability. Clinical correlates of benefit include lower disease burden, higher MAGE-A4 expression, and lack of bridging therapy. And so while we welcome the use of bridging therapy, the suggestion is that those patients with less aggressive disease, lower tumor burden, may perhaps fare better. And this also highlights that perhaps we need to integrate this therapy sooner in a patient's treatment journey. Higher cell dose also may impact efficacy, as appreciated with this study. And given the promise, a biologic license application is currently in progress at the FDA in the United States. With lete-cel, enrollment in the pivotal cohort has been completed, although accrual is currently on hold at this time. In conclusion, T-cell therapy targeting cancer-testis antigen is a very promising therapeutic option, though in selected sarcomas. It demonstrates the feasibility of this approach in a subset of patients with rare diseases and immunologically cold tumors, and really lays the foundation for future efforts in other similar solid tumors. There's an ongoing need, though, to identify biomarkers of response and resistance, and really aim to optimize the durability, especially with lete-cel, and how that can be done remains an unanswered question, though some interesting efforts can include the integration of novel cytokines, epigenetic modulators, and even checkpoint inhibitors. Afami-cel has demonstrated promising efficacy, and the biologic license application is currently in progress. Limitations of TCRs include the HLA requirement, which can prohibit broad applicability, yet the advantage is really the ability to target numerous intracellular proteins. So therefore, the field remains open for important discovery. Thanks so much for your attention, and welcome to entertain any questions.
So Dr. Sandra could not connect to us for the Q&A session. We will send her any questions are there, then we'll send her to that. Next session is on the role of immunotherapy in redefining long-term survivability in recurrent unresectable metastatic head neck squamous cell carcinoma, and it will be delivered by Dr. Markin. So may I request Dr. Jyoti Bajpai to introduce Dr. Markin formally. Dr. Jyoti, please come over here.
So thank you very much, and it is an extreme pleasure and privilege to invite on the dais Dr. Martin Dias. He's a medical oncologist at Gold Coast University and private hospitals. He has completed combined head and neck and skin cancer fellowship at the Princess Alexandra Hospital and the Translational Research Institute in Brisbane. And he's a principal investigator for Keynote B10 trial, which was recently presented in ESMO as well. Apart from that, there are several other credits. So without taking much of the time, I'll invite him.
नहीं इधर से
सर मैं आपको भी डिनर में मिलता हूँ
Just waiting for the slides. Sure. Okay, looks like we're back on track. So without further ado, I'll probably just start. So I'll just repeat the talk is on the role of immunotherapy in improving the long-term survival of patients with incurable head and neck cancer. There's some compulsory slides, but I'll just maybe go through those quickly if I can. Okay. So the talk will focus a lot on Keynote 048, which forms the main piece of data in this sphere. I'll touch on some sequencing and alternatives to that, and I've decided to embed it into a bit of a case presentation to break up the data a little bit. So the case is a patient of mine, a 66-year-old man who presented with a sore throat and a referred ear pain. He had an apparent lesion in his right tonsillar bed and multiple pulmonary lesions. Because upfront presentation with de novo metastatic disease and lack of neck lymphadenopathy were a bit unusual. He had biopsies of both the primary and the pulmonary lesion, but both showed presence of P16 positive squamous cell carcinoma. While his presentation wasn't the most typical for head and neck cancer patient, his risk factors were quite commonplace. He was a lifelong smoker and drank alcohol daily. Although he had a few comorbidities, they were mild and not of significance to his management. He maintained quite an active lifestyle with daily walks and volunteering at an op shop and eco performance status of 1. due to the presence of symptoms rather than any limitation that this disease was putting onto him. A few slides, a few pictures here to just give you a bit of a sense as to what his disease was really like. You can hopefully see his primary in the right tonsillar bed that was reasonably sizable and therefore symptomatic. And although his lung disease wasn't a particularly heavy burden, he did have quite a few lesions scattered throughout both lungs. They were, however, asymptomatic. So, with a case like that, there's a number of things to consider. Although he has metastatic disease, there may still be a role for local therapy due to his symptoms. Obviously, surgery would be quite excessive, but palliative radiotherapy may still be a consideration. At the end of the day, though, systemic treatment in view of his metastatic disease will be the main consideration. And there's a number of potential options to consider, from single agent chemotherapy or immunotherapy to some combination treatments. So chemotherapy alone has been a backbone really of head and neck oncology for decades now. However, by itself is not it's not a very effective treatment option. Whether we use single agent or combination chemotherapy, the median survival of patients is around 6 months, with hardly anyone surviving 2 years. Although responses to doublet chemotherapy are higher, they don't improve survival. Importantly, the companion of platinum, whether it's a taxane or 5-fluoro or fluoropyrimidine, doesn't alter the efficacy of the combination. It wasn't until the extreme regimen, so the combination of cetuximab, 5-FU, and platinum, was reported that the survival for those patients improved somewhat, from the usual 6-7 months of median survival to just over 10 months with the extreme. And the responses increased as well to a third of the patients having an objective response when treated with the triplet. However, the long-term survival wasn't altered significantly by this regimen. Nevertheless, the median overall survival improvement and the response rate made this regimen gold standard for a couple of decades. And it was a few years back when Keynote-048 was reported where the gold standard was changed. The patients tested in this study were fairly typical for at least Western population, median age 62, 61, majority of the male smokers, with only around 20% having a P16 positive oropharyngeal tumor. Majority of the patients were metastatic. The PD-L1 status, importantly, was positive in majority of the patients, more than 80%, and just over 40% had a PD-L1 rich tumors as defined by CPS of 20 or greater. Just as a reminder, the study schema, it was in essence 2 studies in one, comparison between the extreme versus pembrolizumab alone or pembrolizumab in combination with platinum and 5-fluorouracil. And the headline results as seen here at the bottom panel, overall survival improved with chemoimmunotherapy over extreme in total population, and with pembrolizumab over extreme in PD-L1 positive population. The data then was looked in a bit more detail, dividing patients into 3 large groups: those with PD-L1 negative tumors defined as CPS under 1, those with PD-L1 rich tumors defined as CPS of 20 or greater, and then the group in between, sort of CPS light or lower, with a CPS score 1 to 19. And while patients with PD-L1 rich tumors derive benefit from both pembrolizumab or pembrolizumab chemotherapy, and patients did better than with extreme, wasn't necessarily the case for other subgroups. In the top panels, you can see that patients with PD-L1 light tumors still fared better with chemoimmunotherapy. And when it comes to patients with PD-L1 negative tumors, those patients did equally well with both extreme or chemoimmunotherapy. When we look at the bottom panels, you can still see that there's reasonably comparable outcome for patients treated with pembrolizumab or extreme for those with CPS 1 to 19 tumors. But those who had PD-L1 negative tumors did less well or poorly with pembrolizumab without chemotherapy. Importantly, the data was updated at the recent ESMO, showing a 5-year survival. And here you can see the comparison between chemoimmunotherapy and extreme with 16% of patients being alive at 5 years if the first-line treatment was chemoimmunotherapy, compared to 5.2% of those treated with extreme, which represents more than tripling of the chances of surviving at 5 years if patients treated with chemoimmunotherapy. Looking at that 5-year survival in a bit more detail, for two groups, the PD-1 high on your left and any PD-1 expression on your right, you can see that the degree of benefit and the chances of survival increased with increasing PD-1 increasing PD-L1 positivity, so much so that patients with PD-L1 rich tumors have almost 1 in 4 chance of being alive at 5 years if treated with chemoimmunotherapy up front. Responses were reported a bit earlier on, and as you know, the upfront response rate to extreme or chemoimmunotherapy is similar at 36%. However, the durability of the response is longer with the use of immunotherapy. Median duration of response 6.7 months for chemoimmunotherapy, 4.3 for extreme. And when you look at the plateau that sort of forms as the time goes on, it seems to be twice as many patients with durable response when treated with chemoimmunotherapy. Same is seen again through different PD-1 levels, and again increasing responses and durability with higher PD-1 positivity. Quite notably, while the upfront responses were similar in total population, for patients with PD-L1 rich tumors, the response rate to chemoimmunotherapy was almost 44% compared to 38.2% with extreme. And just one slide on comparison of pembrolizumab versus extreme. Again, you can see improved overall survival at 5 years at 15.4% compared to 5.5% with extreme, but this is for PD-L1 positive patients only. And although we've seen that the immunotherapy itself results in responses in fewer than 20% of patients, as seen in this trial and many other trials, again, the durability of response to immunotherapy exceeds that achieved with chemotherapy. For head and neck cancer population, obviously, often tolerability of the treatment is a significant consideration. They often malnourished with multiple comorbidities. Here, pembrolizumab would seem to be the winner with low rates of toxicity or side effects. And the two triplet treatments are quite comparable when it comes to the side effects as seen at the bottom panel. The toxicity is mostly driven by chemotherapy, although there are some differences based on the biologic used, with cetuximab resulting in hypomagnesemia rashes and infusion reactions, and pembrolizumab in immune-related adverse events. However, knowing that chemotherapy is the main driver of toxicity of this treatment, there's been some past and ongoing attempts to try and look for chemotherapy-free treatments. And although combination immunotherapy is by no means an easy treatment, neither of those two combinations listed here surpassed extreme in first-line setting. Looking at a bit more detail at the Checkmate 651 study, which was a large randomized phase 3 study of almost 1,000 patients that randomized patients to either treatment with extreme or nivolumab, ipilimumab in the doses as seen here, showed there was no difference in a 2-year overall survival with around 30% of patients alive in either of the arms. There was a slight non-significant trend to benefits for those with higher expression of PD-L1 status, but overall, there was extreme was not the ipilimumab and nivolumab was not superior to extreme, and also the responses to the combination immunotherapy were somewhat disappointing at 24%, which is only slightly higher to that seen with single agent anti-PD-1, and much lower to that seen with the triplets. However, even with this study, we can see that it's the immunotherapy that results in durable responses. The median duration of response achieved with ipilimumab and nivolumab varied between 16 to 32 months, depending on the PD-L1 expression of the tumor, and that compared quite favorably with the 6-7 months seen with cetuximab. And also at 18 months, almost half to 2/3 of patients treated with the combination immunotherapy maintained their response compared to under 30% if treated with cetuximab and chemotherapy. So back to the case, I've shaded out a couple of options that are probably less relevant, but all the other considerations might be relevant for a patient like that. If he had a tumor that was low in PD-L1, so CPS under 1, certainly the use of cetuximab chemotherapy could still be considered. It would result in a high upfront response rate. However, the durability of this response would probably be lower, and his chances of surviving to 5 years slightly lower as well. On the other side, if he had a PD-L1 rich tumor with CPS score over 20, potentially he could be treated with immunotherapy without chemotherapy, and this would allow him to maintain would allow him to maintain quality of life. However, with a symptomatic tumor and lower response rate, the choice of immunotherapy alone might need to be backed up by palliative radiotherapy to render this patient symptom-free. So arguably, the best option for this patient would be chemoimmunotherapy, resulting in high response rate initially, good durability of the response, and the best chance of 5-year survival. And that's regardless of PD-L1 expression. Now, at the time when I was looking after this patient, the KEYNOTE-048 had a long completed recruitment, and there was no funding for this type of treatment in Australia yet. However, there was a different study open, KEYNOTE-B10, which he enrolled onto. He received treatment with carboplatin, paclitaxel, and pembrolizumab. And despite this being a triplet treatment, he tolerated it well. But as you may remember, he was a reasonably well gentleman. So just a couple of slides on B10. This is a phase 4 single-arm study looking at the combination of pembrolizumab with platinum and paclitaxel as an alternative to the triplet as tested, in KEYNOTE-048 that included 5-fluorouracil. As you know, the choice of paclitaxel or 5-fluorouracil should not alter the efficacy of the treatment. And despite different toxicity profiles of those two drugs, paclitaxel does have the benefit of not needing a protracted infusion that would in turn require either an admission or central venous device. The KEYNOTE-B10, enrolled the typical patient population and aimed at recruiting 100 patients. And as I said, all patients were treated with pembrolizumab at a flat dose, carboplatin, and the investigators had a choice of either 3-weekly or weekly paclitaxel. The primary endpoint was overall response rate, with survival and safety being secondary endpoints. And again, at recent ESMO, there was an early data presented showing that this combination is at the same, comparable to the triplet tested in KEYNOTE-048. The response rate was 42.7%, achieved early with median time to response 1.5 months. The durability of response was also comparable to that seen in KEYNOTE-048, with median duration of response 5.5 months, and around 30% of patients achieving a durable response, at least based on this early data readout. And safety was also as expected. Majority of the side effects driven by chemotherapy. Because of the use of paclitaxel, there were some infusion reactions and neuropathy. So back to the case, he had a very good response to the triplet. His primary regressed fully, symptoms resolved. And although he didn't have a complete response to his pulmonary disease, as you can see on those pictures, he had a deep partial response. He stopped chemotherapy after the planned 6 cycles and continued with pembrolizumab. Developed somewhat scattered itchy skin rash, and initially was put down to pembrolizumab, so he started antihistamine and topical steroid, but without much success. He was noted to have some fungal fingernail infection, and so he had some clippings taken off the fingers, as well as scrapings and biopsy of the skin rash. Biopsy wasn't particularly helpful, but the clippings and the shavings did grow a fungus. And so he initially commenced some topical antifungal cream that wasn't all that helpful, probably because of due to sort of like repeated inoculation from scratching, but the oral antifungal did resolve the rash. And so he continued with pembrolizumab for 6 months without side effects. However, wasn't one of the lucky ones and didn't have a durable response. His disease did progress. Surprisingly, he developed neck lymphadenopathy that wasn't apparent initially, and some, but not all, of his pulmonary lesions progressed, indicating some clonal differentiation that rendered him immune response refractory. So that raised the question as to what we treat those patients with when they progress after treatment with chemo and immunotherapy. Immunotherapy itself, does it make sense to re-expose someone who's just progressed on it, going back to chemotherapy that was effective upfront for this patient and not used for at least 6 months? He never had cetuximab, whether that's the best option, and also metronomic therapy that's championed here in India. Would that be an option for a patient like that? So previously, immunotherapy was your best bet in the second-line setting. Both nivolumab and pembrolizumab were shown to be superior to chemotherapy or cetuximab in that platinum refractory setting. And although responses with those agents were again low, under 20%, they were quite durable, and that resulted in improvement in survival of those patients. However, those agents were tested in the era where immunotherapy wasn't used in the first-line setting, and their efficacy is therefore questionable when a patient received first-line immunotherapy. So what do we treat those patients with? And there's some data, again, from KEYNOTE-048, the secondary analysis of what the patients received. Around half of the patients ever progressed to receive second-line treatment. A little bit fewer after chemoimmunotherapy, 41% compared to 49.53 in the other two arms. But the choice of the subsequent therapy clearly depended on what the patient received up front. And so if the patient only received immunotherapy, then quite obviously they were much more likely to be treated with chemotherapy, 45% of them, compared to just over 30% in the chemo-containing arms. And if someone received cetuximab, they were less likely to be treated with EGFR inhibitor in subsequent lines. Those that received immune checkpoint inhibition, either with or without chemotherapy, only 2 to 4% of those patients ever were re-exposed to immunotherapy subsequently, compared to the 17% of patients treated with extreme. What was really interesting from this data set, though, was that although the PFS wasn't altered in the initial data set and the PFS2, so the time to progression on second-line treatment as counted from the initial randomization, was altered in favor of patients who received immunotherapy up front. That was true for all the patient subgroups, so total population, PD-L1 positive and PD-L1 rich, when treated with chemoimmunotherapy. But for patients treated with pembrolizumab alone, it was true only for those who had PD-L1 positive tumors again. And lastly, metronomic therapy that you probably know more about than I do, but it's quite an intriguing story there. Obviously, it must have been 3 or 4 years ago when this initial data was presented at ASCO, where oral methotrexate together with celecoxib daily were used and compared to intravenous cisplatin, and were shown to be as good, if not better, in efficacy and certainly better tolerated. One caveat to the study was that although it was a first-line study, almost half of the patients were exposed to platinum in the preceding 6 months, so it wasn't, strictly speaking, platinum-sensitive cohort. A smaller study by the same author looked at patients with platinum refractory disease alone, mostly trying to look at optimal dose of methotrexate. This time, the backbone was celecoxib together with erlotinib. And the 6-month overall survival of 61%, as well as response rate of 43% in platinum refractory population, are quite notable. And the most recent addition to the story of metronomic therapy is the comparison of the triplet as tested in the smaller study of erlotinib, methotrexate, and celecoxib versus the same triplet, but with addition of low-dose nivolumab, which is an intriguing concept in itself. And again, the addition of immunotherapy to the treatment seemed to extend the chances of survival for those patients. Quite an interesting story comes from the forest plot, where patients who were previously exposed to chemotherapy, those with platinum refractory disease, seem to derive a definite benefit from this treatment, less so those that were chemotherapy naive, perhaps suggesting that this is a good rescue treatment or subsequent therapy for patients who previously were exposed to chemotherapy. Although at the end of the day, it's obviously, the treatment has been tested as an alternative for resources poor setting, and its real place in the management is still not clearly defined. Onto the patient, he actually, there was an opportunity for him to be part of another study in a nearby facility where he would be treated with either chemotherapy or cetuximab versus pembrolizumab with lenvatinib, looking at the role of immunotherapy backed by the TKI in immunotherapy refractory setting. So to conclude the talk, look at the a quick look at the guidelines, which suggest that pembrolizumab with platinum and 5-FU is the preferred first-line treatment for patients with head and neck cancer, with pembrolizumab reserved as a preferred regimen for those who potentially have PD-L1 positive tumors, and those that have not been exposed to platinum in the first line, to immunotherapy in the first line setting, the use of immunotherapy in the second line setting is recommended, which is a testament to immunotherapy being an important part of those patients' treatment. My personal take on this is that chemoimmunotherapy is the most effective, thoroughly tested treatment for patients with incurable head and neck cancer. However, the sad reality is that more than half of the patients with this disease still don't have an effective treatment options, and there's an ongoing need for further study in this difficult to study population. And that would conclude this talk. Thank you very much.
Yeah, please.
Thank you very much for that excellent presentation. Based on the data that we have now about low-dose nivolumab, that is based on the concept that 0.3 milligram per kg of nivolumab would, target most of the engagement will take place. Similarly, there is also literature where pembrolizumab 0.8 milligram per kg also can do the same job. So do you think that we can also try low dose of pembrolizumab?
Listen, I mean, certainly, looking at the lower doses is more based on, I suppose, financial need, and certainly it's an important undertaking. I think that at the end of the day, if there's ability to access full dose or as tested in the clinical studies doses, that would be preferred. For situations where there's some constraints, obviously trying to look at alternatives like the low doses of immunotherapy is quite relevant. Those immunotherapeutics have a very wide therapeutic range, and that was the basis of going ahead with flat dosing as well as less frequent dosing of those agents, and therefore it is quite likely that lower doses will do a similar good job as the currently used doses. The main question remains, how low can you go? But because there's certainly a dose that will not be enough, and
yes.
At this stage, it's more of a calculation than real life data. It would be good to see the comparison in randomized study between the flat doses or proper doses, if you like, versus lower doses to ensure that that what we've calculated and think that will work, it indeed works in human subjects. But once again, obviously, with such a wide therapeutic range, it's quite plausible that lower doses will do the job.
Yeah. Okay. Yeah. Thank you.
Thanks. Thank you.
So thank you so much. It has been very exciting talk. Next, we'll be moving towards the biomarker session, and this will be a joint symposium of SITSI and Immuno-Oncology Society of India Joint Symposium. And to chair the first session, may I request Dr. Anant Bhushan Ranade, Senior Medical Oncologist from Pune, along with him Dr. Prakash Chitalkar, sir, who is Senior Professor Medical Oncology at Indore, and Dr. Ankur Punia. I think Dr. Ankur will be joining shortly. And the session will be on biomarkers response of immune checkpoint inhibitors. And the first talk will be by Dr. Sacha. She's from Paris and she will be giving the talk on virtual platform. She is highly experienced in the biomarker response assessment with immune checkpoint inhibitors. And she'll be joining in the next session for the panel discussion. Would you like to introduce? Go ahead. But she will be available for impact.
So, hello everyone, and
Hello, my
welcome
name
to
is
this. Okay, fine. This is started, so now I'm not taking time.
Sasha Gnatic. I'm an immunologist at the Mount Sinai School of Medicine in New York. And today I'd like to discuss about challenges and experience from a high-dimensional multi-center immune monitoring lab perspective. I'm really thankful for the organizer of the meeting to have invited me to discuss these challenges to biomarker responses. Are we there yet? My disclosures are here. I mostly have research support from industry, and I will also discuss the methodology that was filed for a patent for multiplex immunohistochemistry. Their talk will be organized in a series of challenges that we face in the field of immune monitoring in general and in trying to understand predictive markers of immunotherapy. And the first one is simply that there are really so many trials ongoing out there that it's difficult to know how to figure out mechanisms of applying immune monitoring tools to an ever-evolving therapeutic landscape. This particular study was conducted by the Cancer Research Institute team and is already a couple of years old, but shows very clearly that in just a few years span, the number of treatments that have been tried as clinical trials for T-cell immunomodulators or even cell therapies have really exponentially grown. And there's been a doubling or more, tripling of number of trials for many of these modalities, and most of them include a variety of different combinations. And so how do we really approach now a biomarker question when there are more trials than actual patients available to test them in? And how do we find common biomarkers given the variety of modalities that are being investigated? So one of the things that is already very clearly needed is to go beyond what is already known. And there are only very few markers that have been approved so far by the FDA to be predictive of response to immunotherapy. And that includes tissue expression of the PD-1 ligand PD-L1, knowing PD-1 is the most common immunotherapy. And as you may know, this particular tissue expression is actually very variable depending on tumor type, but also the way to score it depends on the tumor type and on the specific antibody used in the companion test. And it depends whether you only score it, for example, in non-small cell lung cancer in the tumor cells, or in other tumor types, whether you score both PD-L1 expression in tumors and in immune cells. And based on the amount within each compartment, you can establish different correlations with response rate. And some of them use the 1% threshold, other 10%. So even on its own, this biomarker, even though it's being accepted by the FDA, is really imperfect and doesn't allow you to clearly say which patients should go and shouldn't go on immunotherapy. The other marker that's well established are more genetic in nature, and they include both exclusion markers such as presence of specific mutations, but more interestingly as well, presence of high mutation burden, either as a result of a lot of UV or other mutagen-induced injuries, or as part of this MSI macrosatellite instability high tumors. And this is presumed to be because those mutations lead to more neoantigens. Interestingly, none of those, as I said, are good enough to really predict outcome, and they seem to be really independent of each other. And yet they are no well-established biomarker guidelines that will say which should be the patients who should really avoid immunotherapy because they have no chance of responding versus those that are really likely to, despite having predictive value on their own. And what I find the most remarkable for those biomarkers is that they're also both based on the tumor cell itself rather than on the immune cells, which is actually what this particular therapy is targeting. So there are a lot of different candidates for better biomarkers potentially, or something that can be used in conjunction with those, including things in the peripheral blood and at the tumor site, in particular things like expression of T cells, those type of memory stem cell-like populations that express TCF7, or in this study from my colleague Matt Galsky looking at expression of presence of T cells at the tumor site of bladder cancer, whether they infiltrate the tumor and whether they have also a low stromal signature that predicted outcome better than and independently than PD-L1 immunohistochemistry. And other biomarkers on the horizon include these soluble markers, as well as gut microbiome composition in a couple of papers here from a few years ago showing response in to treatment with PD-1 blockade, depending on the various bacteria used found in the gut. And ctDNA as well, circulating tumor DNA, is being quite interesting. So how do we approach the variety of different biomarker potential assays that need to be performed? To do this, it really, I think, needs to implement this multidimensional approach for a multi-scale dynamic atlas of the immune changes at the tumor site. And we do this at the Human Immune Monitoring Center, which is co-directed by myself with Miriam Murad and Dr. Sung-Hee Kim Schultz, where we have a series of cutting-edge technology platforms that are established as part of this platform to support high-quality correlative studies and discover and validate biomarkers of treatment outcome and study mechanism of action for novel therapies. That is thanks to a large team of investigators with scientific expertise in both human immunology, but also immunopathology, immunogenomics, and other fields of diseases related to what we study. And computational expertise is highly needed so that we can use samples throughout the lifetime of a trial, from baseline collection throughout immunotherapy, post-treatment, and relapse as much as possible, and apply this series of various assays from tissue to the cell level to the molecular level to be eventually analyzed and shared across different samples. And the goal here is to use blood and tissues from the patients to establish all these variety of approaches and eventually go back to understand disease mechanism and discover new biomarkers. So where do we obtain the specimens that we want to analyze from tumor in the periphery? Even though we serve our local community at Mount Sinai, it's really too limiting to establish good biomarkers with enough powers. And so the NCI, the National Cancer Institute in the US, has really pioneered this approach through a cancer moonshot in 2017 that funded 4 institutions throughout the United States, of which we're part of, with these other three centers, MD Anderson, Dana-Farber, and Stanford, where we collaborate with a variety of cooperative groups, including SWOG, Alliance, and others, and obtain specimens from early phase immunotherapy trials, where there are very rich collection, specimen collection design, where we intervene in the trial itself to say we should really collect at this time point and maybe 6 weeks following baseline, and try to get as many biopsies as we can from these, so we understand as much as possible what's going on at the tissue side and provide this cancer immune monitoring analysis, or CMAC, and then combine it with the correlative data such as the response rate as well as the adverse events that's eventually centralized within this immune data commons. And as part of this network, we first had to establish which assays should we run on all the samples and which should be run maybe on specialized specific number of samples, such as maybe extreme responders. And we did this by selecting a number of tests that have been well established enough to be done in a routine longitudinal fashion versus those that are more specialized or up and coming, such as single cell methodologies, or things like seromics, which is looking at, for example, autoantibodies to 20,000 proteins at a time. So I will discuss some of these routine tests, including in particular multiplex immunohistochemistry, but also some of the newer ones as well. But what's really important here is to establish the methodology so that it's robust enough to do it over time and across centers. And for this, we implement very strict SOPs that are all available through this site, which I hope you can see despite some of the things that are on the screen here, and where we are also validating and comparing each other and harmonizing our efforts. So this is really the next challenge, which is how to ensure reproducibility and robustness of data while still allowing innovation to be used in these assays. And so I'll describe a few harmonization efforts and integration of new technology. One of the first examples of our network was that our site at Mount Sinai used a completely different method for multiplex immunohistochemistry compared to the site from MD Anderson and Dana-Farber. We use this chromogen-based approach, which uses a software, a free software called QPath, while the other sites use this multispectral immunofluorescence Vectra approach with the Inform software. And there's really nothing in common, not even the antibody clones we use to detect some of these markers. So how do we approach the center and make sure that we can generate data that eventually can be compared to each other, since this is the goal of the network? And we do this in an iterative process, which started with first establishing the performance of our image quantification software, then using one single slide to stain it locally and understand what's going on, and then eventually moving on to a few more tissues to, at the end, use this tissue microarray with about 25 different cores representing 5 tumor types in replicates that we each sent in consecutive sections to our respective centers and stained locally so that we could analyze them, adjust our algorithms after a first pass analysis, and look at whether we agree with each other in the interpretation. And we did this for a variety of membrane, cellular, and nuclear markers that we compared 2 by 2 here in these boxes. And if you see a diagonal line, that means that we had good concordance across quantification of a variety of tissues for some of these markers. And this was remarkable because we could find not only a great correlation between our group eventually, but low coefficient of variation. That was done despite differences in instrument platforms, clones, operators, and analysis software. And so the theme here is that you don't necessarily need to enforce a single protocol for throughout the labs, but you can have some flexibility while you still have enough reference materials to be able to compare each other. And we just performed another set of runs with these microarrays, and we still compare each other very favorably. And this allows us to now move to more novel, innovative methods, such as the single cell sequencing for RNA. We use the 10x platform here, and this is an effort with another cooperative group that I'm part of, which is sponsored by the Myeloma Research Foundation, where we looked at reproducibility, again, using the same material shared across 3 sites here for gene expression level as well as population levels from single cell sequencing across technical replicates as well as even flow cells, and found again that you can establish with some enforcement, for example, of in similar chemistries and similar batches of the material for 10x, that we can eventually lead to really good cross-site comparisons. And we're now doing this also for spatial transcriptomics, again, using the 10x Vision platform this time, which we try to establish here reproducibility across 2 different slides, and also be able to find out areas of immune infiltration versus areas of tumors. Another challenge is then when we generate all this data, how to interpret it. Here again, we're generating often more data than we can handle. And so for this, we're trying first to use more automation. And so one of the things we currently do for immunohistochemistry is to first manually register our images, then segment them, eventually train a machine learning algorithm to detect positive cells and create this pseudofluorescence visualization. This takes a lot of time and is prone to errors potentially and batch effects. So what we're trying to do now is automate this whole platform through this Markov pipeline that was developed by Mark Buckup and my colleagues as well, with the idea of doing this automatically so that we end up with one single file with the morphological feature of each cell, the staining of that cell, whether it co-expresses a certain number of patterns, and its location. So you can then start looking at things like distance between a cell to another or an immune cell to the tumor. And the more overarching computational problem is when we generate all the data sets together, how do we combine them? And this has to be done first through analysis that are sort of standard, like univariate and multivariate associations with outcome, for example. But we're very, very eager to move past this to integrate them into more complex models, such as this mixed effects model, for example, that can handle a lot of data from disparate sources and use demographics and others so that we can understand which of these variables contribute to the most variance in the data, and eventually interpret our results in the context of all these meta data that we have. And that helps also integrate studies, for example, that may not be designed exactly in the same way, but where we can identify which are the source of variation. Is it in batch effect? Is it in different treatment types, and find commonalities potentially in cross-study analysis. And so this is work in progress right now with some of the trials that we're performing, where we identified a bunch of trials that have similar backbones, such as, for example, PD-1 and CTLA-4 blockade, and see now, even though they have differences in solid versus liquid tumors, whether there's some commonalities in, for example, proteomic patterns in the blood or transcriptomics in tumor. Eventually, all this needs to be correlated with this outcome and be simplified again so it can be integrated into an actionable biomarker. And so we want to put all these methodologies as part of a cycle where we go from even imaging the tumor down to immunostaining to the single cell level and proteomic and gene level expression, so that we can complement some of the existing biomarkers like PD-1, PD-L1, tumor mutation burden, with potential new ones such as infiltration of lymphocytes, PBMC patterns, ctDNA, and create these nomograms where we can have composite biomarkers where if you're high for one, low for the other, you will score it and weigh it differently so that eventually you can suggest that these markers can work better together, which we hypothesize compared to individually, none of them likely to perform well enough to predict the outcome. And so as a take-home message, I think I've emphasized how there's still a big need to understand the immune networks at play with complex and comprehensive approaches such as high-dimensional monitoring. And this will help us understand better the biomarker of response or lack of response, as well as adverse events. There's a lot of single data analysis that are on the horizon, and data mining with deep learning that should help really move us to the next frontier of predictive biomarker discovery. We need to adopt some standards, but not necessarily enforce the exact standardization, but rather use harmonized methods through reference materials and regular cycles of comparisons with each other. And we do this so that we can generate a bit more power to assemble a variety of trials and understand better whether there's commonalities across different modalities. And my prediction is that there won't be ever a single predicted biomarker found for immuno-oncology, but rather we're entering an era of personalized combined biomarkers, and that we'll need to, for each person, identify what's the best way for them to get treated based on these composite biomarkers. And finally, I want to thank all my colleagues that participated in this research, because this, as I emphasized, is a group effort, in particular, all the people involved in the multiplex assay that we perform, in the data analysis at Mount Sinai, but also our colleagues from the CIMAC-CIDC network at the National Cancer Institute and these 3 other institutions, and the FNIH, the Foundation for the NIH, as well as my colleagues from the Multiple Myeloma Research Foundation network, and the funding that was received for all these analyses. I thank you very much for your attention, and I'll be happy to discuss and take questions during the next session. Thank you.
So thank you very much, Dr. Sasha. Indeed, it was a great talk. So we could see that Dr. Jerushka has also joined, and she has requested that because she is having some emergency, so she needs to go early. So can we request that we can shift the biomarker panel to late and the toxicity session to begin with? Dr. Sasha, can you hear me?
Yes, I can. That would be okay with me. Sure, of course.
That's great. That's great. So now we will begin the second part of this Immuno-Oncology Society of India and Society of Immunotherapy of Cancer, that is SIDSI, IOSI Symposium's second part, the toxicity panel, toxicity talk, and then followed by panel. And later we will discuss the questions related to biomarker session in the biomarker panel. So thank you everyone for your cooperation. Chairpersons to conclude the session.
Thank you, Dr. Natik, and thank you, organizers. We'll meet over the next session now.
Thank you. I've got great pleasure in announcing Dr. Jerushka Naidu. She will speak on the she's assistant professor, Department of Medical Oncology, Sidney Kimmel Cancer Center at Johns Hopkins University, Ireland. And she'll speak on the anticipation and management of immune checkpoint inhibitor toxicity, advice for practicing oncologists. Dr. Jerushka Naidu, please.
Good afternoon. My name is Jerushka Naidu, and I am a consultant medical oncologist at the Beaumont RCSI Cancer Centre in Dublin, Ireland, and a professor of medical oncology. Thank you for the opportunity to present on anticipation and management of immune checkpoint inhibitor toxicity, advice for the practicing oncologist. As we know, immune checkpoint inhibitors have truly revolutionized the treatment of cancer with approvals in over 30 different cancer indications, and that these agents are associated with a spectrum of toxicities that may lead to inflammation in nearly any organ system in the body related to the immunologic mechanisms of these agents. Importantly, the advent of immunotherapy has led to the use of immunotherapy even in earlier stages of disease, such that there is now a growing body of immune-related toxicity medicine and a whole group of patients in whom there are specific and unique needs related to the management of their immune-related toxicity. For the purposes of today's presentation, we'll split these into the common toxicities that we see from immune checkpoint inhibitors, the uncommon or fatal toxicities, and new or emerging knowledge on special populations of patients in which immune-related toxicities may be more common or may require a nuanced approach, and how immune-related toxicity management may be refined in today's immune checkpoint inhibitor day and for the future. So where do we start with immune-related toxicity? Well, firstly, there are some general management principles that differentiate the diagnosis and management of immune-related toxicity from those related to other systemic treatments for cancer. First of all, We know there are specific toxicities that are associated with systemic chemotherapy, such as pancytopenia, alopecia, nausea, and vomiting. Similarly, when a patient is treated with immunotherapy, we should always suspect an autoimmune or immune-related toxicity as a possibility. Some of these toxicities are exceedingly common and require us to monitor for them routinely, such as thyroid dysfunction that requires TSH monitoring usually around every 6 weeks. As with other toxicities and in patients with malignancy, we need to rule out competing diagnoses such as infection, progressive disease, and a worsening of known comorbidity. We use our CTCAE criteria to differentiate between some of these toxicities and to assign severity based on CTCAE grade. Importantly, for many of these toxicities, because they may resemble de novo autoimmune conditions, we often need to consult an organ specialist to adapt their knowledge of those de novo conditions and how they may be managed, and occasionally in order to do an invasive procedure for the purposes of diagnosis or grading. Broadly, based on the CTCAE criteria, those with a very mild toxicity are usually treated with supportive care alone, and we would consider drug withholding. In those who are symptomatic, we would certainly withhold drug, and we treat with low-dose corticosteroids defined as prednisolone at a dose of 0.5 to 1 milligram per kilogram per day. We would usually taper this over a 4 to 6 week taper and only redose immunotherapy if the toxicity resolves to grade 1 or less. In the case of high-grade toxicity, except for the endocrine toxicities, we would discontinue study drug or immunotherapy drug and institute high-dose corticosteroids, defined as equivalent dose of prednisolone 1 to 2 milligrams per kilogram per day, again tapered over 4 to 6 weeks. In some instances, for example, in pneumonitis and hepatitis, some of these tapers may be a little bit longer. Usually, we consider additional immunosuppression of patients' immune-related toxicities does not improve after a minimum of 48 to 72 hours. And for those on prolonged corticosteroids, in accordance with your own institutional guidelines, we may institute antiviral, antifungal prophylaxis. There are some important tenets of immune-related toxicity that are distinct from the toxicities of other systemic agents, and that, of course, is time to onset. We know that for immune-related toxicity, this is widely variable and can occur anywhere from days to many months after immunotherapy initiation. This may even occur after immunotherapy is discontinued. However, we know that the onset of toxicity is more common earlier in a treatment journey when patients are treated with combinations, and in certain instances may be chronic, and this may be separated into chronic and active, patients requiring ongoing active immunosuppression, or chronic and inactive, those patients requiring ongoing management but not necessarily active immunosuppression. In terms of the incidence of toxicity, one of the very favorable aspects of immunotherapy treatment is that overall these treatments appear to be broadly more tolerable than chemotherapy. Having said that, we see here across the gamut of primary tumor types that may be treated with immunotherapy that the overall incidence of low-grade toxicity is still quite sizable at around 60 to 80% of patients experiencing some kind of toxicity. But thankfully, the high-grade events are in the single digits to around 20%, and it is these that we will focus on principally for today's talk. So what are some of the common toxicities that we may expect from immune checkpoint inhibitors? So the most common toxicity of CTLA-4 and PD-1 combinations is actually skin-related toxicity. And as you'll see as this presentation evolves, variety is the order of the day. We see here that a number of skin-related toxicities may occur from immunotherapy, the most common of which is pruritus, and second of which is maculopapular rash. Importantly, skin-related toxicity generally appears to be the first toxicity that occurs, particularly when patients receive PD-1, PD-L1, CTLA-4 combinations. The most common toxicity associated with PD-1 or PD-L1 monotherapy that is immune-related is thyroid dysfunction. This may present either as hypothyroidism or hyperthyroidism alone, or patients may present with an initial hyperthyroid phase followed by a prolonged hypothyroid phase with a mechanism of thyroiditis. Historically, it was thought that thyroid dysfunction did not resolve and that this was ongoing toxicity that a patient would need to manage, but we now recognize that a certain proportion of patients may actually recover their thyroid function. Those in the hyperthyroid phase, generally this is the first phase of presentation, usually will present classically with weight loss, sweats, typical hyperthyroid symptoms, and those in the hypothyroid phase, fatigue, hair and skin changes, constipation or fluid retention. And as mentioned, this can be transient or permanent. The mechanisms of toxicity range from lymphocytic infiltration to even antibody formation. The most common endocrine toxicity and a common toxicity in general of CTLA-4 blockade with agents such as ipilimumab or tremelimumab is hypophysitis, inflammation of the pituitary gland. This can be classically a very difficult diagnosis to make. Patients present with very nonspecific symptoms such as fatigue, weakness, headache, and confusion. We would usually send a pituitary hormone panel, including a random cortisol, and in those with headache or changes in their vision, we will also recommend an MRI of pituitary, which is actually abnormal in 75% of cases. It is common to present with this around 4 months into treatment, and usually the finding that we look for or we identify most commonly is low cortisol. Similarly to thyroid dysfunction, the mechanisms underlying this are lymphocytic infiltration and autoantibody formation. However, preclinical models have also demonstrated that CTLA-4 itself may be expressed on the pituitary. A common but somewhat unrecognized toxicity of PD-1 or PD-L1 blockade is rheumatologic immune-related adverse events. And this was poorly recognized in the original randomized control trials due to a lack of standardized reporting based on CTCAE. Many of these patients may have been coded as having arthralgia, arthritis, joint pain, but not really brought together as an all-over syndrome. And in about 10% of patients, we actually see that these patients present with inflammatory arthritis, and that these may substratify into 3 different clinical phenotypes. Most commonly, small joint arthritis similar to rheumatoid arthritis, reactive arthritis that involves conjunctivitis, urethritis, and large joint involvement, and usually a HLA-B27 negative, seronegative spondyloarthropathy that can involve the axial joints and occasionally with the presence of synovitis. But we can see here that actually a range of rheumatologic manifestations of immune-related toxicity may be seen, ranging from other types of inflammatory arthritis such as psoriatic arthritis, polymyalgia rheumatica, Sicca syndrome, and even vasculitides. And some of these have been associated with certain HLA-based phenotypes, which underlies the development of de novo a rheumatoid and inflammatory arthritis as well. Moving on to the fatal toxicities, the quintessential toxicity that was associated with fatality from CTLA-4 in the very early studies of ipilimumab for melanoma was colitis. These patients present with abdominal pain, bleeding per rectum, and usually diarrhea. It is important to discern between diarrhea and colitis, as usually the diagnostic workup is slightly different. In those patients with bleeding, PR, and abdominal pain, it is important to do a CT of abdomen to rule out an abdominal perforation, which is, of course, a severe complication of immune-related colitis. Those with diarrhea are usually graded based on the number of stools produced in a day and the presence of fecal incontinence. Since this toxicity is associated with fatality, it is a priority to start corticosteroids very soon. And usually we have a low threshold for starting this, even when hearing over the phone that a patient has suspected colitis. Prospective studies have demonstrated that there is no benefit for pretreatment with corticosteroids prior to immunotherapy. And colitis that is slow to improve or refractory to corticosteroids, meaning with no clinical improvement after 48 to 72 hours, would usually be treated with an anti-TNF such as infliximab. It is important to do a quantiferon or MAN2 test prior to the institution of infliximab. Some very interesting data here from Mimi Wang's group at MD Anderson has also demonstrated that there may be relevant extrapolation from the inflammatory bowel disease world in the use of the Mayo score on endoscopy to grade the severity of colitis based on the severity of inflammation seen in the GI mucosa and the depth of ulceration, and that this may help us to select for patients who may need to upscale to infliximab therapy. Further lessons from IBD would be potentially the use of stool-based biomarkers. And again, we've seen from Mimi Wang's group that the use of fecal calprotectin and lactoferrin may allow us to predict who has a greater degree of histologic inflammation and ulceration, and that this may particularly be important for identifying which patients will benefit from TNF inhibition and may eventually need hospitalization. We've also borrowed from the IBD world in the use of more specific inflammatory or immunosuppressive agents. Vedolizumab is an anti-integrin alpha-4 beta-7 monoclonal antibody that is a gut-specific inhibitor of T cells that is used for the treatment of inflammatory bowel disease. And we see here that the timing in vedolizumab may help us to identify which patients may benefit from this approach, and that there is some benefit in the steroid refractory setting. Another very important toxicity that is associated with fatalities from anti-PD-1 or PD-L1 monotherapy is pneumonitis. This is defined as a focal or diffuse inflammation of the lung parenchyma, with an overall incidence of about 5 to 10% in prospective studies, but real-world data demonstrates an incidence all the way up to 19%. Meta-analyses, particularly in lung cancer, demonstrate that pneumonitis is more common in any patient receiving immunotherapy or an immune-based combination as compared to chemotherapy. Importantly, pneumonitis is a diagnosis of exclusion. Therefore, in order to truly come to the diagnosis of pneumonitis, we need to incorporate a multidisciplinary approach to exclude common complications such as cardiorespiratory failure, cancer-related features, worsening of comorbidities, and the development of ILD. Specifically in relation to pneumonitis, the Fleischner Radiographic Society has described 4 radiographic subtypes. The non-specific interstitial pneumonia subtype that is characterized by GGOs with or without consolidation tends to be bilateral and involving the lower lobes. An organizing pneumonia subtype that demonstrates patchy alveolar opacities and in some instances can look like metastasis. This is more common in patients who present with severe pneumonitis and in patients with lung cancer. Hypersensitivity pneumonia usually presents with a tree and bud type appearance, and diffuse alveolar damage is a more fulminant version of pneumonitis, characterized by an exudative phase of airspace consolidation, followed by a fibrotic phase. When it comes to the treatment of pneumonitis, thankfully, most patients, around 80%, will improve with corticosteroids alone. However, there is a proportion of patients who will develop pneumonitis that is either steroid resistant, meaning only with a transient improvement to corticosteroids, or steroid refractory, where there is no improvement with corticosteroids at all. In a large series published by the Memorial Sloan Kettering Group, this subset of patients appeared to benefit either from additional immunosuppression from either infliximab or mycophenolate mofetil. In a separate experience published by our group at Johns Hopkins, we identified in patients with steroid refractory pneumonitis specifically that selected patients may benefit from an immune augmenting approach with IVIG, and in certain instances, this treatment allowed patients to come off ventilators. Building on this, we are running a prospective study through ECOG-ACRIN in which patients with steroid refractory pneumonitis are randomized to either infliximab or IVIG, and we measure response to pneumonitis by an improvement in arterial oxygenation on arterial blood gas 28 days after immunosuppression. This study is active and accruing in ECOG-ACRIN, and we would love you to help us accrue. Other potentially fatal toxicities that are of importance, fatal toxicities of CTLA-4 PD-1 blockade include myocarditis. In fact, this complication is associated with the highest fatality rate in those treated with immunotherapy combinations. These patients present with chest pain and conduction abnormalities, and mechanistically, some beautiful work from Javid Mosley and Doug Johnson have identified that sometimes it is the same T cell population that results in response to the tumor that is mediating inflammation in both the heart and skeletal muscle. These patients are usually evaluated with an ESR-CRP troponin, and the gold standard diagnostic evaluation is with an endomyocardial biopsy. These patients are treated with high-dose, pulse-dose corticosteroids, and in the steroid refractory setting, may be treated with ATG, infliximab, IVIG, or MMF. Type 1 diabetes is a rare but emergent toxicity. What's important to know in patients who present with this is that more than 50% of patients will present in diabetic ketoacidosis, and that this can last for several months, can occur several months after the last dose of immunotherapy, particularly in those treated with PD-1. Thankfully, the overall incidence is fairly rare at around 1 to 2%, and the treatment is relatively straightforward as these patients are treated along a DKA type protocol. It is important to distinguish between type 1 and type 2 diabetes, usually with a C-peptide level. The last and sometimes and most complicated syndrome I've come across is the MMM overlap syndrome that may occur, particularly in patients treated with combinations. These patients can present either with myocarditis, myasthenia, or myositis concurrently, and any one of these may present first. Around a third of these patients usually have concomitant myocarditis, and more than 50% are high-grade in nature. There may be some role in surveillance creatinine kinases. However, the outcome in general of managing these patients is poor. This is a very good example of creating an ecosystem in which different organ specialists can talk to each other and how this may be useful. In this case, when patients have different organs that are affected by immune-related toxicity, having a real-time mechanism by which specialists and oncologists can interact about the effect of immunosuppression on different organs is critical. And we set up a similar program at Hopkins and now in Ireland. Moving on to new knowledge in this area, questions that often come up in relation to immune-related toxicity is how to manage them in special populations, such as patients with autoimmune disease, who may have a higher propensity for developing these toxicities. This is a large experience published from one of the groups in Boston, identifying that patients with lung cancer who had bona fide autoimmune conditions have a relatively high incidence of autoimmune flare of around a quarter of patients, and that nearly 40% of patients will have a separate immune-related toxicity unrelated to their known autoimmune condition. Overall, the 6-month incidence of a flare of immune-related of the autoimmune condition is around 21%, and the 18-month cumulative incidence is around 23%. Importantly, when we consent patients to and counsel patients to start immunotherapy with these background conditions, it's important that we explain that about 30% of them will have a high-grade toxicity, but that the treatment of this toxicity and the development of this toxicity is not associated with response to treatment, and neither is baseline corticosteroid use. Open questions are that remain unanswered include whether patients with certain solid organ transplants, bone marrow transplants, and other forms of immunosuppression may have an attenuated response to immunotherapy or a different incidence of immune-related toxicity. It also is important as to what a patient is receiving for their autoimmune condition in terms of their risk of developing subsequent immune-related toxicity or a flare of the known autoimmune condition. And we see here that in patients who are on active therapy for their autoimmune conditions, this is associated with a 4 times higher risk of immune-related toxicity compared to those who have inactive autoimmune conditions. Another question that comes up fairly commonly is when to recommence or re-challenge immunotherapy after the treatment of an immune-related adverse event. A large experience from Memorial Sloan Kettering informs our response to this situation. In around 482 patients with lung cancer, 68 of these patients required or developed an immune-related toxicity warranting treatment withholding. Of these patients, 38 restarted and 30 permanently discontinued. Of the 38 that restarted, approximately 26% developed a recurrence of the original immune-related toxicity, 26% developed a new immune-related toxicity, and around 48% had no subsequent immune-related toxicity. Importantly, we see here that in those patients who had already declared themselves as responders to immunotherapy, these patients did not appear to derive any specific survival benefit from restarting immunotherapy, while those who were perhaps early in their treatment course or had not yet declared themselves as responders appeared to benefit from retreatment. Therefore, the timing of immune-related toxicity and the declaration of response appears to matter as to whom we re-challenge or not. Another area of progress in the area of immune-related toxicity is understanding the different natural histories of these toxicities. We have noticed that a small proportion of patients may develop chronic toxicity, defined as those lasting more than 12 weeks post-immunotherapy stop and requiring immunosuppression for greater than or equal to 12 weeks. We have seen this in pneumonitis, and we see here some examples of BAL phenotypes and immunohistochemical staining that demonstrates this ongoing inflammation. And we've also seen this in the context of inflammatory arthritis. Importantly, a significant number of patients may develop chronic inflammatory arthritis. And we see here that those who develop this persistent arthritis appears to be more common in those receiving immunotherapy combinations, but that this is associated with a more favorable response to immunotherapy. Another subphenotype of immune-related toxicity that we see is synergistic toxicity related to prior treatments that patients may have received. This is an experience of patients with lung cancer, and we see here that patients who have received the EGFR-targeted therapy osimertinib within 3 months of receiving immunotherapy appear to have a higher risk for developing pneumonitis. However, this was not observed in patients treated with other EGFR TKIs or in those in which the sequence was reversed. Therefore, there may be an inciting event, such as the prior treatment with TKI, that may be associated with immune-related toxicity.
Would you conclude,
A
ma'am?
similar phenomenon is seen with immune-related hepatitis after treatment with another TKI, sotorasib, in KRAS G12C mutant lung cancer. And inciting events such as prior TKI or even a viral infection with infections such as CMV have been reported. In order to attend to some of this emerging terminology and observation around the natural history of immune-related toxicity, we called together an IRAE definitions working group that brings together oncologists, industry specialists, nurses, allied health professionals, regulators, and organ specialists to try to comprehensively define some of these biologically different subtypes of immune-related toxicity. And this is currently a paper in progress through the Society for Immunotherapy and Cancer that aims to comprehensively define some of the emerging terminology on immune-related toxicity. This is of particular relevance now that we see more and more survivors from immunotherapy, those who are living more than a year after immunotherapy and may have a significant burden related to the management of these toxicities. And we see here some experience in lung cancer where nearly 30% of patients require ongoing management for immune-related toxicity. It is with this in mind that I'd like to thank all of my colleagues and collaborators who've really contributed to this field. Immune-related toxicity is an important part of oncologic medicine, and I think a lot more to be learned in the coming years. Thank you.
Thank you, Dr. Naidu. I'm sure it's been a very insightful talk and there should be a lot of questions. One quick question from my side is, any patient with pre-morbid connectivity disorder, how does it behave with immunotherapy in the larger cohorts?
So I think we'll be having a panel discussion,
You can bring out
and the same question can be addressed during the panel also. So thank you so much, and thank you, Dr. Naidu, for your excellent talk, and please stay for the panel also. And I'm handing over to Dr. Jyoti Bajpai for conducting the panel on immuno-oncotoxicity in the real-world Indian scenario. May I request others to please join? Dr. Jairishka Naidu is already online. Dr. Ahmed Tarhini is from USA, virtual. He will be joining. Dr. Elad Sharon from USA on virtual line. Dr. Sujit, thank you so much. Dr. Amit Rotan. I think Dr. Amit is not here. Dr. Naresh Somani, he is also probably outside. Dr. Prakash Chitalkar, sir, thank you so much, sir. Dr. Hemant Malhotra, so you can participate from floor only, sir. Thank you. Dr. Deepak Shukla. So over to you, Dr. Jyoti.
Can I please see my slides? So thank you again, each and everyone from Society of Immunotherapy of Cancer, SIDSI, and the Immuno-Oncology Society of India, IOSI. We have tried to collaborate SIDSI and IOSI with this unique joint symposium, and my apologies for some of the confusion in time. That's what I'm noting just at the moment. For some communication gap, but if we have Dr. Jairishka Naidu with us and other panelists, Dr. Tarini and Dr. Sharon, along with the IOSI representatives, then we can begin this panel before, and we have to do some shuffling with biomarkers and immunotoxicity panel because of the time confusion. And again, we are very grateful to Dr. Sacha to kindly accommodate. So from here we'll begin, and so immunotherapy has taken a long course from Cole's toxin to checkpoint Charlie, and with the Nobel Prize winning performance by Dr. Ellison and Dr. Honzo, now immunotherapy is much talked about than any other systemic therapy at present. So it is not a panacea. It is nothing is holy water in this world. So there is efficacy, but there is toxicity as well. And today's discussion we will concentrate on based on the guidelines and personal experiences from the world experts, general guidelines for immune suppression, and then how to deal with the special situations like extreme of ages, autoimmune, immunocompromised comorbidities, and ICIV challenge, and then when to refer to a specialist about the combination. So I'll begin here. Slides is not moving. Right. So this is the guidelines from SIDSI and ESMO. There are several other guidelines as well, but these are the prominent ones. So I would like to ask Dr. Jarushka, what are the general guidelines for immune suppression, the sequence, the determinants, and how to choose one above the other, about the corticosteroids and other immunosuppressive drugs? Do we have Dr. Jarushka with us? I can see Dr. Sharon. Dr. Sharon, would you like to respond to this?
Yeah, certainly. As it happens, steroids are the mainstay of dealing with most of these immune-related adverse events as they occur. It's clear that with the level of innovation that we've had in the treatment of autoimmune conditions, that there are many other options that we probably should be considering. And Dr. Naidu's trial that you mentioned, that's being run in the United States for the most part, with ECOG Akron, one of our cooperative groups looking at pneumonitis, is one of the unique trials that we have available that's exploring ways to, through randomization, actually determine what other types of therapies we might be able to use. But guidelines do include a number of the agents that are listed here, depending on the specific condition. One thing that is important to note is that in most cases, corticosteroids are still the initial therapy, and only at the point of a failure to respond to corticosteroids would you consider the other immunosuppressive drug. It does vary considerably. In most endocrine toxicities, as an example, we simply accept that there is no disease-modifying agent, immune suppressor that we're actually able to give in order to prevent the advent of essentially immune checkpoint inhibitor diabetes, which is effectively type 1 diabetes for life, for the overwhelming majority of patients who experience it as a result of immune checkpoint inhibitors or endocrine toxicities like thyroid dysfunction that ultimately result in hypothyroidism. So in those cases, I wouldn't use anything but the replacement endocrine hormone. But otherwise, most of our guidelines actually require initially attempting to use corticosteroids and only later on going to other immunosuppressive drugs. There are exceptions. Microcytic colitis is a good example where budesonide, which is a very inexpensive but non-absorbed steroid, might be sufficient to actually treat microscopic colitis. But that diagnosis, of course, can only really be made with a colonoscopy and with a biopsy. It really does depend on the specific adverse event in question. obviously working with consultant physicians that are experts in the field, obtaining biopsies and obtaining more information helps with all these choices.
So thank you very much for this elaborate answer, and I think this is very useful for the clinics. So basically, my another question is from the other panelists, your opinion on steroid use with immuno-oncology drugs, their dose, timing, and determinants. Maybe we can start with Dr. Malhotra.
So I actually wanted to ask Dr. Sasha a question now, like a relatively common clinical scenario, a patient who has non-small cell lung cancer and a high PD-L1 is on checkpoint inhibitors and develops or has CNS metastasis with signs and symptoms of increased intracranial tension. So one of the requisites in managing this patient is corticosteroids to reduce the increased intracranial tension. And this patient is a likely candidate to respond to checkpoint inhibitors also because of the high PD-L1. So like not an uncommon clinical scenario. So how do we deal with this? What is your advice?
So Dr. Sharon or Dr. Ahmad Tehrani, anybody can take this. Do we have Dr. Ahmad with us now? Okay, so Dr. Sharon, now I think you need to answer this as well.
Yeah, no, I'm happy to take that up. I'm having some difficulty here hearing the question, but one of the concerns, of course, that you mentioned is that many of these patients who require steroids may have things such as brain metastases that might limit the effectiveness of the immune checkpoint inhibitor. I think that if I'm understanding the question correctly, and please correct me if I'm wrong, I think that for the most part, when we have these significant adverse events, we have to deal with the issue at hand. These events are potentially fatal, and they need to be handled in many cases quite urgently in order to prevent the demise of the patients in some cases. And so obviously this concern that I think is being addressed through this 2018 paper in the Journal of Clinical Oncology is significant. I think what it really points to, however, at least from my perspective, is that the need for further research on other types of agents that might have less of an impact on the outcome for the patient, ultimately from their cancer. So from my perspective, it actually is unfortunately unavoidable in many cases especially when we have severe adverse events, that we do face poorer outcomes, or we may face poorer outcomes associated with steroid use. However, if you are facing a severe colitis, a severe myocarditis, or other potentially severe side effects, there simply aren't other choices available.
So thank you again, and it has been shown that baseline corticosteroid use of more than or equal to 10 milligram equivalent was associated with poorer outcomes in patients with lung cancer who were treated with PD-L1 blockade. So hence, prudent use of corticosteroid at the time of initiating. However, there's also data that once it is already started and we give corticosteroids, perhaps it will not be so much detrimental. So with this, now I'll move on to Sujit. Immunotherapy stoppage due to toxicity. What do you think? Does it really affect outcomes and how we should do? Because at times we have to take these tough decisions. And after 1 dose, 2 doses, and several doses, some point of time we need to stop in between.
I think the last talk had given a clear picture about that. So if the patient has attained response and then has a toxicity, technically it's better not to re-challenge. But the last talk they were mentioning that in case it's an early phase of treatment and the patient has not had complete response or is on response, we may try to re-challenge, provided that around 50% of them may again have toxicity. So I don't remember the study that was quoted, but it was shown that patients have good response, have attained response with toxicity, we can stop. But if they have ongoing responses, better to with very close monitoring to see that they get restarted with treatment. And if they further have toxicity, to stop.
Right. So at present, what we are discussing is essentially that if there is a toxicity which is significant enough, which is life-threatening or it is grade 3 and more, and it is not getting recovered, then perhaps we may need to take a call to stop. And there is enough evidence in the literature that if we stop due to toxicity, then also patients continue to respond. Dr. Sharon, your opinion on this?
I think that's quite reasonable as a strategy, no question. It's also true that there's an association with benefit in those patients that are experiencing immune-related adverse events. We have to, of course, realize, and I'm sure this is an audience that does realize it quite well, but we have to teach our colleagues that immunotherapy of this type is actually somewhat non-specific. It's emerging at the same time as precision oncology, but of course we're modulating not the cancer but the immune system. And so when we're thinking about these treatments, it's not unexpected that there's actually an association between immune-related adverse events and actually the efficacy of the cancer, the efficacy against the cancer, rather, of the immune system. What we're really seeing, essentially, to some degree, is evidence of an effective immune response. Now, in one case, it's an immune response that we desire, an anti-cancer immune response, and in the other, obviously, it's one that we don't desire, don't want, where the immune system is actually attacking the host. But it's just important to realize that what we are doing in treating patients with immune checkpoint inhibitors is we are perturbing a normal homeostatic mechanism. And so that normal homeostatic mechanism is, of course, what is being utilized by the rest of the body to protect itself to some degree, at least in certain conditions, and also being utilized by the cancer to protect itself from the immune system. So that association is not unexpected in many ways.
Right. So I think this is a very, very important scenario, and we are learning to take the beast essentially with the relatively newer modality, and there are many nuances. Now, as specialist referrals, so I think multidisciplinary clinic we always talk about with immunotherapy. Perhaps we need to extend our armamentarium of multidisciplinary specialists. So when essentially we require to send to a specialist, a cardiologist, a neurologist, a nephrologist. So maybe if we will start from you, Doctor.
Ma'am, regarding the previous one, there is some means data that if the toxicity occur in the initial 2 months. So
because in interest of time, I have to.
Yeah. Okay. Sorry. So yeah, for any grade 2, 3 toxicity, we do take opinion of the concerned subspecialists as per the organ involvement based on the immune toxicity is there.
Sure. So, Dr. Sharon, now I'll move on to you again. And, due to certain issues, the other panelists are not there from SIDSI. So, there's a lot of responsibility on you, and I'll take your opinion for almost every question. So, what is your opinion? There are some specific complications like myositis, myocarditis, or neurological symptoms such as myasthenia. And although they are rare, but they do happen. So, how you manage these kind of complications, and when in your practice you essentially involve a specialist?
My opinion is to work with our specialist colleagues early and often. In particular, with regard to some of these more significant adverse events that you list here, neurologic adverse events, those involving myositis, myocarditis, of course. And there's certainly also an association between all three. I was working with one of my mentees, Rafi Nakash, who's of Indian origin, actually, who came to the National Cancer Institute. I was working at the University of Oklahoma on a paper specifically on patients that had a myocarditis in our National Cancer Institute sponsored trial network. We went through all the cases of myocarditis, and this has, of course, been shown in other case series as well. But we have about a 0.6% incidence, at least on our clinical trials, where we actually know the N, we know the denominator of myocarditis or other major adverse cardiac events. What's clear in these extremely severe and concerning cases with immune checkpoint inhibitor associated myocarditis is that the involvement of the specialists, especially the cardiologist, but also potentially getting biopsies of perhaps skeletal muscle if one's not able to get access to the heart as easily, might help confirm a diagnosis. And involvement or administration of more strenuous immunosuppressants, including abatacept, infliximab, other agents of that nature, should be employed early, again, in conjunction and consultation with consultants from cardiology. I think that those relationships have to develop over time, but more intensively for these very severe adverse events that oncologists are facing for our patients.
Thank you so much for this. And now the re-challenge strategy, which Sujit was just talking. So, Dr. Chitalkar, do you want to take this question? You know, if a patient develop a life-threatening toxicity, do you really feel that you would re-challenge ever or never?
I think firstly is the key is what kind of response the patient has already achieved in the immunotherapy that you have been able to deliver. And then, of course, the severity of the toxicity, grade 3 and above. If it comes back to grade 1, maybe. And then at the end of the day, you have to actually see clinically, take a judgment call as to what is more life-threatening, whether the immune checkpoint inhibitor toxicity versus the, the prospect of living long-term without symptoms in terms of a cancer like lung cancer. So I think it's an individual personalized call, and grade 3 onwards, yes, it's a lot of times from the patient's point of view, financial toxicity, so on and so forth, it does sometimes become a demotivating factor also to take. So, but let's come to the topic closer to our heart, which is young people's cancer. And we do treat a lot of Hodgkin's with nivolumab, and that's very well tolerated and that kind of thing. So whereas the lung cancer with pembrolizumab, I think that's where the toxicity will actually occur. So
Dr. Malhotra also wants to say something.
So I think my practice is that I involve an organ specialist sooner rather than later. And 3-4 years back, when these drugs were very new, like it used to be, there was a little bit of two-way education. We had to tell them to read up on the toxicities. But now they are pretty much up to date. And I think it helps if you have an organ specialist on board and you take joint decisions. And this holds true for neurologists, cardiologists, nephrologists, pulmonary medicine experts. All of them can contribute to the management of the patient.
Okay. I can see Dr. Sasha is also there and his camera is not on. So we would welcome you in this panel as the Dr. Sasha, if you wish to, please join us. So you can contribute to both biomarkers and toxicity. So meanwhile, Dr. Sharon, can you answer when you re-challenge and when you really lean away from re-challenging strategy a patient who develops significant toxicity?
Yeah, I would echo the comments that were previously made. Actually, I agree 100% that re-challenge is a risk-benefit question, and many patients probably do have long-term benefits, even if they're not re-challenged, if they did experience a benefit from the ICI. But it is a significant potential risk that can affect long-term quality of life. And so I think that it is something to be taken with some amount of caution. But frequently we feel like we have no choice, and there are certainly cancers that I'm sure many of the panelists have seen where the benefit is significant, and it's hard to simply eliminate the role of PD-1 inhibitors once proven to have some benefit for those patients. Obviously, I think also sometimes we're hoping for a benefit, and so we see the adverse event before the actual benefit from the cancer perspective is there. And I think that there the calculus is actually a little bit different, and it may be worthwhile to consider alternative therapies at that point.
Sure. And about the combinations. So, the combination of pembro with axitinib, or there are dual immunotherapy or immunotherapy along with BRAF inhibitors. So there is especially hepatocellular, renal cell, lung, and melanoma. These are the more major cancers wherein we are using quite a lot of combinations. When we are using more, it is not always the merrier, and there is more toxicity as well. So how to deal with that, and where you want to give a word of caution. For example, there is severe liver toxicity when there is EGFR, TKIs, and anti-PD-L1 immune checkpoint inhibitors are being used. And similarly, there are some other combinations which leads to clinical trial discontinuations, like IPI with vemurafenib, etc. So where you would want to give a word of caution to use combinations?
From my perspective, sorry, I didn't know who you were asking.
Yeah, I'm asking to you, Dr. Shah.
Oh, so from my perspective, I'm inclined to, reserve the combinations that have been proven to have some benefit in clinical trials. So, you note a couple of really great examples where there hasn't been a benefit. There hasn't been a benefit for those patients, for instance, with EGFR mutations at all with PD-1 inhibitors, and also not with the combination of an EGFR TKI and an anti-PD-1 or PD-L1. There have also been other combinations that have essentially failed in clinical trials because of significant liver toxicity, as you note. But the ones where there is a potential benefit, I think that those have actually become essentially standard of care. I think that Dr. Naidu mentioned one of our trials. Actually, she was, before she moved from Hopkins to Ireland, she was actually one of the investigators on, along with me and some others around the country, looking at patients with autoimmune disease and cancer who need an immune checkpoint inhibitor. What I found actually is that our enrollment on that trial is actually slowed to some degree because some investigators, some clinicians, would prefer, if they, for instance, have a kidney cancer patient and they have somebody who needs an immune checkpoint inhibitor, they prefer to use a combination of, let's say, an axitinib and pembrolizumab, or avelumab and pembrolizumab, and axitinib in combination rather than single agent. And so we were looking to modify our trial to really just align ourselves with practice. That even in these high-risk populations, people with autoimmune disease, the field has actually moved in the direction of using combinations whenever possible, because the effectiveness is just that much better. Ipilimumab, probably, at least from the IO combination, is the highest toxicity agent in the immune checkpoint inhibitor armamentarium, but it's still worth it in many cases. And the only reason why I can say really that it's worth it is because of the results that we have had from clinical trials. So I would personally refrain from using the combinations without clinical trial data behind us. But with it, I'm more than all for it. I think that's the right course of action.
Sure. So I think there's a lot to discuss, but I will, sum up with this last case, which is from our institution. Actually, this is a malignant melanotic schwannoma with Carney complex, very, very rare disease as such. And therein, when this young patient who was a professional dancer reached to us, there was hardly any data available. So we have tried, immune checkpoint inhibitor along with radiation because the location was paraspinal. And although this patient lived a long life and finally succumbed, but with a good quality of life as well. And it was the longest survival documented. But she developed skin toxicity. So although her skin toxicity was this grade, but in the literature, there are various grades, various severity and most common. So I just want to take your, opinion that, at times we come across a skin toxicity, which is more than or equal to 30% of BSA, but very mild. The severity of rash is very mild and there is some pruritus. However, at times there are blisters all across and it is only a 5%, 10%, but it is looking very angry and, severe. So when we go by the standard grading, more than 30% qualifies grade 3. So in such scenario, do you recommend stoppage or, how you proceed? Because many times it's so, because of the larger area of skin, there is 30% qualifies. So this is often a dilemma in the clinics. I would take your opinion on that and perhaps we need to then conclude.
For one, I'd actually add that there is a very real need to involve the dermatologists early in cases like this, which I'm sure was done in this case. But it's clear that involvement of specialist colleagues helps improve the outcomes for our patients. That looks like actually a fairly severe toxicity. I know Dr. Njatic actually is working on one aspect of skin-related toxicities from the biomarker perspective in a national consortium, and he might want to comment. But I do believe that there are at least some of these skin toxicities that can be treated sometimes quite easily by the standard, for instance, if there's a psoriatic plaque, treated with standard anti-psoriasis medications, and otherwise, oftentimes the mainstay, as I noted before, is actually steroids. The definitions, I think you're pointing out some problems with CTCAE, so whether or not it should count as a grade 2 or 3. I think that since it's some of my colleagues that help publish CTCAE, it's actually published from the NCI. I'll try to take that into account and making recommendations to them if you want to send that to me after the conference, if there's any ambiguity in that definition.
Right. So I think the last question is about autoimmunity and the immune compromise. So these are again patients that there is the HIV patients are surviving longer. And they develop many cancers as well, and then we need to use immunotherapy in them. Now there is an evidence in Kaposi sarcoma as well. So how you manage an immune compromised patient along where there is indicated immunotherapy. And this is my last question in the interest of time. Otherwise, there were several slides which we could have discussed, but perhaps we will discuss offline.
Yeah, so actually, HIV is an area that we at the NCI and the National Cancer Institute in the US, we have been pushing as aggressively as possible. We don't see a major problem in treating patients with HIV with immune checkpoint inhibitors. We have obviously those that are on antiretroviral therapy simply don't seem to have any significant immune defect that would prevent a response. And so on virtually all our clinical trials that involve immune checkpoint inhibitors, we've allowed patients with HIV. That said, we have several trials that are dedicated exclusively to patients with HIV that we've sponsored at the NCI, one of which was published in 2019. It was called CITN-12, the Cancer Immunotherapy Trials Network in the United States, where we took patients that had lower CD4 counts and gave them immune checkpoint inhibitors, actually specifically pembrolizumab, in what was deemed a phase 1 trial. And as you note, there's been some reporting of benefit for patients with Kaposi sarcoma as well, which is a common, usually HIV-associated and HHV-8 KSHV associated cancer. That effort is still ongoing for us. We're almost done actually enrolling our Kaposi sarcoma cohort on that same trial, which will be published hopefully in the next couple of years. So I've never seen a problem that I can delineate specifically to the HIV on any of the trials that we've conducted with patients with HIV and immune checkpoint inhibitors. And so we feel that we have enough validated data to recommend that fully. Certainly those patients should also be on antiretroviral therapy, the highly active antiretroviral therapy that has proven life-saving for those patients. For the patients with autoimmune disease, I think the questions are still a little bit open. Obviously, if you have no other choice, giving the immune checkpoint inhibitor in somebody, for instance, with a metastatic BRAF wild type melanoma, there is really no other option for a patient if they happen to have a multiple sclerosis or a rheumatoid arthritis. One simply has to treat that individual. There's nothing else that you can do for their cancer other than, in many cases, an immune checkpoint inhibitor. But we are trying to at least learn more from cohorts of patients on our AIM-NIVO trial, which we're running nationally in the United States, and from large data sets of patients that have already been treated who happen to have other autoimmune conditions and end up receiving immune checkpoint inhibitors. There's been a fair amount of success anyway, but I think that there is some risk, and there's probably a need for more translational research and translational science to learn what this particular effect might be of inhibition of PD-1 or CTLA-4 or related immune checkpoint inhibitors.
Thank you very much, and thank you, everyone here present here and in the cyberspace as well. Is there any burning comment from anybody present here in the house, from any panelists? Otherwise, we'll conclude this. And with deep acknowledgement to Immuno-Oncology Society of India and SIDSI, the Society of Immunotherapy of Cancer, and all the people who joined us and helped us in this panel. Thank you very much.
Thank you. Thanks very much for inviting.
So we have half an hour academic activities more left over with us. And next will be again panel discussion, and there are a few online international faculty joined. So to conduct this panel, may I request Dr. Vineet Talwar. Dr. Sujit, may I request to please be for the next panel as well. Dr. Vineet Talwar is Senior Medical Oncologist from Delhi. May I request Dr. Syed Nisar Ahmed, Dr. Santosh Kumar, Dr. Atul Sharma from Noida,
So, thank you so much. And with the paucity of time in mind, I will try to go in a very fast way, and this will be a kind of a rapid fire session. Do we have Dr. Sasha with us?
Yes, hello, I'm here.
Yeah, thank you. Thank you so much. Slides are not moving. Somebody can help me. Slides are not moving. So we are going to discuss about the biomarker selection and its practical use in the real life, and how we try to modulate our treatment accordingly. So I would not be going into the nuances of each organ and the treatment paradigms. I would be discussing how we get stuck, which place, how to maneuver, and how the real life challenges are there which modify our treatment, whether it is the actual diagnosis or the treatment or the logistics or the economics behind it. Still my slides are not moving. Yeah, now they're moving. So as we have seen, Dr. Cooley is the father of immunotherapy. You have the fourth modality of treatment, immunotherapy, which is the fourth bullet, but that comes with its caveats. You don't have a proper biomarker, how to control the toxicity, because you can't decide in that 5 to 7% of patients who will come under the ambit of the actual toxicity in these patients. And of course, the response rates, which are about 10 to 30% in the solid tumors. So with this preamble in background, it is imperative that we should have certain markers on which we can base our treatment planning. And of course, we can expect the outcome as far as the treatment is concerned. So if I can just ask you, Dr. Syed, how much of your practice is immunotherapy at present?
So it has come up in like lung, kidney, but is coming like in SCC. So melanoma as such, because of doublet in cost, main issue in our institute. So it is throughout India is affordability issue. So, but it is picking up.
We'll come to the affordability, but
so
you started using the immunotherapy.
Yes, definitely we are using, but more in lung and kidney, and then coming up in other diseases as
So,
well.
Sujit, in the last year, has the use of immunotherapy increased in your treatment?
Yes, sir. In head and neck cancers, I have started using more of low-dose immunotherapy with OMCT. And after some approvals and patient support programs, I'm able to use it in lung and also in kidney cancers, especially nivolumab, cabozantinib is being possible because of the support.
Is it the same with you also?
Yes, sir. Especially over the past 6 months, it has tremendously increased, sir, especially after the publication of dostarlimab data.
If I may interject, in terms of percentages, how much is the quantum jump?
So last 6 months compared to the previous 6 months, it almost doubled.
Doubled.
So especially patients keep asking for the dostarlimab. Sir, we want that kind of drug. That is.
So if this is the situation that the use of immunotherapy is being doubled and tripled, then obviously we should have good sets or some predictive biomarkers by which we can fine tune our treatment and give the maximum benefit to the patient, especially as far as India is concerned, the finances are involved. So you have these predictive markers, soluble, cellular, and genomic, out of which we are using about 2 or 3 standardized markers. So what biomarkers do you usually use? If I can ask Dr. Sasha, in your clinical practice?
Yeah, I'm not a clinician, so I don't know if I'm the best person to answer, but from what I see, I mean, most of the biomarkers that are used are the only ones that are the approved ones that are usually a companion drug for the particular test, such as PD-L1, but a lot of also tumor mutation burden. I guess those are the 2 FDA approved ones that are the most commonly used.
So, as I said, that they are sometimes unpredictable, these biomarkers which we are using in our clinical practice. Should we believe, and how strong should the data be? Can you just throw any light on that?
So I think that's where really we need to have a good sense of prospective clinical trials that are designed to ask the question of how well the biomarker behaves. So these PD-L1 have now been very well established, and they have been cross-compared, for example, as a biomarker across a variety of diseases. But as I mentioned in my talk, they have also so many variety in the way they're scored, depending on the tumor type and even in the tissue itself. So it is true that at the moment, the clinical decision whether to enroll or not is more about reimbursement of the drug, whether this companion test is needed versus actual expectation of efficacy. And we need more data, I think, and more actual clinical trials that will give us a better combination of biomarkers than just PD-L1 alone, for example, or tumor mutation burden alone.
You're right. I couldn't agree more. And there are challenges when you come to the actual treatment. You have the incomplete understanding of the mechanism of action. The potential predictive markers are mostly in the retrospective trials and substantial variability in standardization. And of course, to top it up, there is the complex tumor microenvironment. So, Dr. Syed, how do you explain to the patient? Suppose, okay, I'll give you an example. How do you explain to the patient as to what these side effects are going to be?
So,
Crisp answer, though. 2 lines, because there's.
so we explain it is not a routine chemo there's something different, but probability is less. But if you respond, you can be a long-term survivor.
So, Sujit, how do you explain the prediction as to how the patient is going to fare?
Sir, regarding the toxicity, I explained to them that the chances of grade 3 or more is less than 10%. And mostly if there are toxicities would be grade 1 or grade 2, which can be managed.
Agreed, but how much is the expectation?
Yeah, so before explaining the efficacy, definitely I tell them about the biomarkers and tell them that only if the biomarkers are positive and approved, we would be giving. And as you rightly said, with chemotherapy, we have a somewhat surety that yes, 70% or 60% might respond. We know that they may not be over time sustained, but in immunotherapy, the counseling is always that it may take some time to respond. If they respond, the response are going to be long lasting.
Fine. So these are the biomarker testing rates. This is the US data. It's about 66% in 2021, 90% for a single biomarker. Spain has again about 50%, 56% for squamous and 85%. So may I ask you, in real world, are we doing molecular testing at all? Or if we are doing, how much in your practice do you see on a percentage basis?
So if we suppose lung cancer, sir, almost if it's female.
Overall, across the board.
Sir, we are doing around 60 to 70% of cases advanced stage 4. We prefer molecular testing.
60%. So any change?
In first line, it would be around 40 to 50%, but in second line, most of the time it does like 80%, it might go.
Dr. Syed, what about you?
So 30 to 50%.
32. So we have a whole range of 50 to about 70 to 75%. Dr. Sasha, what is the situation there? What is the overall percentage of patients whom you test for molecular testing?
As far as I know, most of my colleagues who are clinicians order systematically molecular testing for their patients because of the nature of the university hospital. So I would say the vast majority, but I couldn't tell you the exact percentage.
Roughly in terms of percentage, you have, a galaxy of percentages here, starting from 40-45% to about 75%. So it's about 70%, 80%, or?
I would think it's above 80% of
Okay.
at least such as tumor mutation burden, for example, testing. The PDL1, I would say, depends really on the drugs that being administered, because some of them have a compulsory companion tests, while others are just complementary, just for information rather than for approving the drug for insurance purposes.
Thank you. So this is the Indian survey. The biomarker testing rates are less than 50% in this study which has been done. And we did our own study in our own institute, and we found that about 12% of patients were the ones who actually went for the treatment, and about double of that was the ones who went for the testing. So coming to another Pandora, that is the companion diagnostics. So if we look at that, you see this graph. This is the lab uptake of the diagnostic tests. So if you start a test, the actual 50% is about 2 years, if you see this graph amongst this. And the diagnostics to reach the eligible patients, again, is about 1.5 to 2 years. So these being the caveats, what is the availability of quality testing at your setup? I think I'll start with Dr. Sasha.
So I know that at Mount Sinai, for example, the major test being done for PDL1 is usually the 22C3 one, because it's the most commonly needed for the particular drug that's associated with it. But for the molecular testing that's being sent routinely to either commercial vendors, but there are also like internal panels that are being done for mutation assessment of tumor mutation burden. So both of them are available either internally or as an outsourced test that you can just send your specimen and get the answer fast.
Right. Thank you. So you see, there is a problem amongst the company people to get the test. There is a problem amongst the actual people who are going to get the test. And on top of that, there is a problem of the sequencing. So Dr. Syed, how do you sequence? Crisp answer.
So in our setup, most of times we initially get biopsy, then some IC
What
mark.
I mean to say is, do you do single markers, you do a companion, or do you have a set of markers which are done, which are different from the NGS panel? Or
So in our setting, in any metastatic case, so if we have an upfront like lung, we see upfront all the markers like EGFR across PD-L1. So we do one go.
I think I'll reframe my question. In a typical setting in your hospital, say a lung cancer patient comes, do you put the patient directly to a broad NGS panel, or you have a typical lung panel which suits your criteria?
So usually a disease specific, like a lung panel.
You have a lung panel.
Yes.
Sujit,
Yes.
is it the same with you?
So as we send the lung panel and PD-L1 MSI, not for the lung, but PD-L1 otherwise. And only if it comes negative, we
So you have the markers which focus for the lung.
Yes,
Is it the
sir.
same there?
Yes, sir. Organ specific multi-gene panel we do, sir.
Yeah. So I think we are graduating towards, specific panels for the specific organs. Although some of the markers are agnostic, but still they help. But then apart from that, there are common problems which we encounter. The test is not requested, sample is not available, tissue is the issue, test not offered, quality, reliability, consistency, and of course, the insufficiency of being reimbursed by the TPAs. So the question
I have a question in this, sir.
I'll just ask Dr. Sasha. Is the science moving faster than the system?
I guess so. I mean, we have to acknowledge that there's still a big gap in knowledge in terms of those are all imperfect biomarkers, has been pointed out, and a lot of people will just try some of the immunotherapy, even if not necessarily indicated by the biomarkers. And so in my talk, I talked about all these potential novel methodologies, which are all on the horizon, but will take probably a long time to get approval. Since they're so complex, they will have to be brought down back to something that can be done as a type of easy biomarker, such as the PD-L1 expression, I mean, which is not easy by itself, but that's still a single marker at least being tested versus these multi-panels that we're currently researching.
So I guess all of us are on the same board. So these are the approved biomarkers which we were discussing: PD-L1, TMB, and microsatellite instability. So this is TMB. You see that definitely there is a higher progression-free survival in TMB high tumors. And if you have TMB high and PD-L1 high, again, you have a concomitant response. But TMB is a continuous variable and not limited to categorical cutoff. You have low TMB, you have high TMB. So Dr. Sasha, how do you decipher that?
Yeah, I mean, this was a question that was submitted to FDA as well, like whether there is a harsh cutoff and whether also it's probably dependent also a little bit on the sampling itself, right? That's the same, I guess, for PD-L1. It will probably come to that question as well, which is heterogeneity of the sample and whether you're getting subclones that have potentially higher mutation burden than others. But in general, I think that the consensus seems to be that at least 10 to 20 mutations per megabase seems to be that definition of high, let's say, and that in various cancer has been associated with usually better outcome.
So there is a TNB harmonizing working group which is working towards solving this problem. So coming to the MSI, you find that there are a lot of studies, and this registration trial was there where it was used as an agnostic marker. Impact of tumor heterogeneity on predictive ability. I think Sujit, you can take this short answer.
Sir, currently we don't have, in my knowledge, I don't have an experience to say that depending on the site of tumor, the PDL1 would be changing. So we go with whatever biopsy shows.
So, Dr. Sasha, your short comments on the impact of tumor heterogeneity on the predictive ability.
Yeah, it's a big issue because it is definitely varying a lot within a tumor as well. When you're doing the histochemistry of PDL1, you score it both for the intensity and the amount of surface that is being expressed, as well as where exactly on which cell. And so it's this slide that you're currently projecting is exactly what we see, which depending on where you sample, it changes, and it also changes actually depending on the immune context. So the more T cells, more likely that you have PDL1 expression because it can be induced by interferon gamma. So that's the issue with this type of markers that are inducible and that can be very heterogeneous. So
if you agree with this slide is even more cumbersome. Don't you agree?
Yeah, I mean, it does vary.
Intratumoral difference. There might be a difference in the metastasis and the primary. There might be the lab variation. There might be a standardization problem. So how do you balance in the available situation?
So currently in the big network that I'm part of, the CMAC-CIDC, we're trying to do some comparisons, for example, of the archival material that's often used to assess PDL1 versus the biopsy that's taken right before treatment, and see, for example, whether these PDL1 expression will change and will have a variation there. But it's also probably a good idea to do some biomarker intensive studies where you sample also longitudinally with the treatment and see indeed how PDL1 is being affected. And as it's in itself, that's the challenge of PDL1. And that's why I think we need also maybe better markers because of how variable it can be and how inducible, depending on the context, it can be for both drugs and immune infiltration as well.
So I guess you're right. We should have 2 or 3 good standardized labs in which we can corroborate and see whether they're actually what we.
So that is what I wanted to ask, sir. We have all the company representatives coming and telling about that. Is so who is in India? Which is the agency which actually gives us a standard guideline? The labs which are.
I think that is a very painful and very arduous process, and it requires a lot of clash of egos. Everybody says that my sampling is the best. So we should have some centralized monitor who can see and validate any good institute, either in the private sector or in the government sector, who can validate and of course validate on a regular basis, say after 6 months or 12 months, and then probably you'll get an answer.
It's like IHC has a CAP validation.
But you don't have to go to IHC or PD1, BCR ABL. That is a classical example. So these are the newer markers: TIL, neoantigen loads, somatic mutations. I won't be going into detail. Suffice to say that this retrospective analysis of gastric tumors showed that high TIL is the one which responds more to the ICIs. So I think in the end, I would like to say we need to translate real world data to real world evidence. We should not stop at just real world data. We should have real world evidence to overcome the data set deficiency, which we have just now discussed. And when that will be there, then I think we would be in a nirvana state or a state of panacea. I thank you very much. Thank my esteemed panelists. Thank Dr. Sasha for joining us in the panel discussion. Thank you.
Thank you.
Thank you so much, Dr. Vineet Talwar. Thank you, Dr. Sujit, Dr. Nisar, and Dr. Santosh. And next we have today's last session, but it is very exciting, and I think we will have quality of audience, not the quantity. So to introduce the next speaker, Dr. Bakulesh Kumar, he's from Ahmedabad, and he'll be talking about desmocolin 3 biomarker in cancer. And to introduce and chair this session, may I request Professor Hemant Malhotra, sir, to please come and chair this session and introduce this speaker.
Thank you very much, Lalit. A pleasure to welcome Dr. Bakhilesh. And he's a, so you can read that he is Executive Director of Cadila Pharmaceuticals, and he's a very well-known scientist. Met him several times in several conferences. He's quite highly respected, regarded, and awarded. He's done some special work related to ophthalmology. And I think one of his fortes is integrating Ayurveda into medical practice. So over to you, Dr. Bakhilesh.
Thank you. Thank you for kind words. So I'll just start desmocollin 3 and as a biomarker in cancer. How do I move? How do I move? Can somebody help him with this slide? It's not moving. Okay, now it's starting. Okay. So desmocollin 3 is a calcium-dependent glycoprotein. It is encoded by a single gene, which is known as DSC3. More importantly, it is homophilic adhesion molecule, which means it works as a receptor as well as ligand. For PD1 to be receptor, we need PDL1 ligand. While for DSC3 being homophilic adhesion molecule, it works as a receptor as well as ligand both. And it is a p53 responsive gene, meaning thereby when p53 gets upregulated, DSC3 gets upregulated. And it is expressed on surface protein on the epithelium. But in the rapidly dividing cells like cancer or early embryogenesis, it is also expressed in intracytoplasmic. Normally, majority of the tissue will have a minimal desmocollin 3 expressed. Say in this example for a lung, adenocarcinoma does not express, squamous cell carcinoma will express. So there are cancers which overexpress desmocollin 3, while others won't express. Ovarian cancer, if you go through the cycle from benign to malignant, it starts increasing, expressing desmocollin 3. Colorectal cancer, same story. So there are tissues which normally don't express desmocollin 3, but start expressing it. More important is breast cancer. HER2 positive and TNBC express desmocollin 3 as per the data available from Atlas, and is more likely to be infiltrating globular carcinoma or mixed histology. In head and neck, is seen mainly at HPV negative tumors compared to HPV positive tumors, which is more common in our country, HPV negative tumors. And it has a relationship between TP53 or P53, and when there is a mutation, expression is seen to be higher compared to when there is a normal P53 expression. And this is an example of maxillary squamous carcinoma, where desmocollin 3 expression is 27-fold higher. All the cancers can be divided into what is the ratio between gene expression, DSC3 gene expression in the normal tissue versus tumor tissues, and what is the actual expression in tumor tissue. So they can be, we divided them into 3 groups, where gene expression is 1 to 100, 100 to 1000, and more than 1000. And compared to normal, if you see where there is a lower gene expression, normal tissue will express more than the cancerous tissue, while where there is a higher gene expression, like group 3, they will always express more desmocollin 3 in a cancerous tissue than in normal tissue. Only exception in the lower group is pancreatic cancer, where it is always more than normal tissue in the cancer. So can it be used as a diagnostic marker? Because biomarker has a diagnostic, prognostic, and predictive value. So what do we know about diagnostic? So this was the first paper which tried to establish desmocollin 3 as a new biomarker for squamous differentiated between undifferentiated large cell carcinoma. And this was essentially done to identify whether to give bevacizumab or not to give bevacizumab. And subsequently, there are a series of publications which establish it. So desmocollin 3 has a 100% specificity for squamous variety. So when it is present, it is present. Can we use it as a prognostic marker? What do we know? So when you have a surgically resected lung cancer, fully resected, desmocollin 3 provides good prognosis. This is unlike what we know for squamous cell carcinoma, but if it is a well circumcised and fully resected, it provides a good prognosis because it's a homogeneous tissue or adhere to each other. Same story for colorectal cancer with liver bacterium. So these are the places where you can give good prognosis to the patient. Head and neck carcinoma, same story. Muscle invasive bladder cancer. And now these are gene expression higher versus lower. Muscle invasive bladder cancer, good prognosis. Breast cancer, good prognosis. But remember, in the breast cancer, gene expression actually is very low. Breast cancer in a different way. Melanoma is an exception to this rule. In the melanoma, higher DSC3 expression is associated with the poor prognosis compared to low DSC3 expression. Prostate cancer generally don't express desmocolin 3, but at gene level, lower expression is a better poor prognosis. Cervical cancer is known to express desmocolin 3, and a higher expression is associated with a better prognosis. Then this is a gene, so gene is likely to be methylated, and that's one of the methods by which you silence the gene. So when there's a methylation of a desmocolin 3 gene, the prognosis is poor. In the colorectal cancer, lung cancer, so these are examples where you can use it as a prognostic biomarker. This needs to be validated on large scale, but these are the initial studies published outside India. So I'll summarize. Protein expression of desmocolin 3 when a patient has undergone complete surgical resection provides better prognosis in lung and colorectal cancer. For a gene, head and neck cancer, muscle invasive bladder cancer, breast cancer, cervical cancer, prostate cancer provides better prognosis. While in the melanoma, and when the gene is methylated, it provides poor prognosis in lung and colorectal cancer. Can we use it as a predictive biomarker? That's the next step. So what do we know and how our interest started in this whole program? Okay. Why this is happening? Stop. Okay. Right. Can I have slides? Go back. Go back. Okay. So our interest started when we did this study, and based on which we got the approval for this product in India for non-small lung cancer. We got significant advantage in squamous cell lung cancer compared to rest of the cancer, non-small cell lung cancer. And that triggered our curiosity. And we tried to identify why this is happening in a squamous, why squamous is a preferential. So we did a series of experiments, and then we came to the conclusion, and I'm just showing you a glimpse of it. So when you give Mycobacterium W or Mycelium C, it induces desmocolin 3 expression on immune cells. So these immune cells start expressing desmocolin 3, which they were not expressing originally. And with a multiple injection, practically more than 80% of the immune cells starts expressing desmocolin 3 on their surface. Now, this desmocolin 3 expressing immune cells, which we generate through administration of Mycelium C, kills only desmocolin 3 expressing cancer cells. So in this example is a squamous cell lung cancer versus adenocarcinoma. So adenocarcinoma cells don't get killed, while squamous cell carcinoma cells get killed. And effector function, if you know the basic, is very huge effector function. We took a next step. If it is getting killed, is it because of this or something else? So we neutralize the desmocolin 3 expression either on the cancer cell or on the immune cell by using antibodies. And we realize that effector function disappears. So that again proves that whatever effect we are saying is basically because of the desmocolin 3 expression on cancer cell as well as on the immune cells. And being homophilic, it is easy to understand. What happens in vivo studies when you inject into the tumor-bearing animals? See, generally, because of the whatever has happened in the checkpoint inhibitor space, we believe that immune cells has to be inside the tumor. But here, desmocolin 3 expressing immune cells enter the tumor. So it increases in TIL. And this cells express desmocollin 3. And it decreases FOXP3, which is not disturbed by checkpoint inhibitor, but PD1 also gets decreased, but not 100%. So there is almost half of the PD1 is gone, FOXP3 is gone. So there's an effect on both arms of the immunity. It increases immune activation. Those cells go into the cells, and it decreases tumor-induced immune suppression within the tumor. So these are TIL data, actually. So can we use it and prove it? So we had this study, which was actually suggested by US FDA, that can you show us that BCG recurrent unresponsive non-muscle invasive bladder cancer, if you give this intradermal systemically elsewhere outside the bladder, it works. So, and it meet their requirement, but surprisingly, all the responders had a desmocollin 3 positive. So if you look at it, it again says that this is something which has to do with desmocollin 3 in the real life. I'll just, because we are discussing, I'll just narrate a case. This was a patient with a ECOG 2, got a first-line therapy, first cycle, worsened, became ECOG 3. And at that point in time, that doctor gave mycilexine. And to everybody's surprise, as a monotherapy, patient became disease-free and is maintaining disease-free status. And his performance status has improved from 3 to 0, and he's maintaining that. So you can use it as a therapy, monotherapy. And then we looked at what is this immunohistochemistry. So this patient was PD-L1 negative, no TIL, DSC3 positive, 27%. So if you consider in the modern jargon, his immune phenotype was immune desert. And immune desert can also be treated by this drug as a monotherapy. This is an example. Now, when you look at a PD-L1 checkpoint inhibitor and where they can be used and not used, so there's a publication, large series put together. So 60% of the people with squamous lung cancer will not be eligible for checkpoint inhibitor, but they will be positive for desmocollin 3. And this bioinformatic analysis of a database, which also suggests that PD-L1 expression has nothing to do with desmocollin 3. So actually, desmocollin 3 expression is inversely proportional to immune infiltration. So it is more likely to be immune excluded rather than immune infiltrated when the desmocollin 3 is very significantly high. So these are the list of tumors which are known to express desmocollin 3. Squamous, ovarian cancer, head and neck, cervical cancer, colorectal cancer, bladder cancer, pancreatic cancer. We had a huge microarray of 96, and surprisingly, 60% of them were desmocollin 3 positive. Other tumors which are less in frequency for our countries, triple negative bladder cancer, breast cancer, melanoma, meningioma, chondrosarcoma, pediatric ALL, basal cell carcinoma, meningioma, chondrosarcoma, pediatric basal cell, repeat. And these are some of the examples of monotherapy, what it can do. Pre-treatment, post-treatment, 11 weeks, given weekly. Malignant melanoma, out of 12, 3 became disease-free and remained disease-free. Platinum refractory carcinoma ovary, survival benefit of 5 months. Advanced muscle-invasive bladder cancer, along with palliative radiotherapy, 20 GY, whole tumor disappears and the patient remains disease-free for 2 years. So essentially, desmocollin 3 is a biomarker for cancer. It's membrane expression, which is easily detected by ISC. It's diagnostic for squamous cell lung cancer currently. Prognostic provides better prognosis for lung cancer, colorectal following resection, head and neck cancer, muscle-invasive bladder cancer, breast cancer, cervical cancer, prostate cancer in advanced management. Poor prognosis in melanoma, and when it is methylated for lung and colorectal cancer. And it is a potential predictive biomarker for selecting mycilexine as a therapy. Thank you.
So the talk is open for any comments or questions.
Thank you for the talk, sir. I wanted to know the approval status for
It's
use.
approved in India by DCGI. It's
for
approved.
irrespective of any
It is
tumor.
approved for non-small cell lung cancer,
If ovarian cancer, are we having any trials going on?
not currently.
I think ovarian cancer is one unmet need we all have. So that's what I was asking. And this is currently being used in squamous cell carcinoma. Lung?
I mean,
Approved for?
Yeah, it's approved for non-small cell lung cancer, irrespective of pathology.
And this desmocollin has to be
That is
positive.
also subsequent to that. As I mentioned in my slides, we identify this biomarker post-approval.
Okay.
Approval was irrespective of anything.
Okay.
So I have a question also, sir. Can it synergize with chemotherapy, or do you give it after you finish the chemo as a kind of a maintenance?
So the first trial, the trial based on which it is approved is along with chemotherapy. Okay. So ovarian cancer small data which I showed is along with chemotherapy. But since we started knowing more about it, I mean, they started using monotherapy also, but all original studies were with chemotherapy or radiotherapy.
Yes, Lalit.
In fact, sir, I have heard that Dr. Kumar Prabhash group is doing a trial in Tata Hospital. So that is in head neck or some other cancer?
So they are currently evaluating across non-small cell lung cancer.
And the drug is quite old, sir. In fact, I heard your talk around a decade ago.
It's not decade old. So this drug was originally approved in 1999 for leprosy. So it is that old.
Okay.
Okay. So drug is not new. The indication and science behind it is new. The knowledge which we have got because of various people working together is new. The drug is very old. Actually, it was approved for reducing duration of therapy for multibacillary leprosy. And it reduced the duration of therapy by more than half. So original treatment used to be 5 to 7 years. It reduced to less than 2 years. So that was the original trial, and original drug. But then subsequently, the science improved, immunology improved, our efforts improved. So it's a collective effort of all people in this country. So it's a pure Indian product for India.
I think let's give him one more hand for that.
Yeah. Thank you so much, sir.
So if you permit, sir, if you're going to join us for dinner, we'll carry on the question answers during dinner. Thank you.
Cost, I'm just one more question. So the cost of vials, how much does it?
Cost, if you want to do study, I'll provide it free.
Yeah, that's great.
Thank you very much, sir. That's very generous.
But I'll
And
be able to answer that question. I'm
you.
not a commercial guy.
Thank
But if you want to do a study, I'll provide it free. You don't have to go to anybody.
Thank you very much. Thank you. Okay, so Lalit, over to you again.
So I think with this, we wind up day 3 rather academic activities, and see you guys tomorrow at 9 o'clock in the morning. And we'll go for dinner in Hotel Radisson Blu, 8th floor. I'm sorry, it is 8:30. So I thank all the participants at this time, and we all assemble in Hotel Radisson Blu for dinner. Thank you.